Hanji, good morning everyone. Good morning. Good morning and welcome to the final NEET PG marathon. So, are you all ready? Okay, let me know. Are you all ready for the marathon? Can you hear me? Yes. So, if you are able to hear me, give me a thumbs up and tell me that you are there. Okay. और मुझे बताओ कि कितने बच्चे ऐसे हैं जो पूरी तरह तैयार हैं. Okay. So, what I'll do is after today's session and whatever I've done, I will upload this PDF in your deadly combos. So don't panic. I will upload this PDF for you. Don't worry. So I am so happy to see you all there, and I'm increasing the size of the first image. This is one of the most frequently asked questions. So I'm labeling some questions as my predictors. I have tried my best to keep them separate from the sessions that I've already done for you on YouTube so that we can have a more variety of predictors. You have to look at the side column. It says predictor. Okay, this is a patient who comes to you with cough and fever. Patient comes to you with cough and fever. Can you tell me? Okay. So if the patient comes to you with cough and fever, this is an opacity. This is an opacity. So if this is the opacity, is it breaking the cardiac? Is it obscuring the cardiac border? Is it obscuring the cardiac border? Yes, it appears to obscure the cardiac silhouette. What is the sign? Silhouette sign. So patient comes to you with cough and fever. There is a triangular opacity obscuring the right cardiac border. Can you tell me what is your answer? The answer will be right middle lobe consolidation. Okay. Same question, child with fever and cough and expectoration with right middle lobe consolidation has been asked in NEET PG in the past. It is a very important question for you to get it correct. Okay. Are you able to answer this? Okay. Second question. Patient with cough and foul smelling. Okay. Foul smelling sputum. Foul smelling sputum. Anyone? So why would a patient have foul smelling sputum? Anyone? So I want all of you to look at this image and I want you to imagine this disease. It looks like a circle, but it has a air fluid level. It has a air fluid level. Can you tell me what is the disease? This is a lung abscess. So these are two predictors, either lung abscess or a pneumonia are always asked in your NEET PG exam. Okay, they are very, very important. You should get it correct. Okay, second question, which is multiple times repeated in NEET PG. A patient with old history of tuberculosis. Anyone? Patient with old history of treated tuberculosis. What do you appreciate on the X-ray shown to you? Are you able to see this ball-like structure with surrounding crescent? Can you see there is a air crescent surrounding it? There is a air crescent surrounding it. Can you tell me? Okay, can you tell me what is the diagnosis? This is called as anyone? Aspergilloma, also called as fungal ball, also called as fungal ball. Can you mark it? So this patient would have old history of tuberculosis and the image will show you fungal ball. Name the sign, Monod sign. Last year also they have asked the same question in the last NEET PG, where they had a fungal ball and the question was saying what is the underlying condition? The underlying condition is, tell me, tuberculosis. If you change position, this fungal ball will move. It will move with changing in position. Okay. Very frequently asked question. Anyone can try and tell me, what do you see in the image? What are these? These are dilated bronchi. These are dilated bronchi. Anyone? Why are the bronchi dilated? Why are the bronchi dilated? This is bronchiectasis. This is bronchiectasis. Okay. Anytime you have a question with bronchiectasis, we need to remember, if they show you situs inversus, think of Carter-Jenner syndrome. If they use the word central bronchiectasis, think of allergic bronchopulmonary aspergillosis. If they say pancreatic insufficiency, think of cystic fibrosis. Okay, very, very important questions. Anyone can now try. Patient after an accident is breathless. Patient after the accident is breathless. Anyone? Can you tell me? The trachea and the mediastinum are pushed. Anyone can tell me, what do you see here? You can see pneumothorax. If the dark thing is the pneumothorax, what is this sharp line? What is this sharp line called as? Anyone? This is called as visceral pleural line sign, seen in pneumothorax. What will you see in pneumothorax on M mode ultrasound? Barcode sign. On M mode ultrasound, you will see barcode sign in pneumothorax. Can you do it? Also called as stratosphere sign. On a supine film, pneumothorax will show deep sulcus sign. On a supine film, pneumothorax will show deep sulcus sign. Very good. Okay. Next predictor. A patient with some respiratory complaints, what are you looking at and what will you suspect? Anyone? You are able to see, tell me, multiple coin-shaped, cannonball-like metastasis. So these are the usual suspects in your NEET PG exam. Sometimes they will, so can you see multiple round coin-shaped randomly distributed nodules seen in metastasis? These are metastasis. Next predictor for your NEET PG, patient with pain in the arm and ptosis. I want you to find the disease for me. Patient has pain in the arm and ptosis. You have to tell me where is the disease. Now when you look closely at the X-ray, I want your attention in this area. Look at this. There is a tumor in the lung apex which has caused rib erosion. There is a tumor in the lung apex which has caused rib erosion. It is a cancer which is causing invasion of your brachial plexus and sympathetic chain, causing Horner syndrome. This is Pancoast tumor. The ptosis is because of Horner syndrome. This is also called as superior sulcus tumor. This tumor is also called as superior sulcus tumor. Are you able to do it? Okay. Now let's see another one. Okay. Patient with breathlessness. Patient with breathlessness. What do you see? If the patient has breathlessness and they show you X-ray which has soft fluffy opacities. Soft fluffy opacities. Where? Bilaterally, lower part of the lung in the center. This is called as wing appearance. This is called as bat wing appearance, seen in heart failure due to cardiogenic pulmonary edema. If the entire lung is white, cardiac size is normal, and if the patient has some, remember you might have read about this, patient has some systemic inflammatory disease, then you will think of non-cardiac pulmonary edema. Then you will think of non-cardiac pulmonary edema. Okay. Now, anybody who is having a voice issue, maybe they can just go back and join back again. Maybe you joined earlier and sometimes it happens in YouTube live. Okay. Now see, child with cyanosis, lung fields are appearing oligemic. Child with cyanosis, lung fields are appearing oligemic. What do you think? Boot-shaped heart. Core and Sabbath, seen in tetralogy of Fallot. This is one of the sure short question many times asked in your exam. Tetralogy of Fallot. Can you do it? Okay. So one of my predictions is either they will ask you cardiogenic edema or ARDS, or they will ask you a congenital heart disease. The second congenital heart disease that can be asked in NEET PG is child with cyanosis, lung fields have plethora. Child with cyanosis, lung fields have plethora. What is the shape of the heart? Shape of the heart is like figure of 8 or snowman. Name the condition. Supracardiac TAPVC. Supracardiac TAPVC. Total anomalous pulmonary venous connection. Very important. Don't miss it. So I hope you have seen. I am trying to show you some common questions that are very often asked in your exam that should give you an edge. Okay, beta. One of my predictors for NEET PG. Patient with neutropenia. Patient with neutropenia, CT scan shows a halo-like appearance. CT scan shows dense consolidation surrounded by halo. What will you suspect? What will you suspect? Angio invasive aspergillosis. Angio-invasive aspergillosis. Let me ask you another question. I am sure some of you should be able to solve. If they say a diabetic patient or a patient on steroid, contrast MRI of the face shows a dark turbinate sign. What will you suspect? If the patient is diabetic on steroid, contrast MRI shows a dark turbinate. That is the question in which you will mark mucormycosis. That is the question in which you will mark the answer as mucormycosis. Okay, very good. So happy for you. Okay, beta. Now, this is again one of the common NEET PG questions. TB, if it spreads hematogenously, it will lead to miliary appearance. But if you see branching appearance, I want you to see these nodules present in branching pattern around the bronchovascular bundle. What do you suspect? This is a spread of TB which is through the bronchus. This is endobronchial tuberculosis. Endobronchial tuberculosis. Keep it in mind, very important. The appearance is called as tree in bud sign. Any infection which spreads via endobronchial route, you will see tree in bud sign, tree in bud appearance. Okay, let's try one more. Sometimes in your NEET PG, they like a one-liner. I will ask you the one-liner. Let's see how many of you can tell me. There is a lesion in the left lung which has a air fluid level, but on the top of the air fluid level, some daughter cysts are floating. Name the sign and the cause. This is the pulmonary hydrated cyst. Name the sign. Water lily appearance. This is called as water lily sign, seen in hydrated cyst of the lung. Hydrated cyst of the lung. Why this is not an abscess? Because you could see the daughter cysts floating on the top. This appearance can also be called as Camelot sign. Okay, one more predictor. Now tell me, what do you see in this patient's X-ray? What do you see in this patient's X-ray? We can see dilated bowel loops. Dilated bowel loops are placed centrally and they have complete folds. They have complete folds called as volvulae conniventis. So the dilated loops are central with valvulae conniventis. What do you think you are looking at? Small bowel obstruction. Small bowel obstruction. If the dilated loops are peripheral, if the dilated loops are peripheral with Haustrae, then large bowel obstruction. If the dilated loops are peripheral with Haustrae, then we think of large bowel obstruction. Very good. Now tell me, you have to tell me there is gas in the stomach, gas in the duodenum. Gas in the stomach, gas in the duodenum, no other gas is visible. Which chromosomal anomaly is associated with this? This is your classic double bubble appearance seen in duodenal atresia, associated with Down syndrome. Associated with Down syndrome. Very good. So what we are trying to do is we are looking at some classic questions that can be asked in the exam. Okay, beta, now tell me, this patient comes to the emergency. This is your liver, right kidney, left kidney, aorta, IVC, gallbladder. Which organ is having the disease? Which organ is having the disease? It is the pancreas which is swollen with some peripancreatic fluid. This is a case of acute pancreatitis. This is the case of acute pancreatitis. Anyone? In acute pancreatitis, we do a CCT to look for severity. And tell me, should be done at least after 72 hours. Okay, beta. If they say, remember this line, if they say pancreatitis, CT is mandatory, it is false. CT scan is not mainly done for diagnosis, it is mainly done for severity of pancreatitis. On plain X-ray, colon cutoff sign is seen in acute pancreatitis. If you have acute pancreatitis, there is spasm of the descending colon. As a result, you see transverse colon, then cutoff. It is a sign of acute pancreatitis on plain X-ray. Okay, let's try one more beta. Anyone? Now tell me, on this image, on this CT image, where is the disease? Where is the disease? This is the disease. Now I am going to zoom in and I am asking you, which organ is diseased? Now you see there is calcification in the pancreas. This is chronic pancreatitis. Any one of you can tell me what sign of chronic pancreatitis can you see on a MRCP? Chronic pancreatitis on MRCP will show, anyone? Chain of lakes appearance. Chronic pancreatitis on MRCP will show chain of lakes appearance. Very good, beta. Very good. Now try. Okay. One of the important predictors for our exams. Anyone can tell me where is the disease located? Where is the disease located? I'll zoom in and ask you. Now tell me, where is the disease? The air is seen below the diaphragm. Can you see the gas below the diaphragm? Yes. Now tell me, what is the cause? This is your pneumoperitoneum. Pneumoperitoneum. Can you tell me, why do you have pneumoperitoneum? Due to hollow viscous perforation. How will you manage this case? Hollow viscous perforation usually needs a laparotomy. So after your initial resuscitation, you will go for laparotomy. Initially you will give resuscitation, then go for laparotomy. Very good. Okay, beta. Suppose I do a MCU, I see the bladder, I see the posterior part of urethra is dilated. Can you tell me, in a male child, what is this appearance and why it is seen? In a male child, if you see this, why are you seeing it? This is your posterior urethral valve appearance. Keyhole sign. Appearance on antenatal ultrasound looks like a keyhole. Are you able to revise it? Very good, beta. Now try. Now this is, I took this picture on, just to make you a little happy. Many times I show this X-ray to final MBBS students. I want you all to listen to me carefully. I show this X-ray to final MBBS students and I ask, what is the X-ray showing? They say heart. They say heart. Then I show this X-ray to post interns. They say stone. So in 2 years of your life, the heart becomes stone. 2 साल के अंदर दिल की जगह स्टोन दिखना शुरू हो जाता है. This is not heart. This is stone. Which stone? Okay. So Staghorn calculus. If a patient with Staghorn calculus is having UTI with Proteus infection, then you think of struvite composition. It might be due to struvite. Okay, now let's see an answer. Now I will zooming in. Do you see calcification in the kidney? Do you see calcification in the kidney? Yes. Unilateral, bilateral? Bilateral. Both the kidneys, renal medulla shows calcification. One side slightly more than the other, but there is bilateral nephrocalcinosis. Okay, so I will write this patient has bilateral medullary nephrocalcinosis. You just need to tell me, why would this happen? This would happen if you have increased excretion of calcium. This happens in hyperparathyroidism. This happens in renal tubular acidosis. Okay. So this is one of the confusers in the exam. They might ask you directly in the exam. This is not putti kidney. Putti kidney will be unilateral shrunken calcified kidney. This is nephrocalcinosis due to high excretion of calcium which happens in hyperparathyroidism. Okay. Tell me, do you have a stone on this X-ray? Is there a stone in this X-ray? Anyone can tell me very fast. Is there a stone? Yes. Where? Bladder. This is the vesical calculus. NEET PG likes to show bladder stones. Remember, bladder stone investigation of choice is ultrasound. For bladder stones, investigation of choice is ultrasound. Can you do it? Okay, beta, very good. Okay. Now I will just zoom in. And ask you, are you able to see some stones on the X-ray that I am showing you now? Are you able to see some stones on the X-ray that I am showing you now? Anyone? Yes. These are in the right upper quadrant. They are tightly packed. They are tightly packed. What is this? Anyone? This is gallstones. These are your gallstones. Okay, beta. Now what I'll do is, I will quickly give you some questions to solve. Okay, anyone? Urinary stone. Urinary stone. Investigation of choice for stone in the urinary tract, NCCT. Gallstone. Investigation of choice, ultrasound. Gallstone, investigation of choice, ultrasound. CBD stone, investigation of choice. Anyone? What is the investigation of choice for common bile duct stone? MRCP. Okay, MRCP. Are you able to do it? Okay, beta. What is the IOC for salivary gland stone? What is the investigation of choice for salivary gland stone? NCCT. NCCT. Okay. So I hope you are able to solve these interesting questions in the exam. Now I will give you a question to answer. This is an ultrasound showing us the gallbladder. You need to tell me what is the finding in the gallbladder in this image. There are stones which are hyperechoic. Along with the stones, you can also see acoustic shadow. Okay. So why these are the stones? Anyone? Stones are hyperechoic and they have acoustic shadow. So remember, gallstones, investigation of choice is ultrasound. So what is the investigation of choice for acute cholecystitis? Acute cholecystitis, anyone? Investigation of choice, ultrasound. Okay, second question. Acute cholecystitis, what will you find on HIDA scan? What will you find on HIDA scan in acute cholecystitis? Anyone? Non-visualization of gallbladder. Non-visualization of gallbladder. Very good. If the gallbladder shows comet tail appearance, what will you suspect? If the gallbladder on ultrasound has comet tail appearance, what will you suspect? Adenomyomatosis. Adenomyomatosis. If the uterus on ultrasound shows Venetian blind appearance, what will you suspect? Anyone? Uterus on ultrasound shows Venetian blind appearance, adenomyosis. Then you will think of adenomyosis of the uterus. Very good. If they show you a bladder like this, what is the shape of the bladder? Like a pine tree or like a Christmas tree. What will you think? If the bladder is elongated, hypertrophied, like a pine tree, like a Christmas tree, you will think of neurogenic bladder. Then the answer will be neurogenic bladder. Okay. Suppose they show you image where the ureter is grossly dilated and the UV junction is dilated. Probably there is some congenital narrowing at the UV junction. What do you think? Name the sign. Adder head appearance. Name the cause. Uretrocele. So name the cause. The answer will be uretrocele. This is your adder head appearance or the cobra head appearance seen in uretrocele. Okay, beta. Now in this patient will have some regurgitation of food and halitosis. They will say halitosis or bad breath. What do you think? What is the structure that you see here in the cervical esophagus? There is an outpouching. What is this outpouching? Any one of you can tell me what outpouching do you see here? This is Zenker's diverticulum. This is your Zenker's diverticulum. They will show you a neck X-ray, either a AP view or a lateral view with an outpouching through the upper cervical esophagus. Halitosis will be written. Answer will be Zenker's diverticulum. Okay, beta. Now I want all of you to try a dilated esophagus with tapering at the distal end. Bird beak like appearance. Name the condition. Achalasia. Then it will be achalasia cardia. Achalasia cardia. Can you do it? Yes. How will you confirm? Confirm using manometry. Confirm using manometry. Okay, let's try one more. Suppose on a barium study they show you a contracted conical cecum, fibrosed ileum and a inverted umbrella like ileocecal valve. I'm saying 3 words and I want you to mention those 3 words again for me. I will write them down also. Suppose in the exam they mention these words: a contracted conical pulled up cecum, ileal stricture and a inverted umbrella like ileocecal valve. What will you suspect? These are the signs of bowel TB. Anytime they ask you the image or the question, this is a very likely question in the exam. Bowel TB. Okay. Anyone? Why you have done a X-ray that is shown to you? Why do you think the X-ray that has been done has been done? There is a coin at the anal pit. This is your rectal gas, and the baby is being held upside down. Why would you have done such an X-ray? This is done for anorectal malformation, or they might say anal atresia or anorectal malformation. This is the invertogram done for anorectal malformation. Are you able to understand this? Okay, very good. So this is not diaphragmatic hernia. Some of you are thinking this is diaphragm better. No. So this is a baby which is held upside down. The coin is at the you can see the spine also. If I zoom in, can you see the spine now? Okay, so this is, you can see a coin at the anal pit and the air is not reaching till the anal pit. This is anorectal malformation. This is an invertogram. A child with constipation, I want you to think and tell me what has happened. The rectum appears to have normal caliber, then suddenly there is an abrupt change in caliber. Rectum appears to have normal caliber in this barium enema. Suddenly there is abrupt change of caliber. What do you think has happened? This patient must be having some aganglionic segment. This is your congenital megacolon, also called as the Hirschsprung disease. This is the Hirschsprung's disease. This is not a volvulus. This is a baby with constipation. Sigmoid volvulus will be seen in old feeble patient, and the appearance will be on a plain X-ray. They will show you coffee bean appearance. If they show you barium in a child with abrupt change in caliber, suddenly it is becoming dilated. Think of Hirschsprung's disease. If in colon they show an appearance like this, narrowing has edges like this. What is the appearance like? If in a colonic barium enema they show you apple core appearance, this is classical of CA colon. This is classical of carcinoma colon. Are you able to do it? Apple core appearance, cancer. Okay. Suppose they show you a barium enema. Suppose they show you a barium enema in which the entire colon is ahostral. There are no hostrae. It is like a pipe. Then lead pipe colon. Seen in long-standing ulcerative colitis. Long-standing ulcerative colitis will lead to a lead pipe colon. Okay. Let us try and find the, I'll just give you an X-ray of a pelvis of a child. You need to tell me what is the abnormality. I'm giving you X-ray pelvis of a child. You need to tell me what is the abnormality. I'm zooming in for you to easily see. Now tell me what is the abnormality. So if you look at this left-sided hip, what do you see? There is flattening of the femoral capital epiphysis. The femoral capital epiphysis is flattened. This is what you see in leg calf Perthes disease. The answer will be Perthes disease. Investigation of choice, MRI. Always remember, I'll just add a page here for you for your comfort. Remember this, that any time you are thinking of either the word osteochondritis or avascular necrosis in the exam, the answer will be MRI is the IOC. Perthes disease, investigation of choice, MRI. Avascular necrosis of the hip, MRI. So MRI should be done for all patients with suspected AVN of the hip. It is a potential MCQ in your exams. Okay, simple question now. Tell me, what is the diagnosis on this leg X-ray? What do you think? Here you can see, I'm putting some arrows at the line. There is a dense white line. There is a dense white line which is called as sequestrum, which is the dead bone. Once you see sequestrum, it is pathognomic for chronic osteomyelitis. Over the sequestrum, you should be able to see the involucrum. This is your involucrum. This is a patient with chronic osteomyelitis. Chronic osteomyelitis. Pathognomic finding, sequestrum. Pathognomic finding, sequestrum. Okay. Now, quickly tell me, what is the investigation of choice for acute osteomyelitis? What is the investigation of choice for acute osteomyelitis? MRI. Why? It can show me marrow edema as early as 24 hours of onset. It can show me bone marrow edema as early as 24 hours of onset. Are you able to do it? Okay, beta. Let's see if you can answer another question. Let's see on this next image. Very important question will come. So one of the classic locations in your exam will be upper end of tibia. If in the upper end of tibia you see a lytic lesion with surrounding sclerosis, a lytic lesion with surrounding sclerosis, the location is upper end of tibia. What will you think? What will you think? You have to think there is destruction and healing happening simultaneously. Lytic lesion is because of, tell me, destruction, sclerosis, healing. दोनों साथ में हो रहे हैं, तो this means I am looking at subacute osteomyelitis. Think of Brody's abscess. Think of Brody's abscess as the answer. What is the classic location for Brody's abscess? Upper end of tibia. Upper end of tibia. Okay. Now, this is not osteoid osteoma. Some of you are saying, no, beta. Osteoid osteoma, one side bone cortex will be thick. And in that thickness, you should see the nidus. Osteoid osteoma, they will say pain in the leg, worse at night. Remember, relieved by aspirin, cortical thickening with a nidus in one side, which will be treated by radiofrequency ablation, which can be treated by radiofrequency ablation. Okay, tough question now. Anyone can tell me what is the finding on the X-ray shown to you? What is the finding on the X-ray shown to you? Can you find any disease, any problem on the X-ray? If you find this finding, I will give you maybe some prize later on. If you get this right, you can let me know on my Insta stories. I will give you a prize. But where is the finding? Tell me. Tough one. Where is the finding? Should I tell you? All of you are finding some tumors and rheumatoid arthritis. You are not looking at the finding. नहीं है ये rheumatoid. अब बताओ. Now I want you to look at the fourth metacarpal. The fourth metacarpal is short. This patient had a short fourth metacarpal. Can you see? Sometimes you may know it, but it is difficult to pick up. There is a short fourth metacarpal. Why would you have a short fourth metacarpal? Anyone? Turner syndrome. Turner syndrome. Turner's was the answer. Okay, interesting. Only few of you could get it right. Okay, now next question. Anyone? In which condition do we see clinodactyly? Clinodactyly means if your little finger is curved towards the ring finger. Can you tell me in which condition do we see clinodactyly? Down syndrome. Down syndrome. Okay. In which condition do we see arachnodactyly? Spider-like, thin spider-like fingers. Marfan syndrome. What else can happen in Marfan's? Aortic dissection. Don't forget. What else can happen in Marfan's? Aortic dissection. Sometimes they give a not very good X-ray, but they give a X-ray showing us multiple fractures, multiple diaphyseal fractures in different stages of healing. They will show you X-ray of an infant with multiple fractures in the diaphysis. What will you think? What will you think? So very fast I'll tell you, if you see multiple fractures, different stages of healing located in the diaphysis, think of osteogenesis imperfecta. Think of osteogenesis imperfecta. When will you think of battered baby? When will you think of battered baby? Anyone? Battered baby will be if the fractures are metaphyseal. The words will be corner fracture or they will mention bucket handle fracture. If you have metaphyseal corner fractures and bucket handle fractures, think of battered baby. Okay, easy question. Which metabolic condition will show you ring-like epiphysis? Ring-like epiphysis is your Wimberger's ring, white line of Frankel, Trummerfeld zone, subperiosteal hemorrhages, Pelton spurs. Name the condition that I am trying to tell you. This is your vitamin C deficiency called as scurvy. So what are the radiological signs of scurvy? Wimberger's ring, Pelton spur, white line of Frankel and Trummerfeld zone. and Traumerfeld zone. Okay. अभी ना मैं बहुत बताऊं और आप ये गलत करके आ गए तो वापस मत आना भाई, ये अगला वाला जरूर बताना है। पूरे चैट बॉक्स में आग लगा दो इस आंसर के साथ, किसी ने गलत नहीं करना। कौन सी मेटाबॉलिक डिजीज आप यहां देख पा रहे हैं? नोबडी, कोई भी इसको गलत नहीं करके आएगा। एनीवन? कैन यू सी द ग्रोथ प्लेट इज वाइडन्ड, देयर इज cuppings playing and fraying of the metaphysis. Can you tell me? Rickets. Rickets गलत हो गया ना, बहुत दुख होगा बेटा। This is rickets. So sometimes, because it was the final marathon, I wanted to keep it little simple for you. No hi-fi stuff, the usual things that a doctor should be knowing in MBBS. If you go to your medical college, these are the x-rays they will show you also. I have tried to think like a medical college professor for today's session. Anyone? An old patient has some vitamin deficiency with this breaks. Can you see them? In the pelvis, in the pubic rami, there are some breaks visible on this X-ray. Which vitamin deficiency could this be? These are called as pseudo fractures, which are also called as losers zones. Can you tell me why? What are the condition? Osteomalacia. This is called as osteomalacia. Osteomalacia. Keep in mind, beta. Osteomalacia. Okay, beta. Any one of you can tell me very fast. I'm sure you can tell me. Okay. What is the WHO definition of osteoporosis? What is the WHO definition of osteoporosis? Then I need you to remember T-score less than minus 2.5 according to WHO is osteoporosis. What is between minus 1 and minus 2.5? Osteopenia. Between minus 1 and minus 2.5 it is osteopenia. What is the investigation of choice? DEXA. What is the investigation of choice for osteoporosis? DEXA. Very good. Okay, beta. Suppose they show you a child with a unilocular, centrally placed, non-expansile lytic lesion in the humeral metaphysis. Okay, beta, try this. Child, humeral metaphysis, lytic lesion, non-expansile. Always think of simple bone cyst. Simple bone cyst. If you develop a fracture in simple bone cyst, fallen leaf sign. Then fallen leaf sign. Okay. Name two signs visible. What are these? Sun ray appearance. Sun ray appearance. What is this periosteal reaction visible at the periphery like a triangle? Codman triangle. Name a condition in which you have sun ray appearance, Codman triangle. Anyone? Osteosarcoma. Which eye tumor can be associated with osteosarcoma? Which eye tumor can be associated with osteosarcoma? Retinoblastoma. Retinoblastoma, don't forget. Okay. Suppose in the adult, lower end of radius has a soap bubble like lesion in the epiphysis in an adult. What will you think? Epiphyseal lesion expanding like a soap bubble in the lower end of radius. What will you think? Giant cell tumor. Giant cell tumor. Any other name for GCT? GCT is also called as osteoclastoma. Don't get it wrong in the exam. It is also called as osteoclastoma. Giant cell tumor. Okay, beta. Patient with red eye due to anterior uveitis. On MRI, bilateral sacroiliitis. On MRI, bilateral sacroiliitis, red eye due to uveitis, spine is all fused like a bamboo spine. Can you think of the HLA B27 positive, ankylosing spondylitis? The answer will be ankylosing spondylitis. Okay. Sometimes in your NEET PG they like asking this condition. Anyone? Cotton wool spots in the skull, increased alkaline phosphatase, cotton wool spots in the skull, picture frame vertebra. What condition am I talking about? Cotton wool spots in the skull, picture frame vertebra, alkaline phosphatase is raised. Think of Paget's disease of the bone. Think of Paget's disease of the bone. Okay. In which condition on X-ray will you see a corduroy cloth appearance? Vertical striations, corduroy cloth appearance. Can you tell me the condition? Corduroy cloth appearance will be seen in vertebral hemangioma. Vertebral hemangioma. If you have a hemangioma, it will look like a corduroy cloth. Now, can you imagine how will this look like on a CT scan? How will you see this on a CT scan? If I do a CT scan, I should be able to see the polka dot sign. On a CT, you will see polka dot sign in hemangioma. Hemangioma of the vertebra. Okay. I have a sign for you. Let us see if you can answer. This is femur, tibia, patella. The ligament that you see is your posterior cruciate ligament. Now I want you to appreciate and tell me, are you able to see two PCLs here? Can you see there is a double PCL? Can you have a double PCL? No. So if you have a double PCL, what does this indicate? This is the double PCL sign. Any one of you can tell me, why would you have a double PCL sign? Can you see this here? Can you see the arrows? Why would you have a double PCL sign? It is a sign of bucket handle meniscal tear. Bucket handle medial meniscus tear. If the meniscus is torn, it forms a fragment below the PCL. Double PCL sign is a sign of medial meniscal tear, which is if you have a bucket handle medial meniscal tear, this will happen. Okay, beta. Now suppose they show you a femur which is bent like this with glassy appearance. This is your ground glass appearance of bone. Shepherd crook deformity. What will you suspect? Shepherd crook deformity, ground glass appearance of bone, fibrous dysplasia. If a patient with fibrous dysplasia has precocious puberty, cafe au lait spots, what should you suspect? Then you think of McCune-Albright syndrome. Remember, cafe au lait spots, precocious puberty, think of McCune-Albright syndrome in your NEET PG exam. Okay, tough question. Which arthritis involves the distal interphalangeal joint and causes pencil in cup appearance? Which arthritis is affecting the distal interphalangeal joint and causes a pencil in cup like appearance? Anyone can tell me the answer? Psoriasis, psoriatic arthritis. Sometimes it is not talked about in a routine class, so I thought it is very important to remember. Distal interphalangeal joint, pencil in cup appearance, psoriatic arthritis. Another little less commonly asked or talked about in the classes but a common question. On a AP view, if you see a Napoleon hat like sign, what will you think? AP view में अगर ये Napoleon hat दिख रहा है तो क्या सोचोगे? Can anybody tell me? It is a sign of spondylolisthesis. L5 S1 के ऊपर खिसक गया है. Spondylolisthesis. Okay, beta? Okay, beta. On a lateral oblique view of the spine, you see something like this. Can anybody look at the image and tell me what do you see? On a normal lateral oblique view of the spine, you see the Scotty dog. You see the Scotty dog. Okay. So my questions are, Scotty dog appearance is normal. If you have a beheaded Scotty dog, what will you think? Scotty dog appearance is normal. If you have a beheaded Scotty dog, what will you think? Scotty dog का सर काट दिया, then it is spondylolisthesis. Okay beta, next question. Anyone? If you have a Scotty dog with collar, what will you think? Spondylolysis. Then you will think of spondylolysis, break in pars interarticularis, spondylolysis. Can you do it? Okay beta, next. Suppose you see subperiosteal resorption on the radial side of your phalanges. Suppose you see subperiosteal resorption on the radial side of your phalanges. What will you suspect? Anyone? Subperiosteal resorption. Let me write it down for you. Then you will think of hyperparathyroidism. Hyperparathyroidism. Okay. What is the investigation of choice to localize parathyroid tumor? What is the investigation of choice to localize parathyroid tumor? Anyone? Technetium sestamibi scan, or better will be technetium sestamibi spect. Sestamibi scan is something that you need to always remember for NEET PG. Okay, next image. Predictor. Where is the hemorrhage located? Where is the hemorrhage located? Putamen. Why would you have hemorrhage in the putamen? Why do you have hemorrhage in the putamen? Hypertension. Most common site of hypertensive bleed is putamen. Okay, let us try. Name the sign visible and the cause. Name the sign visible and the cause in the image. Quickly revise with me beta. Jaldi jaldi karenge beta, hai na? What do you see? One side MCA appears dense. This is your dense MCA sign. Can you tell me why? This is the earliest CT sign of infarct. This is the earliest CT sign of infarct. Are you able to do it? Okay, one more. Name the investigation and why it has been done. The investigation is diffusion weighted MRI. You can see the infarct. You can see the infarct. Brain infarct is earliest seen on DWI. How early? 3 to 30 minutes of onset. How early? 3 to 30 minutes of onset. This is diffusion weighted MRI, which can detect brain infarct earliest. Okay. Identify the brain hemorrhage. Shape, biconvex. What do you think? Biconvex. Limited by sutures. Limited by sutures. This is extradural hemorrhage. Why do you have EDH? It is due to rupture of middle meningeal artery. Management is usually surgical. What is the hemorrhage? Extradural hemorrhage. Patient may have lucid interval in the question. Limited by sutures. Limited by sutures due to rupture of middle meningeal artery. And the patient will have a severe head injury written in the question. Accident हुआ, bike से गिर गया, ऐसा. But if they say old man with minor fall or a shaken baby, old man with minor injury, shaken baby, shape of the hemorrhage, concavo-convex. Shape of the hemorrhage, concavo-convex. What do you think? Subdural. Then you think of subdural hemorrhage. इनमें से एक आने के बहुत chances. Then you think of subdural hemorrhage. It cannot cross midline. It cannot cross midline due to rupture of bridging veins. It is due to rupture of bridging veins. Cannot cross midline. Okay, beta. Final question. Before I hand over to Dr. Deepthi for the OBS and Gynae marathon, if you see the central star, can you see the star on NCCT? Blood in the sulci, blood in the cistern, a star like. It is a very important question. It is an aneurysmal rupture. This is subarachnoid hemorrhage. Patient will come to you with sudden severe headache. NCCT will be shown to you. You think of aneurysmal rupture. If the aneurysm is ruptured, you manage it by endovascular coiling. You will manage with endovascular coiling. So this is my side. I tried my best to show you as many images as possible in a short time so that we could revise aloud. इस मैराथन का पर्पस है साथ में बोल बोल के टाइप कर करके रिवाइज कर लेंगे, साथ में बैठ के पूरा सिलेबस आखिर में रिवाइज हो गया तो पेपर ज्यादा अच्छा होगा. लेट मी इनवाइट नाउ डॉक्टर दीप्ति टू कम एंड ज्वाइन फॉर द ऑब्स एंड गायनी मैराथन सेशन. डोंट गो एनीवेयर, जाना नहीं है, पूरी कोशिश करेंगे, इसमें से एग्जाम में क्वेश्चन आए ही आए. आई विश यू ऑल द बेस्ट. गॉड ब्लेस यू. हमेशा याद रखना है अपना टाइम आएगा नहीं, अपना टाइम अपन खुद लाएगा.
Hanji. So a very, very good afternoon, everyone. Good afternoon. And how was the first session of the day? So were you able to revise actively, active recall? Yes, perfect. So now we are going to start with the obs and gynae session, and I wanted to do it different from what we have done in DVT and LRR, but at the same time cover the most high yielding and the most important things for you. Nobody has to write anything, okay? Kuch nahi likhna hai. Everything will be there in the PDF, and we will upload the PDF for you in the Deadly Combo in revision course, and the Deadly Combo is free for everyone. So just revise and recall. We will be covering a lot of important images and a lot of important information around the images. But at the beginning, I really want to say thank you so much for giving us yet another opportunity to be a part of your life, and we are going to try our best so that you remember us for the right reasons. Okay, so everyone, are we ready? Chalo. So should we begin? Okay, chalo ji, chalo, chalo, chalo. So let's look at the first image or images for the day. Okay, so these are important topics, the probable signs of pregnancy. Okay, so please remember these are very often asked in the exams. Do you see the first sign? Yes, there is a bluish discoloration, which is the Chadwick's sign, right? The bluish discoloration can be seen in cervix, magar more importantly, where is it described for? Remember, vagina and vulva. Okay, when does it come? Jaldi jaldi batao. It comes at 8 weeks, also called as Jacqueminier's. Okay, Hagar's sign has been repeatedly coming in the exam. Yes, so bimanual exam, softening of what part? Tell me, is it softening of isthmus or cervix? Isthmus. Okay, how early does it come? It comes as early as 6 weeks. All right, look at the rightmost sign. Which one is this? Which one is this? Right, so this is the Pisca sex sign. Now what you see here is irregular enlargement of the uterus. Okay, one part seems enlarged. Can you tell me the cause of Pisca sex sign? What is the cause of Pisca sex sign? It is, yes, eccentric implantation. है ना? Eccentric implantation is the reason of Pisca sex sign 8 weeks. Softening wale signs 6 weeks. So Goodell's is 6 weeks, Hagar's is 6 weeks. All other probable signs are 8 weeks. Who is going to tell me which one was Osiander's? Osiander's kaun sa hota hai? Lateral vaginal fornix pulsations. Okay, lateral vaginal fornix pulsations. Or Palmer's kaun sa tha? Palmer's. Regular rhythmic uterine contractions is Palmer's. Okay, so remember. Next, very important. Let's look at the 3 most probable images as far as placental abnormalities are concerned. So let's look at the first image. Do you see what is it? Yes, it is marginal insertion of the cord, also called as battledore placenta. What is it risk factor for? PPH. Clinical question, cord can get avulsed and the placenta can remain inside. What will you do? MRP, है ना? Manual removal of placenta. Perfect, very good. Look at the second image. What is that? Accessory lobe. Okay, and this accessory lobe is what is called as succinct curiata. What will happen? Tell me. The accessory lobe can be left inside. So despite the placenta looking complete, the accessory lobe is left inside. Tissue is seen inside. It is again a risk factor for PPH. क्या करना पड़ेगा? Manual removal again. The third image is vela mentis. Okay, now please remember that vela mentis is also called as what? Membranous insertion of the cord. Yes, it is membranous insertion of the cord. And can you tell me what is it risk factor for? APH. So पहले वाले दो PPH. This is primarily a risk factor for APH. Now, please tell me, vasa previa किसके साथ ज़्यादा associated है? So, as I have written here, vasa previa is more seen with vela mentis. The single best answer will be vela mentis. The second best answer will be succinct curiata. We will be covering a lot of lap and gross images as well, right? Which is what is asked in your exams. So, let's look at the 2 other most important images. So, let's see this one here, the snowstorm appearance, right? What is it also called as? Honeycomb appearance. Yes, honeycomb appearance. What is it characteristic of? Jaldi batao. Characteristic of complete mole, complete mole. Now, remember the other things that they ask around it. What will be the karyotype? You will answer it as 46XX, right? It is going to be monospermic. And what is the other finding on ultrasound if we ask you? So, the other finding on ultrasound is going to be bilateral ovarian cyst called as theca lutein cyst, जिनका कारण होता है very high levels of HCG. Yes. Now, please remember the other associated findings on ultrasound. Will there be a fetus? No. No fetus. It is P57 negative. So, complete moles are P57 negative. What is the risk of GTN? 20%. So, up to 20% is the risk of GTN. Yes. Now, let's look at the image on the right. So, what is the image on the right? Let's quickly see. Nuchal translucency. है ना? Nuchal translucency. What is the ideal time to see it? 11 to 13 plus 6. Okay. 11 to 13 plus 6. Very good. When do you say it is increased NT, bache? Increased NT if it is more than or equal to 3 mm, right? And what is it associated with? The single best answer will be trisomy 21. Second aneuploidy is Turner's. So, सबसे ज़्यादा trisomy 21 followed by Turner's. And अगर karyotype normal आता है, suppose NT is raised and karyotype is normal, what should you still suspect? Suspect cardiovascular anomalies. Okay. One more important condition where NT is raised. Yes, twin transfusion syndrome. Okay. So, twin transfusion syndrome. Now, can I ask you an indirect question? So, tell me, if NT is increased, what is the next step? I have taught you, batao mujhe. If NT is increased, what is the next step? The answer should be chorionic villus sampling, right? Chorionic villus sampling. Perfect, very good. Let's look at the next 2 very probable images for your exam. So, the first one here is anencephaly. Beta, anencephaly को identify करने के लिए you should track the spine. Spine जाएगी head पे, but you do not see any cranium here, right? So, there is no cranium. So, this is anencephaly. What is it because of? Failure of closure of anterior neuropore. जल्दी से मुझे बताओ, एंटीरियर न्यूरोपोर कब क्लोज होता है? वेरी इंपॉर्टेंट, इट क्लोजेस बाय डे 25, राइट? डे 25, यहाँ पे वो क्लोज नहीं होगा. परफेक्ट, वेरी गुड. Yes, you would also see a frog eye sign or a Mickey Mouse sign, right? What is it associated with? A very common question. What would be the other finding on ultrasound? The answer has to be polyhydramnios, right? Polyhydramnios. Yes, posterior neuropore is day 27, anterior neuropore is day 25. This is the anomaly which can be diagnosed in first trimester. So if we ask you which anomaly is diagnosed in first trimester, it is anencephaly. Remember, no swallowing. Okay, the next image, let's look at the next one. A very, very probable MCQ in your exams. What is this? This is craniorachis, right? So this is craniorachis. It is a entire neural tube defect. So ranging from anencephaly to open spina bifida, right? So craniorachis mein you will see both the things. You will see anencephaly also, and you will see an open spine as well. Okay, so craniorachis, very good. Good job everyone. Let's look at the next, very commonly asked in NEET PG. So chorionic villus sampling. If you will see, the catheter will be in the placental tissue. When do you do it? 10 to 13 weeks, right? 10 to 13 weeks. Please remember, what is the advantage of chorionic villus sampling? It can give us earliest results or earliest diagnosis. That's the advantage of chorionic villus sampling. The second one is amniocentesis, right? The needle is in the fluid around the baby. When do you do it? Anytime. We can do it beyond 15 weeks, at and beyond. But most importantly, this is the one which has the least fetal risk. This is also the one which is most reliable for karyotyping or things like that, right? So amniocentesis has the least risk. It is more reliable than chorionic villus sampling, can be done anytime after 15. Okay, so please remember, अगर दो भाग में divided होगा 15 to 18 या 18 to 22, what will you answer? 15 to 18. Okay, the earlier you do, the better it is. The third image is chordocentesis, right? Now chordocentesis, it has to be in the umbilical cord, and typically where? Umbilical vein. The needle is in the umbilical vein. Remember, this can be done only beyond 18 weeks, and it has highest fetal risk. It can cause an abortion. So highest risk hota hai. Where do we use nowadays chordocentesis? We use it in RH negative pregnancy, right? So we use it in RH negative pregnancy. So that is chordocentesis. Okay, good to go? Very good. Now, these are some important level 2 ultrasound findings. When do you do level 2 ultrasound? Yes, 18 to 22 weeks is when we do the level 2 ultrasound. So look at the images on the left. Lemon sign. Can you tell me why is it lemon? Concavity of the frontal bones, right? So you will see concavity of the frontal bones. That is the lemon sign. Banana sign, you will see a banana shaped cerebellum, and both of these are features of spina bifida. The single best answer here will be spina bifida. Okay, yes, it can be seen with Arnold Chiari, right, or Chiari type 2, but we will answer the single best answer as spina bifida. Look at the image on the right. Sir has also shown you another image. This is double bubble, right? So double bubble sign is what you see for duodenal atresia. What is associated finding on ultrasound? The other associated finding on ultrasound will be polyhydramnios, and Dr. Sumer has also told you that there is a high risk of Downs syndrome. So now, can I ask you, if you see a double bubble sign on level 2 ultrasound, what should be the next thing that we should do? The next thing should be amniocentesis for karyotyping, है ना? So double bubble दिखेगा. We must do amniocentesis for karyotyping because of very large or high association with Down syndrome. Very good. Perfect. Perfect. Good job. Let's look at the next two images. Again, very fond of, NEET PG is very fond of these images, right? The one on the left are called as sacral agenesis. What else do we call it? Sacral agenesis is also called as caudal regression syndrome. Where do you see it? Please remember, it has to be pre-gestational diabetes, not gestational diabetes. GDM में anomalies नहीं होती. Also, please remember, it is the most specific anomaly in a diabetic pregnancy. Can you tell me which is the most common anomaly in a diabetic pregnancy? VSD. Shabash. Most common पूछेंगे तो VSD. Overall most specific होगा तो sacral agenesis. And if they ask you most specific in the cardiovascular system, then it is TGA. Within the cardiovascular system, the most specific is TGA. Shabash, well done. Look at the image on the right. What is this? Omphalocele, right? Please remember, what is the site? This is a umbilical site hernia. That is how you differentiate it from gastroschisis. Gastroschisis is para-umbilical, right? This is umbilical site hernia. What are the important associations you have to remember? Alpha fetoprotein levels will be high. AFP levels are high. Yes. What is the other problem? There is high risk of other anomalies. Okay. There is high risk of other anomalies. And third, which aneuploidy is linked to it? Trisomy 18. Yes. So the trisomy linked to it is trisomy 18. Yes, herniation can be physiological up to 11. Beyond 11 weeks, umbilical hernia is not physiological. Also, suppose we tell you alpha fetoprotein levels are high or alpha fetoprotein levels are low, whatever it is, then the next step has to be level 2 ultrasound, okay? And usually the values of alpha fetoprotein कितनी होती हैं? 2 to 2.5 mOm, multiples of median. They are usually the normal values if we do it between 16 to 18 weeks. So if we say high hai ya low hai, what is the next step? Your answer should be, we will do a level 2 ultrasound. Okay, is that clear? Good to go? Perfect. Very, very important latest pattern images. So let's quickly look at these two. These are both images of placenta accreta spectrum. Which type of placenta accreta spectrum? These are images of percreta. Can you tell me why? Because with the arrows, can you see, I have shown you with the arrows that placenta has reached the outer part of the uterus, which means it reaches the serosa or even the surrounding structures like the bladder, like the rectum. So these are both images of percreta. Look at the other image. Do you see the arrow? I have shown you the arrow as well. The arrow again shows you placenta has reached on the outer surface of the uterus, right? So these are both images of percreta. What would be the hints? What would be the hints? So remember, the MCQ will say she has previous cesarean and she is a case of placenta previa. That will be your hint. Okay, investigation of choice, ultrasound. Can you tell me the keywords they will use? Yes, one, they can say heterogeneous placenta. Commonly, common word क्या use करते हैं? Moth-eaten placenta. What is the other word they can use? Lacunae, placental lacunae. Okay. Now, please remember, normally IOC is only Doppler, but when in doubt, what we can use? We can, IOC is only ultrasound, but when in doubt, we can add Doppler. And when there is more doubt, we can add MRI. अगर invasion देखना है, whether it has gone into the bladder or not. तो कौन सा investigation करना पड़ेगा? MRI. If you want to see the depth of invasion, it is MRI. Okay. Treatment of choice is a cesarean hysterectomy. Okay, and which cesarean do you do here? Classical cesarean. Do not answer it as LSCS. Okay, classical cesarean, and along with it we do a hysterectomy. When do you do it? As soon as she crosses 34 weeks. So around 34 to 35 we will plan an elective cesarean and we will do a cesarean hysterectomy. Is that clear to everyone? Good job, very good. Let's look at the next important images. Very, very important. Your NEET PG has been asking a lot of gross images in your exam, so you should be knowing these images. These two are images of rupture uterus, right? Can you see? Rupture uterus typically lower segment में होता है and it is usually at the site of previous cesarean. So the biggest risk factor for rupture uterus is previous cesarean, and most commonly it will be in the lower segment, right? Most commonly into lower segment. The image on the right is also rupture uterus. Okay, this is also the image of rupture uterus. It's actually the scar site which has ruptured. Okay, what would be the keywords? Can you tell me the keywords? Yes, there will be fresh bleeding per vaginum, but the bleeding is less in amount. Okay, second, there will be pain and tender abdomen, not tender uterus. See, tender uterus is typically abruption. In rupture, the entire abdomen will be tender. Then superficial fetal parts, right? And very, very important, there will be a decrease in contractions. Abruption में it is the reverse. Abruption में contractions बढ़ जाती हैं. It is increased tone. Here it will be loss of contractions. And yes, what is the most specific finding? Yes, loss of station. Okay, loss of station. Perfect. Very well done. Okay. Very, very probable image this year for your exam is cuvillaire uterus. What is it also called as? Uteroplacental apoplexy. Okay, what is the finding? A bluish discoloration of the uterus. Yes, there is a bluish discoloration of the uterus. What is it seen with? Remember, it is seen with severe abruption. Okay, and if we ask you which type of abruption? Concealed. Because here the blood has gone into the myometrium. So it is seen with severe form of abruption and very likely to be concealed abruption as well. A major part of it is concealed. What is it a risk for? It is a risk factor for PPH, but it is not a direct indication for hysterectomy, right? Not a direct indication for hysterectomy. You will manage PPH, okay? This is an image which NEET PG is very fond of asking, and you students tend to do it wrong. So see it very, very carefully in your exams. Especially the one that is asked is type 3. Now type 3 का image देखो, especially ये वाला जिस पे मैं arrow डाल रही हूँ, and ऊपर वाला. When you say partial or type 3, it does not mean partial internal loss is covered. It means partial part of placenta is over the internal os, right? So it is only a part of placenta which is covering the os, and that is why it is called as partial. Look at image number 4 here. The entire placenta is over the internal os, and that is why type 4 is called as complete or central. Now, whenever we talk about placenta previa, please remember the management is always a cesarean, even with a dead baby, okay? It will be cesarean. Magar, important point, usually your exam will ask conservative management, which is how this is different from abruption. So you should know when you will do the conservative management. Can you tell me when will you do conservative management? So number 1. When there is no, please remember, ऊपर मैंने no लिखा है. So there should be no active bleeding. There should be no fetal distress. there should be no active labor, and there should be no hemodynamic instability. So in सबके साथ no लगाना है, and the PUG has to be less than 37. That's when you do the conservative management called as Johnson's regime. Can you tell me in which condition do you call it as low-lying placenta? What should be the criteria? Low-lying may it has to be within 1 centimeter of internal os. Within 1 centimeter of internal os. Very good. Look at again a very probable topic for your exams. Vasa previa. I told you vasa previa can be seen with velamentous, which is the first image, or it can be seen with succinct curiata, which is the second image. Okay. Please remember the key words for vasa previa. The key words are bleeding, but this bleeding will be associated with severe distress, and it will typically be seen after rupture of membranes, right? That is how you can differentiate it from abruption. Also, there will be no tenderness of the uterus here, right? So, rupture of membranes ke baad fresh bleeding and severe distress. Okay, so please remember this. What is the management? Emergency cesarean. Okay, emergency cesarean. I want to ask you, if you diagnose vasa previa, let's say at 34 weeks, what will you do? You will do a elective cesarean. So again, in vasa previa, delivery is always by cesarean section. Okay, perfect. Chalo आगे बढ़ते हैं. ट्विन प्रेगनेंसी में कुछ ना कुछ एग्जाम्स में जरूर आ रहा है, एंड इमेज बेस्ड. सो लेट्स लुक एट दिस. दिस इज द टिपिकल इमेज ऑफ लैम्डा साइन. व्हाट इज इट आल्सो कॉल्ड एज? ट्विन पीक साइन. यस, ट्विन पीक साइन. यू सी दिस dense placental tissue entering the dividing membrane. What kind of twins is this? Dichorionic, diamniotic. Okay, DCDA. Can you tell me what is the best sign to see lambda sign? 10 to 14 weeks. The earlier the better. Okay, so this is lambda sign. What about T sign? So remember, T sign monochorionic सब सही करते हैं, मगर आप गलती कर देते हो MA मार्क करके. No, it has to be MC and DA. A dividing membrane is present. That is why it is a T sign. Okay. Quickly look at this. Can you tell me, since the answer is already written there, can you tell me why is it dichorionic and diamniotic? Can you tell me the why? The answer is written. Because you are seeing two separate placentas. If you see two separate placentas, it has to be dichorionic, right? So this is DCDA, which is also overall the most common type of twins. Okay, so two placentas is always DCDA. Very good. Now look at these images. What is this? Monochorionic or dichorionic? And monoamniotic or diamniotic? So this is twin transfusion syndrome. Can you tell me why in this image the diagnosis is twin transfusion? Why? Because one baby has poly. Do you see big large water around the baby? So one baby has poly, the second baby has oligo. So it looks like the stuck twin, right? The oligo baby is called as stuck twin. So this is the image for twin transfusion. Which type of twins do you see this? MCDA. Okay, not MA. It is most common with MCDA. What is the name of the staging? NEET PG is fond of asking. It is quintero staging. Especially they will ask you, hydrops is which stage? Stage 4. IUD stage 5, abnormal Doppler stage 3. दोबारा बोलते हैं, hydrops which is most commonly asked is stage 4, IUD is stage 5, and stage 3 is abnormal Doppler. Okay. Now what is the management? Fetoscopic laser ablation, right? Fetoscopic laser ablation is the management. Very well done. Look at this. Can you tell me how will you deliver? So now one thing is sure that these babies are diamniotic. Can you tell me why? Because they have a dividing membrane. They could be monochorionic, they could be dichorionic, we don't know, but they are diamniotic. Okay, very likely MCDA. Okay, very likely MCDA. But how will you deliver? So remember, the first twin which is close to the internal os is non-cephalic. So if the first twin is non-cephalic, the answer is cesarean. How do you deliver twin-twin transfusion syndrome? Again cesarean. Okay, again cesarean. Look at this. Can you tell me what type of twins are these? The third image. What kind of twins? So this is no dividing membrane. Can you all identify? There is no dividing membrane between the twins. So if there is no dividing membrane, what is the type? Yes, this is monochorionic and monoamniotic. It is not MCDA, it is MCMA. Can it be DCMA? No. If it is DC, it has to be DA. So this is MCMA. The most specific complication क्या होती है? अगर पूछेंगे MCMA twins की, then it is cord entanglement, right? Cord entanglement. And the first twin is cephalic, but still the answer will remain as cesarean. So monoamniotic twins are always delivered by cesarean. Please do not say first twin was cephalic and it's vaginal. No, it is still a cesarean which will be done at 34 weeks. ठीक है? Very good, perfect. चलो आगे बढ़ते हैं. आजकल ये ग्राफ बार बार पेपर में आ रहे हैं. So the graphs are already labeled, but yes, we will try and look up the things. So the one that I'm showing you first is late decelerations, right? How? Tell me only one thing which you will look for to identify late decelerations. They have to exist after the contraction. They have to persist after the contraction to say that it is late. It is the most important feature. Cause kya hai? UPI. If they ask you which one is associated with hypoxia, then this is again late deceleration. Late deceleration is hypoxia. Okay. Now, please remember, the second one here is variable. What will you look for to say that it is variable? No relationship to the contraction, and it has to be a quick fall and a quick pickup. Quick fall, quick pickup, no relationship to the contraction. What is the reason for variable? Cord compression. Can you tell me which is the most common deceleration in labor? So please remember, the most common deceleration in labor is variable. Okay, variable. Can you tell me in which condition? So if they give you integrated MCQs, which condition will show you variable decelerations? Conditions where there is oligo. Why? Oligo की वजह से cord compression होगा, right? And because of that, you will see variable deceleration. So remember, they could give you integrated questions. So the key word for variable is oligohydramnios. Okay. Early is easiest. Okay. Head compression. Every time it has to coincide with the contraction. It is a slow fall, slow pickup, right? Early decelerations are nothing to worry about. But yes, this time they could ask you category 3 FHR based on NICHD. Very, very probable this year for exams. So what is put under category 3? Number 1, sinusoidal heart wave pattern, right? So sinusoidal pattern kin conditions mein milta hai? Wherever there is fetal anemia, right? So wherever there is fetal anemia, you will see sinusoidal. Typical examples for sinusoidal are Rh negative pregnancy and vasa previa, right? So Rh negative and vasa previa. The second inclusion in category 3 FHR is absent beat to beat variability. मतलब a flat line, no fluctuations is absent beat to beat variability, but it has to be absent beat to beat variability with any of the following. What are the three things? It could be fetal bradycardia, it could be late decelerations, and it could be variable decelerations. So if you see absent beat to beat variability with any of this, it is called as category 3. Jaldi batao, what is the management for category 3? The absolute management is cesarean section. But if I ask you next step, what will you do in category 3? Left lateral position. Quickly change the position. It increases the oxygenation of the baby, right? So make the mother left lateral, give her oxygen by mask, and stop oxytocin. All of this has to be done. So stop oxytocin, give oxygen, and make her left lateral. Making her left lateral is the most first important thing that you do. Okay, can you tell me amnio infusion? Dhyan se suno, amnio infusion is done for which deceleration? So remember, only and only for variable decelerations can we do amnio infusion. It is not done for any other deceleration. Okay, is that clear? Okay, let's move on to these two. These are very simple, so I will not be wasting a lot of time, but very, very important. You should be able to identify graph of AEDF and REDF in the umbilical artery, right? When do you do termination for AEDF? 34 weeks. When do you do termination for REDF? 32 weeks. The upper limit is 32 weeks. Can you tell me when do you give Magsulf for neuroprotection? कब देते हैं? Magsulf for neuroprotection is given if the pregnancy is less than 32 weeks. Now, very, very important applied MCQ. Are you ready? Now, generally we say in REDF, we want to wait until she reaches 32 weeks. But in which condition will you do a immediate termination? So remember, if they show you REDF, but they are also talking about category 3 FHR, तो REDF है, मगर MCQ में last line में they have written about category 3 FHR, then the answer will become immediate cesarean. Is that clear to everyone? Now you also know what is category 3 FHR. Then the answer will change to immediate cesarean. Okay. Uterine artery Doppler किस चीज के लिए करते हैं? So uterine artery Doppler is used for prediction of preeclampsia. It is also used for a diagnosis of IUGR. Can you tell me what do we measure in the uterine artery Doppler? Pulsatility index. The single most important parameter should be PI. Now tell me, which PI is bad? More than 95th percentile or less than 95th percentile? Which pulsatility index is bad? So remember, if it is more than 95th percentile, then it is bad. As I said, it is used for prediction of early onset preeclampsia. Kaun batayega what is early onset preeclampsia? If it happens before 34 weeks, then it is early onset preeclampsia. Perfect. Very good. Okay. Consistent MCQs for NEET PG. जरूर आएगा, हमेशा आ रहा है, इस बार भी आने की probability very, very high. Are you with me, everyone? Okay. Look at this pelvis. This is android because it is heart-shaped. Which position is associated with android pelvis? Which position? Occipitoposterior. ROP. So ROP is seen in android pelvis. How do you identify that this is ROP? Look at the triangular fontanelle. The triangular fontanelle is close to sacrum. Triangular fontanelle is where the occiput is. So this is close to sacrum. So this is occipitoposterior. It is our left, so it is right for the mother, right? So this is ROP and it is seen in android pelvis. Can you tell me what position is this? Anybody? What position is this? Triangular fontanelle is directly towards sacrum. Yes, it is directly towards sacrum. So this is what is called as direct OP or persistent OP. Which pelvis will you see direct or persistent OP? देखो drawing में भी है. It is anthropoid. Right? So direct OP and persistent OP is seen in anthropoid. How do you identify? AP oval pelvis, antero-posteriorly oval pelvis. Remember, if it is direct OP, how does the delivery happen? Face to pubes. So face to pubes भी कौन सी pelvis में मिलेगा? Again the answer will be anthropoid. Okay, the answer will be anthropoid. Perfect. How do you identify platypeloid? Transverse oval. Transverse oval. Which presentations? Face and brow. Right? So it will show you face and brow. Right? And what do you see in gynecoid pelvis? Almost circular. You will see vertex presentation. Okay, anterior position. So vertex presentations, anterior positions. Now, very probable questions for this year exam are your engaging diameters. So what will be the answer for vertex? Suboccipitobregmatic, 9.5. What is the answer for face? Submentobregmatic, again 9.5. What is the answer for occipito-posterior? For occipito-posterior, it is deflexed head. Very important. It is deflexed head. If it is deflexed head, what would be the engaging diameter? Occipitofrontal, 11.5. Occipitofrontal. Now listen to me very carefully. Exam में गए और लिखा था partial deflection. The answer will change. Now it will be suboccipitofrontal, 10.5. If it is partial deflection, it will be suboccipitofrontal, which is 10.5, right? And what is the answer for brow? We all know. For brow, it is mentovertical, 14 centimeters, right? So EDs and pelvis कुछ ना कुछ इस slide में से जरूर आएगा in your paper. Okay, let's look at this. Easiest, I'm not going to spend time. Leopold 1 is the fundal grip. So you are trying to see what is in the fundus of the uterus. Most commonly asked is Leopold grip 3, where we are using only one hand. Okay, only one hand. And this is also called as Pollux grip. Okay, Leopold 2 is called as umbilical grip, also called as lateral grip. Exactly. Okay, so lateral grip and umbilical grip. And Leopold 4, please remember, it is the 4 which is called as pelvic or deep pelvic grip. It is the grip 4. It is the only grip where the fingers are directed downwards. Only grip where fingers are directed downwards. Okay. Chalo. Very important. What maneuvers? कोई ना कोई maneuver exam में जरूर आ रहा है. It will come. It has come in the FMGE exams as well. It will come in your exam as well. Right? This one is easiest to identify. It is Mac-Roberts. It is the first maneuver that you do for shoulder dystocia, which is seen when the baby has macrosomia or diabetic pregnancy. Right? Definition में it has to be more than 1 minute delay. Yes, more than 1 minute delay. So the first maneuver is Mac-Roberts. Can you tell me what will you do if Mac-Roberts fails? Suprapubic. And what would you do after the suprapubic? It has to be delivery of the posterior arm, then it will be the rotational maneuvers. Okay, what will be the last maneuver? Last wala batao? Zavanelli. Zavanelli is the last. Which destructive procedure can we do? The only one that we can do is cleidotomy, right? So the only destructive procedure that we do is cleidotomy, cutting the clavicle. Okay, look at this. Okay, so this has come in FMGE exam as well. What maneuver is this? This is modified Ritgen maneuver. But the exams are becoming more and more conceptual. So it's not just mugging up. They asked, this maneuver is used for what? So you have to know it is used for prevention of perineal tears. So this is what we do at the time of delivery of the head to prevent perineal tears. Okay, so this is modified Ritgen maneuver because we do it during the contraction. Okay, perfect. Now, what maneuver is shown here? NEET PG is very fond of asking external cephalic version, right? So this is when you do for breech deliveries or pregnancies as well as for transverse lie. What is the ideal time to do ECV? The ideal time is 37 weeks. Okay, 37 weeks is the ideal time for external cephalic version. Now, your exams are specially fond of asking absolute contraindications. So, I have given you both absolute and relative. Absolute may please remember, never do it in twin pregnancy. Do not do it if the membranes are ruptured. Placenta previa, contracted pelvis. If there is a footling breach or a stargazer breach, we do not do a external cephalic version. Obviously, if there is a category 3 fetal heart rate or fetal distress, you won't do a version. Okay. What about relative contraindications? If the paper is slightly difficult, then they will ask you relative contraindications. What are relative contraindications? So they are very important. मतलब हम इनमें भी नहीं करते. Okay. Previous cesarean, we generally avoid version. Pre-eclampsia, we do not do a version because there is a high risk of abruption. IUGR with oligo, we don't do a version. Macrosomia, we again don't do a version. Is that clear? So you should know the absolute and relative contraindications of external cephalic version. Okay, chalo. These maneuvers are repeatedly being asked in the exam. So let's look at this. This is MSV, Maurice Smelly Wheat. Okay, what is it done for? After coming head of breech. Please see what you are doing. We are doing a malar flexion with one hand and shoulder traction with the other hand. So this is MSV. The back is anterior. Yes. Look at this. Your NEET PG ka MCQ last year. Burns-Marshall. This is what is Burns-Marshall. The back is again anterior and you are swinging the legs upwards. Right? So you are swinging the legs upwards. This is what is Burns-Marshall. But look at this. Here again you are swinging the legs upwards, but the back is posterior. So this is not Burns-Marshall. This is Prague's maneuver. Okay, so this is Prague's maneuver because the back is posterior. Very good. Which forceps do we use for after coming head? Yes, please remember this. For after coming head of breech, the forceps we use is a very specific one. It is called as Piper forceps. We will not use Wrigley's. We will use Pipers. Okay. This is the longest forceps and it has a reverse perineal curve. Okay. Remember this. Now, important. Once we have done this, look at this. A very, very probable question this time. It is Pinard's maneuver. but they will ask you what is it used for. Extended legs in breech. So if the legs are extended, it is called as Pinard's maneuver. And in this one, where you seem to rotate the baby, can you appreciate? You are trying to rotate the baby. When you do that, this is called as NORCET maneuver. It is done to deliver extended arms. Okay, so extended arms के लिए क्या करते हैं? NORCET maneuver. Very good. Okay, then let's look at very important PPH images. Definitely one of them is likely to come in the exams. What is this an image of? Controlled cord traction. What is the other name? Modified Brand Andrews method. Is it included in AMTSL? Yes, it is included in AMTSL. What are you doing? Pulling the cord and you are giving a counter traction to the uterus. So pushing the uterus up and cord down, right? CCT. What is this? Bimanual uterine massage. Yes. Is it done in AMTSL? Absolutely no. Okay. This is done for management of PPH. It is not done for prevention. It is not a part of AMTSL. Okay. Balloon tamponade can be a very important MCQ. The amount of fluid is 500 ml. You do it when you give uterotonics and the patient is still bleeding. Then yes, you should add balloon tamponade. Is that clear? So you should know when you will add balloon tamponade. Very good. Now, what is this? Identify. So this is B. Lynch. So during cesarean section, now listen to me carefully. During cesarean, your patient is having PPH. You have already given oxytocin. What will you do next? Now, would you want to do balloon tamponade? No. Since there is already an incision there, the uterus already has a cut, we will straight away go to B. Lynch, which is a kind of uterus ka compression suture, right? So it is uterus ka compression suture. Okay, so B. Lynch, right? Is that clear to everyone? Yes, after oxytocin, you can add more uterotonics, but you should also proceed to B. Lynch. Stepwise pelvic devascularization has already been an MCQ in NEET PG. How do you decide whether you do B. Lynch or you do uterine artery ligation? How do you decide? Vitals. If the patient given to you has stable vitals, you answer it as B. Lynch. If the MCQ says she has unstable vitals, you proceed to stepwise pelvic devascularization. Okay. Now, which is the first vessel? Uterine artery ligation. So, first we will ligate the uterine artery. Unilateral or bilateral? Please remember, यहाँ पे एक तरफ दिखाया है, but we do it bilaterally. Which is the next vessel? Utero-ovarian anastomosis. Okay, so the next in order will be utero-ovarian anastomosis. Is that clear to everyone? You should know the order for stepwise pelvic devascularization. Perfect. Let's go on to the next one. Very important. What is this an image of? Already written there. Uterine inversion. Can you tell me why is this not prolapse? Because you are not seeing the external os. Yes, os is not seen. So this is inversion, right? Please remember, a red fleshy mass, hemorrhage, or patient is bleeding or in shock. The first shock is neurogenic, right? A very important hint. Can you tell me a very important hint? A very important hint is uterus or fundus not palpable per abdomen, right? After delivery, uterus should be palpable. So if it is not palpable, you are seeing a red mass, no os, then this is inversion. Can you tell me what are you going to do? You begin with manual repositioning. which is called as Johnson's method, right? So manual repositioning is called as the Johnson's method. Now, do you separate the placenta or you don't? Do not separate placenta. If placenta is attached like this, do not separate the placenta, right? Begin manual repositioning where? Labor room or OT? Labor room, okay? You begin it in the labor room itself. Okay, what is this an image of? This is a vulval hematoma, okay? It is a vulval or a vulvovaginal hematoma, right? How will you make a diagnosis? So the patient will have pain, okay? And usually the uterus will be well contracted. So there will be pain, the uterus will be well contracted. Majority of times hematoma is unilateral, but sometimes it can be very large and it can cross the midline. Usually it is unilateral. What would be the features? Tender. It will be tender to touch, bluish red mass. Okay, tender to touch, bluish red mass. Pain is the symptom, unilateral, and a well contracted uterus is vulval hematoma. Yes, most of the hematomas are managed conservatively. Only if they are enlarging or they are causing severe pain which is unbearable, then yes, we would operate. If it is associated with shock, yes, we will operate. Otherwise, majority are managed conservatively. Is this clear to everyone? Okay. Obstetric images, and these are the last two that we have, I think. Okay. So this is the Wrigley's forceps. How do you identify? The cross lock, which is the English lock, right? So this is the Wrigley's forceps. A constant doubt. How do you label it? So we label it as a outlet forceps, which means the station has to be more than or equal to +3. Scalp is visible, right? So it is majorly an outlet forceps, but can I also use it for low-lying forceps? Yes, we also use it as a low-lying forceps when the station is +2. Okay, so this is Wrigley's, and this you all know is the vacuum cup. मैंने बार बार पढ़ाया है. They will ask, इस बार मैंने बोला था FMG में आएगा और वो पेपर में आया है. Where do you place the cup? So please remember, the cup has to be on the flexion point. The center of the cup has to be on the flexion point. And where is the flexion point? 3 centimeters anterior to which fontanelle? Posterior fontanelle. Remember, I told you the posterior fontanelle is triangular. So 3 centimeters anterior to posterior fontanelle. You can also say 6 centimeters posterior to anterior fontanelle. एक ही बात है. Anterior से देखेंगे तो 6 centimeters posterior है. Posterior से देखेंगे तो 3 centimeters anterior है. But very very important, they could ask it in the applied format. अगर खाली image दिया होगा, how will you know it is correct application? Correct application होगा when you will know, मैंने क्लास में भी पढ़ाया, the perimeter or the circumference of the cup should touch which fontanelle? Posterior. The perimeter of the cup should touch the posterior fontanelle. That is what is correct application. Very very probable MCQs, contraindication. Please look at this. Contraindication for instrumental delivery. And when I write this, I mean it is a contraindication for both. Okay, contraindication for forceps and vacuum. What are these? They are CPD. Anytime they say CPD, which means a combination of caput and molding, then no forceps, no vacuum. Okay, contracted pelvis, no instruments. Fetal coagulopathy, no instruments. HIV, no instruments. Osteogenesis imperfecta, no instruments. These are contraindications for both forceps and vacuum. But these days, they are very likely to ask you only and only for vacuum. What are only contraindications for vacuum? Pregnancy less than 34 weeks, face presentation, after coming head of breech, and a big caput are contraindications for vacuum, not for forceps. Is that clear to everyone? Chalo batao, which out of the two is going to cause fetal facial nerve palsy? Jaldi jaldi batao. Facial nerve palsy, forceps. Sixth nerve palsy, vacuum. Cephalhematoma, vacuum. Intraventricular hemorrhage, forceps. Okay, so IVH is forceps, cephalhematoma is vacuum. Is that clear to everyone? Perfect. So are you ready for gynae images? So in the gynae we will again have a lot of gross, lot of laparoscopic images for you which are likely to be asked in the exam. So are you all ready? Is it a good revision for everyone? I hope we are able to make it effective revision for you, something that you think that is a good investment of your time at this time. Yes, is it a good revision? Okay, perfect. Let's go on to, beta maine sare forceps I can't cover here. The idea is to look at the lock. If it's cross, it's Wrigley's or outlet. If it is a sliding lock, it's Keyland. Okay, chalo. Let's go on to the gynae images. So lots and lots of lap images, lots of histopath and lots of gross images. Are you ready everyone? Are you with me? Okay, perfect. Let's look at the first. ये सबसे important है because you are getting a lot of lap images और आप लोगों को कई बार सही anatomy नहीं आ रही होती तो हम फंस जाते हैं. So please remember this. This is what normal anatomy on laparoscopy looks like. Okay. Gynae again, we'll be finishing it up by maximum 2 o'clock. So 1 hour for obs, 1 hour for gynae. Okay. So this is what is normal anatomy. You are seeing the posterior surface of the uterus. Behind the uterus is the pouch of Douglas, which is also called as what? So pouch of Douglas is also called as rectouterine pouch. Okay, then please remember this, going from the uterus to the ovary is ovarian ligament. Okay, it is the ovarian ligament. Round ligament kahan jata hai batao? Round ligament jata hai anterior abdominal wall, inguinal canal. Now look at the MCQs. What is the relationship of round fallopian tube and ovarian? So round ligament is most anterior, फिर fallopian tube और फिर ovarian ligament. This is the AP relationship. It could be asked in your exams. Pouch of Douglas is the rectouterine pouch. Again, you have to know that is the deepest part of the pelvis in a standing position. Yes, the most dependent part. Okay, then which ligaments will be responsible for anteversion and anteflexion? Please remember, if we have to mark 2, we will mark round and uterosacral. But if we have to mark 1, the answer will be round. अगर एक करना होगा तो round लगाएंगे. Which ligament will attach ovary to lateral pelvic wall, not to the uterus? To the uterus, it is ovarian. Lateral pelvic wall is suspensory ligament, also called as infundibulopelvic ligament. What is special here? It carries the ovarian vessels. So, इसीलिए you will cut the infundibulopelvic ligament only when you are doing a oophorectomy. Only when you are doing the oophorectomy. Okay. Next, very important, can be a probable MCQ as a image-based question. What do you see here? What is this an image of? Pudendal nerve block. You have to identify. We will ask you what is the landmark. Landmark batao. The landmark is ischial spine. Okay, ischial spine. What do you use it for? Forceps delivery, instrumental delivery, right? Which ligament do you pierce? Batao which ligament? We will pierce the sacrospinous ligament, which goes from ischial spine to the sacrum. What is the root value of pudendal nerve? S234. Okay, S234. What is this an image of? paracervical block. Paracervical block, right? कब करते हैं? Whenever you want to do a cervical dilatation, because dilatation is painful, okay? What is the position? 2 and 10 o'clock. Where will you not give? Do not give at 3 and 9. 3 और 9 पे नहीं देना. Why? Because there are descending cervical arteries, okay? So don't give at 3 and 9. So you should be able to identify paracervical block and pudendal nerve block, okay? Very, very important. Gross images of Mullerian anomalies, right? It is already labeled, but I want you to look at this. The one on the left is uterus didelphius. The one on the right is unicornuate. Can you tell me why? Why? Because the one on the left, both the uterus seem equal size. Can you appreciate? They seem absolutely equal size. They will generally have 2 cervix. If it is a didelphius, it has to have 2 cervix. Completely separated, same size, 2 cervix. It can also, they can also give you a hint of vaginal septa, right? So septa किसमें होता है? Uterus didelphius. Unicornuate uterus में unequal size होता है because one is rudimentary, unequal size, rudimentary. The unicornuate uterus has highest among all risk of urinary anomalies, okay, highest risk. It is also associated with what 2 things मैंने पढ़ाया था? Ectopic pregnancy and ectopic ovary, right? So unicornuate में ectopic pregnancy, ectopic ovary. What are the ducts? So remember, Mullerian ducts का दूसरा नाम है paramesonephric ducts. Has been a question in current FMGE exam. Okay, so paramesonephric ducts, if there is completely no fusion, it will be didelphius. Whereas if one is rudimentary, it is unicornuate. Is that clear to everyone? Which surgery will you do for didelphius? Strassman. Surgery we do for didelphius is Strassman metroplasty. Okay, are you all good? All right. Look at HSG images. So one on the left is septate. Why? Acute angle. If it looks acute, you answer it as septate. If it looks wide, you answer it as bicornuate. Bicornuate और didelphius में क्या फर्क होगा? Bicornuate will have only 1 cervix. Didelphius will have 2 cervices. Okay. A woman having a heart in her pelvis. Is this a heart? Heart-shaped uterus. Could be a possible image. Yes, heart-shaped uterus. Which one is this? What is this? A heart in the pelvis. This is what a bicornuate can look like on gross. Okay. A bicornuate on gross can look like this. Okay. Remember, it will be 1 cervix, a deep dip in the fundus. Yes, the fundus has a dip. Okay. Bicornuate कब बनता है? Partial fusion. Okay. Partial fusion अगर होगा, then it is bicornuate. Now listen to me very carefully, very, very potential MCQs. Which anomaly is most common? Septate. Which one has highest risk with recurrent pregnancy loss? Septate. Highest risk with infertility? Septate. Okay. Worst reproductive outcome? Septate. Which surgery will you do? Hysteroscopic resection. It is also called as transcervical resection, also called as metroplasty. So transcervical metroplasty. Which surgery will you do for bicornuate? Strassman. Bicornuate के लिए भी अगर जरूरत पड़ेगा, we will do Strassman. जो इसमें किया है actually, this is after metroplasty. Yes, Strassman metroplasty. Now, constant MCQs, and please follow this. Okay, this is from a very, very standard place everywhere in even the textbooks and everywhere. Investigation of choice, 3D ultrasound. Gold standard investigation, MRI. which you will only do when 3D ultrasound is not diagnostic. MRI is not done routinely. Best procedure, because it is very, very invasive. It is a last resort. So when MRI is also not able to exactly tell because it's a complex anomaly, then yes, we will go ahead with laparoscopy and hysteroscopy. They are done under general anesthesia. This is the most invasive thing, okay? So it is done only and only as a last resort when there is a doubt, all right? Chalo, next. Very, very potential MCQs, you all know this. Turners, और अब आ गया है Turners के साथ Klinefelter. Surely you are likely to get something from this. So remember, they are quite apart. If you remember one, you can remember the other. Okay, so please remember these things. Turners is 45XO. Klinefelter's is 47XXY, which is more common sex chromosome abnormality, Klinefelter, okay? Turners का classic feature होता है short, Klinefelter's का classic होता है tall. Turners में absent breast, Klinefelter's में gynecomastia. Turners में streak ovary, Klinefelter's में small and firm testes, right? Turners में primary amenorrhea, यहाँ पे azoospermia. Now, what is different again in these? Turners will have normal IQ and no bar body. Klinefelters will have low IQ and they will have a bar body. Okay. What is common to both? Autoimmune diseases, diabetes as well as Hashimoto's. What else is common? Both of them have high LH and FSH. Can you tell me what kind of hypogonadism it becomes? Hypergonadotropic. Hypergonadotropic, hypogonadism. Turners में estrogen लो होगा, Klinefelters में testosterone लो होगा, ठीक है? Both of them have cardiovascular abnormalities and both of them have osteoporosis. Okay, so very, very important. You should know important differences and features. NEET PG बार-बार आपको features देता है. So, low hairline, webbed neck, shield chest. सर ने भी अभी बताया short fourth metacarpal, right? Cubitus valgus, horseshoe kidney, ये classic features हैं जो आपको आने चाहिए. Is that clear to everyone? चलो, let's go further. Very, very important. Your NEET PG is very fond of asking this. Imperforate hymen. How do you make a diagnosis? Local examination. What is the finding? Bluish bulging membrane. There is a vaginal opening. Opening है, मगर वहाँ पे hymen की membrane है. So, bluish bulging membrane. Right? The other is the ultrasound image showing a collection in vagina called as hematocolpos. है ना? Hematocolpos. Now, important remember करने वाले points. Primary amenorrhea होगा. Yes. But key word क्या होगा? Cyclical pain. Primary amenorrhea. Everything else is normal. So, normal hormones, normal karyotype, normal gonads, which is ovary. So, 46XX and ovary. If they ask you acute complication, what will be the answer? Acute complication का answer है acute urinary retention. But if we ask you chronic or a long-term complication, the answer is endometriosis. ठीक है? Endometriosis. Again, your NEET PG is fond of asking these. So, you should know the different types of hymen diagrammatically as well. So, imperforate matlab no opening. Annular matlab goal opening. Septate has been a PYQ. Yes, it has been a PYQ. Cribriform hymen has been a PYQ. So, multiple small openings is cribriform, also called as what? Sieve-like, है ना? S-I-E-V-E. And this is what a normal parous hymen looks like. Irregular margins and a bigger opening, okay? Is that clear to everyone? All right. Chalo. Right. Let's look at the next. Again, very important MCQs for NEET PG, and they are very likely to be asked again. So, HSG image of Asherman syndrome. What is the finding? Multiple small, magar keyword kya hota hai? Irregular openings, right? So, multiple small irregular openings is Asherman's. What else are you supposed to know? All hormones are normal, okay? All hormones are normal. What will be the keyword? History of D&C, yeah, history of instrumentation, right? So, D&C, yeah, history of instrumentation. Is that clear to everyone? Okay. And what is the gonad? Normal ovary, right? The gonad is a normal ovary. राइट कैरियोटाइप भी बिल्कुल नॉर्मल होगा 46XX, ओके 46XX. प्लीज रिमेंबर ट्रीटमेंट क्या होता है? हिस्ट्रोस्कोपिक एडिशियोलाइसिस, राइट? सो हिस्ट्रोस्कोपिक एडिशियोलाइसिस इज व्हाट इज द ट्रीटमेंट ऑफ चॉइस. ठीक है. So Asherman's is very important for everyone. Again, this is an image which your NEET PG people is very fond of asking. What is this? Bilateral hydrosalpinx. Bilateral hydrosalpinx. Whatever could be the cause. But please remember, bilateral hydrosalpinx always means severe tubal injury. Okay, it means severe tubal injury. And if it is severe injury, what is the treatment? The treatment will be IVF. Okay, the treatment will be IVF. Is that clear to everybody? Okay. Next, genital TB. Are you with me? Important HSG images. Okay, the first one is beads on string sign. But this is on HSG as I have written. Beads on string. The second one is golf club appearance. Very characteristic again. Okay. What is the third one? Tobacco pouch appearance. Again, very characteristic. Okay. So, tobacco pouch appearance. These three terms you have to know. Another term is lead pipe. Okay. Another term is lead pipe appearance. Now, more important than HSG images, in TB, it will be gross images. Can you tell me why the answer for the left one is genital TB and why the answer for the right one is PID? Can you tell me? In the left image, which is a very characteristic image, do you all see yellow nodules or tubercles on the surface of the ovary? Yes? So, characteristic of lab finding of TB is small nodules, yellow color nodules or tubercles on the surface of uterus, tubes, ovaries, right? And you will see very thin adhesions also there. Yes? So, there are adhesions and there are tubercles. So, this is TB. But here I don't see any tubercles. All I see is adhesions. Right? Can you all see the adhesions? Yes, and that is why we simply label this as pelvic inflammatory disease. Is that clear to everyone? Yes? Okay. Then, can you tell me what procedure is this? Although it is already labeled, but what procedure is this? Do you see that this is the same lap image that I was showing you in the first slide? This is the uterus. And यहाँ पे क्या है? Pouch of Douglas. What do you see in the pouch of Douglas? Do you see this blue fluid? Yes, can you all see the blue fluid? So this is what is the image of laparoscopic chromoperturbation. Yes, this is lap chromoperturbation. Can you tell me what is it done for? Infertility, right? So it is done whenever you are evaluating patients for infertility. Is that clear? What dye do we use? Methylene blue. Okay, we use methylene blue here. What is this? A laparoscopic image in a patient of PID. So the key word will be a patient is a case of PID. She has now come with pain upper abdomen. Normally PID में pain कहाँ होता है? Lower abdomen. Here there is pain in the upper abdomen. What do you see in the lap image? Very good. Batao, batao, batao. Yes, we are seeing violin string adhesions. Can you all appreciate? Where are the adhesions between liver capsule and anterior abdominal wall? So this is perihepatitis, right? Perihepatitis. What is it called as? Yes, Fitzhugh-Curtis syndrome. Organism batao jaldi se? Chlamydia. The single best answer is chlamydia. Is that clear to everyone? Very nice. Let's look at the next images. I have put arrows for you. Can you tell me what is the finding? Jaldi batao, kaun batayega? So this is the uterus. Normal anatomy mein aapko dikha chuki hu. What is the finding here? Do you see these arrows showing you black bluish dots? Yes, blackish bluish dots. Can you all appreciate? Whenever you see these blackish bluish dots, there is also an enlarged ovary. Blackish bluish dots, yes, is endometriosis. If they have to give you one line in hint, what will be the hint? The hint will be dysmenorrhea. Oh God, this is not gunshot. Okay, this is not gunshot. This is endometriosis. The hint will be dysmenorrhea or chronic pelvic pain. Okay, and remember, this dysmenorrhea is progressive dysmenorrhea, worsens with age. Okay, what is this? Do you again see the blackish bluish discoloration of big ovaries? The ovaries are showing the chocolate cyst. Yes, the ovaries are showing the chocolate cyst. Do you see the ovaries are meeting each other in the pouch of Douglas? So when the ovaries meet each other in the pouch of Douglas, we call them as kissing ovaries, and they are characteristic to endometriosis. Okay, they are characteristic to endometriosis. So when they meet in the pouch of Douglas, we call them as kissing ovaries. Okay, what is this? Do you again see this blackish bluish nodules? Yes. What are these? I said whenever you see blackish bluish dots and you can't make out anything else, it is endometriosis. So this is what scar endometriosis looks like. Okay, so this is what scar endometriosis looks like. Okay, are you good? Now look at these images. So first, do you see enlarged ovaries? So this is the uterus and these are the ovaries, but there is enlargement of ovaries and you see this tiny dots. These are follicles. Remember, this is PCOS. Why not endometriosis? There are no adhesions, no blackish bluish deposits anywhere. This is simply enlarged ovary with PCOS. What would be the hint in the MCQ? What would be the hint? Hint will be the girl has maybe obesity, not necessary, but they might give you. They will say history of irregular cycles and history of hirsutism. If they have to give you the ovaries, they will give you this hint in PCOS. So enlarged ovaries with this hint. What is this? Again, a very probable image. Do you see holes in the ovary? Punctures? Yes, can you all appreciate punctures? So this is what we do in lap ovarian drilling, right? So this is what we do in lap ovarian drilling. And what is it done for in PCOS? It is done as a second line treatment for infertility. It is not the first line. First line is ovulation induction with letrozole, right? After weight loss has been tried. So I'm talking about among therapeutic options, what all do we do? So please remember, lap drilling is second line. Okay, this is the typical image of PCOS on ultrasound. So we have seen gross, we are seeing ultrasound. It is called as necklace pattern of appearance. But is it a Rotterdam's criteria? No. Necklace pattern is a characteristic finding, there is no doubt, but it is not a Rotterdam's criteria. Okay, so this is again PCOS in various forms for you as images. Which hormone is increased? a constantly increased LH. FSH is never increased, it is usually normal. Sex hormone binding globulin is low. Estrogen E2 normal होता है, E1 raised होता है. Testosterone mildly increased. Up to how much? Up to 150 nanograms. Perfect. Very good. Okay. Very, very important for NEET PG. Ovarian hyperstimulation syndrome. What do you see this? Why is it not PCOS? Can you tell me? Why is it not PCOS? Because it is big follicles. So big follicles is not PCOS. This is a hyperstimulated ovary. They can give you the gross as well. This is what is OHSS. Do you see big ovaries? And within the ovaries, you can see these big follicles. So that is the gross image along with the ultrasound image. Okay. Now, please remember the hint. Hint will be IVF. OHSS usually happens only in IVF cycles, right? So hint will be IVF, infertility. The hint can also be PCOS. These are important risk factors they will give you as hints. They might ask you, what is the trigger for this condition? The trigger is HCG. It is the cause of this condition. What is the mediator? VEGF, right? VEGF, okay? And if they ask you which drug has the highest risk, प्लीज गलत मत करके आना. रिस्क में आंसर है इंजेक्शन HMG या इंजेक्शन गोनाडोट्रोपिन्स. दे आर नॉट द कॉज, दे आर द रिस्क. व्हाट अबाउट GnRH? बेटा GnRH agonist and antagonist are actually used for prevention of OHSS. They don't increase the risk. Is that clear to everyone? Perfect. Now, let's look at these images. Again, very commonly asked in your exams. NEET PG, fibroid. सबसे पहले ये मुझे बताओ, बार बार आप लोग कंफ्यूज होते हो, क्या देखोगे तो बोलोगे फाइब्रॉइड है. If there is a growth in the uterus which looks well circumscribed and pale, it is a fibroid. Do you understand this? If it is well circumscribed and pale, it is a fibroid, with only one exception. Here it looks red, it is not pale. This is because it has undergone red degeneration, which is very specific only to pregnancy. It doesn't happen otherwise. So otherwise it will usually look only pale, okay, and well circumscribed, right? Red degeneration aa sakta hai paper mein. This is the condition where it will look red and it occurs in the second trimester of pregnancy. Typically history kaisi hogi? Acute abdomen, right? And the management is medical. Okay, so acute abdomen, medical management. Multiple fibroids, it is a PYQ NEET PG, right? So multiple fibroids, all of them look pale, all of them are well circumscribed, right? Hysterectomy is the last resort. Okay, remember this. Yes, again, very important. This is how the X-ray of a calcified fibroid will look. It is big, okay, and it is eccentric in location. It's not a bladder stone, it's not a dermoid, okay. This is a calcified fibroid. We call it as popcorn kernel calcification. कौन सी कहते हैं? Popcorn kernel calcification. Very potential MCQ. FIGO staging. Please मेरे बच्चों ये सब सही करके आओगे. You have to promise me that. Okay. So please remember, this is the ones that I have marked with arrow are most likely asked in the exam. Type 0, which means completely inside the cavity. Type 1, look at this. Type 1 में आप गड़बड़ करके आते हो. Type 1 is less than 50% intramural, which is same as more than 50% inside the cavity. You get confused, Okay, so please remember this. Less than 50% is intramural. It is same as saying more than 50% intracavitary. Okay, 7 is pedunculated subserosal, and the third one that is asked is 3. Can you see 3 is completely intramyometrium? ठीक है, intramyometrium है, but it is touching the endometrium. Okay, it touches the endometrium, but it is intramyometrial. Okay, so remember the FIGO staging. It is likely to be asked in your exams. What will you do for type 1 symptomatic fibroid? Batao. Type 1 fibroid causing heavy menstrual bleeding. क्या करोगे? Treatment of choice, hysteroscopic myomectomy. ठीक है? So hysteroscopic myomectomy is what we will do for type 1 and heavy menstrual bleeding. ठीक है? चलो. Again, NEET PG is fond of asking adenomyosis. Okay, are you with me, everyone? So this is the gross image of adenomyosis. The two very commonly asked. The third one is actually a PYQ. So all you have to know is there is a globular enlargement. It's a soft uterus. It's a tender uterus and it does not grow beyond 12 weeks. Okay? So 10 to 12 weeks size. Is that clear? Now, some important hints. What will be the hint in the MCQ? History of heavy menstrual bleeding and dysmenorrhea. Right? So heavy bleeding and dysmenorrhea will be your hint. Okay? Investigation of choice क्या होता है? Remember, it is now ultrasound. MRI is only done if required. It is the gold standard. So IOC है ultrasound, gold standard है MRI. Diagnosis is on histopath but not by laparoscopy. It is a post-hysterectomy diagnosis. Laparoscopy कहाँ use करते हैं for diagnosis? Endometriosis. Endometriosis में for diagnosis we have to do a lap to get the histopath specimen, but not in adenomyosis. Okay, so it is a post-hysterectomy diagnosis. All right, very, very important and likely image for your exam. Ultrasound appearance. What is the finding? Venetian blind. What is Venetian blind? Alternate dark and light bands. Yes, so Venetian blind appearance. Okay, what else is the keyword? Poor junctional zone. Poor junctional zone and heterogeneous myometrium. What term do we use? Jaldi se batao. Salt pepper. Salt pepper जैसा myometrium is heterogeneous myometrium. So keywords are Venetian blind, poor junctional zone and salt pepper myometrium. ठीक है? Good to go? You could this time get hysteroscopic images as well. They have been asking about hysteroscopy ka fluids and we have talked a lot in DVT and LRR. So let's look at hysteroscopic images. So image number A is fibroid, submucosal type 0 fibroid, while image number B is a polyp. Can you tell me why? Fibroid is overall pale but it will have surface vessels. Fibroid के surface पे vessels होते हैं and ये irregular होता है और firm होता है. Irregular होगा, firm होगा, surface vessels होंगे. What about hysteroscopy of a polyp? Polyp actually बहुत smooth दिखता है and it is pale. Okay, so pinkish, sorry, not pale, it is pinkish just like the mucosa. So it is pink, it is smooth and soft. What will be the history in a polyp? Irregular bleeding is the history in a polyp. Postmenopausal bleeding is the history in a polyp. What is the sign on ultrasound? Yes, feeder vessel sign on ultrasound. So irregular bleeding, postmenopausal bleeding, right? This is polyp. Treatment of choice in दोनों ही conditions के लिए, whether it is a submucosal fibroid or it is a polyp, the treatment of choice is hysteroscopy. Yes, treatment of choice क्या है? Hysteroscopy. Yes, okay. Are you ready for the next images? So now we come on to ovarian images जो अब पेपर में ज़्यादा आ रही हैं. So first, let's look at some important ultrasound images. Can you tell me why is this a follicular cyst of the ovary? Why is it a follicular cyst? Because it is completely black and it is showing posterior enhancement. So it is anechoic, no septae, posterior enhancement. This is a follicular cyst. What is the management? Simply repeat ultrasound after 2 to 3 months. Nothing else has to be done. Okay. This is the typical appearance of a hemorrhagic cyst. What is the keyword we use? Fishnet appearance, also called as reticular appearance. Okay. So fishnet, reticular, these are words for hemorrhagic cyst. What is the management? Expectant, nothing has to be done, conservative management or follow up. So again, simply follow up with ultrasound, no operative procedure to be done for a hemorrhagic cyst. Is that clear to everyone? Okay. The third, very important, very commonly asked, chocolate cyst. This is a chocolate cyst of the ovary. Can you tell me why? Also called as endometrioma. Why is it chocolate cyst? Because you see homogeneous internal echoes. Yes, ... Homogeneous internal echoes is endometrioma, right? Classic name kya hai? Ground glass. Yes, it's ground glass appearance. On the other hand, this is not homogeneous. This is a complex mass, right? It is a complex mass. The internal echoes are not homogeneous. Why am I saying this is an abscess? Because it is a complex mass and look at the vascularity. It is increased, right? So, यहाँ पे vascularity is increased. History of PID हो सकता है and worsening of symptoms. So, history of PID, worsening of symptoms with this complex mass is likely a tubo-ovarian abscess. Okay, very good, very good. What is this? This is the ultrasound appearance of a dermoid cyst in the ovary. You can easily identify it with the Rokitansky protuberance, tip of iceberg sign, tip of iceberg sign. और कौन सा sign होता है? Dot dash. Okay, dot dash. Chocolate cyst, as long as it is small, matlab less than 5 and asymptomatic, no treatment. If it becomes big or symptomatic, we can start with medical management. But if it is bigger than 5, we can straight away go to cystectomy as well. Okay. Chalo. Now look at this. Can you tell me, this is a gross finding intraoperative of a large ovarian tumor. Now, if you know the keywords, you will know what to answer. For example, if they show you this image, itna bada tumor, and they are giving you CEA is raised, तो answer क्या होगा? Mucinous. So, अगर hint है इतना बड़ा tumor, because mucinous can grow to a huge size, raised CEA, then it is likely to be mucinous, because also mucinous are unilateral and big. So, this is likely a mucinous cyst. But if they change the history, and they say this lady has ascites, she has omental caking, she has raised CA 125, our answer will change. The answer will now become serous. Serous are generally bilateral, right? So, इसीलिए मैंने बोला most likely this is mucinous. But be careful of the keywords. You should know how to identify those words, integrate them, and then give the answer. Which is the most common tumor? So, overall most common are epithelial, and 90% of tumors are epithelial. Their tumor marker is CA 125. They are mostly serous in histology and they have P53 mutation. So this is common to epithelial ovarian tumors. What is this? A very, very characteristic image of dermoid. I think everyone will do it right. Yes, it has all 3 germ layers. What else? You should know it is called as mature teratoma, right? Please remember, it is the most common ovarian tumor in reproductive age. Even in pregnancy, it is usually a dermoid. Dermoids क्या होते हैं? Unilateral. कौन से type के हैं? Germ cell. They are germ cell tumors. They are unilateral usually. Malignancy is rare. So most of these are benign. So agar paper मुश्किल आएगा, they can ask you malignancy rate. It is less than या up to 2% is what we say. And the malignancy will happen in the Rocky-Tansky protuberance. ठीक है? So very, very important. Dysgerminoma, again germ cell tumor. How do you identify? Solid tan lobulated, है ना? Solid tan lobulated. Can you tell me the tumor marker? LDH, alpha fetoprotein is not raised. ठीक है? So it is actually LDH, alpha fetoprotein not raised. Please remember, it is also unilateral, but up to 20% of dysgerminoma can be bilateral. Okay, so usually ये सारे germ cell tumors unilateral होते हैं. Okay, perfect. Very, very important. Some histopathological images. What is this? So this is classic finding in a Brenner's tumor. What is it called as? Waldard cell nest. What is the finding? Periphery में there is transitional epithelium and अंदर क्या होता है? Coffee bean nucleus. Remember, Brenner's is an epithelial tumor and it is benign. Okay, Brenner's is epithelial and benign. Granulosa cell tumor. What is the finding? Karl-Exner body, right? So this is the Karl-Exner body. Yes, classic findings क्या है? Coffee bean nucleus इसमें भी होता है, right? Now, in fact, ज़्यादा characteristic होता है. Also, please remember it is estrogen producing. So, what will it be a risk factor for? Endometrial cancer, bleeding, hyperplasia, polyps, right? So, it is estrogen producing. Magar, what is tumor marker? Inhibin. More specific, inhibin B. Tumor marker is inhibin. Okay. Very, very important finding and a PYQ. Schiller-Duval body. Do you see a central vessel? Yes. So, Schiller-Duval body, right? It is a germ cell tumor and it has bad prognosis. कौन सा है ये? Endodermal sinus tumor. Also called as what? Yolk sac tumor. Yes, yolk sac tumor. Classic tumor marker क्या है? Alpha fetoprotein. It will never have HCG. So, classic tumor marker is alpha fetoprotein. Worst prognosis among germ cell tumors. Do you know why? Because it grows very fast. Okay, and causes acute abdomen. It grows really, really fast. So, worst prognosis. Very, very important, again a PYQ. What is this? Leydig cell tumor. Why? Because you are seeing Rinke's crystals and it is a androgen producing tumor. So, it will cause virilization, right? What is the older name for Leydig tumor? The older name for Leydig tumor is arhenoblastoma. The older name is arhenoblastoma. Yes, good to go. So, we are approaching close to the end. What is this? Lichen sclerosis, a possible question for your NEET PG. This is lichen sclerosis. How do you identify? It is a white plaque. Where do you see it? Vulva and perianal region. Okay, so vulva and perianal region. Remember, it is a risk factor for vulval cancer. And the treatment is what? It is a topical high intensity steroid like clobetasol, right? So, topical high intensity steroid like clobetasol. Okay, what is this? The other one, Yes. So, a swelling in the posterolateral aspect of vagina is Bartholin's. What is the male homologous organ? Bulbourethral glands, which are also called as Cowper's gland. So, bulbourethral or Cowper's glands. What is the other name for Bartholin's? It is also called as greater vestibular glands. Okay, greater vestibular glands. Please remember this. If a Bartholin's is symptomatic or it is bigger than 3 centimeters, we will do a IND. Symptomatic ho ya bada ho, to IND. If it is recurrent, then marsupialization. If it is an abscess, any size, chota, bada, the answer will be IND. Okay, so if it's an abscess, it is an IND. How will you know it's an abscess? History. Pain is going to be there. The swelling will be tender. It will be fluctuant. It will be warm. It will show edema. It will show erythema. So, signs of inflammation. Organism batao. The best answer is E. coli. Second best answer, gonorrhea. Okay, so E. coli best answer hai. Second best hai gonorrhea. Very nice. Okay. Vaginal discharge. The first one is clue cell. I am sure you all know what is a clue cell. It is a epithelial cell which is studded with bacteria, right? Is it a part of Amsel's criteria? Yes, it is a part of Amsel's criteria. Diagnostic of what? Bacterial vaginosis. Okay. What is characteristic of trichomonas? Strawberry cervix. Strawberry cervix. Now, they are quite similar. Both of them, bacterial vaginosis and trichomonas, are going to have a foul discharge. But the discharge is grey in bacterial vaginosis, green or yellow in trichomonas. Both of them will have pH more than 4.5. Okay. How are they different then? The difference is inflammation. There are no polymorphonuclear cells in bacterial vaginosis, whereas polymorphonuclear cells or inflammation will be high in trichomonas. Itching will be present in trichomonas, not in bacterial vaginosis. Trichomonas is a STD, whereas bacterial vaginosis is not an STD. Okay. Please remember, what is the IOC for vaginal discharge? It is always saline microscopy. But if we ask you what is best for diagnosis of bacterial vaginosis, best is Nugent score. बताओ कहाँ देखते हैं Nugent score? Gram stain पे. Okay, gram stain पे देखते हैं. So that is best. Clinically diagnosis कैसे बनाते हैं? Amsel's criteria से. Amsel's में एक चीज आती है जो यहाँ नहीं लिखी. What is that? It is whiff test. 10% KOH positive gives a amine odor, right? You could probably get an image for pseudo-hyphae, but less likely. More likely is bacterial vaginosis and trichomonas. So this is pseudo-hyphae for candida. Now, pH कितना होगा? Less होगा इसमें, less. Discharge is not foul smelling and it is curdy white, not foul smelling. Itching is the main complaint. You could be asked an MCQ, so listen to me carefully. When will you say a woman has recurrent vulvovaginal candidiasis? Listen to me. If she has more than or equal to 4 episodes in 1 year. Are you listening? More than or equal to 4 episodes in 1 year is when we will label her as recurrent vulvovaginal candidiasis. I'm sure you know the drug of choice. For bacterial vaginosis and trichomonas, it's metronidazole. For candida, it is fluconazole, that is DOC. But if we ask you the kit for all 3 is kit 2, green. Tino ke liye, it is the green kit. Okay, coming to the last images, but of a very important topic. What is the topic? Pelvic inflammatory disease. This is a gross image of PID. पहले भी दिखाई थी lap image. उसमें adhesions दिखाए थे. What am I showing you here? hydrosalpinx. So PID ki lap image mein you can see adhesions, you can see hydrosalpinx, you can also see what? You can also see violin string adhesions. These are all lap images. Okay, is that clear to everyone? These are ultrasound images. Very, very important. You should know these terms. What are the names? One is called as waist sign. Can you all see this? A narrowing in the dilated tube. This is a dilated tube with a narrowing. Waist sign. Chronic or acute? Chronic PID. Okay, this is chronic PID. Right? What is this? This is dilated tube with beads on string. So beads on string on HSG was TB. Beads on string on ultrasound is chronic PID again. Okay, chronic PID. What is this? Cogwheel sign. There are infoldings of the mucosa. So this is the cogwheel sign. It is seen in acute PID. Okay, it is seen with acute PID. So this comes to an end of my session for obs and gynae. We have done an intensive image-based revision, right? Because previously we have covered a lot in DVT and LRR. Yes, you should devise DVT, but this was a revision in a different format covering all the images for you, whether it is gross, ultrasound, microscopic, histopathologic. I have tried to bring to you the ones which have the highest probability of being asked. Right? So I hope you have found the session effective for your revision, right? We've covered contraception previously. Please go to DVT or even your LRR to cover contraception. Today was intensively an image-based discussion that we wanted to do. So I hope you find it useful, and I hope that you think it was a good use of your time, because that is what is most important. So thank you so much for making me a part of your journey. Hopefully you all are going to do exceedingly well. Just be confident, go out and give it a strike. Okay, all the best. और जैसे हम बोलते हैं, अपना time अपन खुद लाएगा. So take care everyone. The next session is going to be pathology. Very, very effective, very, very useful. So Path Hemat is here for you. It's going to be pathology. Very, very effective, very, very useful.
Hi, dear students. Hi, dear students. Okay, so I'm Dr. Sanjeev Chitragar. We will be discussing hematology. A quick review of the whole of hematology in another 15-20 minutes, guys. I'll not take much. Okay, so I'm going to talk about hematology. Hi, good afternoon everyone. Good afternoon. Okay, yeah, so first we'll start with the RBC disorders. Okay, so in RBC, very, very important topic are IDA. Then second is megaloblastic anemia, and the third one will be sickle cell or hemoglobinopathies, I would say. So hemoglobinopathies, for sure I'm expecting questions from these. Okay, so IDA versus their DDs, right? Yeah, so IDA versus DDs, and then megaloblastic anemias, and then hemolytic anemias, and in hemolytic specifically hemoglobinopathies. Okay, let me start with first microcytic anemia. Approach to microcytic anemia, important. In microcytic anemias, DDs for microcytic anemia, what mnemonic we discussed? Tell me now. Sita. Very good. Sita is your DD, isn't it? So how do I differentiate between SITA? So 4 important. S is sideroblastic anemia, I is iron deficiency, T thalassemia, and A is, so Sita is the mnemonic, isn't it? Voice break? I don't think so. Just a minute, I'll just check. So Sita is the T thalassemia and A is, so no, absolutely normal. Okay, so Sita, sideroblastic iron deficiency, yeah, correct, absolutely. So now how do I differentiate between them? All of them will be microcytic hypochromic only, isn't it? Yes, so all of them will be There is no voice break. I know there are few people who just want to, distract me. Sorry guys, I'm not that. I'm more focused. Okay, chalo. Sideroblastic anemia. How do I differentiate all of these? I'm going to differentiate them by iron profile. Most important will be one, iron profile. Yeah, tell me now what will be the iron profile of the iron deficiency. How do I remember? I always start with iron deficiency anemia. Iron deficiency anemia, I would say all are decreased. All are decreased except which one? Yes, except TIBC, isn't it? That is what is happening in IDA. Next, in anemia of chronic disease, all are decreased except which one? Except serum ferritin. So I'll remember it like this: all decrease except TIBC, IDA, all decrease except serum ferritin is there, isn't it? Yes, all decrease except serum ferritin. Then next is sideroblastic anemia. In sideroblastic anemia, exactly opposite of IDA. So I did not remember this at all. So opposite of IDA, all are increased except TIBC, right? All are increased except TIBC. Next, thalassemia. Thal will be what? Thalassemia minor here. Thal minor, all will be normal. So we are talking thal minor, all will be normal. In thal major, it will be iron overload. Remember? Yeah, in thal major, it will be iron overload. So this is one. Any other investigation that can help us? Any other investigation that can help us is CBC. CBC, usually in iron deficiency anemia, increase in platelet count will be seen. So there is a reactive thrombocytosis happening in iron deficiency anemia. In anemia of chronic disease, there will be increase in TLC will be seen. Right, increase in TLC. These are the only two important we will be looking for in CBC. So increase TLC, start thinking of anemia of chronic disease, and increase platelet count, more likely of a iron deficiency anemia. Right. Then next, one more, HPLC investigation. HPLC for thal minor. HPLC, hemoglobin A2 levels. Hemoglobin A2 levels between 3.5 to 9%. 3.5 to 9%. Right. Yes. Reticount will not differentiate because all of them will have reticount less than 3%, right? All these conditions will have reticount 3%. Now, so important is thal minor versus IDA. Another important DD here. So IDA versus thal minor. Specifically, I am taking IDA versus thal minor. And usually, remember this, if they are giving you a thal minor case, usually they are going to give you a pregnant woman, right? That is because genetic counseling. It is important for genetic counseling. So IDA versus thal minor. Okay, so both will be microcytic hypochromic. How do I differentiate? In IDA, yes, in IDA, hemoglobin will decrease, whereas in thal minor, hemoglobin remains near normal. RBC count will be decreased in IDA. RBC count will be increased in thal minor. So very, very important. This is how I pick up. So this is how I pick up. One, there should be disproportionate hemoglobin and RBC. See, normally they should be proportional. If hemoglobin is normal, RBC should be normal. If hemoglobin is low, RBC should be low. So this is one important thing I will look for. Next, of course, another somebody said reticount, don't look for reticount. Both of them will have reticount less than 3%. Very good. Somebody has written one more, Menzer index we check. Menzer index in IDA will be more than 14. In thal minor, it will be less than 12. Some books write more than 13, less than 13. That is all fine. Okay. More than 14 and less than 12. Anyway, this is it diagnostic? None of these are diagnostic. So if you are getting an abnormal Menzer index or what, hemoglobin and RBC are disproportionate, immediately do HPLC. That is the gold standard investigation. HPLC, major hemoglobin A2 level. Hemoglobin A2 is alpha to delta 2. Alpha to delta 2 is a hemoglobin A2. It should be between 3.5 to 9% in thal minor. Remember this also, I don't know, hemoglobin A2 more than 9% is considered as hemoglobin E. Both hemoglobin A2 and hemoglobin E have similar HPLC properties. That is the reason why hemoglobin A2 more than 9% will be considered as hemoglobin E. Okay, yeah. So if they are giving more than 9%, then it will be hemoglobin E. What is hemoglobin E? So all the hemoglobin, since we were talking about hemoglobin, variants hemoglobin. Okay, we'll come to that variant hemoglobin later when we are talking in hemoglobinopathies, right? 12 to 14 is normal? No, nothing normal. 12 to 14 is borderline. So some books write more than 13, less than 13. Most of the standard hematology books mention it as, less than 12 and more than 14. That is your idea. And so what is Menzer index, by the way? I forgot to write that only. MCV2 RBC count. That is your Menzer index. Ratio of MCV to RBC count is the Menzer index, right? Yes. So this is about your Sita and the iron deficiency anemia. Now, in IDA treatment wise, so important to note treatment in IDA. So treatment of IDA, what question they will ask you? Yeah, oral iron should be given. Oral iron is the treatment of choice into how many, in how long? 6 to 12 months, isn't it? That is very, very important. Oral iron, right? Yeah. Then what about injectable? Iron injections are also available. What all iron injections are available? Now expect this iron maltose. Iron maltose is single dose IV iron. Single dose IV iron for 1000 milligrams. So we get a single dose, we'll do in one infusion only, right? And we have, yeah, iron isomaltoside or ferric carboxy maltose. We are having iron injections. Okay. So now iron injections, importance about iron injection. Rate of response remains same. So rate of hemoglobin correction is same as oral iron. So that is the reason why, yeah. So if you want to get faster response giving iron deficiency injectable iron, no, that is not the case, right? So what are the indications of parenteral iron? Questions will come from this. Indications of parenteral iron. Indication of iron injection. 1. Malabsorption. We have to give iron when there is malabsorption. Second, GI intolerance. Patient is not able to tolerate oral iron. Gastritis is very common. Then third one is non-compliance. These are the only non-compliance. Severe IDA is not an indication for this itself with a question. Severe IDA is not an indication for parenteral iron, remember. So then what about one more? Blood transfusion in anemia. Blood transfusion in IDA. When you remember, when you do blood transfusion leads to immediate increase in hemoglobin, and when it leads to immediate increase in hemoglobin, it leads to decrease in erythropoietin. That is why this leads to bone marrow suppression. So remember, blood transfusion leads to bone marrow suppression, not bone marrow activation. That is the reason why blood transfusion should be avoided as much as possible in anemia. Yes, blood transfusion should be avoided. So indications of BT. What are the indications of blood transfusion here? Indications of blood transfusion is 1. Severe anemia. Severe anemia. So what is severe anemia? Hemoglobin less than 7, right? That is severe anemia. And another is emergency condition. So if there is immediate need of increase in hemoglobin, then you have to be giving what? Blood transfusion, right? That is your, yeah. So this is about your basic understanding of the IDA. Questions will keep coming. Last trimester is again emergency, right? So you want an immediate improvement in hemoglobin, right? Yeah. So severe anemia and emergency condition. Okay. Yeah. Next in IDA, important few more things. So in IDA, most sensitive test for IDA. Most sensitive test is serum ferritin. Most sensitive, and it is also the earliest test as well, isn't it? Earliest test. Most specific test for IDA. Most specific test for IDA, increase in serum, increase in serum TFR1. So decrease in serum ferritin, this is the earliest and most sensitive test for iron deficiency anemia. Okay. So serum ferritin is reduced, then what? It is definitely iron deficiency anemia, isn't it? That is what I mean to say. If serum ferritin is low, then it is definitely iron deficiency anemia. So remember, for iron overload, we don't use serum ferritin. For iron overload, we don't use serum ferritin. Okay. Yes. So this is about your, no, not TFR. TFR is not, most specific. Yeah, correct. Increase in TFR is the most specific test for iron deficiency anemia. Okay, so this is about this. Next, we'll talk about megaloblastic anemia. So important about megaloblastic anemia, megaloblastic causes. Megaloblastic causes are two important: B12 deficiency and B9. B9 is nothing but folate deficiency. B12 is cobalamin deficiency, right? Cobalamin. Now, so causes of B12 deficiency, or yeah, what will be the sources of B12? Source of B12 will be animal, meat, eggs, fish, milk, or dairy products. B12, B9, that is folate, comes from folium. Folium is what? Fresh fruits and vegetable. Folium means leaf actually. Fresh fruits, vegetables. That is your B9, isn't it? So stores last for 1 to 2 year in B12, around 3 to 4 months in folic acid, isn't it? 3 to 4 months in folic acid. Now, so important B12, okay, importance of this here, two questions can be coming, of course. One is, what is folate trap? So important to understand, in the serum we are having plasma folate will be in the form of methyl THF. Methyl tetrahydrofolate is there, and this methyl tetrahydrofolate, if it has to become into, yeah, so useful form of is THF. So tetrahydrofolate. For this conversion, yes, what should be happening for this conversion? You are having, yeah, homocysteine gets converted into methionine. Homocysteine to methionine conversion will be happening. And this requires vitamin B12. That is why B12 deficiency will lead to folate trap. What is folate trap? Folate trap will be presence of folate trap will be plasma will have folate, but if the patient is unable to utilize the folate, that is called as folate trap. That will happen in B12 deficiency. And remember, in B12 deficiency, the plasma folate levels will be high. That is why we should not measure folate level for diagnosis of a B12 or folic acid deficiency. Okay, yeah. Okay, methyl THF to THF is happening, right? So this is one. Next, one more thing you should remember about B12 is requirement of, okay, B12 is also required for what? B12 is also required for, yeah, methyl malonyl CoA. Methyl malonyl CoA gets converted to succinyl CoA. Right? So methyl malonyl CoA ultimately, okay, methyl malonyl CoA, propionyl CoA, then succinyl CoA ultimately. So this requires B12 again. This also requires B12. So B12 deficiency means methyl malonyl CoA accumulates in the neurons. Accumulates in neuron, that will lead to neuropathy. That is why neuropathy. So very, very important is in B12 deficiency, there will be, in addition to this, yeah, in addition to the anemia, there will be one neuropathy changes, right? Yeah, so important to differentiate. How do I differentiate? Okay, peripheral blood smear. What will be the peripheral blood smears finding? Macroovalocytes. Macroovalocyte and hypersegmented neutrophil. Hypersegmented neutrophils will be seen, right? Macroovalocytes, hypersegmented neutrophils will be seen, correct? Peripheral blood smear. Okay, then next is other investigations that we can do is increase in methyl malanoic acid. Increase in methyl malanoic acid, increase in homocysteine. Both of them are seen in B12 deficiency anemia. Increased FIGLU in urine. Increase in FIGLU is seen in B9 deficiency. Clinical features, yeah, clinical features. In addition to this, clinical feature, patient will have anemia, bald tongue, then as somebody said, neuropathy, SCAD, neuropathy. Initially there will be sensory, later on even motor can be involved. So then hyperpigmented knuckles, this will be seen. So neuropathy in B12 deficiency, hyperpigmented knuckles, also seen in B12 deficiency. Also seen in B12 deficiency. Yeah. So then one more we can do is a Schilling test. One more test we can do is Schilling test. So remember, Schilling test is done to what? Schilling's test is done to identify the etiology of B12 deficiency. So remember, it doesn't diagnose B12 deficiency. Identify the cause of etiology of B12 deficiency. That is what is Schilling test. Treatment of B12 deficiency. What will be the treatment for B12 deficiency anemia? So I will give IM B12, intramuscular B12 injections. That will be the treatment of choice. Okay. Yeah. So for folic acid deficiency, what is the treatment? For folic acid deficiency, we give oral folate and B12 also should be given. B12 only folate if it is given, then neuropathy will precipitate. Okay, yes, so neuropathy will precipitate. So I say B12 IM only unless we know the etiology. If we know the new etiology, if it is nutritional deficiency, then you can be giving oral. Otherwise, usually most common cause is malabsorption. That is why we give what yeah, IM B12 there, right? So that is what is your, next. One more here only I want to discuss. One more is aplastic anemia. So in aplastic anemias. In aplastic anemia, okay, diagnostic criteria for aplastic anemia. First, bone marrow cellularity should be less than 25%. So percentage of the cells in the bone marrow to fat should be less than 25%. So this bone marrow cellularity will be established on bone marrow biopsy. Investigation of choice is bone marrow biopsy, isn't it? Then aplastic anemia, we divide them into three types of aplastic anemia. So bone marrow cellularity will be what? Less than 25% in all of them. Now we divide them into three types of aplastic anemias. What are those three types of aplastic? Very severe aplastic, severe aplastic, and non-severe aplastic. Very severe, severe, and non-severe. Very severe aplastic, what will be there? In addition to bone marrow cellularity less than 25%, very severe will have, yes, what else will be there? Platelet count less than 20,000. Retic count, CRC, corrected retic count less than 1%. And third one, ANC less than 200. Absolute neutrophil count less than 200, right? So that is very severe. In severe, what will be there in severe? Severe will have platelet count less than 20,000, same. CRC less than 1%, correct? But ANC will be 200 to 500. That is your ANC. It is less, but it is 200 to 500. Okay, that is your Cabot rings will be like a ring. Howell Jolly body will be like a small pycnotic nucleus. Okay. Yeah. Non-severe. Non-severe is, yeah, non-severe doesn't have any one of these. So, you know, non-severe is not qualifying for severe. Simple. So, for severe, all should be there. Even for very severe also, all the following should be there. That is what is your severe, very severe and non-severe aplastic anemia. Causes of aplastic anemia. Most common cause of aplastic anemia is autoimmune condition. Autoimmunity is the most common cause, and mostly it is viral hepatitis which is causing. So autoimmune could be idiopathic or it could be viral hepatitis, chronic viral hepatitis, especially hepatitis B virus. Okay, so autoimmune cause. Then infectious causes. Infectious causes, do not confuse this. Infectious causes means the infection has to be happening. So hepatitis B is not an infectious cause. Hepatitis B is an immune mediated, right? Yeah. So infectious cause, parvovirus B19. Parvovirus B19 infection, especially it causes pure red cell aplasia, right? It causes pure red cell aplasia. So viral hepatitis, especially hepatitis B is, yeah. So what is the treatment? Treatment of aplastic anemia. Here only we'll finish it off. So treatment of aplastic anemia will be, first choice will be steroids. Why steroids are the first choice? Tell me now. Because cause is what? Immune mediated. Yeah, steroids. If not responding, definitely second line will be what? Allogenic hematopoietic stem cell transplant. Allogenic HSCT. That is the treatment for aplastic. Clear? Yeah. Next is hemoglobinopathies. So yeah, hemoglobinopathy is a very, very important topic. Hemoglobinopathy. So first let us understand what is hemoglobinopathy. First is, okay, what is HBS? HBS is GLU beta 6, VAL. What do you mean by this? GLU beta 6 VAL. So sixth amino acid in the beta globin. Again, don't get into all those people don't study from what do you call the Google and Chat GPT and I do not know what 6 7. No, it is still 6 only. Not 7. Amino acid is same. Okay, so HBC. What is HBC? HBC is GLU beta 6 LYS. Then next is HBE. HBE is GLU beta 26 LYS. LYS is lysine, by the way, isn't it? Yeah. In celiac, can we give B9 or B12 along with iron? So in celiac, there is a folate deficiency. So there will be folate deficiency. You should be giving B12 always along with folic acid. Okay. Next is HBH. What is HBH? Yeah. So HBH, hemoglobin H. What do you see in hemoglobin H? Hemoglobin H is beta tetramer. What is hemoglobin BART? Hemoglobin BART is gamma tetramer. Hemoglobin BART, gamma tetramer. Okay. No, I did not say. तो आप कहीं से पढ़ के आए हो बीटा 7 नहीं होता है, 6th अमाइनो एसिड ही होगा. Okay, gamma 4 tetramer. Okay, that is your hemoglobin BART. So these are the important different hemoglobinopathies, different hemoglobins that we know of, right? Yeah. So in sickle cell, so these are qualitative hemoglobinopathy. HBH and HB BART are what? Quantitative hemoglobinopathy. Yes, correct. HBH will show golf ball appearance. Golf ball appearance. In HBH, there will be golf ball appearance, not tennis ball, golf ball appearance. Yes, correct. So these are the different hemoglobinopathies that are there. Now, so treatment, I'm expecting this especially in exam for HBS, sickle cell anemia. So for sickle cell anemia, new therapy is available, gene therapy. Gene therapy, just remember the name. Gene therapy, 2 gene therapies are available now. One is LifeGenia. Yes, one is, so 2 gene therapies that are available. There are 2 gene therapies available. Okay, let me try to show you some images as well. So guys, I will be just showing these images from here and I will include them later on in your the PDF also. Okay, so don't worry. Yeah, so let me try to brush up your all images. So I'm using it from my workbook only so that okay, so let me quickly look all the images of RBC disorder. So this is your aplastic anemia, guys. Okay, megaloblastic anemia. What are you seeing in megaloblastic anemia? So hypersegmented neutrophils are seen, right? This is your megaloblastic anemia. Hypersegmented neutrophils are seen in megaloblastic anemia. And on bone marrow aspirate, you will be seeing large or giant megaloblasts. Large cells which are megaloblasts will be seen. So this is your megaloblast. Next is one more we need to know is sickle. Okay, before sickle, this is one more, clumping of RBCs. So you are seeing clumping of RBC, hemagglutination, that will be seen in AIHA. Sickle. So okay, this is hereditary spherocytosis. Central pallor will be there and osmotic fragility curve. Okay, this also can come as a question. Osmotic fragility curve I'll write that as well. Okay, subsequently 2 important questions can come from there. Then sickle, already I've shown sickle images. Okay, this is your sickle. In sickle cell anemia, you'll see sickle cells as well as target cell. Sickle cell and target cell. So treatment of sickle, I told you 2 important new live gene therapy available, Casgevy and LifeGenia. Don't get into details of what is Casgevy and what is LifeGenia there. Not required. Maybe LifeGenia. Okay, another one you have not written, Casgevy. So this one are available. Now osmotic fragility test. So important about osmotic fragility test here. Osmotic fragility test. So OFT, what is the sample that we use in OFT? Heparin. Heparin is the sample in OFT. Okay. So in OFT, remember spherocytes and elliptocytes. Elliptocytes are osmotically more fragile. So we can just write they are more fragile. Obviously in the test we are testing what? Osmotically. Whereas your sickle cell anemia and thalassemia are osmotically less fragile as compared to normal. So remember, but all of them are mechanically more fragile. Mechanically all of them are more fragile. That's why they are getting killed in the spleen, isn't it? They are getting killed in the spleen. Okay. Yeah. So heparin, green colored vacutainer. Correct. That is what we will be using it, right? So they are spherocytes, elliptocytes, sickle cell, thalassemia. So thalassemia, all of these conditions are what? Yeah. All will be mechanically more fragile. They are all mechanically more fragile. Okay. Yes. Next is, yeah, let me talk about, next we'll move on to another important hematology topic, WBC disorders. So in WBC disorders, one is your, yeah, WBC disorders. In WBC disorder, first is marker. Most important is this only, marker and treatment. Two things they will be asking you. Marker approach, okay, approach to marker. Okay, first check for CD3, CD20, two important markers. CD3 positive will be B cell, CD20 positive will be T cell. Okay, let me write CD20 positive B cell, CD3 positive T cell. This will be T cell. So if CD3 positive, check for TDT, CD34 and CD10. Positive, negative. Positive means precursor T cell. So diagnosis will be TALL. Only one condition, precursor T cell will be TALL, right? Yeah. So negative means peripheral T cell. Peripheral T cell neoplasm. Peripheral T cell neoplasm. Now CD20 positive. Yeah, CD20 positive. Then what? So once it is CD20 positive, check for CD5. CD5, if you remember, is a marker for pre-germinal center. Pre-germinal center marker. Check for CD5. Two possibilities with CD5. CD5 positive or CD5 negative, isn't it? CD5 positive means it is pre-germinal. Yeah, CD5 positive means pre-germinal. Okay, if it is CD5 positive, check for CD23. 23 could be positive or negative. So if 23 is positive, then what? BCLL, SLL. 23 is negative, then it is what? Mantle cell lymphoma. 23 negative, mantle cell lymphoma. So you can also check one more, cyclin D1, even FMC7, cyclin D1 positive or negative. Positive is mantle cell lymphoma. Negative is also mantle cell lymphoma, but this will be called cyclin D1 negative mantle cell lymphoma. And marker for cyclin D1 negative mantle cell lymphoma is SOX11. We do SOX11. That is a marker for cyclin D1 negative mantle cell lymphoma. So this is your CD5, yes, based on 5 and 20. So two important markers we studied, 5, 23. Now 5 is a negative. Then what? It is not a pre-germinal. 5 is negative, it is not a pre-germinal. Then immediately check CD10. CD10 is a marker for precursor and germinal marker. It is positive in both precursor and in germinal, CD10. So two possibilities with CD10, CD10 negative or CD10 positive. So CD10 negative means it is not a precursor, not a germinal. It is already not a pre-germinal. Why? Because CD5 is negative. So this is post-germinal. Post-germinal. Which are the examples for post-germinal? Marginal zone lymphoma, maltomas, and hairy cell leukemia. Important post-germinal, right? Next. CD10 positive, that means either it is a precursor or it is a germinal, isn't it? Yeah, so CD10 positive, then either it is a precursor or it is a germinal. Then I will check for CD34, TDT and BCL6. CD34, TDT, BCL6. So what could be the possibilities here? Okay, so CD10, 10 is already there, sorry, 10 is positive, CD34 positive, TDT positive, BCL6 negative, or the other way around, BCL6 positive, TDT negative, 34 negative. So the first one, TDT positive, 34 positive, BCL6 negative. This will be your what? Precursor neoplasm. Precursor, and answer only one, BALL is the answer. See, BCL6 positive, this will be germinal origin. Now once it is germinal origin, I will check for Ki67 index. Ki67 index. Ki67 index low or high. If it is low, follicular lymphoma. If it is high, check how high it is. More than 95% or less than 95%. Usually when I say high, it will be usually 80% plus. So if it is more than 95%, then what is your diagnosis? More than 95%, then this is Burkitt lymphoma. Less than 95%, DLBCL. Follicular will also be BCL2 positive. Follicular will be BCL2 positive as well. So this is your approach to the markers. This is the approach to the markers. Now, next is flow cytometry interpretation. So how do I interpret flow cytometry? So in flow cytometry, okay, really it is more of a NEET PG INICET question, but anyway, we will discuss that as well here. So in a flow cytometry, you will end up getting a curve like this. So remember, focus on these two lines that will be there. So this will serve you as the guidelines, isn't it? So look at this. This is how it will be there. Usually 10 raised to 1, 10 raised to 2 like that. So there will be 10 raised to 1, 10 raised to 2 like that. It will be given, right? So now when we are looking, each dot will be representing one cell. So whatever is a marker here, so marker 1, I'll write marker 1 on y-axis and marker 2 on, marker 1 is on x-axis, marker 2 is on y-axis, right? Slide marker is done already. Okay, so marker 1, marker 2. Marker plot is important for us. Okay, in marker plot, wherever dots are there, let me look at these dots. Okay, let me try to explain you. Okay, right of this line will be positive, left of this line will be considered negative for whatever marker is there. Similarly, above this line will be considered positive, below this line will be considered as negative for the marker 2. So in this, the red dots that I have shown, this is both 1 positive and 2 positive. Both of them are positive here, whatever is a marker given to us, right? So this is what is your marker 1, marker 2. Okay. So in flow cytometry, they will be giving you marker plot 1. Then another is a scatter plot. So another will be scatter plot. So scatter plot again. So marker 1, marker 2, you will be knowing now. So whatever marker they are going to give you based on that. Another will be a scatter plot. So in scatter plot, they will be plotting FSC forward scatter and SSC side scatter. So remember, forward scatter tells you the size of the cell and side scatter tells you the granules in the cytoplasm, or you can just write granules that are seen, right? So forward scatter and side scatter are taught, right? So forward scatter, look at this. This is your low forward scatter, low side scatter. What do you mean by low forward scatter, low side scatter here? So yeah, that means these are small cells without any cytoplasm. There is another group of cell which will be slightly larger cell but slightly larger side scatter also. There is another group of cell which can be like this. Look at this here. So yeah, and here. So can you identify these group of cells? So group 1, 2, 3, 4. Let me label 1, 2, 3 and 4. Tell me now. So there are 4 groups. I told you side scatter and forward scatter. Okay, tell me now which are blasts in this? Which are blasts? Yeah. So which are blasts in this? Forward scatter, side scatter. Which are the blasts in this? 3 and 4 are blasts. 3 will be myeloid blasts, AML blasts most likely, and 4 will be ALL blasts. Why? Because their side scatter is low, isn't it? Yeah. 1 is lymphocyte, 2 is a neutrophil most likely. 1 is lymphocytes, mature lymphocyte, and 2 will be mostly granulocytes. 3 will be AML, 4 will be blast, ALL blast, AML blast and ALL blast, right? So that is one. So forward scatter, side scatter. Now, next is important. One more is the treatment of different neoplasms. Treatment of different neoplasm, treatment of Hodgkin lymphoma, treatment of non-Hodgkin lymphoma. Tell me, treatment of Hodgkin is what? ABVD regimen. Non-Hodgkin, R-CHOP regimen. ABVD will be what? Adriamycin. Adriamycin. Bleomycin. Vin. Blastin. Dacarbazine. R-CHOP regimen. What will be the R-CHOP regimen? R is rituximab, cyclophosphamide, hydroxydonorubicin, oncovin, prednisone. R-CHOP regimen, right? So we use this R-CHOP regimen in non-Hodgkin lymphoma. Now, few other treatment also. Let us talk about, what will be the treatment for BCLL? What will be the treatment for hairy cell leukemia? What is the treatment for ALL? What is the treatment for multiple myeloma? All of them we are talking. So BCLL treatment, asymptomatic, wait and watch. Asymptomatic, wait and watch. Symptomatic, then symptomatic, ibrutinib. Hairy cell leukemia also asymptomatic, wait and watch. Symptomatic, we give cladribine and dabrafenib. If no response, we can add rituximab. If no response, we can be adding rituximab subsequently. Treatment of ALL. What will be the treatment of ALL? Treatment of ALL, childhood onset ALL. It will be LOP regimen. What is LOP? L-asparginase, oncovin, prednisone. Adult onset AL, very rarely adult onset ALL, CAR T-cell therapy. Just remember the name, CAR T-cell therapy. Chimeric antigen receptor T-cell therapy. Multiple myeloma. What is the treatment for multiple myeloma? Multiple myeloma treatment will be BLD regimen. So chemo will be BLD, bortezomib, lenalidomide, dexamethasone. Lenalidomide, dexamethasone. That will be the BLD regimen for multiple myeloma. Of course, one more is allogenic bone marrow transplant. That is curative treatment. So, allogenic hematopoietic stem cell transplant. That is a curative treatment. Next, acute APL, acute promyelocytic leukemia or AML M3 we call it. Treatment, all trans retinoic acid. All trans retinoic acid is a treatment for acute promyelocytic leukemia. Right? Yeah. Next is one more, how to approach blasts. So, okay, leukemia approach. How do I approach a case of leukemia? Leukemia, check for the cells. Cells are large cells, morphology obviously, or small. When I say large, usually more than 3 times the size of RBC. So it can be both morphologically when we are looking at it, or small. Small will be less than 3 times the size of RBC. So 2 to 3 times the size of RBC, smaller than that. So if they are small, then they are what? Peripheral cells or mature cells. So this will be chronic leukemia. Chronic leukemia. If they are large, then they are what? Blasts. That means they are what? Acute leukemias. Acute leukemias. Now, so once I know, if they are blasts, then what? Check for granules in the cytoplasm. Granules, present, absent. Present myeloid, absent lymphoid. Okay, so even in this also, granules, look for granules present or absent. Again, present myeloid, absent lymphoid. Okay, so usually in general for myeloid neoplasm, for myeloid leukemia, we will do FISH PCR. Further subtyping based on FISH PCR. For lymphoid leukemia, we do flow cytometry, CD markers. Basically, we do flow cytometry for CD markers, right? So that is what we are going to look for. Now, so let me try to show you some images as well so that we will look at them. Okay, guys. So here I am just showing you images in the beginning. I will add these images for you guys. So I'm using it from my regular class notes only. I'm showing you images, few images of. Yeah. So what are you seeing here? This is your starry sky appearance of Burkitt lymphoma. Burkitt lymphoma, starry sky appearance, and also on the right hand side you are seeing vacuoles, perinuclear vacuoles that are seen in Burkitt blast, right? Yes. So this is your Burkitt lymphoma. Then next is, okay, this is a classical Hodgkin lymphoma, diagnostic RSLs are there, and on the top this is your collagen nodule you are seeing, and also you are seeing lacunar RSL. So you are also seeing this is a lacunar RSL, this is a collagen nodule, and this is the diagnostic RSL that you are seeing. Next, smudge cells. These are smudge cells that are seen, and this is the image of flow cytometry. Can you interpret? This is CD5, CD23. What about this group? This group is positive for both 5 and 23. 5 and 23 means what? CLL, right? Yeah. So look at this now. This is your hairy cell leukemia, fried egg appearance on bone marrow biopsy. Peripheral blood smear can show hair-like projections. Next, so look at these, identify these now. Look at the cell, compare with the RBC. Is it a mature cell or immature? Immature. Why? Because size is very, very large. Look, this is your 1 RBC. Let me just try to compare. This much will be your 1 RBC. This is your 2 RBC. Probably 3 and 4 size of RBCs are there. These are blast. Next, granular abundant cytoplasm or scant and agranular cytoplasm. Scant and agranular lymphoblast. These are your lymphoblast. And try to interpret this now. Can you interpret this CD marker? CD10 is given, 19 is given. Both are positive here, right? CD19 and CD10 positive, and CD22 and TDT, most of the cells are 10 and 22 also positive, isn't it? Yes. So this is your CD mark flow cytometry of ALL, right? Yes. One more is expect this electrophoresis interpretation. So when they give you electrophoresis interpretation for multiple myeloma, look for kappa and lambda. Look, kappa and lambda both are positive. It is polyclonal, non-neoplastic. If it is a neoplastic, only one will be positive, and it will be a very thick band like this, kappa or lambda. Here kappa is positive, that's why monoclonal. Identification of monoclonal in multiple myeloma. And of course, bone marrow aspirate will show plasma cell and rouleau formation are seen, right? And yeah, let us look at the blast now. Look at this. This is also blast. Compare the size, very, very large, and abundant cytoplasm, and I'm seeing OR rod here. So it is a M2 blast, AML with maturation. Whereas promyelocytic leukemia, multiple OR rod and nuclear indentation can be seen. In this, multiple OR rods are seen. That is called faggot cell, right? And this is your megakaryoblast. Megakaryoblast will have a blebs on the cytoplasmic blebs will be seen on megakaryoblast, right? Yes. So these are your important images. I have tried to what incorporate all the images as well. Okay. So don't worry too much. Don't overthink too much. Keep it very simple, guys. So the simplest and the best way to get good marks is keep simple. Do not overthink too much. Okay. And yes, I have taken RBC, WBC. These are two important topics. I am expecting a lot of questions coming from RBC and WBC. Usually for NEET PG, transfusion medicine and bleeding disorders are less important topic. They are more important for INICET. Okay. Yes, guys. So best wishes all of you. So you'll be having next teacher now coming to you guys. Best wishes all of you. So I have tried to, OR rods are made up of granules only. Okay. Yes. Blood transfusion reaction, as I said, less important for NEET PG, but anyway, it is not less. I mean, in the sense, I could only cover in such a short time only this much. Yes. Transfusion medicine, of course, you can read it from the notes. Okay. Okay, guys. Goodbye. Best wishes, all of you. Thank you. Thank you for your all love that you're all showing me. Thank you, guys.
Okay, good afternoon, everyone. I guess I'm connected. Can you hear me? Everything fine? Shall we start? I guess all good. Shall we start? Right. So you see, we are going to have a half an hour session, and I have made a PPT for you so that I don't have to write because of my writing, which is extraordinary, and because it will take less time. So I will just go through them quickly. So I have to show more than 100 slides to you in half an hour, and it's just a revision. So I guess we can go fast without any problem. So I'll just revise some of the important topics. Like in esophagus, I have chosen 3 topics which I consider important: Zenker, achalasia, and last Sunday we have a question on Plummer-Vinson syndrome. So that's one. So let's see. What is Zenker diverticulum? As you know, it's a protrusion through Killian adjacents, which is a triangular weak area between thyro and cricopharyngeus. So here, and this is called Killian's dehiscence, and a backward protrusion is called Zenker diverticulum due to non-relaxation of cricopharyngeus muscle. Seen in old males, presents with regurgitation, halitosis, dysphagia. And barium is the investigation. You can see lateral view of barium. This is very important. They do ask this MCQ and this photo. Diverticulectomy and cricomyotomy is the treatment. New treatment, Dolman's procedure. It's a false pulsion diverticulum. Okay? Nothing special, nothing new. You all know this. It's just a quick revision. Now, achalasia cardia, very important topic, bird beak sign. Due to absence of inhibitory orbital plexus, also called mandatory plexus, present in muscle. No absence of Meissner's. Meissner's, that is submucosal plexus, are not involved here. Secondary achalasia due to Chagas disease, and pseudoachalasia due to cancer, mainly cardia, lung, and pancreas. Young age, slightly more common female. Important point, dysphagia starts with liquid. This is a very important point, not solid. Later on solid. And increased risk of squamous cell cancer. We are discussing surgery, squamous cell cancer. And in the dilated part, disease part is this, but cancer seen in dilated part. Okay? I don't think it's stuck. I think it's okay. You can go back and rejoin. Is it stuck? At my end, it's okay. Some of you are writing stuck, some are writing okay. So, can anyone tell me what's the problem? I mean, at my end, it's okay. I can see live streaming. All okay, na? Okay. I'll continue because I have to run fast. Just go back and rejoin. Okay. So, X-ray shows bird beak sign, rat tail sign, manometry is gold standard. Chicago classification is used here, and Heller's myotomy with partial fundoplication and POEM, per oral endosomyotomy, is a new treatment. And this is the Heller's myotomy where you only cut the muscle, leave the mucosa intact. This is bird beak sign. This is rat tail sign. This is sigmoid esophagus. All 3 are signs of barium, signs of achalasia. And this is the corkscrew appearance. Very, very commonly asked X-ray corkscrew appearance seen in DES. Okay. Now, Plummer-Vinson was asked last Sunday in FMGE, just 2 days back. So, it has iron deficiency anemia, esophageal web and dysphagia. So you can see the nail, koilonychia, glossitis, chelosis, web and microcephaly anemia. This is Plummer-Vinson syndrome. Not a very important topic, but it is asked sometimes. Like this Sunday it was asked. So this is a endoscopic view. It's a asymmetrical web, which is why elliptical, and this is a barium swallow view. So Plummer-Vinson is asymmetrical mucosal web, post-cricoid, associated with iron deficiency anemia, peri-postmenopausal female, can cause siderobenic dysphagia, mild cancer risk, squamous cell cancer risk is there, and barium swallow is investigation of choice. Dilatation by balloon is the treatment, or bougie is the treatment. So they can show you the X-ray as well as the endoscopic image. Whenever the dysphagia in neck and iron deficiency anemia, this is Plummer-Vinson syndrome. Now, CHPS is exceptionally important topic, congenital hypertrophic peristalsis. Esophageal web or Plummer-Vinson layer doesn't need surgery. The treatment is balloon dilatation. So it's an intervention, not a surgery. Yeah. So more common in male, firstborn male child. Projectile non-bilious vomiting between 2 to 8 weeks. Olive-shaped lump in the epigastrium, which is prominent pylorus. Basically seen after meal. Don't palpate empty stomach. Ask the mother to feed the child. Then when mother feeds or child has vomiting, then you see this. Circular muscle hypertrophy, right to left peristalsis. IOC ultrasound. This image is important. Please remember, asked last year. This is the hypertrophic pylorus. This is the empty stomach. Length of pylorus 16 millimeter, thickness 4 millimeter, and target sign, antral nipple sign, cervix sign are the three main signs. If you look carefully, you can see it looks like cervix, and this projection is called antral nipple sign. In barium, this becomes the shoulder sign. This becomes the diamond sign. That's in barium, not in ultrasound. So in barium, we have these signs. String sign, this is the string sign, and this is the mushroom sign. I'm going fast because we have less time, and already we have discussed this many times. I mean, grand test and regular everywhere in revision. Caterpillar sign, shoulder sign, double track sign, all these signs you get in barium. This is a single bubble sign, a important sign for your exam. This they do ask. X-ray. Electrolyte abnormality, hypochloremic, hypokalemic alkalosis with paradoxical aciduria, and resuscitation should be done before surgery. Any gastric outlet obstruction, normal saline is the fluid of choice, but in adult also, but in neonate we give N/2 saline, 0.45 normal saline with potassium and 5% dextrose, and potassium is only added when the child has passed urine. Ringer lactate can be given, but it will increase the risk of alkalosis. Treatment is first, it is a non-surgical emergency, so never ever advise surgery directly. Correct the dehydration. When the urine output is more than 1 ml per kg per hour, only then you operate, and you do Ramstead pyloromyotomy. Not pyloroplasty, it's pyloromyotomy. Now, GIST, another important tumor. GIST arises from interstitial cell of Kajal, or Kahal, whatever you say. These are GI pacemaker. Most common site stomach, around 50%, then ileum. Most are positive for CD117, DOJ1 and CD34. Main are these two. CD34 you can remove. Most common presentation of hematopoiesis. Tendency for bloodborne secondaries and direct. This is important, node negative. Adenocarcinoma and squamous cell, first they go to lymph node, then bloodborne, but here directly bloodborne without node. Remember, it's a part of MCQ. They don't go to lymph node. Only 5% lymph node involvement. Most are c-KIT positive, some are PD alpha positive. Two types, this is the histological type, spindle cell 70% MCQ. Malignant potential is decided by Fletcher criteria, which includes size and mitotic index. More than 5 cm and 5 mitotic index more than per 50 hyperfield is cancer. IOC CT scan for recurrent GIST PET scan, and for biopsy, EUS guided biopsy, and GIST will be found in layer 4 and 2. Layer 4 is Muscaris propria, toe is muscularis mucosae. Treatment is surgical resection. 1 centimeter margin is adequate and node need not be removed because they don't go to lymph node. Imatinib is the drug of choice. Where do you give this? Only CK positive just. 400 milligram per day is the dose. Sunitinib is for imatinib resistant cases, and this is something new. At some places I tell this, some places I don't tell. So ये भी याद रख लो कि torricelli bernoulli sign is not important, not needed. जिसके अंदर air trapped होती है inside, just you find air in CT scan, that's called torricelli bernoulli sign. This actually I started teaching 3 years back. Then I realized not needed. But because I started teaching, others also started telling them, but it's not needed. Avapritinib is a new drug for PDGA positive. This is something new, unlikely to come in exam, but still you remember. And SDA succinyl dehydrogenase positive has better response. Okay. Mitotic index and tumor size are the main prognostic indicators. And this can cause hypothyroidism called consumptive hypothyroidism. This is a double bubble sign of duodenal atresia. Congenital obstruction duodenum, this is the most common GI atresia. Presents with bilious vomiting but obstruction distal to ampulla vata, but in 10% it can be non-bilious. Okay, 10% may non-bilious bhi ho sakta hai because the obstruction may extend above the ampulla vata. And it's common in Down syndrome and polyhydramnios, found in 50%. X-ray double bubble sign, treatment duodenoscopy. Kimura is optional. याद रखो ठीक है, नहीं याद रखो कोई बात नहीं. Nobody will ask name. Only remember duodenoscopy. These are two double bubble signs: supine view and this is the erect view. Air fluid level. Single bubble sign, gastric outlet obstruction, double bubble duodenal, triple bubble jejunal. All three you need to remember. Now, cholangiocarcinoma, a very important topic. Last 2-3 years, I am frequently seeing that this being asked. Etiology: all cysts of liver. Caroli's disease, Kodakel cyst, pulsary liver disease. Von Meyenberg complex is called biliary hamartoma. This is called biliary hamartoma in liver. What happens at bile duct forms a bunch, they do not communicate with the hepatocytes. Biliary hamartoma. Better I delete this, my writing is not legible. Parasitic infection, clonorchis. Remember these two. This was a question of 2023 NEET. Ki fish, clonorchis cancers, fishworm causes which cancer of GIT? They cause gallbladder cancer as well as Chinese liver fluke and Opisthochus. Gallstone can also cause primary sclerosing cholangitis, and ulcerative colitis can cause, and primary sclerosis is another risk factor. Toxics not important, ये छोड़ दो, इस part को याद नहीं रखना है. Drugs छोड़ दो, ये याद नहीं रखना है. Yeah, typhoid carrier can cause, ये याद रखना है. This you remember. What's the treatment? TIS carcinoma in situ, T1A lamina propria. This you delete. Only treated by cholecystectomy. No role of port site excision. ध्यान रखना, port site excision now we don't order. From the port from where the gallbladder has been removed, it's only removed for the staging purpose. It has no prognostic role. So TIS, T1 treated by only cholecystectomy, T1A. T1B, that's a muscle involvement. T2 serosa and outside is treated by radical, also called extended cholecystectomy. You remove liver, either ridge of liver 1 centimeter or segment 5 and 4B, depending on the invasion, N1, N2, N3 lymph node, and complete lesser omentum. This is what you remove, radical cholecystectomy. So that's done for T1B muscle, T2 serosa, and T3 outside, or one organ involved. Now, post cholecystectomy leak, what's the approach? First thing, put a ultrasound guided drain. What to remember? I'll repeat what to remember. In gallbladder cancer, I presume you are saying, I presume only melody, you mean gallbladder cancer, what to remember? मैं बता रहा हूं, देखिए आपको, this is the mucosa TIS and lamina propria T1A, only cholecystectomy, no port site excision. T1B muscle, T2 serosa and outside or one organ involvement, extended cholecystectomy. If you remember these two lines, आपके ज़्यादातर MCQ इससे हो जाएंगे. In post cholecystectomy leak, just put a drain or drain already placed, observe for 1 to 2 days. Then if the leak is, and then order ERCP. If the leak is only from cystic duct, stenting will suffice. Just CBD stenting you do if the leak from cystic stump. But if the CBD has been transected or cut, C, less than 50% injury, repair over T-tube, more than 50%, see the gap transected, less than 1 centimeter, you can do anastomosis, more than 1 centimeter, Roux-en-Y hepatocogenostomy. Pigtail is not placed in CBD, pigtail is placed either in liver abscess or in ureter, the double J stent. CBD का pigtail stent नहीं कहलाता है, हाँ, pigtail catheter, okay. In the collection, you can definitely put a normal drain or a pigtail catheter. There you can put a pigtail, no problem. Yeah, correct. So, but stent is not pigtail. So, if the gap is less, then go for CBD anastomosis. If the gap is more, do Roux-en-Y. But if you are doing CBD anastomosis, remember the risk of stricture is high. So, this is the best treatment. Now, X-rays, this is the X-ray air below diaphragm. At this moment, I am sure all of you can identify this. Hollow viscous perforation, air below diaphragm. Next step, IV fluid treatment, laparotomy. 2 more X-rays, air below diaphragm. And these 2 signs you remember, 2 signs of pneumoperitoneum, regular sign where you can see air, you can see bowel wall. If bowel wall is visible, this is called regular sign. And when you see air on the left lobe of liver connecting both the diaphragm, this is cupola sign. Both these are signs of pneumoperitoneum. Of course, the most important sign is air below diaphragm, but these 2 signs I want you to remember. Regular sign and cupola sign, both are signs of pneumoperitoneum. And how you close duodenal perforation? Omental patch repair. How you close ileal perforation? Transverse closure without omentum, just transverse closure. Regular triad is a gallstone ileus characterized by stone in ileum here, dilated bowel showing obstruction and pneumobulia, air in the biliary tree. So, regular sign and regular triad are different. Regular sign you get in pneumoperitoneum, regular triad you get in gallstone ileus. And this is a X-ray of multiple air fluid level suggesting intestinal obstruction. Another very important X-ray for your exam. Close sign intussusception, I am sure all of you know. Target sign intussusception on ultrasound and CT. This I tell you will become MCQ in future. A young 9-month-old child having red currant, jelly stool or sausage ileum, and they will show this ultrasound and ask the diagnosis. And this is a barium meal follow through of Mickels, intraoperative picture of Mickels, and technetium picture of Mickels. Sigmoid volvulus coffee bean sign. Very important sign for your exam. Sawtooth appearance, diverticulosis, mainly seen in old person, mainly seen in left colon. Fistula in NO. This photo they very often give a small opening by the side of funnel work with minimal pus discharge. They gave this. So, due to rupture of perianal abscess, there is minimal pus discharge divided into low and high type by anorectal ring. And MRI fistulogram is IOC. For low type, we do fistulotomy. For high type, we do CTON. So, fistula and NO photo also you have to identify. 2 things you remember. 1, the photo. 2nd, IOC, MR. These 2 they ask. Gallbladder, polyp and stone. How to differentiate? Stone will have acoustic shadow, polyp do not have acoustic shadow, and if the size is more than 1 centimeter, then surgery should be done. All polyp more than 1 centimeter have risk of cancer, they need surgery. Less than 1 centimeter, conservative. And this is a MRCP showing gallstone and CBD stone. Gallstone, the investigation of choice is ultrasound. For CBD, investigation is MRCP. What's the approach? Whenever patient comes with right upper abdominal pain, order LFT and ultrasound. Ultrasound showing only gallstone, operate. But if the ultrasound is showing either dilated CBD like more than 8 millimeter or LFT showing obstructive jaundice, always go for MRCP. Obstructive jaundice means high alkaline phosphatase and high GGT. and direct bilirubin more, direct bilirubin, conjugated more. So whenever you have these findings, don't do cholecystectomy, order MRCP, and in case you have a stone in CBD, do ERCP and then do gallbladder. If I give you this image and ask what you'll do, you will say first I'll do ERCP, clear the CBD, then I'll do this is first and this is second cholecystectomy. So LFT and ultrasound should be normal in regard CBD, only then go for cholecystectomy. Ultrasound showing dilated CBD, LFT showing obstructive jaundice, always order MRCP, then decide if MRCP showing stone, go for ERCP and then cholecystectomy. This is choledochal cyst, MRCP, another asymptomatic gallstone, only more than 3 centimeters should be removed. So this is a ERCP of choledochal cyst, and this is Tudani classification they do ask. 1 is more than 80% cystic dilatation, 2 is a diverticulum, 3 is a choledochal seal, 4 is intra and extrahepatic, both 4A, only extrahepatic 4B, only intrahepatic 5. This is called Caroli's disease. Type 1 is treated by Roux-en-Y hepatocytostomy after excision like this. Never ever drain this cyst into the duodenum. That has a very high risk of cholangitis as well as risk of cancer. So internal drainage of cyst is not done. It should be excised and Roux-en-Y hepatocytostomy should be done. Okay, and this is central dot sign of Caroli disease. This is a question. Central dot sign. Fine. Then you see this is a Nissen's fundoplication 360-degree posterior wrap. ये आपसे last year पूछा गया था NEET में. Now, bariatric surgery, I just want to remember 4 figures. This is sleeve gastrectomy. Stomach is converted into a banana shaped structure like 32 French tube. And expected weight loss 50 to 60% above 40 BMI, size of C32. This is the most commonly done surgery, reduces ghrelin also, main side effect GERD. This is Roux-en-Y gastric bypass. You can see the stomach has been converted into a small pouch and Roux-en-Y bypass. This is restrictive and malabsorptive both. Weight loss 60%. Length of roux limb. This is the roux limb. This red line is the roux limb. Length of roux limb 100 to 150 centimeter. Caroli's is this. Bache, Ujjwal. Caroli's is this. Intrahepatic. ये है Caroli's. ये. Type 5. Only intrahepatic. And this is the CT finding of Caroli. Central dot sign. Okay? Yeah. So coming back to bariatric. This is the most accepted bariatric surgery and main side effect Peterson hernia, which is behind the roux limb. And these 3 surgeries, Roux-en-Y, first is Roux-en-Y gastric bypass where the stomach is preserved. Second is bilio-pancreatic diversion where distal gastrectomy is done with Roux-en-Y. Third is duodenal switch where sleeve gastrectomy is done with Roux-en-Y. So if you have sleeve gastrectomy and Roux-en-Y, that is duodenal switch. If you have distal gastrectomy and Roux-en-Y, that is BPD, and if you have no gastrectomy and Roux-en-Y, that is Roux-en-Y gastric bypass. And this is a SARDI-S where sleeve gastrectomy is done but no Roux-en-Y. The loop is taken and loop is anastomosis, and from where you have cut is duodenum, not stomach, it's first part duodenum. So here you don't make Roux-en-Y, you simply take the loop up, anastomosis, first part duodenum. Another point, the roux limb is the common channel is quite long here, 250 centimeter, unlike duodenal switch where the common channel is only 100 centimeter and in BPD only 50 centimeter. So malabsorption problem you get less in SARDS and you only do single anastomosis. ये नाभि में लिखा हुआ single anastomosis. And side by side to make you understand the difference, if sleeve gastrectomy without Roux-en-Y, this is SARDS, and sleeve gastrectomy with Roux-en-Y, this is duodenal switch. Another difference, the common channel 100 centimeter, here common channel 250 centimeter. Coming to hernia, This triangle, vas deferens, testicular artery and peritoneum, is called triangle of doom. Medially vas deferens, laterally testicular artery and inferiorly peritoneum covering the vas. This is called triangle of doom, and you have external iliac artery and vein, you can see here, and genital branch of genitofemoral nerve. So, medially vas deferens, laterally testicular artery, inferiorly peritoneum, having external iliac artery and vein and genital branch of genitofemoral nerve. Triangle of pain, iliopubic tract, peritoneum and testicular artery. We can draw it here. This is the triangle of pain, testicular artery, peritoneum and iliopubic tract. This is triangle of pain. The content are lateral cutaneous nerve of thigh, most commonly injured nerve, which is a 2023 NEET question. Most commonly injured nerve in lap surgery, lateral cutaneous nerve of thigh. Anterior cutaneous nerve, femoral branch of genitofemoral nerve and femoral nerve. These are the content of triangle of pain. And this is myoperitoneal reference of for short. This is the area we reinforce, we strengthen in lap surgery. Medial boundary is rectus. Medial boundary is rectus. Superior boundary conjoint tendon. Lateral boundary psoas and inferior boundary pectineal ligament covering the pubic bone. This also they do ask. These points you remember. Most common hernia, whether male or female, is indirect inguinal hernia. Deep ring is a defect in fascia transversalis. Femoral hernia is 4 times more common in female, but still in female also, most common hernia is indirect inguinal hernia, and femoral has highest risk of obstruction. Sac of inguinal hernia is above and lateral to tubercle, femoral below and lateral, which is a question also. And most commonly nerve injured are in appendix surgery, iliohypogastric nerve, in hernia surgery, ilioinguinal nerve, in lap hernia surgery, lateral nerve thigh, and in mesh entrapment, iliohypogastric nerve. All 4 nerves you remember, this is frequently asked. Now, this is EH classification, European Hernia Society classification for ventral hernia, 3 cm below xiphoid, 3 cm above umbilicus, 3 cm below umbilicus, 3 cm above pubic bone. You have 5 zones, subxiphoid, epigastric, umbilical, infraumbilical and suprapubic. अब आप 2 लाइनें याद रखेंगे. Umbilical hernia comes in M3. Remember, this is MCQ. And on either side of umbilicus, 3 cm is umbilical hernia. Umbilical, paraumbilical are different. I'll show the image. Photo exam में आती है. लेकिन in EHS both are in M3. See, this is the umbilical hernia where the umbilical is everted, protruded. This is called Mayo operation. ये भी याद रखना है. Mayo operation is for umbilical hernia, and this is paraumbilical hernia. You have to identify. You have to differentiate between umbilical and paraumbilical. In paraumbilical, a slit-like umbilicus is seen, like a slit with protrusion by the side of umbilicus. Bagal se aata hai. I'll magnify it for you so that you understand. Here the umbilicus is not everted. Here, umbilicus is here. It's by the side of umbilicus. And here it is, umbilicus is everted. Both are different. Both come under M3 in EHS. Going through urology quickly. It'll take 10 to 15 minutes maximum. Potter's syndrome is congenital renal agenesis causing severe oligohydramnios. The amniotic fluid is formed by the urine. Renal agenesis, no urine, no amniotic fluid, oligohydramnios, and the uterus presses the fetus. So, Potter triad is characterized by oligohydramnios causing pulmonary hypoplasia, limb deformity in Potter face. Flat face, compressed by the uterus. Flat nose, beak-like nose, flat chin, epicanthic fold. So, Potter face, pulmonary hypoplasia, limb deformity, this is called Potter triad. A triad of renal agenesis due to oligohydramnios. Then, Wig law, which says when there are 2 ureter, they always cross. Upper moiety consisting of 1/3 kidney, lower moiety 2/3, they always cross. The upper will always open inferomedially, and this will have a ureterocele, and lower moiety will always open superolaterally. This will have VUR. Is it stuck? Oh, क्या नहीं हुआ है? अच्छा अच्छा अच्छा, वो करना पड़ेगा। अच्छा नहीं, स्टॉप। ठीक है, आया। अरे मैं यूनिट कुछ और लिखा हुआ है, कुछ एक बार देखो, आ गया। टाइम कम है यार, हो गया, देखो चेक करो, हो गया, ठीक है। I guess it is okay now. Okay. So let's quickly go. Sorry for this interruption. That is beyond my control. There's some technical glitch. Right. तो मैं ये बता रहा था कि देखो, I'll just take maximum 15 minutes, maximum. Weger-Mayer law ये कहता है कि when there are two ureter, they cross each other. The upper kidney is having 1/3 part, lower having 2/3 part. The upper ureter always open inferomedially because they cross each other, and it has ureterocele. And audio not available? Is audio not available? So ureterocele, and the lower one having VUR, which has a lateral opening. Another point, they gave a question: a young female having regular urination, normal desire, normal urination. At the same time, she is having incontinence. What is the diagnosis? The diagnosis is ectopic ureter. One ureter opening in the vagina or in the urethra will have incontinence. Another one opening in normal position will have normal voiding. So that they do ask, normal voiding and incontinence है तो क्या है? Another topic, minor topic, horseshoe kidney, lower pole fused. Most common, normally common in male, isthmus lies against L4Y. See this image, inferior mesenteric artery prevents the ascent of kidney. And CT also they show either this or this. So ascent is T3rd, so it is at L4. Usually patient has PUG obstruction, IVP show flower vase deformity, usually not done. We do CT scan now, and prophylactic supplementary has no role. This you can see, this is the flower vase deformity where the lowermost calyx inferiormost is directed medially. Normally we do not have calyx directed medially, but the inferiormost calyx directed medially, called flower vase sign, is sign of horseshoe kidney. Now this is autosomal dominant polycystic kidney disease. Another image asks question, chromosome 16 and 4, you can identify multiple. If there are more than 2 cysts bilaterally in kidney, then this is polycystic kidney. Chromosome 16 and 4, liver, pancreas, spleen, ovary, 2 can have cysts. Berry aneurysm is found, and mitral prolapse syndrome. Diverticulosis and liver cysts are 2 most common associated normally that we get here. IVP may show spider-leg deformity, not asked nowadays, not done. We do CT scan plain. And tolvaptan V2 receptor antagonist is the new drug. Rovsing operation not done anymore. This is the obsolete surgery. Only definitive treatment is transplant. Neither Rovsing is done nor IVP is done, so we order CT and we order transplant when it gets affected. This is the spider-leg deformity, although not done nowadays. Prune belly syndrome, other congenital anomaly. You can see here the abdomen is wrinkled and lax because the muscle do not have tone. Absolutely atonic. So prune belly, lack of abdominal muscle, mega bladder and VUR and undescended testes. This is called prune belly syndrome or Eagle-Barrett syndrome. See here, Eagle-Barrett or prune belly characterized by wrinkled abdominal muscle, no tone, mega bladder and reflux, and cryptorchidis. This is another important MCU, posterior urethral valve. They do ask very often. Only seen, this is the keyhole sign of posterior valve. Only seen in male child, most common bladder outlet obstruction in neonate. The fold is below verumontanum, type 1 is 98% most common. Can cause back pressure, mega bladder, mega ureter, VER, oligohydramnios, etc. Urinary obstructive symptom. And MCU is treatment of investigation, endoscopic fulguration treatment. So this image I want you to remember, this one. This they do ask very often. Another condition of congenital PUG obstruction, although may present in adult also, pelvic-urethric junction obstruction. A IVP showing hydronephrosis, here it is normal, and CT uro showing hydronephrosis. At the site of PUJ, there is the obstruction. Ureter not visualized. which is why it is PUJ, pelvic junction. And most common renal obstructive uropathy. Intrinsic defect, the motility disorder is most common, followed by aberrant vessel. Presents with lump in neonate and pain in adult, can cause Dietz crisis, flank pain, lump. Patient comes with flank pain and lump when there is a diuresis. He takes lots of alcohol or something, or tea or coffee, any diuretic. Then he comes with a lump and pain. That's a hydronephrotic kidney, and then he passes urine, he is comfortable. That's called Dietz crisis. A borderline PUJ can cause this. Stone can cause this. Ultrasound is first test. Scan is the investigational choice, mainly MAC3. Not available, go for DTPA. CT and IVP can show the anatomy but not ordered in neonate. Only in adult we do. Surgery of choice, dismembered pyeloplasty, Anderson-Hines pyeloplasty. This is the image of Anderson-Hines pyeloplasty. This is a testicular torsion, and this is a borderline gangrene. This is a definite gangrene. So when you have an image like this and I ask what you will do, you will say I'll do orchidectomy on this side and fixation on this side. Do orchidopexy bilaterally because the pathology is bilateral, etiology is bilateral. What is the point we need to know? Common in teenage, most common type intravaginal, high invagination of tunica vaginis, clapperable deformity is the most common abnormality. Pain is inguinoscotal. 3 signs, Prehn sign, elevate the testis, pain gets aggravated, torsion, loss of chromatic reflex, and other testis transversely lying. This is called angel sign. So 3 signs, Prehn sign to differentiate from epidural, elevate the testis, and you find the pain gets aggravated, the torsion gets relieved in epidural. Loss of reflex, Deming sign, and angel sign is contralateral. See the other side, testis transversely lying. Immediate Doppler should be done, that's the investigational choice, and bilateral fixation should be done. But we have this is the clapper belt deformity, high invagination of tunica. So the testis is transversely lying here in this, the last image here, and patient can have torsion on this. 2 types, extravaginal and intravaginal. This is the common type. This is seen in very young age, like 1-2 year, very rare. And here only unilateral fixation is done, here bilateral fixation. So intravaginal is the common type. This is the blue dot sign that you don't get in testicular torsion, that you get in torsion of appendix of epididymis or appendix of testis here. So that, and it's managed conservatively. Now testicular cancer, what investigation order? You order ultrasound scrotum, you order CT abdomen and marker, maybe PET and X-ray chest if you have. No procedure should be done from the scrotum, otherwise you will spread the cancer to inguinal node. The testis drains into the para-aortic node, so I only treat the abdominal lymph node. But if you go through FNAC or biopsy from the scrotum, then you upstage the tumor, it will go to inguinal node as well. Tumor marker for seminoma, LDH, beta HCG high in 10% due to we do arterial Doppler, but this is not called arterial Doppler. It's only called testicular Doppler because we are not looking for artery or vein. We are looking for vascularity in the testis. You are not looking for vessel. You are looking for blood flow in the testis. So it's a testicular Doppler. 10% will have beta HCG. This is due to syncytiotrophoblasts. Only 10% seminoma has syncytiotrophoblasts. That's why 10% high. Yolk sac, AFP, choriocarcinoma, beta HCG. These are the main marker. OCT3 and 4 is a immunomarker for seminoma. The problem is in the treatment. The early stage, the conventional treatment was radiotherapy, inverted Y field radiotherapy, 2500 rats. But now chemotherapy is also given. Same is true in non-seminoma, where conventional treatment for early stage was RP-LND, retroperitoneal lymph node dissection, but now chemotherapy is also given. So that's the problem. Chemo can also be given. Okay. This is Rinke crystal seen in Leydig cell tumor of testis. This is Schiller-Duval body seen in yolk sac tumor, coffee-shaped nucleus and pars positive hyaline. This is seen in granulosa cell tumor. 3 inclusion body, granular tumor के लिए Carl Exner body जो gynae में पढ़ते हो, Schiller-Devalian yolk sac, Enrique crystalline leading cell. Important images, yeah, BEP is the chemotherapy regime, bleomycin, etoposide and cisplatin, but that's not the only regime. We have at least 3-4 more regimes. Wilms tumor, 2 to 6 year, a child having huge abdominal lump and this kind of CT, this is Wilms tumor. This is clause sign functioning kidney. This clause sign is not important. The interception clause sign is important. Renal stone crystal, envelope shaped calcium oxalate, hexagonal cysteine, coffin lip triple phosphate and rhomboid or needle shaped uric acid. ये तीनों पूछा जाता है, all 3 you remember. Staghorn calculus is a infected urine calculus in alkaline urine made up of triple phosphate. Retroperitoneal fibrosis called Ormond's disease. The ureter gets very close to each other, gets trapped in the fibrosis, having a shape like this called maiden waist deformity. Uric acid is radiolucent. H2 white is same. H2 white is triple phosphate. इसी को कहते हैं, ये जो आप देख रहे हो कॉफिन लिट, इसी को H2 white कहते हैं. They are H2 white stone. Pyavasai image they do ask, and they ask to make pubic symphysis, which bone is cut? Iliac bone is, ilial osteotomy is done to reconstruct pubic symphysis. This is an image of, this has been asked earlier, brachytherapy for prostate cancer. Interest, prostate के अंदर you put the radioisotope either iodine 125 or palladium 103 or iridium 192. This is the intraprostatic radiotherapy, brachytherapy. Again stuck? No, I don't think it's stuck. Okay, so ये फोटो याद रखना, ये पूछते हैं. This is the putty kidney tubercular. देखो, ये है kidney. Look carefully. I'll tell you something. The stone forms here. This is the Staghorn calculus having a shape like this, and the putty kidney forms here. So putty kidney will be shaped like kidney. So both are kind of radio dense image in the kidney, but putty kidney will have a shape of the kidney. Staghorn calculus will have a shape of the pelvis. You can differentiate between the two. Okay, goal fold ureter. This is the normal anatomy here. The ureter having intramural course. Fibrosis pulled up becomes end on goal. This is goal fold ureter. In tuberculosis, this is a normal opening volcano shape. So the ureteric orifice is slightly elevated up like volcano. Goal fold is the end on. So this needs ureteric reimplantation. This will cause vesico-ureteric reflux. This is a neurogenic bladder Christmas tree appearance. Upper motor neuron, sphincter diffusa synergia. This is champagne glass sign, transition cell cancer of the ureter seen in retrograde pyelography. Not important. This I won't say important for you. This is retrocaval ureter. This is the vena cava. The kidney here, ureter goes behind the vena cava, giving a shape like this retrocaval ureter, fish-hook appearance. This is again Wiegert-Mayer law, 2 ureter crossing each other, but the duplex system, but the upper one pushes the lower one. So this is called drooping lily sign. This is very, very important X-ray for you. Adder head or cobra head sign of ureterocele. Frequently asked. Ask in FMGE this year only. This is bouquet of flower sign, medullary sponge kidney. And this is again transversely lying testis prone for torsion. Okay, torsion ke liye prone hota high invasion tunica. This is a normal retrograde urethrogram. This is prostatic urethra, this is membranous, this is bulbous, this is penile. So this also they do show sometime retrograde urethrogram. This is a flame sign of bladder injury, bladder rupture, intra or extra, both can give. This is a pelvic fracture with rupture of prostatic urethra here, and it's called pie in the sky bladder. Pie in sky. What is pie in sky? The bladder has gone up, bladder is pulled up because of this transected urethra. So, posturethral injury caused pie in the sky bladder, bladder gone up. This is perineal hematoma, butterfly shape seen in anterior urethral injury. Anterior urethral. Page kidney means when the kidney gets compressed from outside, causing hypertension. Then not ischemia, extra renal compression. Anything pressing from outside causing hypertension, and you remove the pressure, kidney becomes normal. This all of you can identify. Fournier gangrene. Fournier gangrene. Synergistic infection, testis never involved. ये दो चीजें याद रखनी है. And this is emphysematous air in the kidney caused by E. coli. This is desiccative pulmonary caused by proteus infection. There's stone, xanthoma cells, hard kidney, non-functioning kidney, giving beer paw sign, and non-functioning, requires nephrectomy. This incision is called Gibson incision, made for renal transplant, muscle cutting incision. This is a DJ stent, double J stent, and I'll finish with the question asked in last year exam. How do you insert this stent? You only insert by cystoscopy. Cystoscopy, put the stent to the uterine orifice, and by X-ray you can see its position. And this is the last message for you. Best wishes for the success. You have cleared 10th exam, 12th exam, MBBS, internship. Now it's time for MBBS, and this is for PG, which will come after 3 years. So this is the time for illumination. Don't get confused, don't get disheartened. बिल्कुल relax रहो, मस्त रहो, बहुत मेहनत किया. It's time to get the best when you give your best. So all the answers will be correct. मस्त रहो. All the best to all of you. Okay. So any question you have? And all these pictures are with member of cat family, tiger, lion and cheetah. So कोई भी सवाल फटाफट लिख सकते हो if you have any question. Already it's 20 minutes, 30 minutes late. I started also 15 minutes late. In 10 minutes we wasted in correction. Beta, Bosniak is for cyst, it's not for tumor actually. DJ stent का answer है cystoscopy, only by cystoscope. I think next session is pathology, I'm not sure, but most likely. So already वो faculty wait कर रही होगी, it's already too late. Sorry for this delay. All the best to all of you. मस्त होके exam देना, बिल्कुल relax होके. So I'm going to stop the streaming now. No, inguinal hernia is above and lateral, and femoris below and lateral. बेटा यूरोथेरेपी ट्रीटमेंट यहाँ तो मैं नहीं डिस्कस कर पाऊंगा, बट आई विल मेक ए शॉर्ट वीडियो फॉर यू. आज मैं अपलोड कर दूंगा on this telegram. I'll upload the video for यूरोथेरेपी today only by night. IOC for hypersomnia conventionally is barium meal, but now people are saying CT, but still I'll go for barium. चलो मैं इसका फिर बंद करता हूँ. Okay, and sorry for the delay to the next faculty.
Okay, so yes, good afternoon, good evening everyone. Yes, everybody, good evening. Please acknowledge whether the audio and video is clear so that we can proceed. Hanji everybody, audio and video is clear. Without wasting any time, can we proceed? हाँ जी, yes, good afternoon everybody. So चलिए बिना किसी time waste करे, let's start with your journal pathology revision. Okay, so I'm here to cover your journal path aspect, and basically I will be talking about your NEET PG previous year topics which you have to focus on. But if I want to summarize your journal pathology, so I would say that NEET PG people, they have a special love for your genetics chapter. They really like genetics. They keep on asking cell injury, inflammation, yeah, okay, they can ask one or two questions, but not sure about it. Neoplasia also, it overlaps with your systemic path and your medicine surgery. They asked about the BRAF mutation, papillary carcinoma. So yes, that can be covered. One or two Warburg effect and everything, yes, we will discuss. And immunodeficiency diseases and genetics is one of the favorite topic. So chaliye, without wasting any time, yes, and please, there is no need to write anything. एक भी word लिखने का जरूरत नहीं है. The PDF is going to be uploaded in your app in the deadly combos section, which is going to be free for all. So please, PDF आपको मिलेगा. आपने सिर्फ मेरे साथ फटाफट से रिवाइज करना है NEET PG में क्या क्या सवाल आए थे. So the first topic with which I want to start talking about right now is going to be your cellular aging, right? So sabse pehle, yes, the most common cause of cellular aging is going to be a free radical injury, but yes, I can have other causes like telomere shortening, insulin resistance, and DNA repair defects. So yes, I'm saying that with every cell division telomere shorten, but do we have any limit that after which there is no more division possible? Yes, that limit is called as Hayflick limit, and that means average number of somatic cell divisions, they are going to fall 60 to 70 approximately. Now this was your NEET PG PYQ regarding telomerase. So please remember, telomerase, they are what? They are RNA dependent DNA polymerases, and yes, they prevent shortening of telomeres. Now what was the question? True statement regarding telomerase, and please remember, telomerase is decreased in aging because I just told you that it prevents shortening of telomeres. So cancer cells, they have more telomerase, but in aging I will have decreased telomerase. Hanji, done? Perfect. Okay, now if I'm talking about aging, so obviously you students know that I have to talk about another important one, SIR-twins. This is also your NEET PG PYQ. Right, this is also your NEET PG PYQ. Now what are SIR-twins? SIR-twins are NAD dependent protein deacetylases. Yes, they prolong the cell survival. Now this was your PYQ NEET PG कि SIR-twins कैसे cellular survival को prolong करता है. I can increase them in diet by, this was the option given, by calorie restriction. But yes, apart from that, low doses of red wine consumption. Now please remember, SIR-twins, they are derived from the SIRT genes, which are a total of 7 types. And yes, if I want to summarize the function of SIR-twins, yes, they have a role in aging. They prolong the cell survival. A little controversial role. They can promote as well as inhibit cancers. And yes, they can increase the insulin sensitivity. That's why we use SIR-twins in the treatment of diabetes mellitus. Now, if I want to talk about the mechanism of action of SIR-twins, obviously they will reduce apoptosis, they will reduce the free radical injury, and they will activate the DNA repair enzyme. So a very, very important last minute table of NEET PG PYQ SIR-twins. Now next, there were one more important previous year topic, that was your nets. Now nets क्या होते हैं? They are neutrophil extracellular traps. क्या हैं ये? They are a special form of killing. But where do you utilize nets? To kill the bacteria in sepsis, severe bacterial infection. होते क्या हैं? They are extracellular fibrillar networks. Now extra means outside, cellular means cell के outside. कौन सा cell? Neutrophil. क्या बन रहा है? Fibrillar networks. Now what is the composition? Because this was the PYQ. What is the composition of this nets? So if you look here, I always tell this in the class. So if I say that this is a neutrophil and this is the outline, what is this? This is the nucleus. Yes. If I say this is the nucleus of neutrophil, right? Now if you look here, again I will make an outline here. And yes, I'll make an outline. This is what? This is your nucleus. So what is the color of the nucleus? Orange color. So if you focus here in this image, this is 1, this is 2. If you see, this orange nucleus is disintegrating its shape and trying to come outside. But if you look here, oh my god, the orange nucleus has come totally outside, forming a trap, forming a network in which the bacteria is going to be trapped. So the next question is कि क्या फिब्रिलर नेटवर्क इसका कंपोजिशन क्या है? न्यूट्रोफिल का खुद का न्यूक्लियर मटेरियल क्रोमैटिन, एंड दैट वाज द आंसर, बिकॉज उसमें पूछा था फॉल्स स्टेटमेंट क्या है, तो वो बोला माइटोकॉन्ड्रियल डीएनए. नो, इट्स नॉट माइटोकॉन्ड्रियल डीएनए, इट्स अ न्यूट्रोफिल का डीएनए विच हैज कम आउटसाइड. नाउ टेल मी, इफ न्यूट्रोफिल इज गिविंग इट्स डीएनए आउटसाइड, तो क्या उसके बाद वो जिंदा रह पाएगा? कोई भी सेल न्यूक्लियस देने के बाद जिंदा रहता है? नो. सो यानी कि द न्यूट्रोफिल इज कमिटिंग सुसाइड बाय गिविंग इट्स ओन क्रोमैटिन मटेरियल आउटसाइड so as to cause benefit of your body by eradicating bacteria from your body. That is why NETs is also called to be an example of beneficial suicide. Absolutely correct. Which amino acid helps in the formation of NETs? That is going to be your arginine. Done. So this was your NETs. Okay, another NEET PG PYQ, your last year question. Chemokines. देखिए सीधा सीधा सवाल आया था. They gave you a history of ARDS and they told you that in ARDS, you read this in your medicine as well, in ARDS interleukin 8 comes and play and role. और उसमें पूछा गया था लास्ट लाइन में कि what is the function of interleukin 8 in a patient of ARDS. So I always tell this in the class that interleukin 8, which is an alpha chemokine, which is also called as CXC, it is responsible for attracting your neutrophil. So my correct answer was neutrophil chemotaxis, right? So my correct answer was neutrophil chemotaxis responsible ILA. Now I want to make a mention here that when I was looking at the options and in the recall, my students told me, ma'am, there was one more option, lymphocyte chemotaxis, right? Obviously it was not the answer in that scenario, but if in the future I'm being asked lymphocyte chemotaxis, so for lymphocyte, who is going to be the chemokine? Lymphotactin, which is an example of gamma chemokine, also called as C. And yes, for other mononuclear cells, fractalkine, which is CX3C, all WBCs except neutrophils is your beta chemokine or CC. जिसमें one example you can remember, eotexin. Eotexin is a chemokine for eosinophils. ठीक है जी? हाँ जी. Yes, Shivani Bache, I told you, you will be getting the PDF of this in your eMedico's app in the Deadly Combo Revision course, so need not to worry. कुछ लिखने की जरूरत नहीं है, मैं बार बार बोल रही हूँ, आप सुन क्यों नहीं रहे हो? कुछ लिखने की जरूरत नहीं है, अभी सिर्फ आप मेरे साथ फटाफट क्विक रिविजन करिए, लास्ट मिनट रिविजन टॉपिक्स का. Yes, next question, please remember. So obviously if chemotactic agents being asked means mediators of inflammation are very important. So first let's talk about histamine and serotonin. Both have the exact same functions. What are the exact same function? That arterioles ka they will cause vasodilation and arteries ka they will cause vasoconstriction. HSBC, this is a mnemonic. For me, histamine, serotonin both cause bronchoconstriction and yes, increase in permeability. Next is going to be nitric oxide. The mnemonic is no iPad. No means nitric oxide inhibit platelet aggregation and vasodilation. Cytokines में yes, fever के लिए most important cytokine interleukin 1, for cancer cachexia it's TNF alpha, for angiogenesis it is VEGF, for fibrosis it is TGF beta, very important, G for gamma, G for granuloma, so interferon gamma for granulomas. Yes, absolutely correct. So many correct answers in the chat box. You guys are participating, makes me happy, making it a very important interactive session. Thank you so much. चलिए नेक्स्ट दो ऐसे अराकिडोनिक एसिड मेटाबोलाइट्स हैं विच आर वेरी इंपॉर्टेंट, क्वेश्चंस आर बीइंग आस्क्ड एंड विच आई ऑलवेज से दैट दे आर द एग्जैक्ट दुश्मन्स ऑफ ईच अदर, मींस दे आर द एग्जैक्ट एनिमीज ऑफ ईच अदर. आई एम टॉकिंग अबाउट PGI2 and TXA2. What are the exact opposite function? PGI2 will inhibit platelet aggregation, I for inhibit and A for TXA2 activate platelet aggregation. PGI2 causes vasodilation and TXA2 will cause vasoconstriction. ठीक है जी, done. Next, if I'm talking about your leukotrienes, so LTB4 is yes, chemotactic agent. Apart from that, LTC4, D4, yes, LTC4, D4, E4, vasoconstriction, bronchoconstriction, increase in permeability. Now, lipoxins, they are also LOX derivatives, but they are anti-inflammatory in function. Now, platelet activating factor, name itself is telling you, platelet activating factor. So, they activate platelet aggregation, vasoconstriction, and bronchoconstriction. Now, let's talk about the kinins. Kinins, what do they cause? Vasodilation, increase permeability, and pain, right? These were the important mediators which you have to remember. Okay, I always tell this in the class that this is a straightforward question. NEET INI दोनों में straightforward सवाल पूछा जाता है regarding your very important DNA repair defects. 3 repair defect mechanism. First is इसी पे ही सवाल आया था, ये आप ही का PYQ है, न्यूक्लियोटाइड एक्सिजन रिपेयर डिफेक्ट. ना क्वेश्चन था कि एक पेशेंट है उसको मल्टीपल पिगमेंटेड लेजन्स हैं तो आपको कौन सा DNA रिपेयर डिफेक्ट होगा. तो बेसिकली क्वेश्चन इज एक्सप्लेनिंग यू xeroderma pigmentosum and yes this is because of nucleotide excision repair defect. अब और क्या पूछा जा सकता है? Yes, mismatch repair genes defect causes HNPCC, hereditary non-polyposis colon cancer. Homologous recombination repair defect, इससे क्या होता है? You become fabulous. No. Fab means Fanconi anemia, ataxia telangiectasia and Bloom syndrome. Yes, MMR, mismatch repair genes. Okay, yes, very good, shabash, correct answers. Okay, there was a question on the Warburg effect. So Warburg effect is very simple. I do not want any controversy here. It's a very simple thing that your cancer cells, even in the presence of ample oxygen, they utilize glucose for their method of energy production, and that's why Warburg is also called as aerobic glycolysis. This is according to your Robbins, right? आपकी Robbins कहती है, this is aerobic glycolysis. Now basically when Warburg effect is happening, when your cancer cells, they, for example, they are utilizing glucose for their energy production, because we always say that cancer cells, they have a glucose hunger, and that's why this property we use for PET scan also. PET scan में भी हम Warburg effect property को use करते हैं, and Warburg effect जो होता है क्यों useful होता है? Because it is useful to make the intermediates for the survival of the cells, and that was your correct answer. Yes, increased intermediates. Very good, Priyanka. Shabash बच्चे लोग, आपको सब आता है. I'm so happy. Very good. Now again a very important question from the important carcinogens. अब इसमें chemicals भी पूछे जा चुके हैं, microbes भी पूछे जा चुके हैं, तो आपको सारे याद करने हैं. Last minute revision table in front of you. Students who have read with me, they know how much I love tables. So wherever I go, tables follow. Can't avoid them. चलिए, very important table. Yes, alkylating agents, yes, cause leukemias, lymphomas. Aromatic amines, for example, benzidine causes TCC, transitional cell carcinoma of bladder. Arsenic, so please remember arsenic, vinyl chloride and thorotrust, all three causes, yes, hepatic angiosarcoma. But yes, for arsenic, one more important one that you have to remember is lung carcinoma. ठीक है जी. Asbestos, most common lung carcinoma, and most specific is mesothelioma. Very important. Tobacco smoke causes SCC, adenocarcinoma, small cell lung carcinoma, oropharyngeal carcinoma, renal cell carcinoma. Ethanol, yes, it causes hepatocellular carcinoma, right? Now if I'm talking about ionizing radiations, yes, papillary thyroid carcinoma and leukemias. One leukemia which is not associated with ionizing radiation, and that is going to be my straightforward CLL. Next, nickel, chromium, beryllium, silica. Yes, lung carcinoma. Nitrosamines, that is your smoke food consumption. Yes, intestinal type of gastric carcinoma. Very important, benzene AML. No confusion, benzidine, bladder carcinoma, benzene AML. Aflatoxin, yes, hepatocellular carcinoma. Diethyl stilbestrol, clear cell carcinoma of female genital tract, that too 10 to 20 years later in the daughter, right? This was your another important table. हाँ जी, अब as I told you, this is also your NEET PG. आप ही के exam का PYQ है microbial carcinogenesis. So let's talk about first bacteria which can cause cancer. Number one is H. pylori, gastric adenocarcinoma and malt lymphoma. Yes, very good guys. So many correct answers in the chat box. Which viruses can cause cancer? Number one is Epstein-Barr virus, Burkitt's lymphoma, Hodgkin lymphoma, nasopharyngeal carcinoma. Now HPV, two strains of HPV, low risk HPV 611, which causes condyloma acuminatum, that is Warts. Now this is your NEET PG PYQ. High risk HPV 1618, पूछा गया था which HPV causes anal carcinoma, that is, and the option was HPV 18. So cervical carcinoma, anal and penile carcinoma 1618. ठीक है. Now coming to your, yes, hepatitis B virus, hepatitis C virus, hepatocellular carcinoma. Next, HTLV1 causes ATLL. HHV8, human herpes virus 8, Kaposi sarcoma. आप ही के NEET PG का PYQ है. Yes, Clonorchis sinensis. Opisthorchis sinensis, fasciola hepatica, all three will cause cholangiocarcinoma. Your NEET PG PYQ clonorchis के ऊपर आप ही का सवाल था. And yes, there is one more parasite that is schistosomiasis that causes squamous cell carcinoma of bladder. तो ये थे आपके important oncogenic microbes and the cancers associated with them. Yes, very good, absolutely correct. ना सीधा सीधा आप ही के नीट पीजी में क्वेश्चन आया था कि एक पेशेंट है जो कि क्रॉनिक स्मोकर है, ठीक है, और उसको 1 साल से ज़्यादा कॉफ हो रहा है, हैविंग कॉफ फॉर मोर देन 1 year विद वेट लॉस, हैज़ अ लंग कैंसर. व्हाट डू यू थिंक इज द डायग्नोसिस हियर? एंड देयर इज हाइपरकैल्सीमिया. सो दिस वाज द एग्जैक्ट क्वेश्चन. क्रॉनिक स्मोकर विद वेट लॉस, हैविंग कॉफ फॉर मोर देन 1 year and has a lung cancer with hypercalcemia. So straight away examiner थोड़ा सा घुमा के पूछ रहा है, लेकिन किसके बारे में? Paraneoplastic syndrome. Because if I'm talking about a lung cancer with hypercalcemia, yes, my correct answer was straight away squamous cell lung carcinoma with keratin pearls, right? But hypercalcemia जो है, अब एक question आ चुका है, so means paraneoplastic syndromes are important. So this is again your last minute table for revision of all the important paraneoplastic syndrome. So SCC lung के अलावा breast carcinoma, renal cell carcinoma, Cushing's, SIADH and Lambert-Eaton. All three are paraneoplastic association in small cell lung carcinoma. Hypoglycemia as a paraneoplastic association in fibrosarcoma. Polycythemia in RCC, HCC, hemangioblastoma. Trojo syndrome in bronchogenic and pancreatic carcinoma. Myasthenia in bronchogenic thymoma. Acanthosis nigricans in gastric carcinoma. Yes, absolutely correct. हाँ जी बेटा, ये important है. We have covered this in your LRR as well, and the same table in the NEET predictor series on the DAMS YouTube channel also. I have given this that this is a predictor question, a very important question. So NEET predictor में भी मैंने ये question cover किया था, और यहाँ पे फिर से आपको याद दिला रही हूँ कि बहुत important table है paraneoplastic syndromes की. हाँ जी, very good. So many correct answers in the chat box. शाबाश. And yes, students who know me, they know how much I love, and in fact, not just me, your NEET as well as INICET, आपके NEET PG को भी जेनेटिक्स बहुत पसंद है, और इस आपका ही PYQ है. उन्होंने क्या किया, उन्होंने एक ही क्वेश्चन में सारा खिचड़ी बना दिया. दे गेव यू अ पेडिग्री एंड दे आस्क्ड यू कि खुद ही पेडिग्री को डीकोड करो, और डीकोड करने के बाद ऑप्शंस में से उसी इनहेरिटेंस का आंसर ढूंढो. यानी कि 1 question आस्किंग 2 questions टू बी प्रोसाइज. तो सबसे पहले मैं आपको बताऊंगी हाउ टू डीकोड पेडिग्री, फिर उसके बाद I will give you a list of inheritance disorder. From that list you have to pick the disease, look into the answers in the options and mark the correct answer. So this is how your approach is going to be. So yes, if you know, this is the easiest pedigree to decode. Yes, so you guys remember my 2G rule. मेरे बच्चे हर जगह छा रहे हैं, शाबाश. चलिए देखिए यहाँ पे. Now easiest pedigree to decode. When a mother is having the disease, she will give disease to all the children. When mother is having the disease, she will give disease to all the children. When father is having the disease, he is giving disease to none of the children. So this is a classical, yes, माइटोकॉन्ड्रियल इनहेरिटेंस पेडिग्री. मेलास हो गया इसके अंदर एग्जाम्पल में, लॉन हो गया इसके अंदर एग्जाम्पल में. हाँ जी, वेरी गुड, सो मेनी करेक्ट आंसर. हाँ, ये पेडिग्री आप ही के नीट पीजी में आई थी. येस, यू कैन सी व्हाट दीज आर कैरियर फीमेल्स and there is skipping of generation and with males having the disease. So males having the disease, females being carrier, skipping of generation. Yes, this is a classical X-linked recessive pedigree. Absolutely correct. Very good. ठीक है जी, चलिए next. हाँ जी, next pedigree here. So all the males of all the generations are involved. मतलब every generation only males are involved. That means this is a classical Y-linked or the Hollandric inheritance pedigree. हाँ जी, done done done. Yes, very easy to decode, right? Now moving ahead. चलिए आगे चलते हैं. हाँ जी, so आपको पता ही है, you guys know that I have a favorite 2G rule. First G is for gender. Gender में female having the disease, yes. Male having the disease, yes. So means that makes it an autosomal disorder. First generation disease, yes. Second generation disease, no. Third generation disease, yes. There is skipping of generation. That means this is a autosomal recessive pedigree, right? So that means it is a autosomal recessive pedigree. Correct. हाँ जी. चलिए next. Again you are going to follow the 2G rule. Male having the disease, yes. Female having the disease, yes. So that makes it an autosomal. First generation disease, yes. Second, yes. Third, yes. That means this is a dominant, all generations involved. So this is a autosomal dominant pedigree. Okay, yes, one of the most easiest and one of the most confusing as well क्योंकि मेरे students ये वाले गलत करते हैं. Please आप गलत नहीं करेंगे, ध्यान से देखिए. You're following the 2G rule. Male having the disease, yes. Female having the disease, yes. So that makes it an autosomal. First generation disease, yes. Second, yes. Third, yes. Fourth, yes. All generations involved makes it a dominant pedigree. Absolutely wrong. ध्यान से, be very careful. Whenever you see both male female involved and generations being involved, in that case you have to see कि कहीं ऐसा तो नहीं है that father is giving the disease to all the daughters. So father is giving disease to all the daughters. और कहीं ऐसा तो नहीं है that mother is giving disease to the 50% of the offsprings. If this is the case, that means this is not at all autosomal dominant. This is a X-linked dominant. Always remember, father to daughter, father to son नहीं होता. ये देखिए यहाँ पे father to son transmission हो रहा है. So father to son is never seen in XLD. In XLD only father to all the daughter transmission. Clear to everybody? Yes, yes, yes. X-linked dominant. हाँ जी. So please listen to me carefully. ये बहुत important है. मैंने आपको बोला था, सवाल आया था, पेडिग्री चार्ट दिया. पेडिग्री चार्ट से मुझे पता चला that this is an X-linked recessive and option में मैंने ढूंढा तो Viscott Eldrick was there, so I marked it कि यही मेरा जवाब है. तो एक क्वेश्चन में 2 सवाल पूछ लिए. तो बहुत इंपॉर्टेंट है पेडिग्रीज, बहुत इंपॉर्टेंट है इनहेरिटेंस डिसऑर्डर. और आपके एक और नीट पीजी में पीवाईक्यू सीधा सीधा पूछ लिया था कि बता दीजिए सिस्टिक फाइब्रोसिस का क्या इनहेरिटेंस पैटर्न है. सो 2 वेज में क्वेश्चंस आर आस्क्ड. ईदर डायरेक्टली दे आर गोइंग टू आस्क यू और दे विल आस्क यू इन अ haphazard way. They will give pedigree or something like that, or they will give you a clinical history and they will ask you the inheritance. You have to make the diagnosis. Anyway, whatever the case is, I just want to say these are the screenshots of my class only for you guys for inheritance disorders with the mnemonics for AD, AR, XLD, XLR. Now listen to me carefully. These inheritances I have shared already in the LRR, already in the DBT, already in the YouTube DAMS channel पे आप जितने भी sessions देखेंगे NEET Predictor में भी है. And yesterday only I shared all these inheritance diseases on the DAMS official Telegram channel as well. ठीक है? And I have pinned that as well. तो कल मैंने शाम को शेयर किया था. तो घबराने की जरूरत नहीं है. मैडम स्क्रीन पे दिख नहीं रहा, बहुत छोटा छोटा लिखा है, कुछ समझ नहीं आ रहा. बिल्कुल नहीं घबराना है. वी हैव गॉट यू कवर्ड. यहाँ पे हम आपको पहले से कवर करके चल रहे हैं, तो टेंशन नहीं लेने का है. डैम्स के ऑफिशियल यूट्यूब चैनल पे भी है, ऑफिशियल टेलीग्राम चैनल पे भी है. आप जाके पोस्ट देख सकते हैं. इवन मेरे खुद के टेलीग्राम चैनल पे भी आपको ये पोस्ट मिल जाएगी. सो टेंशन नहीं लेने का है. चलिए नेक्स्ट पीवाईक्यू के ऊपर आ जाते हैं. जिनोमिक इम्प्रिंटिंग डिसऑर्डर पे सीधा सीधा सवाल आया था. इमेज दी थी और बीच में से पापा के ऊपर एक पार्ट ऑफ द जीन को डिलीट कर दिया था. तो बेसिकली व्हाट आई एम टॉकिंग अबाउट, दैट आई एम टॉकिंग अबाउट जिनोमिक इम्प्रिंटिंग डिसऑर्डर्स व्हिच बेसिकली इन्वॉल्व द क्रोमोसोम नंबर 50. Right now, if you guys know and if you have read with me in DVT, LRR as well as in my lectures, I always say कि जब भी genomic imprinting disorders को nomenclature देना है, नामकरण करना है, you always give importance to the one. This is my hack of learning, that you always give importance to the one which is deleted. यानी कि what I'm trying to say, that if I'm saying that there is paternal deletion, so जब पापा डिलीट हो रहे हैं, आपने जो डिलीट हो रहा है उसे इंपॉर्टेंस देनी है. यानी कि पापा डिलीटेड. सो दिस इज व्हाट Prader-Willi syndrome. So Prader-Willi syndrome means yes, your SNORP set of genes are getting deleted. Yes, very good. Right? So your Prader-Willi में your chromosome 15 SNORP set of genes paternal deletion. Now there is one more way. There is another pathogenesis of getting Prader-Willi, and that is going to be your maternal disomy. And Prader-Willi ka what is the classical MCQ history? Chota mota bacha, a short bacha with obese bacha with developmental delay wala bacha. Now coming here, I just told you this is how I have remembered. जो delete हो रहा है आप please उसे importance दीजिए. यहाँ पे कौन delete हो रहा है? मम्मी delete हो रही हैं. और मम्मी हमारी life में क्या होती हैं? Angel. So this is your Angelman syndrome. So that means there is maternal deletion. This one more way of getting Angelman syndrome, that is paternal disomy of your UBE3A set of genes. And yes, very very important, Angelman syndrome babies, they are called as happy puppets. Why happy? Because of the inappropriate laughter. Why puppets? Because of the ataxic movements. ठीक है जी, डन। ये हो गया आपके जीनोमिक इम्प्रिंटिंग। हाँ जी, आप ही का PYQ है, स्ट्रेट फॉरवर्ड कैरियोटाइप आया था और टर्नर सिंड्रोम का कैरियोटाइप आया था, तो ऑब्वियसली आई हैव टू शो यू ऑल द कैरियोटाइप्स। हाँ जी, नाउ डी कोड, वेरी इजी, फटाफट क्विकली। ये कैरियोटाइप देखिए, व्हाट इज दिस? Yes, this is trisomy 21. So that means this is a karyotype of Down syndrome. चलिए, हाँ जी, look at this karyotype. What is the problem here? Trisomy 13. So this is what? This is your Patau syndrome का karyotype. ठीक है जी, चलिए, now look here. हाँ जी, हाँ जी, हाँ जी. What is the problem here? Yes, trisomy 18. So this is what? This is your Edward syndrome here, right? चलिए, next. हाँ जी, हाँ जी, ये देखिए, what is the problem here? X, X, Y. So that means what is this? This is a Klinefelter karyotype. हाँ जी, चलिए, next. Yes, this was your NEET PG PYQ. NEET PG people love Turner syndrome. They ask you so many questions. Streak ovaries, rudimentary ovaries, short stature, webbed neck, primary amenorrhea. Yes, a single X, monosomy X. So this is what? Turner syndrome, 45XO, monosomy X. Yes, this is Turner. हाँ जी, सी ऑलवेज रिमेंबर वेन एवर एग्जामिनर वॉन्ट्स कि आपका ज़्यादा टाइम वेस्ट ना हो, सो वॉट एग्जामिनर डज इज ईदर दे विल सर्कल द क्रोमोजोम और दे विल पुट एन एरो मार्क ऑन द क्रोमोजोम सो दैट यू कैन जस्ट फोकस ऑन दैट पर्टिकुलर number of the chromosome and you can come up with the diagnosis. So here the examiner has circled 5 chromosomes. So what is this? Basically they are telling you this is cry-do-chat syndrome, which is also called as cat cry syndrome. Cry-do-chat, cat cry syndrome. ठीक है जी, चलिए next. हाँ जी, look here, what is the problem in this pedigree? Yes, this is trisomy 22. So this is cat eye syndrome. This is trisomy 22. So वो क्या था? cat cry. This is cat eye syndrome, trisomy 22. ठीक है जी, हाँ जी, next. So in this karyotype, 2 arrows are marked on chromosome 9 and chromosome 22. और 2 पे arrow है, मतलब what they are trying to show? Translocation 922. यानी कि this is a karyotype of CML. हाँ जी, now look here. In this, there is only 1 arrow mark on chromosome 16. So that means what they are trying to show is inversion 16. And this is a karyotype of AM. हाँ जी, ठीक है, डन। यस यस यस, वेरी गुड। तो ये थे आपके वेरी वेरी इजी इजी सिंपल सिंपल कैरियोटाइप्स। एंड यस, इफ यू रिमेंबर, आई ऑलवेज से अ स्टार टॉपिक यस ऑफ जर्नल पैथोलॉजी फॉर बोथ INI NEET is amyloidosis. So this is a star table for all of you. See, amyloid may you know that it is mostly a fibrillary protein. There is a less peak component also, and yes, you have a beta pleated sheet configuration on X-ray crystallography. ये सारी बातें आपको पता है। Investigation of choice GIT के अंदर, if you know the location, specific organ का biopsy. But if you do not know, the investigation of choice is yes, aspiration of abdominal part of fat, right? But यहाँ पे what was the NEET PG? आप ही के NEET PG का PYQ था, बहुत स्मार्टली उन्होंने आपको हिस्ट्री दे दी कि एक पेशेंट है, ठीक है, उसको बोन पेन है और हमें 22% प्लाज्मा सेल्स दिखे। एंड फ्रॉम द नॉलेज ऑफ हेमेटोलॉजी वी नो दैट दिस इज अ क्लियर कट हिस्ट्री ऑफ मल्टीपल माइलोमा एंड दे गिव यू एन इमेज ऑल्सो जिसमें यू सॉ द पिंक पिंक मटीरियल। तो उन्होंने पूछा ये क्या है भैया? मल्टीपल माइलोमा की आपने हिस्ट्री दे दी है, बायोप्सी में आपने हमको पिंक पिंक मटीरियल दे दिया, सो पिंक पिंक मल्टीपल माइलोमा, दैट मीन्स द आंसर इज अमाइलॉइड एंड दैट वाज वन ऑफ द ऑप्शन। सो बेसिकली अब मैं आपको बताती हूँ कि मल्टीपल माइलोमा में कौन सा माइलॉइड होता है? AL, वेयर L स्टैंड्स फॉर light chain. Hemodialysis associated or seen in patients of chronic renal failure is A beta 2 microglobulin. Senile systemic amyloidosis ATTR, मतलब normal ATTR. TTR is transthyretin. In familial amyloidotic polyneuropathy is again ATTR, but this is a mutant ATTR. Familial Mediterranean fever, it is AA. Alzheimer's disease, again your NEET PG PYQ, A beta. Type 2 diabetes mellitus, AIA AIAPP. Medullary carcinoma of thyroid, ACAL. Chronic inflammation like tuberculosis, rheumatoid arthritis, it is again AA. ठीक है जी, ये थे आपके important amyloid. And yes, obviously when I'm talking about amyloid, you should know very very important stain is Congo red stain. On light microscopy, it will give salmon pink color, and on polarizing microscopy, it will give me classical apple green birefringence. लेकिन इसके अलावा और कौन कौन सी stains होती है amyloid के लिए? Thioflavin T, Thioflavin S, crystal violet, methyl violet, Alcian blue, and PAS are some other stains that we can use for amyloid. ठीक है जी. नाउ अगैन दिस टेबल LRR में है. ये टेबल मैंने आपके नीट प्रिडिक्टर में भी डाली थी क्योंकि मुझे पता है दैट इम्यूनो डेफिशिएंसी डिजीजेस आर वेरी इंपॉर्टेंट बिकॉज PYQ हैज बीन आस्क्ड ऑन स्किड, राइट. सो प्लीज दिस इज द लास्ट मिनट 1 डे बिफोर द एग्जामिनेशन वाला टेबल है. इस टेबल में मैंने सारे इम्यूनो डेफिशिएंसी कंपाइल कर दिए हैं एक ही जगह पे, सारे MCQs के साथ, सारे PYQs के साथ. तो कोई चक्कर ही नहीं है बॉस, इधर उधर जाने की जरूरत नहीं है. ये टेबल आपका लास्ट मिनट सॉल्यूशन है. चलिए, पहला इम्यूनो डेफिशिएंसी डिजीज मेरे साथ चलते चलेंगे. नंबर 1 इज एक्स लिंक्ड ब्रूटॉन ए गामा ग्लोबिनीमिया. सो बी में मैंने क्या बोला है? बी फॉर ब्रूटॉन, बी फॉर बॉयज, बी फॉर BTK एंड बी फॉर नो बी सेल्स. So there is Bruton tyrosine kinase BTK defect. It has an X-linked recessive inheritance and B cells are absent, plasma cells are absent. So इसका मतलब if there are no plasma cells, there is no antibody. So recurrent bacterial and enteroviral infections. But the catch point is after 6 months. Why? Because till 6 months the maternal immunoglobulins are going to protect the baby. Next अब हम आ जाते हैं isolated IgA deficiency. It is the most common primary immunodeficiency disease, and now this is very very easy because this person majority of the life is having a asymptomatic life. उसको कुछ नहीं होता है, just a mild airway, थोड़ा बहुत cold cough और GI infections होते हैं. But अगर गलती से if you give blood products, so there is going to be a severe anaphylactic reaction to the IgA in the blood products on transfusion. This is the classical MCQ history of isolated IgA deficiency. Yes, absolutely correct guys, so many correct answers in the chat box. Next is going to be your DGeorge syndrome, which is also called as thymic hypoplasia. They have a 22q11 deletion. Now in these people you are going to have parathyroid hypoplasia leading to hypocalcemia leading to tetany. लेकिन अगर इसी patient में you can also have cardiac defects, palate defects and facial defects. And when you see that, now this is called as velocardiofacial DGeorge. It is called as velocardiofacial DGeorge. ठीक है जी. Next is going to be your Bayer lymphocyte syndrome. Name itself is telling you. Bayer means naked lymphocyte. मतलब lymphocyte के ऊपर ऐसा क्या है जो चला गया जिसकी वजह से naked हो गया. So I have mutation in the transcription factors which are required for the MHC class 2 चला गया है, for MHC class 2 expression. और MHC class 2 किस पे होता है? CD4, CD8, CD4. So if I have mutation in the transcription factors which are required for MHC class 2 expression, that means I will have no development of helper T cells. This was your Bayer lymphocyte. Next is going to be your hyper IgE syndrome, which is also called as, yes, Job syndrome. Now, in hyper IgE or Job syndrome, you are going to have STAT3 mutation, because of which there is going to be deficiency of T helper 17 cells. Now, what is the classical presentation? Increased IgE antibody, cold, यानी कि non-inflamed staphylococcal abscesses, retained baby teeth, recurrent skin infection, bone fractures from even minor trauma. ये आपकी MCQ की हिस्ट्री हो सकती है जब आपसे सवाल पूछा जाएगा. ठीक है जी. Now this was your NEET PG PYQ SCID, severe combined immunodeficiency. Now it can, yes, exist as X-linked recessive inheritance and AR inheritance. सीधा सीधा सवाल था कि भैया एक बच्चा है और बच्चे में क्या हो रहा है? adenosine deaminase deficiency है. So ADA levels are low. ADA levels low सुनते ही this is going to be a SCID baby. Now in दोनों inheritance में से, yes, it is most common. In X-linked recessive SCID में the problem is the defect is in the common gamma chain of cytokine receptor. मैम कौन कौन से cytokine receptors में problem है? Interleukin 2, 4, 7, 9, 11, 15 and 21. और अगर autosomal recessive SCID है तो उसमें, yes, there is going to be ADA deficiency, there is going to be RAG mutation, or I can have JAK3 mutation. Now basically SCID के baby को हम बोलते हैं bubble baby syndrome. Why bubble baby? Because this baby has zero immunity. No B cells, no T cells, no NK cells, कुछ भी नहीं है इनके पास. The classical MCQ history is कि एक छोटू सा infant होता है जिसको oral thrush होता है, डाइपर रैश होता है और सीधा सीधा बोलो तो भैया जीना ही मुश्किल है, फेलियर टू थ्राइव. You name the infection, this baby is going to have the infection. Recurrent bacterial infection, viral infection, fungal infection, protozoal infection, सारे infection इस baby के अंदर होंगे. Now, the next immunodeficiency is your Wiskott-Eldrick syndrome. Yes, absolutely correct. Very good. So many correct answers in the chat box. Wiskott-Eldrick syndrome. Now, Wiskott-Eldrick syndrome ka, yes, X-linked recessive inheritance hai. There is mutation in the VAS gene because of which I have defective VAS protein. Now, Wiskott ka MCQ kaise aayega, madam? A classical triad of thrombocytopenia, eczema and recurrent infections. Or if you do the peripheral smear examination of these people, you are going to see small platelets. And yes, in Wiskott-Eldrick babies, you are going to have low IgM levels, normal IgG levels, IgA and IgE levels are elevated. This is a classical presentation of Wiskott-Eldrick syndrome. Next is going to be your, yes, ataxia telangiectasia. Now, it has an autosomal recessive mode of inheritance. There is ATM mutation on chromosome number 11. Name itself is telling you the patient is going to have ataxia, abnormal gait. The patient is going to have telangiectasia, yani ki vascular malformations. There's going to be neurological deficits, increased incidence of tumors and immunodeficiency. See, increased incidence of tumors. I just told you. Which DNA repair defect? Homologous recombination repair defect. Yes, it can cause ataxia telangiectasia leading to cancers. Now, the last one is going to be your hyper IgM syndrome. Now, basically, what is the problem here is that in hyper IgM syndrome people, there is defect in either CD40 और CD40 ligand. दोनों में से कोई भी एक डिफेक्ट हो सकता है, because of which the class switching is not possible. और आपको पता ही है, माइक्रोबायोलॉजी आपने पढ़ी है, if class switching is not possible, that means there is going to be only IgM antibody production happening. That's why it is called as hyper IgM syndrome, right? So और कोई antibody नहीं बनेगी. That's why this patient is going to have recurrent bacterial infections in respiratory tract and GIT. Ma'am, a classical MCQ presentation, recurrent infection with pneumocystis jirovecii is equal to hyper IgM. और हम बोलते हैं ना, excess of everything is bad, because इतना ज़्यादा IgM will start reacting against my own body cells. If it start reacting against my own RBC, I'm going to have autoimmune hemolytic anemia. If it start reacting against my own platelets, destroying them, leading to thrombocytopenia. So this is your classical, yes, hyper IgM syndrome, right? Now, there was a question in your NEET previous year that question दिया गया था आपको, एक biopsy image दी थी, that was your papillary carcinoma of thyroid, और उसमें आपसे पूछा गया था कि which mutation, and the correct answer was, क्योंकि इसमें orphan nuclei था, so the correct answer was your papillary carcinoma of thyroid, right? So BRAF पूछा गया है, so obviously I think, yes, I want to give you a last minute list. बहुत सारे हैं, but these are the last minute ones which I want you to remember, the cancers and the genes associated with them, right? So please, let's start one by one. So yes, RET mutation, MEN2A, MEN2B and medullary carcinoma of thyroid, ALK, lung adenocarcinoma and ALCL, anaplastic large cell lymphoma. Yes, it will be uploaded. तुम लोग focus क्यों नहीं करते हो? Focus करो यहाँ पे. CKIT, yes, very important. जिस CKIT का दूसरा नाम, it is also called as CD117, ABL, CML, ALL, KRAS mutation, colon carcinoma, pancreatic carcinoma, CMYC, yes, very, very important, starry sky appearance, Burkitt's lymphoma, LMYC, yes, small cell lung carcinoma, EGFR, which is also called as ERBB1, causing lung adenocarcinoma, ERBB2, also called as HER2, causing breast carcinoma. Yes, this was the one which was asked. BRAF mutation, hairy cell leukemia. मैं बोलती हूँ HCL, then reverse the alphabets. LCH, Langerhans cell histiocytosis, and yes, papillary carcinoma of thyroid. Yes, APC, FAP associated colorectal carcinoma. P10, Cowden syndrome, और इसका निमोनिक क्या था? काउ पे क्या लगाओ? बेट लगाओ. Cowden syndrome, the mnemonic is bet. कौन कौन से cancers होंगे? B for breast carcinoma, E for endometrial carcinoma, and T for thyroid carcinoma. Yes. Next is your VHL gene. Yes, mutation VHL syndrome. What are the collections in VHL? This was also one of your NEET PG PYQs. Clear cell RCC. Clear cell RCC, yes. Cerebellar hemangioblastoma and pheochromocytoma. RB gene, retinoblastoma, osteosarcoma. Next is P53 gene, right? P53 gene, Lee-Fromani syndrome. और Lee-Fromani syndrome में किसका collection होता है? Which tumors? Sarcomas, leukemias, breast carcinoma, brain tumors. And yes, if I'm talking about P53, I have to talk about HPV. HPV causes what? Cervical carcinoma. Why? Because of two proteins of HPV. E6 will inhibit P53 gene and E7 will inhibit RBG. Next is your, yes, BRCA1 gene. BRCA1 gene, breast carcinoma in females and ovarian carcinoma. BRCA2, very, very important, breast carcinoma in males and breast carcinoma in females and prostate carcinoma. Yes, MMR genes, HNPCC और Lynch syndrome. अभी हमने बात भी करी थी, your MMR mismatch repair defect. STK11 और LKB1, yes, Peutz-Jeghers polyp. SMAD4, yes, juvenile polyp. CDH1, diffuse type of gastric carcinoma, lobular type of breast carcinoma. If you can remember, signet ring cells. और breast में, yes, there was your Indian file pattern. ठीक है जी? So ये आपकी list थी of all the important mutations that I want all of you to remember, right? So this was all from my side. See guys, I have tried to compile all the important things in just a short span of time for your journal pathology. ये तो आपने देख के जाना है. मैंने सारे previous year topics compile किए हैं and I'm really rooting for you guys. मेरी तरफ से बहुत सारी best wishes. बस एक ही request है, लास्ट डेज बचे हैं, कुछ नया नहीं उठाना है, जो पढ़ा है वही रिवाइज करना है और हम आपके लिए वो चीज़ कर रहे हैं. वी हैव कम अप विद दिस सेशन सो दैट यू गाइज कैन रिवाइज विद अस. सो जस्ट बी फोकस. लास्ट लैप है, मेहनत करके सारी मुश्किलों से हम आसानी से बाहर निकल जाएंगे एंड वी आर ऑलवेज देयर विद यू. सो बेस्ट ऑफ लक एंड बी देयर फॉर योर नेक्स्ट सेशन. योर नेक्स्ट फैकल्टी इज कमिंग. ओके, सो टेक केयर, बाय बाय, थैंक यू.
Hi everyone. Am I audible? Am I visible? If I'm audible, not visible, then just rejoin, just like how I am doing. Yeah, perfect. So we are going to quickly revise anesthesia. All right. Wonderful. So you guys have been upbeat about everything, and we had two wonderful sessions with surgery and Dr. Shagun, which I was a part to. And so let's dive into anesthesia, and we know anesthesia is a relatively easy subject. So we'll just quickly go through everything that is very, very relevant. So factors affecting or factors for difficult laryngoscopy and intubation. We know we can remember it using a mnemonic lemon, that is looking externally, looking for certain obvious signs of difficult airway like facial trauma, large incisor, beard of mustache, high arched palate, large tongue, evaluating certain distances, that is the rule of 332, that is looking at mouth opening, which is one of the most important rules, has to be more than 3 finger bits. Malampatti score of equal to more than 3. Obstruction, that is looking for everything that is going to prevent you from putting the tube through the vocal cords. And then finally neck mobility, and a restricted neck mobility is a predictor of difficult airway. Let's come to the most common question asked from airway assessment, Malampatti classification. Malampatti classification. So what are the 4 structures that you look for in Malampatti? Push, pillar, uvula, soft palate, hard palate. Based on visualization of push, you have 4 classes, 1, 2, 3 and 4. We will only discuss the catch points of each. Class 1, what is the catch point? What is the catch point? All 4 structures are visible. Class 2, what is the catch point? Only tip of uvula is missing. Class 3, what is the catch point? Only base is visible. Class 4, what is the catch point? Only hard palate visible. Class 0, what is the catch point? Epiglottis is visible on mouth opening. Epiglottis is visible on mouth opening. What is the interpretation? 1 and 2 are easy airways. 3 and 4 are difficult airways. and Malampatti class 0 has no correlation to difficulty. No correlation to difficulty. Malampatti is a airway assessment tool. It's a airway assessment tool, but final confirmation of difficulty of airway, Cormack and Lehane classification, again visualization of 3 structures on direct laryngoscopy. On direct laryngoscopy, which is epiglottis, vocal cords, posterior commissure. When you can see all 3 of them, 1. When you have predominant view of posterior commissure, 2. When you have hanging epiglottis, 3. And when no glottic structures are visible, 4. Grade 1 and 2, where vocal cords are visible, would obviously be easy airways. Where they are not visible, difficult airways. Difficult airways. Alright, so Malampatti, Cormack Lehane, MPG, MPC, or CL grade or CL classification, both 1 and 2 easy, 3 and 4 difficult. Ideal position for intubation. What is not an ideal position for intubation? It is not Rose position. It is not Rose position. It is very important that you write it and cross it. Not Rose position. Ideal is barking dog or sniffing. Involves extension at atlanto-occipital joint and flexion at lower cervical joints. Extension at atlanto-occipital joint and flexion at lower cervical joints. Lower cervical joints. Okay. Last year's question, identification of this. This is a nasopharyngeal airway. This is a oropharyngeal airway. You will never have a problem in identifying the oropharyngeal and a nasopharyngeal airway. Only if they give a uncuffed endotracheal tube along with a nasopharyngeal airway. Uncuffed endotracheal tube along with a nasopharyngeal airway. How will you differentiate between an uncuffed endotracheal tube and a nasopharyngeal airway? Uncuffed nasopharyngeal airway would have no markings. It will be opaque and it will have no connector for connection to the circuit. No markings, opaque, and no connector. Okay. The purpose of both oropharyngeal and nasopharyngeal airway is to prevent tongue fall. Prevent tongue fall. Whenever somebody loses consciousness, the tongue falls back posteriorly, causing tongue fall. How can you relieve tongue fall without introducing anything in the oral cavity? So for tongue fall, the first thing you can do is head tilt, chin lift. The first thing you can do is head tilt, chin lift. Okay, head tilt, chin lift. LMA. It is a device which is between a endotracheal tube and a face mask ventilation. 2 types. First generation only airway tube. Second generation additional drain tube. Only one example of a first generation classic. You can have unique, which is a disposable variant of LMA. It is a disposable variant of first generation LMA. You have ProSeal, Supreme and iGel as the 3 second generation LMAs. Second generation LMAs. How would you identify? Just look at the tube. One tube, first generation LMA. What does this look like? LMA Classic. LMA Classic. Alright. If you have 2 tubes, it is called as a second generation LMA. 2 tubes. 2 tubes. How would you identify? Look at the shape. No shape, ProSeal. Anatomical shape, Supreme. Anatomical shape, Supreme. Intubating LMA is a special type of LMA. It doesn't come in first and second generation. You don't use intubating LMA for intubation. Okay. You don't use intubating LMA for ventilation. You only use it for intubation. This is I-gel. 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 Why not left lateral position for avoiding tongue fall? Because that is simply going to, you have to change the entire position of the patient. I'm talking of managing the tongue fall while the patient is supine. While the patient, if you do it in prone, then also there is no tongue fall. But will you give the patient prone position? No. So try to understand, you have to give oxygen also. You have to manage the patient also, right? So managing airway means while the patient is supine and there is tongue fall, there is obstruction, the maneuver that you have to do is head tilt chin lift. Okay. All right. Technique of laryngoscopy. In which hand do you hold the laryngoscope? In which hand do you hold the laryngoscope? Left hand. Always left hand. Insert from right angle of mouth. Applied force. Would you use your wrist joint? Would you use your wrist joint like this? No, you will lift forwards and upwards. And when you use your wrist joint, then you cause most common complication, that is trauma to upper central incisors. Trauma to upper central incisors. Trauma to upper central incisors. All right. Endotracheal tube. In FMGE exam 2 days back, they gave a tube and asked what is the function of this thing. So parts of endotracheal tube. This is the patient end. This is the machine end. Machine end has a universal connector. Patient end has bevel, which is always facing left. Improves visualization of vocal cords during intubation. Murphy's eye. Second ventilation port. Cuff prevents aspiration. Cuff prevents aspiration. Cuff prevents aspiration. That was asked 2 days back in your FMG. Cuff prevents aspiration. All right. If you are not able to intubate somebody, difficult airway, which is a unanticipated difficult airway. Unanticipated difficult airway. Unanticipated difficult airway. What would you do? 4 plans. 4 plans. Plan A, face mask ventilation, that is you'll do laryngoscopy and intubate. Plan B, oxygenate using a SAD. When you fail in plan C, face mask ventilation and waking the patient up. If you are not able to do that, this condition is called as CICO. CICO, can't intubate, can't oxygenate. What would you do? Front of neck access, emergency cricothyroidotomy. Again, asked in your FMG exam 2 days back, somebody who is having maxillofacial trauma, you are not able to intubate and ventilate. What are you going to do? Emergency cricothyroidotomy. Remember, tracheostomy is not an emergency airway access. It is a definitive airway access. But initially, when you have an emergency, you don't have time, you will go for emergency cricothyroidotomy. Emergency cricothyroidotomy. ASA physical status classification. It is done for risk assessment. Divide the patient based on his own clinical condition into 4 classes. Class 1, 2, 3, 4. Class 1, normal healthy adult. 2, mild controlled systemic disease. The most important example to remember, normal pregnancy, which is considered as ASA2, normal pregnancy. 3, severe systemic disease, that is limiting but not incapacitating, like uncontrolled hypertension, diabetes, chronic smoker, alcohol addict, ESRD on regular dialysis, and history of coronary artery disease, stroke, MI, stent. If not intubated, we'll do LMA, but the question said was not able to intubate and ventilate. So it was very specifically given you are not able to do plan A as well as plan C. And anyway, in maxillofacial trauma, would you want to use an LMA? It's one of the contraindications to use an LMA, right? Because it is a condition associated with, increased risk of aspiration. All right. 4 is a severe systemic disease that is a constant threat to life, like ESRD, not on regular dialysis, severe sepsis, and history of all those 5 conditions in less than 3 months old. 5 is a surgically emergent condition. 6 is a brain dead organ donor. 6 is a brain dead organ donor. So 1, 2, 3, and 4 are all medical problems. 5 and 6 are surgical issues. Multi-para monitor. What does this tell you? ECG. Which is the most common ECG lead used? V4, V5, lead 2. What is this telling you? Pulse oximetry. What is the principle for pulse oximetry? Beer-Lambert law. What is this telling you? Once again, asked yesterday. Capnography. Capnography is measurement of end tidal CO2 concentration. And tidal CO2 concentration. Whenever you get a capnographic waveform, you have to use this clinical approach to capnography. Clinical approach to capnography. First, see what is given in the question: hypo or hypercapnia. Hypocapnia less than 35, hypercapnia more than 45. Then see whether gradual or sudden. Gradual hypocapnia where the graph is decreasing, hyperventilation, hypotension, graph is slowly going down to 0, ill-sustained capnograph, esophageal intubation. Sudden hypocapnia, sitting position given during the surgery, venous air embolism, goes to 0, cardiac arrest. Gradual hypercapnia, graph touching the baseline, hypoventilation, not touching the baseline, rebreathing of CO2. Sudden hypercapnia, which is seen intraoperatively, malignant hyperthermia during CPR, ROSC, return of spontaneous circulation. So everything that will be asked to you will be done by this except bronchospasm. So there would be a history of allergy or a histamine releasing drug, and you will get a shark fin appearance. You will get a shark fin appearance. Scoline. Just quick facts about scoline. Fastest, shortest overall. Metabolized by pseudocholinesterase. Prolonged in deficiency. Genetic variant phase 2 for genetic variant diagnosis is Debucane number. Debucane number. Causes fasciculation, myalgia, hyperkalemia, risk of malignant hyperthermia. So avoid in hyperkalemia. Increase in ICP, open eye injury, myotonica dystrophica, and indicated for RSI. Which NDMR can replace choline for RSI? ROC can be used in RSI if choline cannot be used. If choline cannot be used. Alright. Neuromuscular monitoring. This is a neuromuscular monitoring. Most of the time you get this image. Again, FMGE exam, we got this image 2 days back. Something which has been asked to us in the past. Most common nerve muscle combination use: ulnar nerve adductor pollicis muscle. Second most common, facial nerve orbicularis oculi muscle. 3 methods of recording of response: mechanomyography, gold standard, acceleromyography, most commonly used. 3 patterns of stimulation. Most common used pattern is strain of 4. 4 stimulations given over 2 seconds. How do you identify the type of block? Fade on TOF is a feature of NDMR. That is the one that you have to remember. Fade on TOF is a feature of NDMR. Fade on TOF is a feature of NDMR. We use 2 concepts, TOF count and TOF ratio. Count is number of twitches observed on TOF stimulation used for intubation. TOF counts 0 or 1. Maintenance 1 or 2. TOF ratio, fourth to first twitch ratio, normally has to be 1. For extubation you will use 0.9. For extubation you will use 0.9. Inhaled anesthetic agents. Pharmacokinetics. Blood gas partition coefficient decides the solubility in the blood. Inverse relationship to speed of onset and recovery. Order of lowest to highest solubility, that is fastest to slowest. fastest to slowest. Xenon is fastest. Look at the order CO, ISO, halo. Look at the order CO, ISO, halo will always follow the same order. CO faster, then ISO, which is faster than halo, then MAC tells you about the potency. Lower the MAC, higher the potency. Again, order of MAC from highest to lowest, that is least potent to most potent. So nitrous oxide least potent, follow CO, ISO, halo. CO less potent than ISO, which is less potent than halo. Metabolism tells you about the toxicity, highest toxicity in modern anesthetic agents. Halothane causes halothane hepatitis. Halothane hepatitis. No toxicity of nitrous oxide and xenon. Pharmacodynamics. All inhaled anesthetic agents are myocardial depressants except nitrous oxide. All agents increase respiratory rate, decrease tidal volume. No exception. All increase ICP, no exception. All decrease CMRO2 except nitrous. All cause muscle relaxation except nitrous. All trigger malignant hyperthermia except nitrous. All are tocolytics except nitrous. Okay. So we know nitrous oxide is an exception. Let's look at agent of choice. Raised ICP surgery. The one thing you have to remember, thiopentone. Neurosurgery. One thing you have to remember, propofol. You don't prefer an inhaled anesthetic agent for the maintenance, but if you do for both the condition, you will prefer SIVO. Otherwise, your choice of maintenance is TIVA, total intravenous anesthesia. Cardiac patient, you want in IV induction agents, etomidate. In inhaled anesthetic agents, isoflurane. Pediatric patient, for ease of induction, inhalational induction preferred over IV. If inhalational SIVO, sweet smelling fast. If IV, ketamine, painless. Daycare surgery, your choice of induction agent as well as for maintenance is propofol. In inhaled anesthetic agent, you will prefer sevoflurane. In ECT, you want to avoid anticonvulsant agent. So agent of choice is methotrexate, not given in the option etomidate, not given in the option ketamine. And your choice of airway is LMA. Asthma, maximum bronchodilation. So remember, you don't talk about safety when you are talking about only asthma. So the question says inhaled anesthetic agent of choice for asthma. Don't think about safety, only think about bronchodilation. Mark halothane. IV induction agent ketamine. Basically avoid any histamine releasing drugs. What are the drugs that release histamine? Thioscoline, Miva, Atra, morphine, meperidine. Morphine, meperidine. All right. So avoid these agents. PIH, pregnancy-induced hypertension, epidural will always be your choice, and heart disease in pregnancy, you will prefer etomidate, except the three conditions where you give GA, coarctation of aorta, Eisenmenger syndrome, and uncorrected TOF. That are the only three conditions where you will directly go for GA. Now, the two complications that are a must for you, and malignant hyperthermia is something that is asked every year. I'm expecting this year they will ask venous air embolism. What are the triggers for MH? Succinylcholine, volatile anesthetic agent. That means all inhaled anesthetic agents except xenon and nitrous oxide. VAE, always remember, sitting position surgery. Pathophysiology, mutation in RYR1 gene. Again asked yesterday, in day before yesterday in FMGE exam. Excessive calcium release, sustained muscle contraction, hypermetabolism. Entry of air into the venous circulation for VAE causing blockage of pulmonary artery, increasing pulmonary artery pressure, and right heart strain. Clinical features, most important, increased end tidal CO2, tachycardia, masseter Here there would be sudden and abrupt drop of EtCO2. So rise of EtCO2, MH, drop of EtCO2, venous air embolism. How do you diagnose malignant hyperthermia? Preoperative diagnosis, gold standard, caffeine halothane contracture test. Otherwise, sudden and abrupt rise of EtCO2. Most sensitive invasive modality for diagnosis of venous air embolism is transesophageal echocardiography. Otherwise, you can use precordial Doppler, which is most sensitive, non-invasive, and sudden drop in EtCO2. How can you prevent? Avoid triggering agents. Give a TIVA based anesthesia. Don't use volatile anesthetic agent. Avoid surgical positions that promote air entry. Tight closure of venous opening. Use air filters in intravenous line. How do you treat malignant hyperthermia? Remember dandrolin, skeletal muscle relaxant, agent of choice, 2.5 mg per kg IV bolus. And here, stop the surgery, flood the field, bilateral jugular compression, and aspirate using a central venous catheter. Aspirate using a central venous catheter. All right. Pharmacology of local anesthetics. Mechanism of action: blocked voltage gated sodium channel. So any drug that blocks the sodium channel is a local anesthetic. Order of susceptibility of nerve fibers. And I am folding my hands and begging you not to ask this question again to me. And just remember A, gamma, delta, alpha, beta, B, and C. A, B, C. Please don't ask this question again. The order was, is, and will always remain A, B, C. There is no confusion here, and there should be no confusion to you. That is my humblest request to you a week before the exam. Please don't get trapped. Toxicity, CNS, CVS. CNS is always early. You initially get excitatory symptoms, then you get depressive symptoms. How can you just make sure that you stop LA and you give benzodiazepines or barbiturates for seizures? CVS appears late and a grave form of toxicity, and most cardiotoxic LA is bupivacaine. The idea is to give lipid emulsion, which is given as a bolus dose of 1.5 ml, 1.5 ml per kg, 1.5 ml per kg bolus, followed by 0.25 ml per kg per minute. This is very, very important. This has been asked 3-4 times in the last 5 years. Okay. Methemoglobinemia, seen only with prelocaine and benzocaine, and because EMLA, eutectic mixture of LA, contains prelocaine, so the potential complication of using EMLA is that it can cause methemoglobinemia. It can cause methemoglobinemia. Something that we don't use anymore but is very frequently asked in the exam: intravenous regional anesthesia, Bayer's block, where you give for peripheral arm, peripheral forearm, wrist and hand surgeries, or leg, ankle, foot surgeries. You exsanguinate the limb and you inject local anesthetic intravenously. So you will always get an image where there is a BP cuff and there is an IV line, and they are giving a local anesthetic for a regional anesthetic technique. Because you are injecting intravenously, you prefer safer drugs like prelocaine or lignocaine. If prelocaine in the option, then you will mark that, otherwise lignocaine. And absolutely contraindicated is bupivacaine. Why? Because it is most cardiotoxic. Let's come to oxygen delivery devices. So just remember these 4. Nasal cannula works between 1 to 6 liter per minute. FiO2 24 to 44%. Just add 4% FiO2 per liter of oxygen. That is the formula, right? It is simplest device, very well tolerated, doesn't affect eating, talking, limited FiO2, drying of nasal mucosa is a disadvantage. Simple face mask, works between 5 to 10 liters per minute. Venturi gives a fixed FiO2 identified by Venturi valve, and NRBM gives maximum FiO2. So just remember fixed FiO2, maximum FiO2. How would you identify? Nasal cannula will look like a cannula put in the nose. This is Hudson's mask or face mask. This is non-rebreathing mask, face mask with reservoir bag, and a Venturi mask which has Venturi valves, which are different colored valves. Let's come to CPR. The most important part of CPR is the 5 do's and 5 don'ts of high quality CPR. 5 do's are compression rate 100 to 120 per minute. That means not less than 100, not more than 120. Then depth at least 2 inches, not less than 2, not more than 2.4. Allow adequate chest recoil between the compressions. That is, do not lean on the chest between compressions. Then ventilate adequately. That is, for every 30 compressions, give 2 breaths. Do not over ventilate and do not stop for more than 10 seconds. Do not interrupt compressions for more than 10 seconds. Every year you get one question from this. So this is a sure shot. I'm telling you, I'm giving you a key for your exam. This is going to be asked. So please remember these 10 points. One question is done. What do you do in an event of cardiac arrest? Chest compression, airway, breathing. Airway, patient's own airway. Head, tail, chin lift or jaw thrust. When you do three things together, head, tail, chin lift, jaw thrust and mouth open, you call it triple maneuver. Has been asked 3 years back. 5 differences between adult and pediatric CPR. 5 differences. Activation of emergency response system. Unwitnessed collapse in a pediatric patient. First, give 2 minutes of CPR before leaving the victim to call for help. Compression to ventilation ratio without advanced airway to rescuer in a child is 15:2. With advanced airway, 1 every 2 to 3 seconds. Depth of compression for a children is about 2 inches, for an infant is about 1.5 inches, and hand placement when you are two rescuer, then 2 thumb encircling technique is preferred over a 2 finger technique. Cardiac arrest rhythms. 4 cardiac arrest rhythms. 2 are shockable, VF and VT, and 2 are non-shockable, asystole and PEA. Which are amenable to shock are VF and VT. Which are not amenable to shock are asystole and PEA, pulseless electrical activity. All right. Let's look at the algorithm. What is the first step in a cardiac arrest or a collapsed victim? First step, always verify the scene safety. Always verify the scene safety. Then once you have verified, the second step is to check for responsiveness. If the patient is unresponsive, the third step is to call for help. Third step is to call for help, and only then you start with pulse and breathing check. So pulse and breathing check in CPR is the fourth step. Once you do that, 3 scenarios: pulse present, breathing present. What do you need to do? Give recovery position to the patient. Since 2 years this has been asked very frequently in the exam every year. Unconscious victim with pulse and breathing present. What do you give? Recovery position. Turn on one side, one hand under the cheek and one leg over another, called as recovery position. Pulse present, no breathing, rescue breaths, mouth to mouth or mouth to mask, 1 every 6 seconds. No pulse, no breathing or gasping breathing is when you will start CPR in the cycles of 30:2. 5 such cycles over 2 minutes. In the meantime, somebody will get an AED. You will check the rhythm. The AED will check the rhythm. If it is shockable, press shock. What do you do immediately after shock? What do you do immediately after shock? What do you do immediately after shock? Very good. Resume CPR. Immediately after shock, resume CPR. But if it is non-shockable, just continue CPR till the AED arrives. Keep analyzing the rhythm after every 2 minutes and continue CPR. In the meantime, the ACLS team will come. They will always arrive in a scenario where cardiac arrest has happened. So they will immediately start CPR, give oxygen, attach monitors, analyze rhythm, shockable, press shock, first shock. Immediately resume CPR, start taking an IV IO line, analyze rhythm, rhythm shockable, press shock. What do you do? Second shock. Then start giving drug of choice, which is epinephrine, given 1 milligram dose, dilution 1 in 10,000, given every 3 to 5 minutes, infinite doses. Again analyze rhythm. If it is shockable, give third shock. Now give the second drug of choice, that is amiodarone or lignocaine. Amiodarone or lignocaine. Right? Amiodarone or lignocaine can only be given 2 times. Amiodarone first dose 300 milligram, second dose 150 milligram, and lignocaine first dose 1 to 1.5 milligram, second dose 0.5 to 0.75 milligram. If your patient is in non-shockable rhythm, just give epinephrine ASAP and continue CPR. A very, very important scenario that has been asked to you almost every year, and even last year it was asked, is foreign body obstruction. Foreign body obstruction. Just a second. Just a second. I don't know why this last slide is. Yeah. So when you have a foreign body obstruction or a choking victim, then first thing to see is whether it is a partial foreign body obstruction or a complete foreign body obstruction. How would you know whether it is partial or complete? If it is partial, the patient can produce any sound. If the patient cannot produce any sound and gives a universal choking sound, then that is a complete foreign body obstruction. Do not do anything with partial foreign body obstruction. Send him to ENT surgeon or promote them to cuff. But complete foreign body obstruction, you have to immediately treat. Start by assessing responsiveness. If responsive, less than 1 year, you will give 5 back blows, 5 chest compressions. If more than 1 year, you will give Heimlich's maneuver. But if your victim is unresponsive after foreign body obstruction or during the management of foreign body obstruction, what will you do? Call for help and start CPR. This is what is going to be asked this year. Last year you got a question, you are sitting in a restaurant, somebody chokes on food. What is the first step that you will do? You will say start Heimlich's maneuver. This year they will give the same question but give the patient is unresponsive. What will you do? Resume CPR. Alright. So this is what I wanted to discuss in anesthesia. I went fast because the revision is supposed to be fast and you know most of the things and you have your DVTs and your LRRs to go through it, and this video will be available. There's no question of asking that question. It is YouTube. Ultimately this session is going to be forever there. So you can always go back and check again these things. My best wishes are with you. Keep calm. In the last few days, focus more on good food as well as good sleep. If you are well slept and you are well fed, you'll feel happy. If you feel happy, you will perform better in the exam. All the very best.
Hi guys, good evening all of you. Welcome to this. Hi guys, good evening all of you. Welcome to this marathon session which we are running for all of you. Now, before I just set in the tone, I would just like to tell you that this marathon session is important because in probably 30 minutes you get all the good points which you should be focusing for the exam. Okay? So now we'll start the series of PSM where both me and Kashyap sir will be taking up the session. Okay? FMGE exam was there just a couple of days back. That's the reason if you ask me, question pattern is very clear. Ki boss, questions will be easy, but they would be asking 2 or 3 questions which will be out of the way. Baaki sab apne note se aayega. ठीक है? Done? Okay. Measures of central tendency. First and foremost, let me tell you the common mistake which students do is when they calculate the median. In median, do not forget to arrange in ascending or descending order. Yes, guys? Now, why I am telling you, in the year NEET 2024, the question was 132 and they asked what is the median. Bina soche samjhe, students answered that the answer is 3. It is wrong. Why it is wrong? The first thing which you should answer is 1, 2, 3. Yes, guys? So over here you need to understand that the median will be 2. The median would be 2. I hope I'm clear with this. Yes, guys, I hope I'm clear with this. No doubt. Yes. Mean, arithmetic mean, they would ask you to basically arrange in ascending or descending order, and mid value, yes, guys, is the issue. Yes. I hope everything is clear. Okay. Yes. Done. Okay. Yes. Everything's clear. Good. Now, so hello guys, we are starting with the PSM session in which I am telling you the key points which you should be looking into measures of central tendency. Now, measures of central tendency are only 3. That is the mean, the median and the mode. Please understand, in mean, arithmetic mean is the most common one. When we talk about median, do not forget to arrange in a sequence. If you arrange in a sequence, the mid value becomes the median. Mode is the most frequently occurring. Preferred measure of central tendency in case of a normal distribution. What is a normal distribution? Mean equal to median equal to mode is the mean. In case of a non-normal distribution, mean not equal to median not equal to mode is the median. Outlier, extreme value. Just like if you would have seen the scorecard, your Shubman Gill scoring 700 plus run against England, whereas Karun Nair scoring only 70 runs. Outlier, extreme value. Okay? So, in case of outlier, most affected is the mean. least affected is the mode, most preferred is the median. ठीक है, bimodal, there can be two modes which can come. ठीक है, now range, minimum to maximum value is the range. Standard deviation is root mean square deviation. You can get a formula to identify x minus x bar divided by sample size. You can get this question where they can ask you the formula of standard deviation. Standard error root over pq by n, standard error sd by root over n, z score x minus x bar by standard deviation. COV, please remember, it is used to compare two dissimilar variables. Like if I want to compare the systolic blood pressure versus height, I will use a COV. But imagine I have to compare the systolic blood pressure of boys and girls. Then I will use another indicator which is called as variance. Variance is standard deviation whole square. ठीक है, तो इस चीज पे ध्यान रखेंगे that you should not miss out on this. Formula for COV is SD by mean into 100. ठीक है, no problem. Okay. Bell shaped curve, bilaterally symmetrical, area under the curve 1, standard deviation 1, variance 1. तीन 1 है. There is only one which is 0. So NEET में commonly a question आता है where they ask which of the following is true for standard normal curve except. This image is called as the standard normal curve. ठीक है. Now theorems, definite question, ये पक्का आने वाला इस बार guys. ठीक है. Mean is equals to median is equals to mode is equals to prevalence. Plus minus 1 standard deviation is 68. Plus minus 2 standard deviation is 95. Plus minus 3 standard deviation is 99. 100% आएगा. कैसे आएगा? They will say that height जो है that is 150 centimeter. They will say SD is 10 and they will ask you the range of plus or minus 2 SD. So करना कुछ नहीं है. 150 plus minus 2 into 10. आंसर विल बी 130 to 170. ठीक है, सो भूलना नहीं है, ये एब्सोल्यूट इंपॉर्टेंट है. ठीक है. नेक्स्ट, नॉर्मल में मीन इज इक्वल्स टू मीडियन इज इक्वल्स टू मोड. द मोमेंट वी से इट इज अ राइट और पॉजिटिव स्क्यूड, mean will be maximum. Remember the direction of skewness, mean is always on that side. So left or negative skewed, mean will be minimum. Uniform bimodal, mean will be equal to median, not equal to mode. ठीक है, I hope I am clear with this. ठीक है. Now this image can come, you have to just identify. So here it is a tail right skewed, here it is a tail left skewed. This is the uniform bimodal. ठीक है. Now quantitative, how much, height in centimeter, quali, how is it? So if I talk about birth weight, low birth weight or normal, it is quali. Whereas if I say mean birth weight, then it will be quanti. So be very careful about it. Do not just mug up. वैसे if I say hypertension, yes or no, it is quali. But if I say mean systolic blood pressure is 140 mm of mercury after seeing the movie Sayara, then it will be quanti. ठीक है. So be very careful with this. Binary, only 2 answer, boy girl. Polytomous, more than 2 answer, tall, intermediate, short. Discrete, can't take in between values. जैसे heart rate है 72 per minute, 73 per minute, no 72.5, ऐसा नहीं हो सकता है. Continuous, where you have a continuous 13.4 hemoglobin, 13.6 hemoglobin. ठीक है. Categorical scale is for quali. Nominal is names only, that is male and female. Ordinal is ordered data, जैसे कि TNM staging. Metric is quanti. Likert is a ordinal scale summarizing human behavior. Please understand, Likert में ना we can calculate the median or the mode. We will never be able to calculate the mean. So if I ask you, yes, how much do you like your Ananya Pandey, you will put up a Likert scale and you will say, sir, this much. ठीक है. But when you say how much do you like Deepika Padukone, it will be this much. Yes guys. So this is a ordinal scale. You are summarizing the human behavior. ठीक है. Now important, bar, quali data which is discrete. So you will get a image based question. Please ध्यान रखना, gap होएगा. There will be a gap. Histogram, it is continuous. There will be no gap at all. Line diagram will tell you about trends, number of students who are appearing NEET PG, trends. Spot map, geographical distribution, different centers of NEET PG over India. Venn diagram, overlap, students who get NEET and INICET both. Tree diagram talks about the spread. Scatter diagram, relationship. इसको नहीं भूलना, scatter diagram is relationship. ठीक है, done? Okay. पक्का क्वेश्चन आएगा इससे, डेफिनेट है इस बार क्वेश्चन आना. एंड दे विल आस्क यू स्ट्रैटिफाइड. इफ दे राइट माइल्ड, मॉडरेट, सिवियर, so they are looking into a meaningful division of the disease. It is stratified. If they say that they are talking about disease, yes or no, yes, then it is quali data. But if they are putting as mild, moderate, severe and there is a meaning, or they are talking about hemoglobin and they are saying male, female, these are all examples of meaningful data. So be very careful. It will be meaningful. It will be stratified. Okay. So convenient means as per my choice. Simple random means random or lottery numbers. Quota means meaningful non-random. Stratified is meaningful random. Be very careful in the question. Random selection why or non-random. Now guys, because quota and stratified are absolutely same. The only difference is stratified में random होता है, quota में it is non-random. Cluster, it is non-meaningful. ठीक है? So be very careful whether the question gives you a meaning or not. Systematic is orderly. Multi-stage or multi-phase will be more than 2 stages. I hope I'm clear with this. So generally immunization पूछेगा, so it will be cluster, because in cluster a very important example is WHO immunization coverage evaluation survey. Okay Aishwarya, looks fine. Now tests, पक्का question, guaranteed question आएगा. Para, non-para. Parametric is done for quanti data where we compare mean. Non-parametric is done for quali data where we compare median or proportion. Be very careful of the keywords. Proportion is quali. ठीक है? Now groups. सबसे पहले look whether there are 2 or more than 2 groups, whether it is paired or unpaired. If it is quali, just close your eyes and say it is chi-square. No confusion. There is no other test which can be an answer. Quanti, 2 groups, more than 2 groups. 2 groups, it is t-test. If it is unpaired, then unpaired t-test. If it is paired, then paired t-test. More than 2 groups, it is ANOVA. ठीक है? So I hope I am clear with this. ठीक है? Now, Sana, random का example, lottery method. ठीक है? Like they take out lottery. Who will qualify NEET PG this time? Yes, so Sana is going to be picked up in the lottery. Yes, random method. ठीक है? Now, sir, class section, girl boy division will be stratified or systematic. Now, beta, please try to understand. It depends upon what are you looking at. Suppose they ask about prevalence of dating and you're selecting girls and boys. It is stratified, meaningful, hai na? Yes, but imagine they are just saying that you want to just randomly take kids, okay? And you are just taking girl boy, something like that. Then non-meaningful hai, okay? So it will depend upon the research question whether it is meaningful or not. I hope I'm clear with this, Sarjan. Okay? Okay. Now, please understand the cell 1 is confidence. Now, what is confidence? When null is sahi in both. What is power? When alternate is sahi in both. What is type 2 error? Be very careful with this. When in reality the HA is right and in RCT the H0 is right. Okay? Now here, when in reality H0 is right and RCT HA is right. Be very clear with this. Many times you are going to get a question over here. Okay? Done. So just understand, read the question carefully. This is the only thing which makes a difference. Decide in reality and in RCT which hypothesis is correct. Like if I say in reality H0 is true, okay? Now in RCT HA is true. So if that is the case, H0 HA, यहाँ पे H0 सही है, यहाँ HA सही है, यहाँ intersection हुआ, it is alpha. I hope I'm clear with this. Now paired unpaired एक बार बता दो. See guys, please try to understand what is unpaired. Students doing this marathon session and students not doing this marathon session, unpaired. Whereas your score before the marathon session and after the marathon session, paired. Salman Khan's acting in Dabang 1 versus Dabang 2, paired. Salman Khan's acting versus Tiger Shroff acting, unpaired. I hope I'm clear with this. ठीक है, कोई डाउट नहीं है, डन है. Guys, please understand, इस टेबल का खेल सिर्फ ये है, read the question carefully. If you do not read, you are dead. ठीक है, so be very very clear with it. डन है. Now type 1 and type 2, एक छोटा सा mnemonics. Type 1 error is also called as alpha, also called as p-value, also called as false positive. इसमें एक लड्डू, इसमें एक लड्डू, इसमें एक लड्डू. Do not forget the लड्डू वाला concept. 2 is beta. 2 लिखते कैसे? ऐसे, false negative. So beta में 2 लड्डू. So it is type 2. ठीक है, डन है. Now switch of the chapter. Coming to environment. Hypochlorous acid सबसे important है. 1 hour is the contact period. Residual chlorine level 0.5 ppm. ठीक है, do not forget this. एग्जाम में एकदम दिमाग का दही करता है. 1 hour 0.5 ppm देगा, हाफ आवर 1 ppm देगा, हाफ आवर हाफ ppm देगा, ऐसे बकवास करता है. प्लीज अंडरस्टैंड, यू नीड टू ओनली हिट फॉर 1 hour 0.5 ppm. ठीक है. Acts best at pH of 7. 1 chlorine tablet 0.5 grams. They have asked the dose as yes guys, looks fine. Okay, so in this hypochlorous acid is important. ठीक है. Next you should look into 1 hour 0.5, acts best at pH of 7. ठीक है. 20 liters of water. Horrocks apparatus is very important, which you should be careful of because it is used for calculation. Now it kills bacteria only, doesn't kill others. Free and residual chlorine are being estimated separately. ठीक है, done. Now free level 0.5 drinking water, post disaster 0.7. This is drinkable. Non-drinkable swimming pool 1, risk of cholera outbreak 2, killing cyclops is 5. ठीक है, done. Now coliforms, primary and most reliable indicator, E. coli most important, भूलना ही नहीं है. This is Horrocks apparatus. Please remember there are 7 cups. ठीक है. This is a chloroscope. This in his hand is orthotoluidine arsenite. Venturi meter, water will enter, water will go out. So bed flow resistance. ठीक है. This will tell you about bed flow resistance. ठीक है. Now over here you should understand this is used for a slow sand filter. Slow sand filter. Okay. Best indicator sulfur dioxide. Old answer. If option में AQI है, AQI is a better indicator than sulfur dioxide. AQI is a better indicator than sulfur dioxide. This is monitored by CPCB. More in winters. Most dangerous particle is PM 2.5. Guys, this is a mandatory question इस बार. 8 components of AQI. Mandatory question. PM 2.5, PM10, carbon monoxide, NO2, SO2, ozone, ammonia, lead. Just remember one thing. CO2 नहीं है. There is no CO2. ठीक है, डन है. Now kata thermometer cooling power. If a question comes, they will always give kata thermometer. बाकी you should just have a rough idea. ठीक है. Now this is the kata thermometer. The direction they will always give it like this. Even ऐसा खड़ा भी नहीं करते हैं. So guys, you are clear with this. ठीक है. Now these images you know, so no problem. Now AQI. Please remember Delhi. Hint आया मतलब बॉस we stay in severe. ठीक है. Now good is 0 to 50. Good is 0 to suffering from yes guys, cute girl from West Japan, suffering point from joint pain. So cute girl, Culex. West Japan, West Nile fever, Japanese encephalitis, joint pain, viral arthritis, viral arthritis. ठीक है. Now Aedes, everything which is yellow in color, everything which is yellow in color, that is yellow fever, dengue, chikungunya. Please understand, Aedes is an artificial collection. 100 meter is what we are looking at. Why? This is for yellow fever. Why is this artificial collection important? Because it is for dengue. It is for dengue. Okay. Those of you who missed out this AQI slide, guys, good is at 0 to 50. Good is at 0 to 50. Now, severe is typically seen in Delhi. So if you get a hint as Delhi, it will be severe. I hope I'm clear with this. ठीक है? Machhad में please remember, flight range is 100, but airport and seaport have to be kept free 400 meters. Be very careful of this googly question. Common mistake happens in the exam. Okay. Now, eggs, please understand, Anopheles is parallel to water surface, whereas Culex and Aedes are perpendicular to the water surface. Because they are perpendicular, they need a siphon tube for respiration. Okay. Here, there is no need of siphon tube. Okay. Now, eggs, Anopheles is typically like a boat. Culex, C for Culex, C for clusters. Aedes typically looks like a cigar. Mansonia is star shaped. Guys, why am I focusing on eggs? Larva पे question आ चुका है, adult पे आ चुका है. Most probably they will put up a question for eggs this time. So be careful. ठीक है? Now, Anopheles sits at an angle. Aedes is a tiger. Culex, there is a hump. Anopheles is parallel to water surface. Culex and Aedes are perpendicular. Remember, by looking at image, you cannot differentiate between a Culex and Aedes. Utna clarity nahi hai image mein. So do not worry for that. Gambusia will feed on the mosquitoes. Okay? Done. Over. White talcum powder, DDT. Vaseline lotion, BHC. Abate, brown color liquid. Now, green color powder, Paris green. Okay? Now, disaster vaccination. एक ही वैक्सीन 1000 बार they have asked measles vitamin A, which is given post disaster to victims. ठीक है? Now, color, red color, highest priority, most severe. Yellow, intermediate. Green, ambulatory patient. Black, dead patient. Remember, कोई blue नहीं है. So there is no confusion. This is the standard color coding for disaster. ठीक है? Now, disaster cycle. Mitigation पे question आया था. What is mitigation? Lowering the impact. This time, probably the question will be preparedness. On the 7th of May 2025, the government had announced mock drills, war mock drills. They will ask which stage it is. Answer होगा preparedness. This is probably a probable question इस बार. So do not miss out over here. ठीक है? Done. Over. Okay. Now, Factories Act, 10% with electricity or more than or equal to 20%. All pneumoconiosis except bagasosis is notifiable. Occupational cancer. 14 साल से छोटा, it is child labor. Adults 9 hours per day. With overtime, it is 60. Without overtime, it is 48. Pakka question comes from occupational health on this. ESI, medical or rehab full benefit, 100% wage. That means not even 1 rupee salary cut. Enhanced sickness, 7 days for vasectomy, 14 days for tubectomy. Maternity, 26 hafte, now it is 6 months. ठीक है? 90% wage, temporary disablement, permanent disablement and dependent. Extended sickness is 80%. Here we have 34 disease. Which 34? If you ask me, very easy. It will be an occupational cancer or it will be a pneumoconiosis except bagasosis. ठीक है? These are definitely notifiable, or some serious disease. Like this time there was a question in FMGE. Burns का criteria is more than 20%. 20% से ज़्यादा if there is burn, it has to be extended sickness. ठीक है? Sickness 70% of daily wage. Funeral expense is 15,000. ESI again a potential question in your exam. ठीक है? I hope I'm clear with this. Burns recent question था 20% से ज़्यादा burn will go to extended sickness. 20 से कम होएगा then it is only sickness. ठीक है? Now family cycle पक्का question. Formation, extension, contraction, dissolution. Formation, शादी हुई, पहला बच्चा, एक्सटेंशन पहला बच्चा से आखिरी बच्चा, कंप्लीट एक्सटेंशन आखिरी बच्चा से फर्स्ट चाइल्ड लीव्स होम. इन इंडिया नो चाइल्ड लीव्स होम, बट दिस इज अ यूएस कॉन्सेप्ट. Contraction, first child leaves home till the last child has left home of parents. Complete contraction, last child has left home till the first spouse dies. Dissolution, first spouse dies till the death of survivor, that is extinction. Again family cycle, mandatory question आएगा ये, ठीक है. Now types of communication, one way or didactic. Yes, TV, newspaper, radio, everything is minimum. Two way or Socratic. Socratic is the name of great Socrates. FGD, panel, symposium, workshop, face to face, counseling and advice, everything is good. ठीक है, everything is good. ठीक है. Now focus group discussion, do not forget the number of people, 6 से 12. ठीक है, they will discuss on one issue. Panel discussion versus symposium, S for symposium, S for sequence, otherwise everything is common. There will be 4-5 experts sitting in front of a large audience. ठीक है. Workshop, practical demonstration is going on. Delphi's method might become a question. Keyword will be consensus. Keyword will be experts. Keyword will be experts. So two keywords, consensus, that is ek mat or same views, and they will be experts. ठीक है, done. Now barriers of communication, C for community, C for cultural. If the entire community is not understanding a thing, it is cultural. Individual, environment, there is lot of noise. Physiological, तारे ज़मीन पे is the best example. Psychological is mentally disturbed, परेशान है किसी चीज़ को लेके. ठीक है, so it will be a barrier in communication. ठीक है, done है. नेक्स्ट सीमेंटिक बैरियर, बहुत बच्चों को इसमें कंफ्यूजन है. सी सीमेंटिक बैरियर मीन्स द सेम वर्ड हैज टू मीनिंग्स. लाइक इन हिंदी इफ आई से चोर इट मीन्स अ थीफ, whereas in Malayalam चोर मीन्स राइस. ठीक है. नाई इन हिंदी मीन्स बार्बर, कन्नड़ा और तमिल इट इज अ डॉग. ठेकुआ इन हिंदी इज अ कुकी, बट इन ओरिया इट इज अ रैबिट. दिस इज अ सीमेंटिक बैरियर. ठीक है. लैंग्वेज बैरियर जो होता है, that means I am unable to understand your language. ठीक है. Your friend Ruturaj is speaking in Marathi, मुझे मराठी नहीं आती है. It becomes a language barrier. I hope I am clear with this. ठीक है, तो confusion नहीं होना चाहिए. Barriers पे पक्का question आएगा. Surveillance, passive, I am sitting in my hospital, patient is coming to me, passive. Active, I am going to the home of the patient. Sentinel, varies from disease to disease. We find missing cases. Please understand there is a common confusion. Contact tracing, guys, contact tracing is active 95% unless until you are doing it for STDs, which become sentinel surveillance. So contact tracing in STDs is sentinel, baki it is active surveillance only. I hope I am clear with this. Done है, over, no problem. ठीक है. Now UNICEF, GOBI, FFF, growth monitoring, oral dehydration, breastfeeding, immunization, family planning, food supplements, female education. गड़बड़ मत करना, पत्ता गोभी बंधा गोभी नहीं सोचना है. What is the WHO theme for the year 2025? Yes, healthy beginnings leading to hopeful future. ठीक है. तस्लीम, semantic barrier मतलब the same word has got two different meanings. Like in Bengali if they say kurta, it is a cloth, whereas in Punjabi it is the language or the person. ठीक है. So semantic barrier means the same word becomes two different meanings. So you might be telling me something else, I am understanding something else. That is semantic barrier. ठीक है. I hope I am clear with this. Cultural, C for community, C for cultural. If they say the entire community doesn't understand, it will be a cultural barrier. I hope I am clear with this. ठीक है. Done, over. I hope I am clear with this. Done. चले आगे. Great. ILO, World Bank, UNFPA, WHO, UNICEF. ये फर्स्ट एड का लोगो है. ठीक है. ये रेड क्रॉस का लोगो है. सुरक्षा क्लिनिक, देयर इज अ रेड डॉट इन द मिडिल. ठीक है. This is the logo of doctor. बहुत चांस है this will come. People like me who are color blind, they won't be able to pick up. So girls, you are safe. Boys, ध्यान रखना. ठीक है. Done. Okay. Now आशा, you know about आशा. One major update, आशा की तनख्वाह जस्ट 2 दिन पहले 3,500 रुपीस. ठीक है, प्लीज अंडरस्टैंड, आशा हो या उषा, बोथ आर सेम, 3500 रुपए. ठीक है, रिडक्शन ऑफ IMR इज अ मेजर इंपैक्ट इंडिकेटर. रिडक्शन ऑफ IMR. ठीक है, डन, ओवर. नाउ हेल्थ वर्कर में, हेल्थ वर्कर फीमेल और मल्टीपर्पस वर्कर फीमेल और ANM, शी विल डू ओनली फंक्शन ऑफ फीमेल. ठीक है, सब कुछ फीमेल का करेगी, मेल विल डू दूसरा काम. ठीक है, नाउ इंपॉर्टेंट CHO, 2 इंपॉर्टेंट पॉइंट्स फॉर MCQ, NCD और E-संजीवनी. टेलीमेडिसिन, वही अगर मेंटल हेल्थ का टेलीमेडिसिन, उसका नाम है टेलीमानस. ठीक है, टेलीमानस. यस गाइस, 2 इंपॉर्टेंट पॉइंट्स फॉर CHO you should be knowing. ठीक है, नाउ टाइप A, टाइप B सब सेंटर. टाइप A में नो डिलीवरी, टाइप B में डिलीवरी होता है, सिंपल. सो इफ दे हैव आस्क्ड सब सेंटर, दिस वाज ऑलरेडी अ क्वेश्चन इन FMGE in January. So if they ask FMGE this, they might ask you PHC. So in PHC, please try to understand less than 20 deliveries per month, type A. ठीक है, more than 20 deliveries per month, type B. ठीक है, I hope I'm clear with this. Now this is a mandatory table, must आएगा बॉस. सब सेंटर PHC, प्राइमरी CHC, सेकेंडरी डिस्ट्रिक्ट हॉस्पिटल, सेकेंडरी मेडिकल कॉलेज, टर्शियरी. ठीक है, गांव में होती है आशा, शी इज अ ब्रिज, 1000 पे एक आशा, हिली ट्राइबल भी 1000, NUHM में 2000 पे अ उषा, नो मोर अदर वैल्यू 2000. सब सेंटर में हेल्थ वर्कर फीमेल एंड हेल्थ वर्कर मेल, द मोमेंट इट इज ए CHO, इट इज ए हेल्थ एंड वेलनेस सेंटर. OPD एंड डिलीवरी 5000 इन प्लेन्स, 3000 इन हिली ट्राइबल. अर्बन एरिया में देर इज ओनली HWC, 15 से 20,000. PHC, इट इज अ स्टेट गवर्नमेंट ग्रेजुएट डॉक्टर, 30,000, 20,000, 50,000. CHE, स्टेट गवर्नमेंट PG डॉक्टर, 1.2 lakhs, 2.8 lakhs, and the value for population is 2.5 to 5 lakhs. If it is a non-metro, it is 2.5 lakhs. ठीक है, अगर मेट्रो है तो it will be 5 lakhs. ठीक है, now please understand, is CHO responsible in telemanus? Yes. ठीक है, आशा की एजुकेशन 10th क्लास नहीं है, देन 8th क्लास. ओके, यहां उषा 3,500 नहीं हुआ है, पैसे मनी इज 3,500, नॉट पॉपुलेशन. ठीक है तस्लीम, आई होप आई एम क्लियर विद दिस. 3,500 पैसा है, ये पॉपुलेशन नॉर्म है, दोनों को मिक्स नहीं करने का. आई होप आई एम क्लियर विद दिस. ठीक है, डन, ओवर. विल द आशा अपडेट रिफ्लेक्ट इन पेपर? यस गाइस, प्लीज अंडरस्टैंड, अपडेट्स till the day the exam is conducted becomes important. ठीक है, डन. ओके, ये ब्लू में मेटालिक बॉडी इम्प्लांट्स, ग्लासवेयर, ब्रोकन एंड इंटैक्ट, ऑल वैक्सीन्स एक्सेप्ट लाइव एटेन्युएटेड, जो कि येलो में जाता है. सो येलो विल हैव लाइव एटेन्युएटेड, विल हैव साइटोटॉक्सिक, विल हैव एक्सपायर्ड, विल हैव ब्लड बैग. यस, प्लीज अंडरस्टैंड, रेड में ग्लव्स प्लस माइनस ब्लड डज नॉट मेक ए डिफरेंस. नो प्लास्टिक कैन बी बर्न, सो ऑल प्लास्टिक इन रेड एक्सेप्ट यूरिन बैग, एक्सेप्ट ब्लड बैग. ब्लड बैग इज मेड ऑफ स्पेशल प्लास्टिक, सो उसको हम कर सकते हैं. आई होप आई एम क्लियर विद दिस. डन है, ओवर. ठीक है, नाउ ब्लड स्पिल, सोडियम हाइपोक्लोराइड, 3 hours मर्क्यूरी स्पिल्स, रीयूज, रिकलेक्ट, रिसाइकल. बायोहैजार्ड, बीच में सुअर आया तो स्वाइन फ्लू, डू नॉट गेट कंफ्यूज विद सुअर, सी फॉर साइटोटॉक्सिक. ठीक है गाइस, प्लीज रिमेंबर द टेक होम मैसेज, इफ यू आर नॉट गुड इन PSM you will get PSM PG. Guys, this is my Telegram channel, please feel free to be there, and most important is, if you have any queries in PSM for the NEET exam, do not hesitate to reach out. This is my WhatsApp number, please आराम से reach out, do not worry at all. ठीक है, take home message, please, the time is too less, there is no secret ingredient, it is just you. Love you all, bye bye, take care. Over to my dear friend
All right, so hi dear friends, this is Dr. Kashish Grover, your PSM faculty at DAMS, and we are going to start this marathon session. So, pre-written things, we are just going to revise, right? Now, first and very important, very important, okay, very important is, okay, please refresh guys, when from one channel another faculty joins from another channel, there is a stuck, please rejoin, you will be able to join it. Please rejoin guys, it is going good at my end without any delay. Please rejoin. Sorted? Yes, everyone sorted, because it's going good at my end. Okay, now guys, neurolathyrism, this is a topic where every year we get questions, right? So neurolathyrism, which dal is responsible? It is khesari dal. Now if I talk about the prevention, number 1, ban the crop, number 2, genetic modification, number 3, removal of the toxin, and number 4 it is vitamin C prophylaxis. This vitamin C, guys, let me tell you one thing. It is my experience from last 2-3 years. NEET PG and FMGE, especially for PSM, they are going hand in hand, right? Last to last year also. Now this is very important. Vitamin C was asked recently in FMGE, and also it was asked recently in NEET PG, right? Vitamin C is given for the prophylaxis of neurolathyrism. Now point check, what are they? Number 1, khesari dal. Number 2 is boa. Toxin name, boa. Number 3, which vitamin to prevent? Vitamin C. Vitamin C. Now guys, quickly I am going to next point. Quickly going to next topic. Next topic is epidemic dropsy. The argemone oil is mixed with mustard oil. Name the toxin. Yes, name the toxin. It is sanguinarine. Second point, guys, I want to tell you here, the symptoms are filled with drop. Name is dropsy. So pedal edema, do not forget this. Pedal edema, what was the mnemonic? A drop of mustard oil. The mnemonic is a drop of mustard oil, right? Diarrhea, glaucoma, and CHF, and the death, right? The cause of death here is CHF. Guys, last year NEET PG question was most sensitive test. So 2 tests are there. Number 1, nitric acid test. Number 2, paper chromatography. Which test is most sensitive? It is paper chromatography. Paper chromatography is most sensitive. Now if I talk about endemic ascites, it is pyrrolizidin. The toxin is pyrrolizidin, right? Here crotalaria seeds are mixed with millets. Okay, keywords. Yes, keywords. Number 1, toxin, sanguinarine. Number 2, if anywhere in question you see pedal edema, glaucoma, congestive heart failure, it is epidemic dropsy. Keyword number 3, what is the most sensitive? It is paper chromatography. Now coming to ergotism, guys, ergotism, FMGE, 2 days back, this was the question. Ergotism, guys, because of bajra and rye fields, they get infested because of fungus. Name the fungus. It is Claviceps purpura. Take home, okay, guys, from every slide. We are going to talk about keywords. We are going to talk about take note. The words which should be go here. This is the meaning of the marathon, right? Marathon is the only meaning of marathon is keywords should stick here, right? Keywords should stick here. One more time. Name the fungus, claviceps. Name the food, bajra or rye. Point number 3, how to prevent it. You soak the fungus infested seeds in 20% salt solution. What will happen when you soak it in the 20% salt solution in the water, 20% salt water, the good seeds of bajra, they will settle down. The fungus infested, they will be above on the surface. You can remove them and thus you can prevent the ergotism. Now coming to, right, aflatoxicosis, fungus, yes, keyword, take note, it is aspergillus. It is aspergillus. Food, it is because of when the food is stored with the moisture. When the food is stored with the moisture, it happens. So what to do? Store after drying. Now guys, one more point. Among all, this is the only point which is associated with liver cancer. It is associated with liver cancer. Coming to the next one. So guys, these are the logos. BISFSSAI. This is plus F. This is important. Fortified. This is important. And this one is vegan. And this one is vegan. Coming to vitamin B1 deficiency. Thiamine. It causes beriberi. It causes beriberi. Dry, wet, infantile. Not very important. The keyword here is vernix encephalopathy. Vernix encephalopathy. It is because of, it is seen in chronic alcoholics. Chronic vernix encephalopathy, chronic alcoholic. Goa. Goa means global confusion, ophthalmoplegia, ataxia, where you get the maximum, where you get the maximum. Goa. Global confusion, ophthalmoplegia, ataxia. Now, Pellagra, exam is incomplete without Pellagra. Every year they give Pellagra. What is Pellagra? Because this vitamin B3 is needed for skin, intestine and brain. So dermatitis, diarrhea and dementia. Where dermatitis? It is bilateral. Where? Bilateral. Sun exposed area. Name of the Cazal's necklace. Now can you name some foods which cause pellagra? And the name is maize and jawar. Guys, it also, apart from dementia, dermatitis, diarrhea, it also causes glossitis and stomatitis. Now we are done with the topic nutrition. Now we are coming to topic maternal mortality. I don't know why from last 2-3 years these formulas are their big weak points. In every exam they are giving. What is maternal mortality rate? Number of maternal death divided by women in reproductive age. What is maternal mortality ratio? Maternal death divided by live birth. And it is live birth. So guys, do remember the SDG target is less than 70 and the current maternal mortality ratio is 88 per lakh live birth. Now guys, what is maternal mortality? Listen, death of any woman during pregnancy, during childbirth, after childbirth, 42 days, irrespective of duration of pregnancy. So if any woman dies because of abortion, it is maternal mortality. If any woman dies because of ectopic pregnancy, this is maternal mortality. Exception, any accident, road traffic accident, any fall, any injury, or any snake bite, any electrocution. These are the exception. Guys, this is very important, right? And take note, SDG target less than 70. SDG target less than 70. Yes, less than 70. Now, coming to the child mortality rates. So, if from birth to 1 month, it is 28 days, it is neonatal. First 7, early neonatal, then late neonatal. Stillbirth plus early neonatal is perinatal, and birth to 1 year, it is infant mortality. It is infant mortality. Surgeon, sir, current maternal mortality is 88. From 97 it came to 93, and recently the data which was released, it says 88, right? Recently, earlier they said 97, but now the recent data said 93, and after 93 one more data they released, it said 88, right? It says 88. Now next is the formula. Neonatal mortality. The formula neonatal mortality, most common cause prematurity and low birth weight. Prematurity and low birth weight, right? Most common cause. Now next is infant mortality. Guys, infant mortality is the best indicator for healthcare utilization of country. Most common cause prematurity and low birth weight. Under 5 mortality, it is prematurity and low birth weight. But if they talk about 1 to 4 year, then the recent data says injuries are most common, then other NCD, and then pneumonia. This is the recent data, right? This is the recent data. Now you know about the formulas. Now you know about everything. Coming to, so guys, this is also important. Post neonatal death between 28 days to 1 year. Last year NEET PG question, you know what they asked? Last year NEET PG question, they ask you to calculate early neonatal mortality. They will give you the number of death during 1 year is this, during 1 month is this, during first 7 days is this, and you have to calculate everything, right? Now coming to next one. Now guys, this slide, in this slide, just remember minimum antenatal care, Government of India says 4, WHO, recent WHO guidelines say 8 visit, right? Ideal visits are, it is 13 to 14 visits. Ideal visit are 13 to 14 visit, right? Now hemoglobin less than 11 is anemia in pregnancy. Less than 11 hemoglobin is anemia. And weight gain, it is around 10 to 12 kgs if the BMI is normal, but the recent guidelines say if the BMI is high, 5 to 9 kg. 5 to 9 kg. Now coming to IFA tablet, so iron 60 mg, folic acid 500 to be taken daily, right? And 6 months before delivery, 6 months after delivery, 6 months before delivery, 6 months after delivery. TT, 2 doses are needed 4 weeks apart. If previously immunized within 3 years, guys, then only 1 booster is needed. Only 1 booster is needed, right? Only 1 booster is needed. Coming to demography, what are the demographic processes? I don't know why I have an intuition that this time they will ask this thing. Demographic processes. What are the demographic processes? 5. Marriage, right? Marriage, fertility, social mobility, migration, mortality, and mortality, right? These are the demographic processes. Coming to next one, demographic cycle. Guys, this is important. Last year, very easy. Last year, very easy question they asked. They marked this and they asked what is this, and the answer was death rate, right? Birth rate is high, death rate is high, stage 1. Then it is high stationary. In both the birth rate and death rate are low, it is low stationary. The demographic cycle is very important, right? So here birth rate and death rate both are high, here they both are low, right? Now maximum birth rate, stage 1. Stage 5, when the population starts decreasing. Stage 5, and when the population starts decreasing. If they ask you in the exam, currently India is in which stage, what will you mark? Please write in the chat box. What will you mark? Please write in the chat box. Now coming to dependency ratio. No, before you ask me, I knew this question you are going to ask me. India is in which stage? That is why. Before you ask me, I am asking you. India is in which stage? Please comment in the chat box. Dependency ratio, guys. I don't know what is there in this dependency ratio. This year FMG, this year INICET, this year NEET PG. The same question was there, right? The same question was there. The same question was there. It is ratio of dependent. Who are dependent? Less than 15 year plus more than 65 year divided by 15 to 65 year. It is ratio of dependent versus independent. Now, if you understood the concept, so answer to my question is India is in stage 3. India is in stage 3. For your MCQ purpose, it is stage 3. Yes, we are believing that India is in stage 4, but till now no government document updates this. So before we don't have anything documented, we do not follow it for our MCQs, right? So India is in stage 3. Now, if you understood this concept, I have a quick question for you. Can you please answer me? Can you please answer? Find the dependency ratio of this family. Quickly update in the chat box. Quickly write in the chat box. Quickly write in the chat box. Quickly write in the chat box. Now, coming to fertility indicator. Guys, if I talk about fertility indicator, total number of children born to a woman. Total number of children born to a woman is total fertility rate. Total children born to a woman. Total girls born to a woman is gross reproduction rate. It is gross reproduction rate. And total number of newborn girls that a newborn girl would born in her lifetime, it is net reproduction rate. Now it represents the less than, right? It represents total fertility rate represents the family size. Very good. The answer is 2/3. Superb, bacho. Amazing. Superb. Amazing. No, Shubham. Not 1/2 beta. It is 2/3. 2/3. This is the kind of question they are going to ask you. Now coming to growth of the baby. Now, if weight for age is less, it is underweight. Height for age, chronic malnutrition, you can say stunting. Weight for height tells us about acute malnutrition, which is wasting. Acute malnutrition, which is wasting. My another question, right? So this is my question to you. Let us see who is going to mark in the chat box, right? The question is, tell me the criteria for SAM. Tell me the criteria for SAM. Meanwhile, you write in the chat box. I'm going to the next slide. Now, okay, it is Shakir's tape. This Shakir's tape tells us about, it measures mid upper arm circumference and less than 11.5 is SAM. Less than 11.5 is SAM. Guys, many places they are teaching that it is less than 12.5. This is wrong, absolutely wrong. The update is here since last 3 years. Less than 11.5. Less than 11.5. I was not asking about MUAC criteria for SAM. I was asking about weight for height. Weight for height. How much weight for height less than? Now, guys, school health criteria, school health environment. 10 less than 10 square feet space per capita, 25% window plus door, 40 students in a class, right? One urinal for 60 students, one latrine for 100 students, minus type desk, and the light should come from left. Yes, very good, beta, very good. So 3 criteria for SAM. MUAC less than 11.5. Weight for height less than -3 standard deviation. And pedal edema. Superb. Tejas bache, very good. Superb everyone, superb. So everyone, good. Now, coming to, this is one question which came last year NEET PG. School health services under Ayushman Bharat. Number 1, health promotion. We make health and wellness ambassador. Who are they? they are school teachers. They are school teachers. One male teacher, PT teacher, one female teacher, science teacher. If you remember my meme on this, right, then screening under RBSK. After that, services, we give TT, we give iron folic acid, albendazole, sanitary napkin. So guys, this is weekly. Last year MCQ, they asked monthly iron folic acid. It is not correct. Weekly iron folic acid is given, right? Weekly iron folic acid is given. Now, coming to iceberg phenomena, a lot of confusion is there. No confusion. Cut the noise. Let's end the controversy. Iceberg phenomena is shown by trip to Delhi, typhoid, rubella, influenza, polio, diphtheria, right? And it is not shown by MTR, measles, tetanus, rabies. One student is writing in the chat box, computer teacher. Boy, you know the meme. You are the one. You know the meme. Yes, good. Computer teacher. Hashtag English teacher here. Alright, so this is iceberg phenomena. Now guys, formula quickly for the sensitivity. Sensitivity, guys, A upon A plus C. Right? A upon A plus C is sensitivity. D upon B plus D is specificity. A upon A plus B. A upon A plus B, positive predictive value. D upon C plus D. D upon C plus D. It is negative predictive value. Not shown, SK, not shown by MTR. It is not shown by MTR. Measles, tetanus and rabies. Measles, tetanus and rabies. Measles, tetanus and rabies. Guys, quickly, cut off. From this slide, only one question is possible. The possible question is, they can ask you false negative, false positive, false negative, false positive. Now, if we increase the cutoff, then false negative will increase and false positive will decrease, which will in return decrease sensitivity and decrease negative predictive value. Both specificity and positive predictive value, they increase. If I decrease the cutoff, then false positive will increase, false negative will decrease, right? Now, this is about increasing or decreasing cutoff. Now, coming to the next one, guys, this is very, very important. I don't know why. These two slides, they give maximum every year. They keep on changing. NEET PG 23, FMGE 24, FMGE 25. This year, this was asked. NEET PG 21, FMGE 23. Every year they ask these questions, right? Now, Now, coming to the next one, guys, rule of half. This is only for hypertension, not for all NCDs, right? This is only for hypertension. It says out of total population, 50% they have hypertension. Those who have hypertension, 50% they know they have hypertension. Those who know they have hypertension, only 50% are taking treatment. Those who are taking treatment, only 50% are able to control it. Then comes tracking of blood pressure. So if we track blood pressure from childhood, then those who have high blood pressure in childhood will have high blood pressure when they become adult. So a child with high blood pressure will have high blood pressure when the child will be adult. This is tracking of blood pressure, right? Now, WHO steps approach. First of all, steps approach. This is for NCD risk factor. This is for NCD risk factor. In this, what we do, we take there. This is step 1. Step 1 says, this is step 1. In step 1, we talk about we take the questionnaire about their age, their family history, their habits, smoking, alcohol. If anyone found on high risk, now we take that person to step 2, weight, height, BMI, blood pressure. We measure physical measurements. After that, if anyone found high risk on this, now we take to biochemical. Very good beta. No treatment here. Good bacho. Superb. Amazing. Very good. Super proud of you. You are going to rock. Trust me. Mark my words. You are going to rock, right? Okay, can I see some fire in the chat box? Yes, guys. Can I see some fire in the chat box? Now, coming to the next one. HDI, PQLI. I don't know why they love these two topics every year. So, knowledge, income, life expectancy at birth. And here, the mnemonic is ill at the age of 1 year. Ill at the age of 1 year, right? Ill means IMR, literacy, life expectancy at 1 year. Ill at the age of 1 year. Here, do not kill at birth. Repeat with me. Knowledge, income, life expectancy at birth. Here, IMR, literacy, life expectancy at 1 year. Superb. Amazing. Coming to the next one. MMM. What is the mnemonic? MMM. Malnutrition, overall population. Malnutrition, less than 5 year. Mortality, less than 5 year. MMM. IMR is not included here. A PYQ, IMR is not included here. Guys, isolation and quarantine. Isolation is done for cases. Quarantine is done for contacts. Quarantine is done for maximum incubation period. Guys, listen. Last year this question came and I felt very bad when some students, they told me that they could not mark this question correct because they got confused. Guys, this is very important and serious. When we lose our marks because of even in these simple questions, it is this situation is not good. So very simple. They have given incubation period 2 to 14 days. Right? They have given incubation period 2 to 14 days. Now, in this incubation period 2 to 14 days, they asked period of quarantine. So it is for maximum incubation period 14 days. Super, but amazing. 14 days. Right? Now, coming to level of prevention. This is also very important. Level of prevention. If there is no risk factor, right? It is primordial. Risk factor present, no disease. It is primary. Guys, prophylaxis. Many students, they make a mistake here. Sir, dog bite happened and the patient came to us and we gave ARV, we gave vaccine. How this is primary? This is primary, guys. This is primary. Rabies nahi hua abhi. So dog bite is a risk factor for rabies. We are preventing rabies because there is a risk factor now, dog bite. So even if it is a pre-exposure prophylaxis or a post-exposure prophylaxis or chemo prophylaxis or re-exposure prophylaxis, immunoprophylaxis, I don't care. Prophylaxis means primary prevention. That's it. Right? Prophylaxis is primary prevention. Any screening of disease is secondary. Pap smear, mammography, screening for colorectal cancer. This is, right? This is secondary. Now, tertiary, when disease is beyond early stage. Vaccine of children, vaccine of elderly, always primary. Any vaccine you are giving except BCG for bladder cancer, right? Now, coming to measurement of morbidity, incidence and prevalence. Guys, the relationship between incidence and prevalence is prevalence is equal to incidence into duration. Now, if good cure is available, prevalence decreases. Mortality, if mortality is there, prevalence decreases. Any drug which prolongs life but does not cure, it is going to increase prevalence. Right? It is going to increase prevalence. Now, coming to case control study. So we are taking history from the cases and controls. So matching is selecting controls in such a way that they are similar to cases, because it removes selection bias. Which bias is seen here? It is recall bias. Now, coming to next one. What is the strength of association in case control study? It is odds ratio. It is cross product ratio. Formula AD by BC. Now, coming to cohort study, when we follow someone, it is cohort study, more time consuming, more money consuming. In this study, there are drawbacks that this is more time consuming, more money consuming, and a bias is there. The bias is attrition bias, loss to follow up bias. One more bias: people change their behavior when they know they are observed. This is Hawthorne bias. Now, guys, coming to the next one. The next one here means relative risk. If relative risk is more than 1, then here, if relative risk is more than 1, it is positive association. For example, if relative risk is 4, it means smoking is causing lung cancer. If relative risk is less than 1, it means negative association. It is protective. So less than 0.8. Suppose if relative risk is 0.8, it means it is protective. Right? It is protective. Now coming to the next one. What is retrospective cohort study? Guys, please pay attention here. 2 times the question came, one in NEET PG and recently in FMGE exam. Guys, listen, I don't want to do any study. I don't want to do a cohort study. I don't want to wait for 20 years. Right? Second, the case control study, recall bias chances are there. So what I do, I collect. See, I am telling you here about the keyword, take note. So I am collecting exposure from the records. I am collecting exposure history from the records. Right? Record based. And what is MBspective? It is a mixture of retrospective. And prospective cohort. Example, I am doing a study. I went to a factory. I collected a list of workers 20 years back who were there, and also I collected a list of clerical workers who were there 20 years back. Which study is this? Yes, which study is this? All right, guys. All right. Good. Very good. So with this, thank you so much. Thank you so much for listening me. Thank you so much for your patience. Please listen what I am saying now. Guys, this time where you are standing right now, this is not the time to panic, to think, to doubt. This is not the time. This is the time to remain calm, because a calm mind is going to mark the correct answer. Right? A calm mind is going to recall all the things which you have read. A calm hand is going to mark the correct answer. This is the time to maintain the calmness, right? This is the time to maintain the calmness. No noise, no noise. So give me a promise. This till from today till the exam, you have to maintain your calmness, right? Take care of your health, take care of your sleep, take care of your gut. That is very important. Do not eat junk. Very, very important, right? God bless you, right? And see you. God bless you, right? See you after exam, right? Maybe after exam, before exam, if you want to ask any doubt, you can ask, right? You can ask. Signing off. Thank you so much. God bless you. Signing off. Thank you so much. God bless you. And do not forget the promise. Do not forget the promise. Calm mind, calm heart, and take care of your gut. Sleep as well.
Yes, very good evening, doctors. How are you? All good. Very fantastic evening. So, marathon is going very fastly. You are ready for your near coming NEET PG examination. Okay. So, final revision we're going to make. So, all of you please enjoy. Okay. Without wasting time, we're starting. You are ready for your near coming NEET PG examination. Okay. So, we done everything, multiple revision, LRR, DVT, TND, lot of things we done. Okay. Now the last me to focus. My session will be discussion of so-called slide not moving. Just 1 second, doctor. Slide. Just give 1 second time. Just not moving. So just 1 second, sir. Slide. Hello. 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 Now only moving. Now only moving. Just it. Okay. Okay. Right. Fine. 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 Right. We start. Sorry. So final revision we won't discuss. My part will be discussion of some important aspect of ANS, CVS, renal, blood, endo, and GAT. To start in the ANS, first chapter, our cholinergic. In that, the most important things you should know: drug interfering synthesis, storage, release, and metabolism of acetylcholine. To start, look here. The choline uptake blocked by our hemicholineum. This is very important. And then after synthesis acetylcholine, the synthesized acetylcholine taken by vesicle, this step is blocked by vesicular uptake inhibitor, so-called vesamicol. And then few years back, one old NEET page question, name the drug inhibiting release of the ACH. The release of ACH blocked by botulinum toxin. This is important. This was previous year question. You should know. So in the synthesis storage release part, you should know botulinum toxin acting by inhibiting release of ACH. Okay. And then they are very frequently asking drug acting on bladder. This is very important. Expect the area again. Look here. I have one thing called Bethany call. Bethany call. Call mean a cholinergic drug. a cholinergic drug acting on M3 receptor in the bladder, going to contract and have prokinetic property. This property useful for treatment of post-operative urinary retention. Very important. And then I have mirabegron, one more drug called vbegron. Vbegron, both are beta 3. Both are beta 3 agonists acting on beta 3 and detrusor, causing detrusor relaxation, causing urine retention. This property useful for treatment of overactive bladder. And then very important, duloxetine. It is one of the SNRI, that is serotonin norepinephrine reuptake inhibitor, one of the antidepressant acting on urethra, causes urethral tone, increasing the urethral tone, thereby controlling urination while coughing, while sneezing. That means useful for treatment of stress incontinence. Very important. Name the antidepressant useful for treatment of stress incontinence called duloxetine. And then, very important, they may ask clinical scenario. A patient with a benign prostate hypertrophy scenario where you should know alpha 1A receptor causing internal urethral sphincter constriction. So, in case of benign prostatic hypertrophy, for symptom relief, we can go for tamsulosin, a highly selective alpha 1A blocker useful for treatment of symptom relief in benign prostatic hypertrophy. Whereas to reduce the size of the prostate, we go for 5 alpha reductase enzyme blocker, so-called finasteride. So, drug acting on bladder, very important area, please revise. And then, in cholinergic, another clinical scenario-based MC question mean, what about Alzheimer's disease? Here, acetylcholine deficiency is the most important problem in Alzheimer. So, for treating Alzheimer, the first line drugs will be cholinergic enhancer like rivastigmine, donepezil, galantamine, and tacrine. In fact, you should know the rivastigmine we have patch, transcranial patch. So, which is the drug? It's a patch form. Rivastigmine. And one more thing, rivastigmine also useful for treatment of dementia in Parkinson. Name the drug useful for treating dementia in Parkinson. Mean the only one FDA approved drug is rivastigmine. And then tacrine we don't use because of causing adverse effect of severe hepatotoxicity. In this junction, you should know if they asking some new drug mean name the NMDA blocker. Memantine. Memantine, a NMDA blocker useful for treatment of moderate to severe Alzheimer. If at all they want to go for a high level win, MCQs on name some MEBs. For example, we have monoclonal antibody useful for treating Alzheimer like aducanumab, lecanemab, and donanemab. All these antibody targeting against beta amyloid. So the targeting against beta amyloid. So this another important point. Another important area in cholinergic where to put myasthenia. What in myasthenia gravis? It's not moving. Some disturbance in the comment. Just 1 second. My God. Just 1 second after. Guys, don't disturb. Actually, yes. Yeah. So, in case of myasthenia gravis, the expected question, look at, they're asking about new drug useful for treatment of myasthenia gravis. For example, we have something called rituximab. a monoclonal antibody targeting against C20. Name the MAB useful for treatment of your myasthenia gravis, new drug rituximab, and they may ask about complement component C5 blocker useful for treatment of your myasthenia, eculizumab and silicoplan. Eculizumab and silicoplan are drug useful for myasthenia targeting against complement component C5, and then we have efgartigimod and rozanolixizumab. These two are latest drug useful for myasthenia targeting against neonatal FC receptor inhibiting IgG recycling. Here, one more thing, expect a question. The eculizumab silicoplan may cause severe infection, especially meningococcal infection. So, a patient who is on eculizumab needs meningococcal infection prophylaxis. And you should also know they also useful for treatment of PNH, paroxysmal nocturnal hemoglobinuria. Okay, so that for finishes cholinergic. And coming to very important point, look here. For the treatment of Datura poisoning, Datura, the so-called Atropa belladonna plant. We have one thing called Atropelladonna, one more thing Datura. Both of them having atropine-like substance. So question, in case of atropine poisoning, can you please answer after what is the important drug of choice for treatment of atropine poisoning? Answer, 5-sostigmine. 5-sostigmine, yeah, anticholinergic, lipid soluble, easily crossing the blood-brain barrier, drug of choice for treatment of atropine poisoning, very important. And then we have something called a drug acting on skeletal muscle. In that repeated question, how to reverses the action of curare drug toxicity. Normally for treatment reversal of SMR for curare drug, we go for neostigmine with glycopyrrolate. Okay, but you should know we have one drug called sugammadex. Very important, very important. Can I answer? The sugammadex useful for reversal of vecronium and rocronium. Vecronium and rocronium. This is very important. Sugammadex useful for reversal of vecronium and rocronium. Okay, and then in cholinergic, you should know nicotine. Nicotine means deal with smoking. So, what is the most effective drug useful for controlling smoking? Can you please answer? The most effective drug controlling smoking means think of varenicline. What is varenicline? Varenicline, a partial nicotinic agonist, alpha 4 beta 2 partial nicotinic agonist. It may cause adverse effect of suicidal tendency, depression, causing suicidal depression. Okay, so the most effective drugs go for varenicline. And coming to sympathetic, in sympathetic, expect a question. Name the wonderful drug useful for controlling opioid withdrawal syndrome. We have something called clonidine and lofexine. The clonidine and lofexines are called alpha 2 agonists. So remember, alpha 2 agonists are wonderful drug for controlling clonidine withdrawal syndrome. Again, very important area. The clonidine alpha antagonist is useful for hypertension, but it's a danger. Sudden stopping of clonidine causes severe rebound hypertension. Very important, very important. So, we have clonidine, sudden withdrawal of clonidine causes severe rebound hypertension. Now, all must answer. If a patient on clonidine suddenly stop taking clonidine, mean go for severe rebound hypertension. My question, for treating this hypertensive crisis, what is the best anti-hypertension? Yes, good. Phentermine. Phentermine. Phentermine is the drug of choice for treatment of clonidine withdrawal induced hypertensive crisis. And what is this? It's a non-selective reversible alpha blocker. So, phentermine. Okay. And then we have expected question in this coming examination in sympathetic. Name some drug got FDA approval for treatment of orthostatic hypotension. For treatment of neurogenic orthostatic hypotension and for treatment of dialysis induced hypotension, because not alpha blocker, alpha agonist. Remember, For treating orthostatic hypotension, we have something called droxidopa. What is this? It's a prodrug. It's a prodrug of noradrenaline. It is useful for treatment of orthostatic hypotension. One more drug, midodrine. Midodrine is selective alpha 1 agonist approved for treatment of orthostatic hypotension. So remember, midodrine, a selective alpha 1 agonist, droxidopa, a prodrug, norepinephrine, both are FDA approved drug for treatment of orthostatic hypotension as well as useful for treatment of dialysis induced hypotension. Okay, and then regarding beta blocker, you must know question, which are the beta blocker got approval for treatment of heart failure? Very important. Among the beta blocker, the fantastic drug for treatment of heart failure, we have carvedilol. It's a beta plus alpha blocker, a wonderful drug, disease modifying drug in heart failure. And then other beta blocker useful for treatment of heart failure are bisoprolol, metoprolol, and nebivolol. These three are cardioselective beta blocker. Remember, a disease modifying drug in the treatment of heart failure. Among the beta blocker mean the most super drug is carvedilol. Other drugs are bisoprolol, and remember, metoprolol succinate. It is not the tartrate. Succinate is the longer acting drug, whereas metoprolol tartrate short acting. It is useful only for hypertension. Only for hypertension. My God, against. Hello, hello, check. Hello, hello. Hello. Yes, yes, we continue. Okay, so question, when you talk about beta blocker, we have metoprolol. Remember, metoprolol succinate is useful for treating heart failure. It is not tartrate. Tartrate is the short acting, useful for hypertension and for post MI. Okay, and then there is some all fine, but my slide not moving. There is some issue. Slides not moving properly. That's only now is moving, so I don't understand what the technical issue. Okay, yes, okay. Now after finishing ANS, yes, all fine, good. Naveen, thank you, thank you. Okay, now we want to drugs therapy in cardiology. Okay, right. So regarding angina, very important. Nitrate chapter, very important. Nitrate, please answer. Nitrate should never given along with the what? Please answer. Sildenafil, very good. See, nitrates also acting by accumulating cyclic GMP. Nitrates also acting by accumulating cyclic GMP. Your sildenafil, a PD5 blocker, that is also acting by accumulating cyclic GMP. So when both are given together, risk of severe accumulated cyclic GMP causing vasodilation and causing severe hypotensive shock and cardiac arrest can occur. So be careful, be careful. Next, this is fine important. Nitrate should never given along with the sildenafil. Okay. Next question. In anginal chapter, you must revise ranelazine. Ranelazine, a anti-anginal. Can you please answer? It is acting primarily by what mechanism? The primary action of ranelazine, it is acting by blocking late sodium channel. It's a late sodium blocker, thereby reduces intracellular calcium load. See, PFOX, pathway of fatty acid oxidation blocking, I do understand, it's okay. That is secondary action. The main action of ranelizine acting by blocking late sodium channel current and reduces intracellular calcium. Secondary action only blocking pathway of fatty acid oxidation. Okay. And third point, it is also has mild beta blocking property. So 3 point actor. Please remember the primary action of ranelizine acting by blocking late sodium channel thereby reduces intracellular calcium. The secondary action is blocking pathway of fatty acid oxidation, and third is mild beta blocking property. And advantage, it has good control of diabetes, controlling glycemic control, controlling HbA1c also, but only one causing adverse effect of causing QT prolongation. That point important. Adverse effect causing QT prolongation, and this undergo renal route of excretion, so be careful in kidney failure. Whereas we have one drug called trimetaserine. The trimetaserine primary action is PFOX, pathway of fatty acid oxidation inhibition. Primary action PFOX blocker. So trimetaserine mean primarily blocking pathway of fatty acid oxidation, whereas ranelizine mainly blocking late sodium current. And then regarding heart failure, you should know some newer drug useful for heart failure, very important. BNP, can you answer? The brain natriuretic peptide analog name is necessary. As the name indicates, brain natriuretic peptide. That means they cause natriuresis, diuresis, and vasodilation, thereby useful for treatment of congestive heart failure. Drug name necessary. And then it is very short acting, given only IV. See, it's a natriuretic peptide. Peptide cannot be taken orally, give only IV infusion. And then ARNI, angiotensin receptor plus neprilysin inhibitor. What is the best FDC? We have combination of valsartan plus sacubitril. Here, valsartan is a angiotensin receptor inhibitor. Sacubitril is a neprilysin inhibitor. So, question: find out the selective neprilysin blocker. Mean go for sacubitril. Whereas, name the FDC, which is the ARB available as a combination with sacubitril. Mean go for valsartan. Very good drug for treatment of congestive heart failure. And then the direct guanyl cyclase activator useful for treatment of heart failure. We have one drug called vericiguat. Vericiguat directly activating guanyl cyclase, thereby accumulating cycle GMP, causing vasodilation, useful for heart failure. Whereas we have something called riociguat, riociguat and chinociguat. They are useful for treatment of pulmonary hypertension. So we have riociguat, chinociguats are direct guanyl cyclase activator useful for pulmonary hypertension. Vericiguat useful for heart failure. And then drug inhibiting ACE plus neprilysin, very important PYQ doctor. We have something called omapatalat and sampatalat. These two drugs are inhibiting angiotensin converting enzyme as well as neprilysin enzyme. Drug name omapatalat and sampatalat. Okay, useful for hypertension and for heart failure. And coming to third chapter, hypertension chapter, they're asking clinical question. Hypertension with diabetes, very good drug, escitalopram ARB. Like that, they give some clinical scenario and asking to choose best anti-hypertensive. Can you please answer? Hypertension with the CKD mean what is the best anti-hypertensive to prevent the progression of kidney disorder? Best is go for ACE inhibitor ARB. They prevents the progression of CKD. We have CKD, lot of stage 1, stage 2, stage 3, and end stage disease. So, if you are using inhibitor ARB, they preventing the progression of CKD. So, best. Another very important question can I answer? Hypertension and stroke prevention. Today, For controlling stroke, for preventing stroke, the best is thiazide diuretic. Next only ACE inhibitor. So today for stroke control, best is thiazide diuretic. Next option can be ACE inhibitor. That's about hypertension associated clinical scenario based questions are repeatedly coming. You must know, okay? And then periodic arrhythmias. Look here. Dorsey dividers called long QT syndrome. Look at easy. Different shape, different morphology called polymorphic VT. For this case, again easy question. We have two type of long QT. One is congenital, one more thing acquired. Can you please answer? For acquired long QT syndrome, always the drug of choice is MGSO4. Very good. Max up. Whereas for treatment of congenital anxiety syndrome, we go for propranolol. Okay. And once again, MGSO4, a wonderful tocolytic, wonderful drug for treatment of eclampsia. MGSO4, very, very, very important. You must revise. Useful for treatment of long QT syndrome, useful for treating eclampsia. It's a bronchodilator, useful in acute asthma, and monitor three things, that is knee jerk, ankle jerk, urine output, as well as respiratory rate. All the things you have to monitor. And antidote is calcium gluconate. Like that, MG is a topic very important. You must revise. Okay. And then look at this. Here, there is clinically patient presenting with no pulse, no BP, almost unconscious. When they take ECG, that shows undulating QRS, like a snake bending forward, backward, funding. No proper QRS diagnosis, ventricular fibrillation. For this case, the best anti-arrhythmic for treatment of VF, for VF, anti-arrhythmic mean go for intravenous amiodarone. FDA approved drug for treatment of ventricular fibrillation is amiodarone. But for this case, the proper treatment ACLS guidelines is go for CPR, cardiopulmonary resuscitation, give injection adrenaline, also give DC shock. When they give shock, the problem will solve. But anti-arrhythmic go for intravenous amiodarone. Like that, different arrhythmia. Drug of choice for SVT, your adenosine. Drug of choice for VTVF, your amiodarone. Like that, they give different clinical scenario. You should find out diagnosis and go for appropriate treatment. Okay. And then coming to blood chapter, we done ANS, we done CVS. Now we in the blood chapter. In blood chapter, antidote for various anticoagulant, mechanism action of anticoagulant, antiplatelet, and how to monitor the toxicity of anticoagulants, all very important area. So please watch. The streptokinase, urokinase, all are TPA, tissue plasminogen activator. That means they're going to useful for thrombolytic therapy. So for treatment of thrombolytic, for antidote, we go epsilon aminocapric acid. Very good. EACA, epsilon aminocapric acid. Okay. And then we have something called tranexamic acid and one more thing called aprotenin. Sometimes they give all the three options and ask you to choose what the best. Remember, epsilon aminocapric acid, tranexamic acid, aprotein. In this, the most specifics go for EACA. EAC is the most specific antidote, very important. And then we know warfarin. Warfarin is a oral anticoagulant for that antidote between K1, so-called phytonadione. Whereas we have some latest drug, very important, that's oral cream. We have dabigatran. Dabigatran is the orally given direct thrombin inhibitor, a latest anticoagulant. Now you should tell, come on, what is the antidote for dabigatran? This is expected question, important question, all must know. Answer, it is idarucizumab. Very good. Idarucizumab is the antidote for direct 2A blocker. Okay. And then we have something called oral 10A blocker like apixaban, edoxaban, rivaroxaban. Those drugs name ending with the XABN. For this, the antidote is we one thing called anti Zenith alpha. It's a recombinant 10A and the Zenith alpha is a recombinant 10A preparation. Now, my dear friends, can you please answer? Edarazumab antidote for dabigatran and this for 10A blocker for both for dabigatran and for 10A blocker for both we have one common antidote called what? Siraparentak. Siraparentak is a common antidote for both 10A and 2A blocker. So antidote part very important. Please thoroughly revise this. Okay. And then simply they give image based question. This came already. There's a lady presenting with skin necrosis and hypercoagulation due to some anticoagulant. What drug? Answer warfarin. Warfarin causes hypercoagulation and dermal necrosis. Anybody? It is due to what mechanism? Warfarin inhibiting protein C. By inhibiting protein C, they're going to increases factor 5 and 8 level. This causes hypercoagulation and dermal necrosis. Okay. Similar to this, you should also know warfarin may cause purple toe syndrome. A purple toe syndrome is due to release of cholesterol emboli from arteriovenous plaque. That part is also important, and it is due to protein C blocker. Okay, and then this question, OG question, pharmacology question, anywhere question: which are the safest anticoagulant for treatment of deep vein thrombosis in pregnancy? In the first trimester, always go for LMWH. In second trimester, 12 to 36. In this weeks also best is LMWH. If not, if we can also go for warfarin. In this trimester, warfarin allowed. For example, this lady having prostate wall. In prostate wall patient, best is warfarin. But warfarin unsafe in first trimester. We can allow this in second trimester. Whereas after 37 weeks, better go for LMWH. This are all very important obstetric gynae question as well as pharmacology question. Very important question. Okay. And then look here. Coming to cholesterol chapter, this is important. Name the cholesterol lowering drug causes cutaneous flushing and hyperuricemia. Answer nicotine. Nicotinamide, the so-called vitamin B3, called nicotinic acid. It is useful for controlling LDL. It reduces LPA cholesterol and increasing HDL cholesterol. Such a wonderful drug elevating HDL but causing adverse effect of cutaneous flushing, also causing adverse effect of increased uric acid, hyperuricemia. Remember, hyperuricemia and also flushing are the characteristic adverse effect of nicotine, so-called niacin, so-called vitamin B3. And can you please answer? To control the flushing, what can be done? The flushing is due to release of vasodilatory prostaglandin. So to control that, add with the aspirin. Aspirin going to inhibit prostaglandin synthesis. So question, niacin given with aspirin. The purpose is aspirin controlling synthesis of prostaglandin, thereby controlling the risk of flushing. If not, we can have one drug called laropiprand. It's a prostaglandin receptor blocker. This also can be tried, but usually we go with the aspirin. Remember, for controlling niacin induced flushing, best to go for aspirin. And then mechanism action based questions on cholesterol lowering, very important, you must remember. For example, you all know statin acting by inhibiting HMG co-reactase, a rate limiting enzyme. By inhibiting HMG co-reactase, statin decrease cholesterol synthesis. But you should know, whenever statin decreasing cholesterol synthesis, they causes upregulation of LDL receptor on liver cells. This causes engulfing. They're going to engulf the LDL from the blood into liver. So question, my statin decreases total cholesterol and decreasing LDL cholesterol. Total cholesterol control by inhibiting HMG co-reactase. LDL controlled by upregulating LDL receptor. But here you should know they cause adverse effect myopathy, all these things. But look here, name the drug going to prevent the, come on, actually LDL receptor undergo degradation by PCSK9. Now please answer, name some drug going to inhibit PCSK9. This is what important. PCSK9 blockers are having alirocumab and evolocumab. Very, very important. Name some monoclonal antibody that is targeting against PCSK9. Main thing of alirocumab, evolocumab, given injection subcutaneously, decreasing LDL cholesterol. And this year we may expect one more latest question. Name the drug going to inhibiting the synthesis of PCSK9. We have one thing called inclisiran. Inclisiran is going to inhibit synthesis of PCSK9. That's important. And similar to that, we should also revise some more drug. Name the cholesterol lowering drug inhibiting NPC1L1. NP, Niemann-Pick C1L1 transporter. This is blocked by your acetimibe. Acetimibe inhibiting cholesterol absorption from the intestine by inhibiting NPC1L1 transporter and causing adverse effect of passing cholesterol in the stool called steatorrhea. Okay, and can you please answer one latest expected question? Name the drug inhibiting angiopoietin like 3 protein. Well, angiopoietin like 3 protein. You have one think of Ivinacumab. We have one drug called Ivinacumab. A latest drug going to inhibit angiopoietin 3. Actually, the angiopoietin like 3 is normally inhibiting lipase enzyme. If I give evinacumab, it's going to inhibit this, thereby it's going to activate lipase enzyme, thereby decreasing cholesterol. So question, evinacumab targeting against angiopoietin T3. And then this important name the drug inhibiting citrate lyase. We have one drug called pemvidinic acid. Pemvidinic acid inhibiting ATP citrate lyase enzyme, inhibiting cholesterol synthesis. That means some important new drug in cholesterol lowering chapter. And kindly revise drugs and the important adverse effect. For example, statin mean myopathy. 5 it's mean causing gallstone. Like that, some important adverse effect. Niacin mean very important, causing flushing and hyperuricemia. And coming to kidney, come on. Following dialysis, there is a risk of dialysis disequilibrium syndrome. This causing severe. Please answer. A patient undergone aggressive dialysis developed severe. For this case, name the best diuretic. Answer Mantol. Mantol is the best diuretic for treatment of dialysis disequilibrium syndrome. And then nowadays asking only clinical scenario based question in diabetes chapter. So please answer. Patient with the liver disease having cirrhosis. For treating liver cirrhosis, the best diuretic go for spironolactone. Because in liver disease, there's a hyperaldosteronism. So it's an aldosterone antagonist. Aldosterone antagonist useful for treatment of liver cirrhosis. Whereas in liver failure, avoid using acetazolamide. Acetazolamide, a carbonic anhydrase enzyme blocker, is going to accumulate ammonia, so risk of hepatic encephalopathy. So be careful, avoid using acetazolamide in liver disease. And then heart failure. In heart failure, 3 questions. For rapid symptom relief alone, main go for furosemide. Furosemide having vasodilating property. The first action vasodilation, second action dilating. So furosemide useful only for symptom relief in LVF, whereas it is not going to modify disease. Whereas name the disease modifying diuretic in heart failure, go for spironolactone. So we have RAS. Renin. The RAS pathway blockers are wonderful disease modifying drug. So all those antagonists, so-called spironolactone having disease modifying property in heart failure. Whereas Last question. Name the diuretic contraindicated in pulmonema. Mannitol. Mannitol going to increases extracellular fluid volume, thereby going to aggravate the risk of pulmonema. And it's also contraindicated in severe kidney failure. Because in these cases they're going to aggravate the extracellular fluid volume. And then very simple question you must revise. Name the diuretic causing kidney stones. Loop. Loop diuretic loses calcium, thereby causing calciuria. The calciuria going to form stones. Okay. Whereas the stones are treated by thiazide. Thiazide causing calcium reabsorption, thereby useful for treating stones. Remember, thiazide useful for treating, causing stones. Okay, and then going to say in this portion. Okay, in alcohol chapter, for one answer for the what is the best drug for de-addiction alcohol? It is disulfiram. Disulfiram acting by inhibiting aldehyde dehydrogenation. So best drug of choice for de-addiction alcohol. But one interesting question. Come on. After de-addiction, can answer after de-addiction, name the FDA approved drug to prevent relapse. I have done proper de-addiction. Even after de-addiction, the chance of craving for alcoholism. So to prevent the craving, I have to put them on anti-craving drug like naltrexone. Very good. Naltrexone or acamprosate. Naltrexone, we know opioid antagonist. Acamprosate is an NMDA blocker. NMDA blocker with GABA agonistic property. Both are FDA approved drug for preventing relapse. And then antidote for methyl alcohol, you should know it is 4-methylpyrazole, the so-called fluibazole. Fluibazole acting by inhibiting alcohol dehydrogenase enzyme. Remember, fluibazole also called 4-methylpyrazole, that is the specific antidote for methanol, and it's also antidote for ethylene glycol. For ethylene glycol also it is the antidote. Okay, and then come on. A chronic alcoholic patient, one fine day suddenly stop alcohol. Say October 2nd, Gandhi Jayanti, all the shops are closed. When you go for sudden stopping, go for withdrawal syndrome. Can be for treating alcohol withdrawal syndrome, best go for benzodiazepine like diazepam or chlordiazepoxide or lorazepam. We go for diazepam or lorazepam or chlordiazepoxide. All are wonderful drug for preventing withdrawal. One interesting question. Suppose a patient taken overdose of benzo. Please answer. What is the antidote for benzodiazepine? Very important, very important. Come on. Name the specific antidote for benzodiazepine. It is flumazenil. Flumazenil is the specific antidote for benzodiazepine poisoning. Very important. Okay. And then anti-epileptic chapter, very important. You must revise. There is common anti-epileptic drugs and the important mechanism of action, adverse effect, and some choice. For example, infantile spasm, also called West syndrome. Here, EEG shows hypothermia. Now, please answer. Only for infantile spasm alone, main choice go for ACTH. Only for alone, main go for adrenocorticotropic hormone. Whereas a baby with infantile spasm having multiple brain tumor, so-called tuberculosis. In that case, drug choice go for vigabatrin. Okay, so only for infantile spasm alone mean go for ACTH with multiple benign tumor, so-called mean go for vigabatrin, and vigabatrin causing adverse effect of bilateral field of vision defect. Very important, causing vision defect, rarely causing psychosis. Okay, and can you please answer? If a child is having in the school only star looking, only absence seizure, nothing else. See, absence is also called petimol. Here the problem is T type of calcium channel. So for treating this case, the best is go for ethosuximide, a T type of CCB. Only absence alone main choice is ethosuspect. Whereas absence seizure with the extra problem like myocardial jerk or tonic-clonic mean in that case go for valproate. So only for abscess alone main answer is the suspect with myocardial jerk with it with the tonic-clonic mean go for valproate. And then serotonin syndrome based question important. Suppose a patient taking SSRI antidepressant with the MAO inhibitor, there will be too much of accumulation of serotonin. They cause serotonin syndrome. Can you please answer? If fetal syndrome, what is the best symptomatic therapy for this case? Yes, good answer. Cyproheptadine, very important. Cyproheptadine, a first generation antihistamine, has additionally anticholinergic property plus 5-HT2 blocking property. It is the drug very useful for managing symptoms of serotonin syndrome. So this is again expected question, important question. Okay, and then can you please answer this question? Attention deficit hyperkinetic disorder. Here, what are the best choice? Name one non-stimulant drug, very important drug for this case. You want to think of atomoxetine. It's a non-stimulant called selective noradrenaline reuptake blocker. Atomoxetine, a selective norepinephrine reuptake inhibitor. Whereas, name the stimulant drug, very fantastic drug of choice for treatment of this case, mean go for methylphenidate. The methylphenidate acting by releasing noradrenaline and dopamine. So remember, methylphenidate acting by releasing norepinephrine and dopamine, whereas atomoxetine acting by inhibiting reuptake of norepinephrine. These two are expected. So please revise this. Okay. And then can you please answer? Name one antipsychotic drug causing adverse effect of hypersalivation, clozapine. This drug, because of hypersalivation, pillow become which we call pillow wet syndrome, and it also causing adverse effect of myocarditis and very important dose independent agranulocytosis. Very important. Dose independent. Even on single dose, this problem going to occur. So, patient on clozapine should advise to undergo every week, complete complete blood count checkup should be done every week, at least for first 3 months. And one important point, this drug has property of anti-suicide activity. Can you please answer? Name the two wonderful drug having anti-suicide action. One is clozapine. Anybody? Name any other drug what you know having anti-suicide action. Lithium. Lithium also having anti-suicide activity. So clozapine and lithium having anti-suicide activity. Very good, very good. And then can you please answer regarding antipsychotic, that to atypical antipsychotic, very important. Their mechanism action, their adverse effect, very important. Name the atypical drug causing adverse effect of QT prolongation. It's mainly ziprasidone, also QT but mainly ziprasidone. The unique adverse effect of ziprasidone causes QT prolongation. And usually atypical antipsychotic causing less EPS. Whereas my question, name one atypical drug causing more EPS. Answer risperidone. We have one thing called risperidone. Risperidone. It's a 5-HT2A blocker plus D2 blocking property. So question, risperidone has strong D2 blocking property, so risk IPS. That's why whenever you give risperidone, better supplement with centrally acting anticholinergic like trihexyphenidyl. For treatment of EPS, we use centrally acting anticholinergic like trihexyphenidyl, so-called benzhexol. So, question: which is the atypical drug needs supplementation of central anticholinergic? Think of risperidone. Okay, and then anybody, what is the best drug for treatment of PDP, Parkinson disease psychosis? For treatment of PDP, we go for atypical antipsychotic like clozapine or quetiapine. But in this August, you must know question for near coming PG. Name the FDA approved drug for treatment of PDP. Go for pimavanserin. It's FDA approved atypical antipsychotic called 5-HT1A inverse agonist. It is FDA approved drug for treatment of PDP, Parkinson disease psychosis. And then TCA poisoning, very important. You must know. Look here. In TCA poisoning, the classical symptoms are thesis pneumonic, cardiotoxicity, convulsion, coma, also metabolic acidosis. So, can you please answer what is the antidote? Come on. What is the antidote for treatment of this poisoning? The first thing, correction of acidosis by injecting sodium bicarbonate. Very important, very important. And then correction of other problem. Look here. For treatment of arrhythmias, we can use lignocaine or betlium. If there's a QT prolongation, we can also go for MgSO4. But remember, doctor, the TCA having sodium channel blocking property plus anticholinergic property also. So, my question, for treating TCA induced arrhythmia, don't use class 1A drug because class 1A drug also has sodium blocking property plus anticholinergic. So, question, which is the anti-arrhythmic class should never used for treatment of TCA poisoning class 1A drug. Very important, very important. For treatment of convulsion, we can go for diazepam, and for coma, supportive therapy. Remember, for TCA poisoning, there's no role for hemodialysis because it has large volume of distribution. Remember, any drug having large vitamin distributed in the cellular compartment, there's no role for hemodialysis. Okay, and then can you please answer? Name the wonderful FDA approved drug for treatment of postpartum depression. I have two drugs. One is injection, one oral. The injection is brexanolone. Brexanolone, a injectable drug, is a neurosteroid, a GABA agonist given intravenous infusion for 2.5 days. So 60-hour delivery called brexanolone. Whereas oral drug is zuranolone. It is also a neurosteroid, GABA agonist, orally once a day for 14 days. So, read the question, doctor. Injectable intravenous drug mean go for brexanolone, whereas oral drug mean go for zuranolone. Both are FDA approved drug for treatment of postpartum depression. Okay, and then can you please answer? Name the NMDA blocker useful for treating depression that too given as a intranasal spray form called S-ketamine. Very important. S-ketamine, a ketamine derivative, NMDA blocker approved for treatment depression that too intranasal spray form. Spray form. Okay, good, good, good. And then name the antidepressant useful for treatment of ED. We have one drug called trazodone. Trazodone. It causes adverse effect of priapism. This property was exploited for treatment of ED. Okay, and remember we have something called SSRI. SSRI causing adverse effect of delay in ejaculation. This property useful for treatment of premature ejaculation. For example, dapaxetin, a FDA approved drug for treatment of premature ejaculation. Now you should know which are all the antidepressant having no sexual problem. For example, among the antidepressant, least sexual problem with bupropion. Bupropion, one of the NDRI, very important, is a norepinephrine dopamine reuptake inhibitor. A wonderful drug, has no sexual side effect at all. Wonderful drug. And one more thing, it's a wonderful drug for treatment of depression, smoking control, as well as improve attention span in ADHD, also controlling body weight, useful for obesity. But the only thing it causes adverse effect of seizure, also causing anxiety. That's one important. And Mirtazapine also having less risk of sexual side effect, but it is a very good drug having anti-histaminic property. It has anti-histaminic property, thereby improve appetite. Also have good sleep. So depression with insomnia, I can go for mirtazapine. Depression with insomnia, I can go for mirtazapine. I'm going to improve body weight also. Okay, and then for opioid de-addiction, the best drugs are we have one thing called methadone, one more drug called buprenorphine. So methadone, a full agonist of opioid, full agonist, pure agonist. Buprenorphine, a partial opioid agonist useful for de-addiction. So read the question. Name the pure opioid agonist useful for de-addiction mean methadone. Partial mean go for buprenorphine. Okay, and then after complete de-addiction, can I please answer? To prevent relapse, to prevent the recurrence, put them on naltrexone. Naltrexone, a wonderful opioid antagonist, useful for preventing relapse after de-addiction of alcohol as well as after de-addiction of your opioid. Okay, so naltrexone is the best. Okay, and then coming to endo, we done CNS part, now endo part. If I finish endo and then only GAT, another hardly 5 to 6 minutes. Okay, come on. In endo, very important question. Look at HIV associated lipodystrophy. Remember, HIV with lipodystrophy. Look here. When I use anti-retroviral drug, they cause lipid redistribution causing lipodystrophy. For treating that, we go for tesamorelin. It's a growth hormone releasing factor analog. It's a growth hormone releasing factor analog approved for treatment of HIV with lipodystrophy. And then, can you please answer? Name one recombinant IGF, insulin-like growth factor analog, useful for treatment of dwarfism. Can you please answer? Name one IGF analog. Answer: mecasermin. Mecasermin is a recombinant IGF analog useful for dwarfism. Actually, for dwarfism, I will try something called somatram, or I try somatropin. Now tell me, the somatropins are growth hormone. They are the one commonly useful for treating dwarfism. But question, even after using somatropin, patient not responding. That means growth hormone insensitive case. We call this Lawrence syndrome. Growth hormone is not acting because receptor are not working properly. So in case of growth hormone insensitivity case called Lawrence syndrome, in that case directly we go for IGF analog, so called mecasermin. So mecasermin, a wonderful drug for treatment of growth hormone insensitivity syndrome, so called Lawrence syndrome. And then, can you please answer these three questions? Very interesting question. Name the drug reducing growth hormone release, thereby useful for treatment acromegaly. That's called somatostatin analog, so-called octreotide. The octreotide acting on hypothalamus, controlling release of growth hormone, whereas it is injection. Whereas name the oral drug controlling growth hormone release mean go for bromocriptine. D to agonist bromocriptine. Whereas this what very important today, because something called growth hormone receptor blocker useful for acromegaly. That's called PEGI. So remember, pegosermin is the growth hormone receptor blocker useful for treatment of acromegaly. So it is reducing release, it is blocking a receptor. This difference you should know. Very important. And then, can you answer? Name one somatostatin analog useful for treatment of Cushing syndrome. You won't recall. Pesario. The pesariotide, like octreotide, it's a somatostatin analog. It is able to decreases ACTH release from pituitary, thereby useful for treatment of Cushing syndrome. Remember, since decreasing this, it is also useful for treatment of Nelson syndrome. Nelson syndrome. So in Nelson syndrome also, they are able to decreases release of ACTH. In this conjunction, you should know the two wonderful drugs useful for treating Nelson syndrome. What is Nelson syndrome? That is, if you do bilaterally adenectomy, in bilaterally adenectomy cases, no feedback control of ACTH. So too much of ACTH release causing hyperpigmentation. To control that, we have something called cabergoline and pursuing. Remember, cabergoline is a D2. It's a D2 agonist. Pursued a somatostatin analog. Both of them able to decreases release of ACTH. This property useful in the treatment of Nelson syndrome. And then, can you please answer? Name the drug useful in the treatment of hyperthyroidism in pregnancy, causing adverse effect of keratogenicity in the form of aplastic cutis. Look here, there's absence of skin in the scalp. Answer: thioamide, like carbimazole, carbimazole. Okay, thioamide, methimazole, very good, methimazole. They call thioamide. They are causing aplastic cutis and corneal atresia. That's why they are unsafe in first trimester. Can you please answer? In first trimester, best is go for PTU. Propyl thiouracil is safe in first trimester. But you should know, when I give this for more than 3 months, mother will develop severe hepatotoxicity. So only for first trimester. From second trimester, we can go for methimazole. This point, OG point, but very important point. Okay, and then additions. Addition is mean deficiency of both glucocorticoid and mineralocorticoid. For this case, we have to go for supplementation of gluco and mineralocorticoid. Look here, hydrocortisone. Here, glucocorticoid has highest mineralocorticoid activity. Also, fluorocortisone, primarily a mineralocorticoid, also has glucocorticoid also. So, for treatment of what is the best treatment for addiction mean? Go for hydrocortisone plus fluorocortisone, best for treatment of addiction disease. Addiction disease. Okay. So once again, name the glucocorticoid having highest mineral action mean go for hydrocortisone. Okay. And the one and only mineralocorticoid having additionally gluco action is fluorocortisone. Very important. And finally, we have something called beta methazone, beta and dexa. They have very high gluco action, thus way useful for antenatally to improve fetal lung maturity. So, which are the steroid recommended antenatally to improve fetus lung growth? Mean think of beta methazone and dexamethasone. Very important. Beta mean 2 dose, dexa mean 4 dose. All are very important. Okay. And then diabetes chapter, very important. You must revise. Look here. Can you please revise the important point? Anti-diabetic drug causing heart failure mean think of saxaglutine and pioglitazone. Pioglitazone causing fluid retention, causing heart failure. Saxaglutine, a DPP4 inhibitor. This also causing risk of heart failure. But again, you should know which are the anti-diabetic useful for treating heart failure. Very important. The useful for heart failure of SGLT2 blocker. Especially the 3 important FDA approved drugs are DAPA, EMPA and sotagliflozin. Remember, DAPA gliflozin, EMPA gliflozin and sotagliflozin is a AGLT1 and 2 blocker. It is both blocking AGLT1 and 2. Okay, so which are mean DAPA, EMPA and sotagliflozin. Okay, and then some adverse effect based questions are repeatedly coming on. regarding anti-diabetic, which are causing recurrently UTI, that too mainly causing fungal infection. Answer AGLT2 blocker. They cause glycosuria, the glucose acting as a cultural media, they way causing fungal infection. And very important, name the group of drug causing upper respiratory infection. It is DPP4 blocker. They cause minimal decrease in lymphocyte count. By decreasing lymphocyte count, they cause minimal immunodeficiency, causing upper respiratory infection like sinusitis, cold, all these things. Okay. And then come on. Name the group of drug causes external genitalia ulcer gangrene called found gangrene. Again, think of AGLT2 blocker. And here you should know. Name the anti-diabetic drugs causing adverse effect of osteoporosis. That way, be careful in post-menopause ladies. One is paclitaxel, one more thing, AGLT blocker, especially canagliflozin. Remember, the two important anti-diabetic drugs reported to cause osteoporosis are number one, pioglitazone, one more drug called AGLT2 blocker, so-called canagliflozin. And this is very important, okay? And then, can you please answer? Name the three important anti-diabetic drugs approved for treatment of obesity. One is liraglutide, semaglutide. These two are GLP, that is glucagon-like peptide. Liraglutide and semaglutides are GLP-1 analog, whereas we have a new drug called tirzepatide. Tirzepatide, it's a GIP plus GLP. GIP means glucose dependent insulinotropic polypeptide. GLP mean glucagon-like peptide. So the tirzepatide, a latest drug called GIP plus GLP agonist, all are given injection subcutaneously for treatment of obesity. And here one extra point, semaglutide is an injection, can also used orally. So the one and only GLP drug can be used to oral mean answer semaglutide. Okay. Next, can you please answer? Name the corticosteroid called a soft shell. We have one thing called cyclizonide. It's a prodrug. It is activated and inactivated in the airway itself. It never causing any systemic adverse effect. Since it has no systemic adverse effect, it is called harmless, so-called soft steroid called cyclizonide. And then in endo, the last one important chapter, osteoporosis. Drugs useful for osteoporosis. Name, mechanism, ADR, very important. Can you please answer? Name the drug useful in the treatment of osteoporosis causing adverse effect of DVT. That's called relaxin. Relaxin, one of the ACRM, useful for treatment of breast cancer as well as useful for preventing DVT, but uh, has the risk of causing DVT. Useful for preventing breast cancer and for osteoporosis, but risk is deep vein thrombosis. Next, name the group of drug useful for osteoporosis causing adverse effect of femoral shaft fracture called Chokshi fracture. Answer: bisphosphonates, a group of drug, has the risk of causing atypical femoral fracture, also called Chokshi fracture or stress fracture. Remember, we have one drug called zoledronate, causing this problem. And one thing, we have something called oral bisphosphonate like alendronate. Oral drug causing mainly erosive esophagitis, very important. And then name the drug useful in osteoporosis causing risk of bone cancer. This point very important, very important. We have something called parathermone analog like teriparatide. It's a para analog useful only for 1 year. At the maximum 1.5 years, not more than. If you give more than 2 years, if you give more than 2 years, risk of causing bone cancer. Very, very important. Name the drug useful in osteoporosis, causing adverse effect of causing bone cancer, mean teriparatide. And then name the drug useful in osteoporosis, causing adverse effect of liver cancer, calcitonin. It may cause adverse effect of hepatic cancer. Like that, you should know, doctor. And one more thing, can you answer? What is the target? Name the target. Target of denosumab. Denosumab. Targeting rank rank L. Targeting against rank L receptor. Denosumab rank L. Very important. Okay. And then coming to GIT, my last part. See, I covered ANS, CVS, renal, blood, and then now end over. Now last part is going for GIT. Anti-cancer drug causing vomiting. For controlling vomiting due to anti-cancer, best is 5-HT3 blocker like ondansetron, granisetron, palnosetron, the best. So generally for treatment of vomiting due to anti-cancer, mean I go for 5-HT3 blocker. Whereas question starts. For treatment of late phase vomiting, I have one thing called NK1, neurokinin 1 antagonist, like aprepitant, fast aprepitant, rolapitant, NEETPG, all are NK1. They are long acting drug useful for treatment of late phase vomiting. Again, one super important question. Name one 5-HT3 blocker having long acting. It is called Palano. Half-life is about 40 hours. So, it's a wonderful drug even for late phase vomiting. So, name the 5-HT3 blocker longest acting mean answer palnosertib. And one say, today in most of the hospital use there is one atypical antipsychotic having anti-emetic property as well as inducing appetite that may improve weight gain in cancer patient called olanzapine. Very important, very important. Today it's very famous. Name the antipsychotic drug useful for treatment of cancer chemo vomiting. Think of olanzapine. You have atypical drug having anti-emetic property plus appetite stimulating property. Wonderful, wonderful drug. And then, can you please answer simple question? Name the drug useful in the treatment of constipation causing melanocytic. There's a pigment in colon called melanocytic called senna. Senna is the herbal medicine useful for treatment of constipation causing melanocytic. And then, very important question, very simple. Name the drug useful in gastritis, acid peptic disorder causing adverse effect of black color tongue. Bismuth. Bismuth, one of the drug called ulcer protective agent causing adverse effect of black color tongue and black color stool. Okay. And very interesting question. Name the drug useful in the treatment of diarrheal type of IBS causing adverse effect of ischemic colitis. Answer allocertan. Allocertan, a 5-HT3 antagonist acting on intestine having prokinetic property useful for treatment of useful for diarrhea, useful for diarrhea. Actually, it's 5-HT block. Remember, just one clarity. Actually, the 5-HT3 receptor in the intestine having prokinetic property. My drug is a 5-HT3 blocker, thereby controlling the motility, thereby useful for treatment area, causing adverse effect of constipation. One more thing causes ischemic colitis. So, question: name the drug causing ischemic colitis. Mean think of allocertan. And then very frequent question, you must know question. Omeprazole and clopidogrel drug interaction based on dexamethasone actor. Clopidogrel, a antiplatelet but prodrug, it needs activation by CYP2C19. So question, omeprazole has the property of inhibiting CYP2C19, thereby interfering the activation of clopidogrel. So 2C19. And then Moebius syndrome, keratogenicity caused by what? we want to call misoprostol. It's a PGE1 analog useful for abortion, useful for gastritis. When using for abortion, if abortion takes place, okay. If not taken, the chance of this syndrome. Can you please answer? In this syndrome, the baby born with the dash and dash nerve defect, sixth and seventh nerve defect, very important. In this syndrome, risk of sixth and seventh nerve damage. Okay. And then this I discuss black color tongue advertisement of your so-called bismuth, yeah, ulcer protective agent. Okay. And then anti-emetic shaft reports. Look here. Name the best anti-emetic for mountain sickness. Actually, for mountain sickness, the first statement is asking to come down rapidly. Rapid descent is the first option. Whereas anti-emetic mean we go for uh, astazolamide. Astazolamide, a carbonic anhydrase enzyme inhibitor, causing metabolic acidosis, thereby increasing ventilation, thereby overcoming hypoxia. Okay, so first treatment rapid descent, drug main go for astazolamide. And then very interesting question. There's a patient receiving anti-emetic drug developed acutely basal dystonia, one type of EPS. What drug? Answer metoclopramide. Metoclopramide actually a D2 blocker having additionally 5-HT4 agonism property plus 5-HT3 antagonism property. The metoclopramide able to cross the blood-brain barrier because of blocking D2 causing EPS. So, a anti-emetic cause EPS means think of metoclopramide. For treating this, we go for either benzhexol or go for promethazine. Promethazine, a antihistamine having high anticholinergic property. So, you should know how to treat various type of EPS also very important. Okay, and then finishing question, only three more slides. Look here. Name the direct chloride channel activator useful in the treatment of constipation type of IBS. Name the direct we want to call luibresome. Luibresome acting on prostaglandin receptor in the intestine. It's a direct chloride channel activator useful for treatment of constipation IBS. And then anybody name the drug called sodium hydrogen exchange. Sodium hydrogen exchange blocker approved for treatment of constipation type IBS. It is tenapanor. Expect the question. Tenapanor is the so NH means sodium hydrogen exchange blocker called tenapanor, useful for treatment of IBS. We have linaclotide and plicanotide. These are gonal cyclase activator useful for treatment of constipation type of IBS. Whereas important question, tenapanor is the latest drug called sodium hydrogen exchange inhibitor. Okay, so what we done so far, actor? We finished with the given time. Initially, small struggle in the connection, all these things. Sorry for that small inconvenience, but after 5 minutes, everything very fine. I think I covered most of the important points from ANS, CNS, your blood, renal, CVS, also endo, GAT. I think what we discussing LRR and then DVT last 2 days, today and tomorrow marathon, and then small relax, and enjoy. Okay, and don't develop pharmacophobia, develop pharmacophilia, and become a pharmacomaniac. Okay, so don't get worried, actor. You know subject when you're discussing your rapid typing mean that much amount of energy you are having. So definitely you're going to get a very good rank. So the bright future waiting for you. Remember, nothing is impossible. You are going to have a very good rank. You are born to win. So going to success. You are going to see success. So may God bless you. I am fully praying for you to get a very good rank. All the very best. May God bless you. Thank you all. Thank you all.
Yeah, hello guys. So good evening all of you, and I'm Dr. Dinesh, and we are going to start the remaining topics in pharmacology. I will not take the much time because most of the topics are already covered, but the remaining part like general pharmacology and anti-cancer chemotherapy part is remaining. So let's discuss about it. So yeah, I hope I'm audible and visible. So good evening all of you, and I'm Dr. Dinesh, and we are going to start the remaining topics in pharmacology. Okay. So let's start without wasting the time. So the first important question in general pharmacology is about the P glycoprotein. So P glycoprotein efflux is there. P glycoprotein efflux is there. In P glycoprotein efflux, it is one of the ATP binding cassette. The main drug for this substrate drug is digoxin, and we should know the PGP inhibitors. These are the PGP inhibitors. So there will be interactions. There will be interactions based on this. So in the interactions, you can see the quinidine, verapamil. These two are very important drugs. These are causing the interaction with the digoxin, and because of this, there will be increased digoxin concentration that leads to toxicity. So that is very important. Don't forget the P glycoprotein efflux. Next is bioavailability. In the bioavailability, this graph is important, and the value of Tmax will tell us about the rate of absorption. The value of Cmax will tell us about the maximum concentration, and the most important is area under the curve, which will tell us about the extent of absorption. So we have these two, Tmax and area under the curve. So bioequivalence means if the drugs are having the same bioavailability from the different brands, but one exception for this is phenytoin. Okay, so let's see next. Volume of distribution. You should know the drug which is having highest volume of distribution, and the name of the drug is chloroquine. And don't forget this. I think every bacha knows it is the bull's eye maculopathy due to chloroquine hydroxychloroquine. Okay, great. So these three are important points in general pharmacology. The first is redistribution phenomenon seen in which drug? The name of the drug is thiopentone sodium, and that's why it is short acting drug for induction purpose. The drug metabolized in the plasma, many drugs are there, but very important drug is landiolol. It's a new drug. It is beta blocker, and it is the shortest acting beta blocker. So nowadays the shortest acting beta blocker is landiolol, not the esmolol. Esmolol is one of the short, but landiolol is the new. And the third, which is very frequently asked, is Hoffmann's elimination, the drug which is going to eliminate through lungs, and that is etracurium. So these three are the direct question. One more important question is about the hemodialysis, where the dialysis is not effective or where the dialysis is effective. So my request to all of you, please don't forget these two drugs. One is digoxin and one is benzodiazepines like diazepam. In these two drugs, they are frequently asking the question that dialysis is having no role, and that's why we should know the antidote of these two drugs. And in rest of these drugs, aspirin or the alcohol or the barbiturates, you will see the dialysis will be very effective. The reason the dialysis is not effective in the digoxin and benzodiazepine because they have the high distribution in the tissues, and because of that there will be no role of dialysis. Next comes to the order of kinetic, first order versus zero order. Don't forget the rate of elimination is constant in the zero order kinetic, but elimination is directly proportional to plasma concentration in the first order kinetic. But in first order kinetic, the fraction is constant, the half-life is constant. So this is mostly followed by most of the drug, but some drugs which follows the zero order kinetic, and that is alcohol, most important. So alcohol is the drug which is following the true zero order kinetic or pure zero order kinetic. Okay. And guys, this is one of the very important interaction based question. Out of the interaction based question, one question is frequently asked: rifampicin causing the occipitals failure. Rifampicin causes the occipitals failure. Cat group of drug. Cat group of drugs, there will be toxicity of cat group of drug if you inhibit the CYP, like ketoconazole, erythromycin, they are the CYP inhibitor, and you will see that cat group of drugs are having the toxicity risk. This is interaction, I think already covered in the hematology. Clopidogrel is a prodrug, it is going to activate through this CYP2C19, and omeprazole will suppress this, so slow the activation of the clopidogrel. Same with the tamoxifen, which is the drug for breast cancer, SSRIs, antidepressant, and they inhibit this CYP2D6. So don't forget these 4 interactions which are frequently asked in your NEET PG exam. Okay. Frequently asked question from these formulas, or they can ask you the numerical as well. From the loading dose, it depends mainly on volume of distribution. From the maintenance dose, which mainly depends on the clearance rate. And half-life, very important guys. Half-life is 0.693 in exam. Don't forget to convert it into 0.7. 0.7 multiplied by VD and divided by the CL. And don't forget that VD is given in the liter or liter per kilogram, so you have to see that. Clearance, you have to see whether it is ml per minute or liter per hour, you have to see that. So that is these formulas, these 3 formulas are very important in general pharmacology. Next one about this antagonism graph. So this is, you can see the effect of antagonist, and this is also the effect of antagonist. If the graph shifted to right side, you can see the efficacy remains same, but the potency will be down. So this is always competitive. But if the efficacy goes down, you can see the graph shifted to down, efficacy goes down, but the potency remains same, because 50% the dose required is same. That means it is the irreversible non-competitive antagonist. So don't forget, in right we have the competition, right? Okay, competition is always right. This image, they are asking this about this image, a full agonist, because you can see only activator, no inhibitory, so it is a full agonist. In this both are there, but A is more, so it is partial. In this both are equal, so because of minus and plus equal, this is antagonist and this is pure blocker. This is pure blocker, zero intrinsic activity. And in the inverse agonist, you can see there is no A, only I, it is opposite action. This is the inverse agonist. So these 4 type of possibilities in the receptors actions are possible. Okay. And you know, in every exam, one question from the antidote. These antidotes are most important. One is fomepizole for alcohol. One is benzodiazepine, flumazenil for benzodiazepine, diazepam, naloxone for opioid. These 2 are one of the frequently asked, but the other is for organophosphate, we have the atropine, but they can ask you the opposite. For atropine or belladonna poisoning, we have the drug physostigmine. These antidotes are frequently asked. So one question from the antidotes you can expect in your exam. Next is, this is very hit thing nowadays, cranberry juice used for amphetamines, or you can say the alkaline drugs. For alkaline drugs we use the cranberry juice because this is acidic juice. And soda bicarb is used for acidic drug poisonings like aspirin, barbiturates, etc. Okay. Then range of some of the drug, therapeutic range of some of the drug, the most important is lithium. Without this, you know, the exam is not over. They ask the question from the lithium. The level is 0.5 to 1.2, but if it is more than 1.5, then it is risky, it is toxic. So up to 1.5 okay, but more than 1.5 is toxic. Okay, don't forget the lithium. Second important is digoxin, but mostly they ask about the lithium. If the level of lithium is more than 4, then dialysis. If I ask you that we need to do the dialysis in the lithium, and when to stop this dialysis in the lithium, when the level of lithium comes down to which level, when you will stop the dialysis? Any bacha, when to stop the dialysis in the lithium? Tell me. I'm waiting for your answer. Dialysis has to be stopped when? One of the important is about the intracellular receptors. In the intracellular receptor, cytoplasmic and nuclear receptor. Cytoplasmic and nuclear receptor. So in the cytoplasmic, they are frequently asking about the vitamin D, and in the nuclear, one of the frequently asked is T3, T4 or vitamin A. Okay, so most of you are giving the answer 1, 0.8. So the correct answer is below 1. So 1 is the correct answer. If it goes below 1, then definitely you can stop. So 1 is the correct answer. PPAR, one important drug for PPAR alpha and PPAR gamma. For PPAR alpha, we have the fibrates, and for PPAR gamma, we have the glitazones. What is the name of the drug which is for dual PPAR? Dual PPAR. In the dual PPAR, we have one important drug, and the name of the drug is saroglitazar. Saroglitazar. Very important. Saroglitazar is the drug which is for both purpose. Very good, bache. Some important definition for essential drug. It is priority healthcare need, and the latest list for essential drug is NLEM 2022. The rare disease drugs are called as orphan disease drugs. Prescription drugs are called as Schedule H and H1, and narcotics are Schedule X like ketamine. Nowadays, we don't have the Schedule Y, that has been scrapped. We have the new Drug and Cosmetic Act. About the sham drug, these are the placebos, right? Okay, you can see this. This is jet track technique, and in the jet track technique, the two important drugs, iron and haloperidol, antipsychotic drug to avoid the staining. This is very important. Very important. One is misbranded, one is spurious, and one is adulterated. Adulteration means you are mixing something, impurities are there. Spurious means imitation or fake drug, Misbranded means inaccurate or misleading label information. So if I ask you, instead of paracetamol 500 mg, we got the PCM 200 mg. The label includes PCM 500 mg, but in real it was 200. What is the answer? Is it misbranded or the spurious or adulterated? What is the correct answer for this? Tell me, what is the correct answer? And then we will discuss the clinical trial. In the clinical trial, phase 1 is mainly for safety, human safety and tolerability. Very good, bache. All of you have given the correct answer. It is the misbranded. Phase 2 is just exploring the therapeutic effect, but phase 3 is very important. That is for confirmation of the best data. You will get the best data in the phase 3 regarding the efficacy and safety. And phase 4 is definitely for the rare things about the drug, that is post-marketing surveillance. Phase 0 is not the mandatory phase, that is the microdosing. Very good, bache. Bahut badhiya. So if I ask you, out of the phase 1, 2, 3, 4, where is the maximum failure rate? Where you will get the maximum failure rate out of the phase 1, 2, 3, 4? What will be the correct answer? The failure rate is maximum in which phase? Failure rate maximum in which phase? When you need to stop the trial. And one of the important topic is therapeutic index, that is the safety margin, the ratio of median toxic and effective dose. Yeah. In spurious, bache, there is no example for all the drugs. Spurious is possible. Like instead of remdesivir, you got the normal saline, right? But the label and everything is like remdesivir. That is copy, fake, right? Okay, phase 2, very good, very good. RCT, Abhishek ji, phase 2, phase 3, both are RCT. RCT is the best way to do the clinical trial. So phase 2 is having the maximum failure rate. Phase 2, and that's why most of the time you will see after phase 2 we stop the trial if the data are not good. If I ask you the value of this ED50 or EC50, the value of this ED50 or EC50 is important for what purpose? So this is important for potency. So this ED50 will tell us about the potency of the drug, but the ratio is therapeutic index. Okay, now let's discuss some of the important question from the antihistaminic. One important question from the antihistaminic is the drugs causing QT prolongation. So don't forget these 3 drugs. T. This is very important. The drug which is used during daytime, or you can say the least sedative drug. Least sedative drug overall is fexofenadine. That is one of the third generation. And there is one important drug for narcolepsy which is inverse agonist for narco S3 receptor, and that is tiprolizant or pitolisant drug. So that is the drug for narcolepsy, but I hope you know the best drug for narcolepsy. Can you tell me the name of the best drug for narcolepsy? What is the drug of choice for narcolepsy? Therapeutic window is the window where the drug is having the best effect, right? Or you can say the optimal effect. That window is called as therapeutic window. Out of the non-steroidal anti-inflammatory drug, one of the frequently asked thing is about the this Rage syndrome with the aspirin and semterstride with the aspirin. But there is one condition where you give the aspirin in the children. Can you tell me the name of that? Very good, bache. Modafinil or modafinil. Very good, bache. So can you tell me where we use the aspirin in children? There is one condition where we use the aspirin in children. One important condition. Any bacha, can you tell me where we use this aspirin in the children? Bata sakte hain? Okay. And we have the selective COX-2 inhibitor, but selective COX-2 inhibitor should not be used in the heart patients, risk of MI. So we should not use in the heart patients. So in heart patients, we prefer the still aspirin. Very good, bache. Very good. Kawasaki. And can you tell me in Kawasaki disease, if there is aneurysm, in the coronary artery, in the aorta, then for what time, till what time we continue the aspirin? If there is aneurysm, then what is the duration? That is also one of the important question. Okay, next is the drug for PDA closure. The best drug for PDA closure is ibuprofen, but we have the indomethacin, which is very effective. Very good, bache. For aneurysm, we give the lifelong. Very good, Harshimran. Very good, bache. Bahut badhiya. In the gout, overall best and very effective drug is colchicine, but the first choice of drug is NSAID, but overall most effective drug is colchicine, which is causing diarrhea as a common side effect and bone marrow suppression as the serious side effect. Very good. In chronic, allopurinol or febuxostat, that is the xanthine oxidase inhibitor. They are the best, but we have the uricase also, like rasburicase or baglodicase, which are also approved. Out of these, this febuxostat is a good drug for the CKD patients. This is a good drug for CKD patients. Very good, bache. There are some direct question from these antihypertensives which are having the uricosuric property. Is one of the important is losartan, and anti-dyslipidemic drug is having uricosuric property, that is fenofibrate. And this is one of the frequently asked topic is drugs causing hyperuricemia. So don't forget to remember the pained drugs are causing the hyperuricemia. So pyrazinamide and ethambutol from the antitubercular, then aspirin, niacin, one of the dyslipidemia drug, diuretics and immunosuppressants. Right? No, atorvastatin is not having the uricosuric property, but fenofibrate is the drug we are adding with this. Right? Okay. Out of the paracetamol, one of the frequently asked question is this interaction with the isoniazid. This isoniazid is inducing only this CYP, rest of the CYP was inhibited. Only CYP2E1 is induced, and that's why there will be more NAPQI, and this NAPQI will cause the centrilobular necrosis of the liver. But remember, PCM is overall very safe drug in children as well as during pregnancy we use it. But there is high risk of fulminant hepatic failure if the PCM level is very high. That's why acute toxicity as well as chronic both are possible. The antidote we use is the N-acetylcysteine. The role of this N-acetylcysteine it increase the glutathione peroxidation, and because of this glutathione peroxidation, now NEEPQI production will be less, because you induce the peroxidase. So NEEPQI will be less NEEPQI production, less toxicity. That is the reason we use the N-style system. And remember, after 3 days only you will get the symptoms of this, paracetamol toxicity. That's why it is very risky. Most of the time the patient comes with the liver damage only. One of the frequently asked topic is migraine in your exam. In the migraine, they are asking what is the drug for acute migraine having the risk of ergotism. So that is the peripheral end artery vasoconstriction. What is the drug which is not safe in the hypertension or ischemic heart disease? So both these drugs are not safe in the ischemic heart disease and hypertension, because there is risk of peripheral vasoconstriction. So it is risky for both, but peripheral vasoconstriction is mainly seen due to ergot. Out of these, if they ask you the longest acting, then it is the frovatriptan. But zolmitriptan is one of the drug which is recently approved, and that is given via intranasal. One more important drug is approved now, that is 5-HT1F, and they are more effective. So they are approved for the resistant cases of triptans. So we use the miditans, last miditan. CGRP antagonist, already approved but not commonly used, and these are the monoclonal antibodies as well. These are the MAB. Remember the EFG. These are three main: erinumab, fremanizumab, and galsezumab. These three. And out of the anti-migraine drug, one question is the drug which is risky for asthma, that is the beta blocker. So that's why in asthmatic patient, then we use the calcium channel blockers like verapamil. So if I ask you one drug out of the prophylaxis of migraine, one drug which is used for migraine as well as cluster headache, can you tell me the name of that drug? The drug for migraine as well as cluster headache, and that is used in the prophylaxis mainly. Can you tell me the name? Out of these only, can you tell me the name? So one drug which is for both migraine as well as cluster, that is one of the drug. Can you tell me the name? And don't forget, nowadays we use the onabotulinum, that is the scalp injection in the scalp. Very good, bache. Bahut badhiya. That is the verapamil drug. Then some question from the bronchial asthma. One of the frequently asked question is nowadays these monoclonal antibodies. So omalizumab for IgE, and mepolizumab, reslizumab, benralizumab, these three MRB, these three are interleukin 5, and dupilumab is interleukin 4. So remember the D comes at 4 number, so that is the interleukin 4 inhibitor, dupilumab. Nowadays tralokinumab and lebrikizumab, they are also under investigation. They are approved for atopic dermatitis. They are interleukin 13. So we have the 4, 5 and 13. Don't forget. Out of this, mepolizumab is also approved for Churg-Strauss syndrome. That is approved for Churg-Strauss syndrome. Mepolizumab. Don't forget that. Okay. Now some of the question from the antibiotics. Out of the antibiotic, one question from the cell wall inhibitor. The drug which inhibits the transglycosylase, by that inhibiting the chain elongation process, is vancomycin, which binds to D-alanine sequence. And transpeptidase, which is for cross-linking, that is the beta-lactam, and which is binding with the penicillin binding proteins. Right? Okay. Very good, bache. One important question from this N-methyl tetrathiazole ring. This ring is present in some of the cephalosporin, and which is causing the hemostatic abnormalities. So remember the parazone, para, tan and man. So parazone is the main important question. Cefoperazone, that is one of the third generation, which is very effective drug for Pseudomonas, and cefoperazone is also safe in the renal failure patient. It is safe in the renal failure patients as well. It is the drug which is effective for Pseudomonas. One regimen, beta-lactam plus beta-lactamase inhibitor, which is approved for carbapenem resistant Acinetobacter. Very important is sulbactam, durlobactam. So sulbactam, durlobactam, these two are approved. Durlobactam is used as beta-lactamase inhibitor out of these, and sulbactam having its own antibacterial property, and that's why sulbactam and durlobactam combination is approved. Very good. In the carbapenem resistant enterobacteriaceae like Klebsiella, E. coli, these two are very notorious. So in these type of bacteria, Nowadays we use the in the carbapenem resistance. What we use? So out of these we use the colistin drug, colistin or one tigecycline, or you can use the fosfomycin, because in the UTI we are using these drugs. But if aminoglycosides are resistant, in the New Delhi metalloproteinase type of bacteria, then we have these novel drugs, and out of these one drug we use commonly is ceftazidime plus avibactam. We use the imipenem relibactam or meropenem weberbactam. But out of these, don't forget these three new important drugs. One is plazomicin, that is one of the aminoglycoside, and cefidercol, that is one of the newer cephalosporin. It is having the class 3 in third generation as well as fourth generation property. Cefidercol. So that is important drug, cefidercol. Okay. So let's see now. One question from the Clostridium difficile diarrhea. I think every bacha knows about the pseudomembranous enterocolitis, and the most effective drug for this nowadays is fidaxomicin. The most effective is fidaxomicin, but one of the monoclonal antibody which is approved is basilotocumab. Okay. The second question from the MRSA. In injectable vancomycin is most effective, but in the topical we have the mupirocin, which is the most effective drug. Don't forget, nowadays the commonly used drug is linezolid because of the resistance risk. And out of the oral drug which is very effective for this is clindamycin. Many doctors or physicians are using the rifampicin, but we should avoid. Okay. Now, frequently asked question for chlamydia, azithromycin is the drug of choice. For mycoplasma, azithromycin is the drug of choice. For cholera, it is doxycycline, but in pregnancy or children, we use the azithromycin. Listeria, very important, listeriosis, we use ampicillin, and this is one of the very frequently asked question, B vaginosis, and that is metronidazole. Okay. So don't forget this drug of choices from the antibiotics. In antibiotics, two topics are frequently asked. One is mechanism of action and one is the drug of choice. Some of the side effects of antibiotics. Out of the side effect, one of the side effect is disulfiram reaction, and you know metronidazole is having the risk of disulfiram reaction. Which enzyme is inhibited? Any bacha? Which enzyme is inhibited? Is it alcohol dehydrogenase or aldehyde dehydrogenase? Which enzyme is inhibited by this? Alcohol or aldehyde? Which enzyme is inhibited? Any bacha? Which enzyme is inhibited? Congenital pyloric stenosis is due to erythromycin as well as diarrhea. QT prolongation is mainly due to macrolides azithromycin. Very good. It is the aldehyde dehydrogenase. Cartilage and tendons problems due to fluoroquinolones, and neuromuscular, that is aminoglycoside. That's why we should avoid these drugs in the myasthenia gravis patient. Even all these three we should avoid in the myasthenia gravis patients. Very good. Bahut badhiya. One direct question from vancomycin Redman syndrome, so we should give it slowly because of histamine. Rapid injection can cause the histamine release. Gray baby syndrome and aplastic anemia due to chloramphenicol. Linezolid is one of the frequently asked question nowadays. It is causing ocular side effects. It is MAO inhibitor, and because of this there will be cheese reactions as well as it can cause the serotonin syndrome. Because of this MAO inhibition. So don't forget this. Okay. Very important. Remember, in children less than 8 years we don't use the tetracyclines. Guys, how can you forget that tuberculosis? Tuberculosis is very important for MDR or XDR TB. Bedaquiline, delaminid and pretominid. These three are main drug, but one drug we use nowadays is linezolid. Don't forget the mechanism. It inhibits mycobacterial ATP synthesis. It inhibits mycolic acid synthesis, but it inhibits cell wall as well as respiratory poison because it is one of the nitro-free radical. It is DNA inhibitor. So don't forget this pretominid. That is one of the nitro-free radical. Right. So this is one of the regimen we are using, and that is this one, B-PAL-M regimen. I hope this has been covered as well in the community medicine. So B-PAL-M regimen is important for the resistant MDR TB patients. So we use it. It is the short course regimen. Oral drugs are there. So this is oral as well short course. 6 months. It can be extended up to 9 months. But mostly we use the 6 months. And this is the resistance of drug. Can you tell me the name of gene we are testing in the CB NAT for resistance? Which gene is going to we test for this gene? Gene mutations are there. So which gene we test in this? Is it RPOB gene or CAT-G gene? Which gene? Which gene you will test? I hope every bacha knows this one as well. As per the NACO, when the patient is having HIV or TB co-infected, so we start the ATT first, then only you start the ART. Very good bache. It is the RPOB gene. CAT-G gene we don't check. So this is ATT first. After 2 weeks up to 2 months, means up to 8 weeks, you can start the ART. But in the meningeal TB, wait for 8 weeks. Wait for 8 weeks in the meningeal TB, because the severe reactions and the patient may die as well. Out of the antiretroviral drug, the drug which is effective for hepatitis B as well, tenofovir and lamivudine. And one of the CYP inhibitor approved as booster therapy with anti-HIV drugs, like it is approved with the this gravir, elvidegravir. So we use the cobicistat. For treatment as well as post-exposure prophylaxis, the same regimen we are using, TLD regimen. Don't forget that dolutegravir dose has to be changed. Extra 50 milligram dose has to be given with rifampicin, because rifampicin is a CYP inducer. In mother to child transmission, I am not going into detail. That is the topic of community medicine. But in the high risk patient, we use the Zidovudine plus nevirapine. If the mother is not taking the ART and all, then we give the nevirapine plus Zidovudine. बहुत बढ़िया बच्चे. Very, very, very important question, guys. Don't forget these two drugs, lenacapavir and cabotegravir. These are the longer. So you can see every 6 months or every 2 months. So lenacapavir is one of the very important drug, and one is fostemsavir. Fostemsavir is GP120 inhibitor. So don't forget these two drugs, lenacapavir and fostemsavir. Very, very, very important drug for HIV patient. In hepatitis B, the most effective drug is tenofovir, but the specific drug we use is the entecavir. In the hepatitis C also, nowadays we have the specific drug. This is SB. So when there is SB, remember the NS5B inhibitor. And where is Asvir? So remember the 5A inhibitor. So whenever you see the SB or AS, you can accordingly give the answer. In the herpes, these are the drugs, except cytomegalovirus, we don't use it. In cytomegalovirus, we use these ganciclovir and valganciclovir. And the drug foscarnet and cidofovir. These are the drugs for resistant cases. Foscarnet and cidofovir. One from the fungus, the best antifungal for mucormycosis, black fungus, that is liposomal amphotericin B. And for there is risk of nephrotoxicity, that's why liposomal preparations are used. In esophageal candidiasis, it is fluconazole. For cryptococcal meningitis is also LAM. So can you tell me which azole is important for aspergillosis? Any bacha? Aspergillosis. Which azole is used for aspergillosis? And this is the recent question, recent PYQ, tavabrol, that is the nail lacquer form for onychomycosis, topically application. Then aspergillosis, one of the drug we use out of the azole, and that is voriconazole. बहुत बढ़िया. Out of the anti-malarial drug, one question is that exoerythrocytic cycle. So primaquine we use for 6 weeks. 2 weeks. And tafenoquine, that is a single dose. Can you tell me that primaquine is used in falciparum malaria for what purpose? So primaquine in falciparum malaria for what purpose? Then falciparum malaria, primaquine used for what purpose? That is gametocidal. So the both purpose is different. This is for this Vivex. In severe complicated, it is always artesunate, but in the first trimester we can give the quinine. For prophylaxis, start 1 week before and up to 4 weeks after we use. Yes. So in falciparum there is no role of radical cure, that is gametocidal. That is gametocidal. So if the journey is for more than 6 weeks, mefloquine. If the journey is less than 6 weeks, we use the doxycycline. For neurocysticercosis, it is definitely albendazole. For hydrated disease also, it is the albendazole. For river blindness, it is the ivermectin, that is acting via GABA chloride channel complex. Spastic paralysis. For most of the trematodes and cestodes, we use the praziquantel, but don't forget the liver fluke is one of the exception. In liver fluke, we use the triclabendazole. And for scabies, ivermectin is the oral drug, but topically we use the permethrin. That is the important topic in dermatology. Okay, बहुत बढ़िया बच्चे. Now last topic is anti-cancer drug. Out of the anti-cancer drug, the first question is bone marrow suppression. Bone marrow suppression. For anemia, we use the erythropoietin. One of the longer acting erythropoietin is darbepoetin. And out of the leukopenia, we use the filgrastim. And for thrombocytopenia, we use the oprelvecin. Don't forget this. Don't forget this bone marrow suppression. Vomiting, sir has already covered. I hope you know this. CINV. And nowadays, can you tell me the name of the latest drug which antipsychotic is approved? Antipsychotic drug for this. Any bacha? Antipsychotic drug approved for the chemotherapy vomiting in the resistant cases. I hope remember or you know. This is the olanzapine, atypical antipsychotic drug. Now, not clozapine, bache, olanzapine. Hand and foot syndrome commonly caused by 5-fluorouracil or capecitabine. Pulmonary fibrosis is commonly caused by bleomycin. Type 1 pneumocytes are damaged. Very good, bache. Also causing the flagellate dermatitis. These two are important questions: hand and foot syndrome and pulmonary fibrosis. Very important question. And the drug used in ENT for laryngeal stenosis as well as can be used for nasal septal surgeries. So what is the name of the drug which is used? That is mitomycin C. Topical infiltration. The drug which inhibits the DHFRase is methotrexate, and the drug which inhibits the thymidylate synthase is 5-fluorouracil. For both these drugs, to decrease the toxicity, we use the tetrahydrofolate or leucovorin. Cetrovorum. That is to decrease the toxicity. We use the tetrahydrofolate with that. One question from the anti-cancers causing radiosensitivity, that is gemcitabine. The drug causing radiation recall, that is anthracyclines. And the drug causing radiation protection, that is amifostine. So don't forget this. Amifostine is also nephroprotective. One question which is frequently asked is the from the platinum compounds. Remember, in platinum compounds, cisplatin is most toxic. Cisplatin, maximum nausea, vomiting, maximum nephrotoxicity, maximum ototoxicity. Nausea, vomiting, nephro and oto. But if they ask you which is more neurotoxic, then it is the oxaliplatin which is most neurotoxic. And carboplatin is having the more risk of bone marrow suppression. So these two toxicities are not maximum with the cisplatin, but nausea, vomiting, nephrotoxicity, ototoxicity is maximum. Some of the newer important thing, EGFR inhibitor, third generation for T790M positive non-small cell lung cancer, that is osimertinib. Don't forget this osimertinib. Out of the TKIs from the for the CML, first generation, second generation and third generation. Don't forget IND, India is first generation, bosutinib, India is the BOS, that is second generation, and Ponarado is third generation. Lepa-Nera, these are for breast carcinoma. So don't forget this generation. Don't forget this generation. These are important point in the TKIs. Osimertinib, don't forget. BRAF inhibitors and MEK inhibitors. So in this you will get the fenib, and in the MEK you get the metinib. So we use these for malignant melanoma. Important question for malignant melanoma. We use these drugs, BRAF and MEK inhibitor, malignant melanoma. Proteasomes inhibitors are Zomib, that is for multiple myeloma. That is for multiple myeloma, bortezomib. One important monoclonal antibody also approved, daratumumab. Bache, can you tell me which is orally used proteasome inhibitor? Which proteasome inhibitor is approved orally? Orally, only one. Then Janus kinase inhibitor. Socho batao. In Janus kinase we have the cetinib. These are approved for inflammatory bowel disease and rheumatoid arthritis. So one oral drug, I am waiting for your answer. The oral drug is ixazomib. Okay. Cyclin dependent kinase, that is palbociclib, and that is for breast cancer. That is for breast carcinoma. Okay, बहुत बढ़िया. PARP inhibitor for breast cancer, that is parib, olaparib, talazoparib, also used in the ovarian cancer also, PARP. And for cutaneous T cell lymphoma we have these drugs, NORCET. But penabinostat is also approved for multiple myeloma. So just remember the suffix, and by this you will get the answer. Okay, sir, which is the drug which is histone deacetylase inhibitor, which is the PARP inhibitor. Very good, bache. That was ixazomib. Immune checkpoint inhibitors. So direct questions are there. Direct question में you can see नए पुराने सेमी दोस्त. तो नए पुराने सेमी दोस्त is PD1. आते आवे दूर is PDL1, and pili meli is CTLA, and relatively is lag. तो relative is lag pulling. Pili meli is Katla. आते आवे दूर is PDL1, and PD1 is this one. But just remember the suffix and you will get the correct answer. So that we discussed. For breast cancer, very important question. Very important for breast cancer. If they ask you for HER2, then definitely they are asking the HER2 antibodies, that everybody knows. But TKIs are also there for this. But hormone receptor positive and HER negative, then remember Ciclibs are there. Ciclib. I am telling you what they can ask. These three. Then triple negative. We have the pembrolizumab. And for Barcazine we have the PARP inhibitor. Okay? So these are direct question from the breast cancer. Some important monoclonal antibodies, and that is diabetes, we have the teplizumab, that is CD3 inhibitor. For HIV it is Bali, that is inhibiting the CD4 cells. So tepli and ibalizumab. Alpha 4 beta 7 integrin inhibitor, that is vedolizumab, and alpha 4 beta 1, that is natalizumab. So don't forget Vedoli and Natali. Vedoli and Natal. And then we have the last one, immunosuppressant. For calcineurin we have the cyclosporin. For mTOR we have the tacrolimus. In the stent coating we have the everolimus. Everolimus for stent coating. So these these are calcineurin inhibitor. For mTOR we have the sirolimus and everolimus. Out of these, the drug which is causing the gingival hypertrophy and hirsutism, that is cyclosporin. Okay. One last recommendation from my side, don't forget this suzetrigine, that is a new sodium channel blocker approved for severe pain. That is one of the recommendation from my side. One drug also approved for non-alcoholic hepatitis, that is resmetirom. These two are important drug from the recent. So that's all. So this is all about pharmacology. Revise these topics in pharmacology. So sir has covered most of the systems. The remaining, the most boring part I have covered. General pharmacology, chemotherapy, most boring part we have covered. So that is all. I wish you all good luck, and only few days are left. Now don't solve the MCQs. My only advice is don't solve the MCQs and just focus on the quick revision, right? So best of luck to all of you. I pray to God you get to your dream branch, or whatever the branch you are thinking, you get that. Thank you. Bye bye. Take care. Namaskar.
Okay, so good evening, all of you. I hope I'm audible and visible. Can I get a quick thumbs up? So yes, it's a very tiring session for you. I can totally understand. Back to back, so many subjects, and you recently had your pharmacology, so I was there on the session for some time. I was listening to sir. So I hope you are all ready for dermatology now. Can I get a quick thumbs up? Yes, good evening, all of you. Good evening. Okay, so I think without wasting time, we should quickly start with NEET PG PYTs. So again, I'll tell you the same thing that we have, or I have made this session in such a way that I will almost touch all the important topics. And along with that, I'll keep asking you the questions and I'll keep telling you what are the important things you have to know for your NEET PG exam. Okay, chalo. So I think everybody is ready. I'm getting too much of thumbs up. Chalo ji. Yes, I can understood your brain is fried, but I hope you are all ready for the dermatology. Chalo. So we'll start with one image. The diagram is already, the diagnosis is already given. But what is this? This is an image of mycetoma, bacho. We are starting with subcutaneous fungal infections. Frequently asked. I've seen that almost every year we get one or two questions out of almost every alternate year we get one or two questions from the deep fungal infection. So mycetoma, what is the classical triad? They can ask you, anyone. The classical triad of mycetoma, it is swelling or tumification, discharging sinuses. So tumification or swelling of the affected area. Then we have sinuses, and if you keep a cloth on these sinuses, you can see some grains. Now, if you remember, I have told you there are mainly two colors of the grain. One is black and another is yellow. Can anybody tell me what does black color grain indicate? What type of mycetoma is this? Yes, this is a very classical eumycetoma. And if the color of the grain is yellow, what type of it? It is bacterial, which is actinomycetoma. Actinomycetoma. So please remember, you should know the clinical image, you should know this triad, and on the basis of the color you can decide whether it is a bacterial, which is actinomycetoma, or it is a fungal mycetoma, which is mycetoma. Okay, so this is the clinical image. You can see swelling, discharging sinus, and the grain. Amazing. First very important topic, that is mycetoma. This is the second very important topic. Can you see this lesion? A verrucous lesion which is present on the exposed areas. A plaque with rough surface. This is very classical of chromoblastomycosis. The causative agent of chromoblastomycosis is Phyllophora verrucosa. Please remember, this is a fungus which is usually present in the sand, in the soil, and the individual come in contact with them when they are walking barefoot, either in a soil, in a forest, or some place like that. Now, what is the characteristic feature is, when you do the histopath, you see brown color bodies. And what are these brown color bodies? Copper penny bodies, medullary bodies. Can anybody tell me one more name for it? Sclerotic bodies. So please remember from this topic, chromoblastomycosis, these two things, one is the causative agent, second is the histopath appearance is very important. So chromoblastomycosis mein you see verrucous plaque with copper penny bodies. Coming to the next, linear arrangement. Where do you see the very classical linear arrangement of nodules and ulcer? This is your sporotrichosis. Can anybody tell me what is the other name of sporotrichosis? What do you call? You call it Rose Gardner's disease. Rose Gardner's disease. What is the causative agent? Sporothrix shanki. The characteristic feature, why you see linearly arranged nodules and ulcers? Because this fungus enters the lymphatics and it spreads in a linear direction through these lymphatics. So very, very important, lymphatic spread, also known as sporotrichoid spread. But so there was a question which is asked previously, other than sporotrichosis, what all infections can have sporotrichoid spread? So Mycobacterium marinum infection as well as nocardia. So these three, Sporothrix, Mycobacterium marinum and nocardia, they all can spread through lymphatics, and that is why they have linear spread. What do you see on histopath? You see a very classical star-shaped bodies which is known as asteroid bodies. So these are some of the findings which you should know from sporotrichosis. So we are done with 3 subcutaneous fungus, very important, and I will say frequently asked in your exams. Coming to sebaceous gland, what do you know about, or what are the important aspect about the sebaceous gland? There are 2 conditions from which you get question. One is acne vulgaris, second is rosacea. Sebaceous gland always opens into the hair follicle, opens on the hair follicle, but there are some exceptions to it, and we call it ectopic sebaceous gland. On eyelid, meibomian gland. On areola, it is the Montgomery tubercle. On prepuce or penile shaft, it is Tyson's gland. And on the upper lip or verbena border, it is the Fordyce spot. Please remember, the sebaceous gland, its location, it is always opening onto the hair follicle. You can get this in your exam. It is an androgen dependent gland. Whenever patient attains puberty, when the androgen comes into the circulation, these sebaceous gland produce sebum. Can anybody tell me what is the content of the sebum? What is the content? Sebum is made up of 3 things. One is cholesterol, wax ester, and squalene. These are the 3 things of which you see sebum made up of. And please remember, if they ask you what is the common or the maximum concentration of sebaceous gland, it is present on the face and the scalp. So this is the important points. So sebaceous gland, first, it is always present in relation to the hair follicle, but there is some exception where it is not related to hair follicle, these 4. Maximum sebaceous gland on the scalp and face, and what is the content? It is the sebum. Coming to the next part, acne vulgaris. Acne is a disease of pilosebaceous gland. Please remember, acne is not a disease of sebaceous gland alone. It is a disease of pilosebaceous unit. Now, in your exam, you frequently get questions on the grades of acne. Grade 1, comedone. two type. One is known as blackhead or open comedones, and whitehead, which is the closed comedones. Whitehead, which is the closed comedones. So there are two types of comedones, and these are considered to be the grade 1. What is grade 2? Papules. Grade 3, pustules. Grade 4, cyst, abscess, scar, and even nodule belongs to grade 4. Now if you see, this is the image of a papule, this is the image of a pustule, and the one which is behind me here, this is a nodule. So in your exam you should know the images also, because sometimes they just give you the image and they will ask you question, what is this, or how to manage this patient. So please remember 4 grades: grade 1 comedone, which can be open or closed, grade 2 papule, grade 3 pustules, and grade 4 cyst or nodule. Now if I ask you treatment, can you tell me what is the treatment of grade 1? Anyone? Tell me, grade 1 treatment of choice, grade 2 what is the treatment of choice, grade 3 and grade 4 of acne. Anyone can tell me the answer. Grade 1 topical retinoid, drugs like adapalene, drug like tretinoin. These are the drug of choice for grade 1. For grade 2, what is the treatment of choice or drug of choice? Topical antibiotic, like you give Depson gel, you give clindamycin gel, you give benzoyl peroxide gel. So these are all topical antibiotics which are given. Oral antibiotic, we give either doxycycline or we give minocycline. But bacho, remember, minocycline has a very common side effects of pigmentation, and that is why we prefer doxycycline over minocycline. And coming to grade 4, what is grade 4 bacho? Oral retinoid, you have to give isotretinoin. If I ask you what is the most common side effect of isotretinoin, what will be your answer? Most common side effect of isotretinoin, please remember, dryness. The patient complains of dryness of lips followed by dryness of skin. But if I ask you which is the most serious side effect, or something which you should keep in your mind, please remember teratogenicity. Teratogenicity is the side effect. And that is why we always try to do a urine pregnancy test if we are giving the isotretinoin to a female or a married female with a reproductive age group. So always remember, if somebody is planning of pregnancy or if somebody is pregnant, don't give isotretinoin. Only when she is not thinking of pregnancy, you should start the patient on isotretinoin. Now, if somebody is already on isotretinoin and now she is thinking of getting pregnant, obviously you'll stop isotretinoin. But can you tell me what should be the period of contraception after stopping isotretinoin? Very nice. 1 to 3 months should be the period of contraception after stopping the isotretinoin. Chalo, very nice. And yes, for acitretin, which is used in psoriasis, 3 years is the period of contraception. But for isotretinoin, which is used in acne patients, 1 to 3 months is the period of contraception. Now, coming to something which is related to leprosy. Now, please remember, in leprosy, you should know 2 things. One is, what is the 2 classification system used? Before going to this, there are 2 classification system. One is known as Ridley-Joplin classification. Can you tell me what are the component of Ridley-Joplin classification, bacho? What are the components of Ridley-Joplin classification? We have 5 types of leprosy: tuberculoid, borderline tuberculoid, borderline lepromatous, and lepromatous leprosy. Ridley-Joplin has used 4 criteria: clinical criteria, bacteriological criteria, immunological criteria, and histopathological criteria to classify the patient into 5 types. Now, what are the characteristic feature? Please remember, in your exam they ask you, where do you see satellite lesions, BT? Second, they will ask you, where do you see the inverted saucer shape appearance? Inverted saucer shape appearance, also known as Swiss cheese appearance. That's a feature of DB. Where do you see leonine facies? Leonine facies, LL. And where do you see the saucer placed upside appearance? TT. So please remember, these are some of the things which they can ask you in your exam. Ridley-Joplin classification uses 4 criteria: TT, BT, BB, BL and LL. And what are the important things that we have discussed just in a nutshell. Coming to second classification system, which is Indian classification system. Indian classification has used just one criteria. And can anybody tell me what is that one criteria used? Clinical. Indian has classified patient into tuberculoid leprosy, borderline leprosy, lepromatous leprosy, then pure neuritic. Please remember, what is pure neuritic? No skin lesion, only nerve damage, and indeterminate, which is usually seen in children where there is a hypopigmented patch on the face with atrophy and with loss of sensation. Please remember, in your exam they will ask you what is the commonest differential diagnosis of indeterminate leprosy. Can anybody think of something? It is pityriasis alba. Pityriasis alba, which is the pityriasis alba is the classical differential diagnosis, which is a feature of the atopic dermatitis individuals. It looks very similar, hypopigmented patch on the face. But please remember, in pityriasis alba, what do you see? Itching and scaling. But in indeterminate leprosy, you see atrophy and loss of sensation. So these are some of the very important features about the two classification system. Coming to lepra reaction type 1, please remember it is type 4 hypersensitivity reaction. The rule of 5, how much you should add in 1 that it becomes 5? 4. So type 1 lepra reaction, which is type 4 leprosy, common in borderline patients, BB, BL and BT. What do you see in type 1? The existing lesion becomes more red, more inflamed, more prominent, loss of nerve function, neuritis, edema of the extremities. These are the common feature of type 1 lepra reaction. But what is type 2? Type 2 is type 3. Again, rule of 5. How much you should add in 2 that it becomes 5? 3. So type 2 is type 3 hypersensitivity reaction, which is very commonly seen in lepromatous patient. Lepromatous patient, it is very frequently seen. Please remember, type 1 mein what was happening? Existing lesions becomes more prominent, more red, more inflamed. But what is happening here? The new lesions, painful lesions, pink color, plaque, papules, painful lesions are coming. This is known as erythema nodosum leprosum. Erythema nodosum leprosum. That is ENL. ENL is the another name given to type 2 lepra reaction. What do you give for treatment? For treatment, you continue giving multi-drug therapy. Along with that, you give oral steroids, which is considered to be the drug of choice for both type 1 and type 2 lepra reaction. No confusion, it is drug of choice for both type 1 and type 2. In the end, coming to the treatment of leprosy in general, please remember, nowadays we are not using any 2-drug kit. 2-drug kit are not used. We use 3-drug kit only for both paucibacillary and for multibacillary. Please remember, for paucibacillary, we use 3 drugs for 6 months. And for multibacillary, we use 3 drugs for 12 months. Please remember the dosage. They will ask you the dose of adult as well as children. What is the dose of rifampicin given? For adult, we give 600 mg once in a week. For children, 450 mg, not once in a week, once in a month. In children, 450 mg once in a month rifampicin. Clofazamine, 300 mg once in a month for adult, but for children, 150 mg once in a month. Daily dose of clofazamine is 50 mg for adult. For children, it is 50 mg alternate day. Depson is 100 mg every day for adult, but 50 mg every day for children. So please remember the dosage of childhood kit as well as the adult kit. No 2-drug kit is used. We are using 3-drug kit only. I hope this is clear to all of you. Now, coming to the next part, erythrasma. Please remember, they will ask you, what is the causative agent of erythrasma? Corynebacteria minutissimum. Second, they will ask you, what is the discoloration you see under the Woods lamp? Coral red or coral pink fluorescence, bachcho. Coral red and coral pink. I am asking you here only, what are the other conditions which are positive under the Woods lamp? What is the color you see when you see pityriasis versicolor or malassezia infection under the Woods lamp? Anyone? It appears yellow in its color. Pseudomonas, it appear green. Tinea capitis, which mainly occurs because of microsporum species, microsporum. The color which you see is blue green, and in the end vitiligo, what color you see in vitiligo? Ivory white is the color which you see. So please remember, what are the other findings you should know under the Woods lamp? Here erythrasma, which is coral red. Other than that, we have pityriasis versicolor yellow, pseudomonas green, tinea capitis blue green, and vitiligo ivory white. What is the wavelength of Woods lamp? 365 nanometer. And what is the Woods lamp filter made up of? Barium silicate and nickel oxide. Barium silicate and nickel oxide. So please remember, sometimes it is frequently asked, sometimes it is not asked. They usually give you image based question, or they can directly ask this type of questions also. Now coming to the next, that is sexually transmitted disorder. Coming to primary canker. Can you tell me what is this condition? Where do you see primary canker? It is a feature of syphilis, a treponema pallidum infection. What type of lesion is this? This is a painless hard ulcer. A painless hard ulcer which you see in a patient of syphilis, that indicate the site of entry of treponema in skin. If you remember in my class, I told you this indicate that exactly from what site the treponema have entered the skin. Painless hard ulcer with a very characteristic button-like consistency. What is syphilitic DMLE? These are those syphilis with no primary stage. There is no hard canker in this syphilis, and there are two examples. One is congenital syphilis, and second is syphilis secondary to blood transfusion. Syphilis secondary to blood transfusion. Next, canker redux. It is a feature of early relapsing syphilis. Sometimes what happens in early latent syphilis, instead of going from early latent to late latent, the patient relapses back and he will get primary canker again. This is known as early relapsing syphilis. And in the end, what is pseudo canker redux? This is the gamma of tertiary syphilis, exactly on the same site where the patient developed the lesion of primary stage ulcer. So please remember, this is very important. You should know these terminology: canker redux, pseudo canker redux, syphilis DMLE. What is the primary canker, also known as hard canker? Okay, so this is related to syphilis. Coming to the next part, what do you see in a secondary stage of syphilis, which is great imitator? Important features: remember, condyloma lata, flat moist lesions of syphilis on the genital, condyloma lata. Mucus patch, painless ulcer in the oral cavity, mucus patch. Macular syphilid is dark spot on the palm, dark spot on the palm. Please remember, in secondary stage, lesions are always asymptomatic. You will not get any itching. There is no itching, and if you remember, I told you no vesicles. Vesicles are only seen in a patient of congenital syphilis. What is Ollendorff sign? Sometimes deep tenderness can be observed when you press the lesions. Sometimes because of end arthritis, it causes pain, and that is known as Ollendorff sign. So remember, condyloma lata, mucus patch, and macular syphilid, these are the characteristic feature of syphilis. You're absolutely right, Akansha. One more feature which you see in secondary syphilis is moth-eaten alopecia. What type of hair loss is this? This is the non-scarring hair loss. Other than this, you can even get generalized lymphadenopathy. These are the features of secondary syphilis. Coming to latent syphilis. Can you tell me what is the feature of latent syphilis? Anyone? What skin lesion you see in latent? No skin lesion. Latent syphilis means the patient has live treponemas on their skin, but it is not manifesting with any clinical feature. So latent stage, which is a very long period, early latent up to 2 years, late latent 2 to 10 years, no clinical feature. But after latent phase, patient develops tertiary stage, where patient can get gummas on the skin. Cardiovascular, what is this? Aortic aneurysm. Why the patient develops aortic aneurysm? Because of involvement of vasa vasorams. The blood vessels of aorta get blocked, and because of this there is atrophy of the wall of the aorta, bulging of the aorta, and please remember, rupture of aortic aneurysm is one of the very common cause of death in the patients of tertiary syphilis. What do you get in central nervous system? CNS involvement, meningitis, parenchymal involvement, which presents as general paresis of insane or tabes dorsalis. So these are the features very classical of tertiary stage of syphilis. Coming to the next part, congenital syphilis. What is Hutchinson syphilitic triad? Gandhi ji ke teen bandar. Remember I told you mnemonic. Bura mat dekho, bura mat suno, bura mat bolo. You have interstitial keratitis, you have eighth nerve deafness, and you have Hutchinson's teeth. So Hutchinson syphilitic triad, very important for us to remember. Okay. Next, what are the other sequelae? You have saddle nose because of loss of the nasal septum. Hutchinson teeth, broad central incisors with a gap in between. Clutton joint, swelling, pain in the joint, and because of swelling and pain, the child refused to walk. We call it pseudo paralysis of Parrot. On the anterior part of the tibia, there is thickening, and this causes clinical bowing of the lower limb. We call it saber tibia. So these are the features of congenital syphilis. Other features, the erosion at the epiphyseal and metaphyseal margin known as Wimberger sign, prominent sternoclavicular joint, Higo-Minaki sign, and frontal bossing, Olympian brow. So please remember, these are all features of the congenital syphilis. The congenital syphilis mein there is no primary stage, and that is why it is syphilis DMBLE. What is the treatment you give in a patient of syphilis? In adult patient, what do you give? Can you tell me? You give injection benzathine penicillin. What is the dose? 2.4 million international unit intramuscularly. You give single dose if it is a patient of primary, secondary, and early latent. Okay, and if it is a patient, you give 3 doses at weekly interval if it is a patient of late latent and tertiary. So please remember that treatment of patient of syphilis is benzathine penicillin. The dose depend upon the stage of the patient. Now please remember, always remember, you have to do a allergy test before giving benzathine penicillin. Benzathine penicillin, if a patient is allergic, can you tell me what is the treatment of choice when the patient is allergic to benzathine penicillin? We give doxycycline 100 mg twice a day for 15 days. Now some students are asking, ma'am, what about pregnant female? In pregnant female, benzathine penicillin is given. If the patient is allergic to benzathine penicillin, you have to desensitize the patient and then give the full dose. You cannot give doxycycline if the patient is pregnant. Okay? So that is about your syphilis. Coming to the second image, what is this, bacho? Multiple painful ulcers, painful lymph node, multiple painful ulcer, and painful lymph node. These ulcers are soft to touch. You call it soft canker. Can you tell me which is that condition where you have painful ulcer, painful lymph node, and you call it soft canker? Please remember, this is your chancroid. What are the features of chancroid? That it is painful. And if you remember, I told you the causative agent is Haemophilus ducreyi. And for your exam, you can remember Haemophilus ducreyi. Because of pain, they keep crying. Or in Hindi, we call it dukh raha. So Haemophilus mein sab dukh raha. While if you remember, I told you in my class, syphilis ko you can remember syphilis. Everything is painless. Ulcer, painless lymph node. Okay, so that is a feature. Coming to the investigation, what do you do? You do gram stain for chancroid and you see a very characteristic school of fish or railroad track appearance. Treatment may prefer azithromycin 1 gram for chancroid. This is the classical school of fish appearance on the gram stain in a patient of chancroid. Okay. Now coming to the next part, very quickly we are discussing about the STD kit. I'm not discussing the other STDs, other genital ulcer, or if you want, I can discuss it very quickly. Please remember, when you see an ulcer which is red, exuberant genital ulcer, exuberant ulcer with granulation tissue, this is a feature of donovanosis, genital ulcer with exuberant donovanosis, granulation tissue like appearance, donovanosis. What do you do as an investigation? GIMSA stain. And bacho, what do you get on GIMSA stain in donovanosis? We get the bipolar bodies, also known as safety pin bodies or Donovan bodies. Okay, safety pin bodies. So this is something again I want my students to remember. Next, LGV mein what do you get? Causative agent of LGV is chlamydia, trachomatis, L1, L2, L3. In these patients, the main defect is the involvement of the lymph node, buboes, painful lymph node enlargement. Sometimes there is genital deformity. You get what is known as ischemia in females and saxophone penis in males. Okay, so females में genital elephantiasis ischemia, in male it is saxophone penis deformity, very classical. That's a feature of LGV. Now urethritis, little bit about urethritis I want to mention here. There are mainly two causes of urethritis: gonococcal urethritis because of Neisseria gonorrhea, and we have non-gonococcal urethritis. Can you tell me what is the most commonest cause of non-gonococcal urethritis? Chlamydia. But which strain of chlamydia? Trachomatis, D2K. What are the other causes? Trichomonas vaginalis. Please remember, Trichomonas vaginalis causes urethritis in both male and female. Urea plasma, urea lyticum, and mycoplasma. Okay. How to diagnose whether it is gonococcal or non-gonococcal? Do a gram stain. If you do a gram stain in gonococcal, you will get gram-negative diplococci. What is the treatment you give for gonorrhea? You give ceftriaxone or cefixime. But how do you treat non-gonococcal? Azithromycin. Okay, so that is very quick about the urethritis. Very important and very quick about urethritis. Coming to the next, vaginal discharge. What are the three causes of vaginal discharge, bacho? We have bacterial vaginosis, Trichomonas vaginalis, and candidiasis. Bacterial vaginosis, you have profuse white discharge, foul smelling, profuse white discharge, very foul smelling. If you do a microscopy, you will see clue cells, which are the vaginal cell with lot of bacteria on the top. What is the name of the criteria used for bacterial vaginosis? Emsel's criteria is used for bacterial vaginosis. Trichomonas vaginalis, greenish, frothy discharge is what you see. Greenish, frothy discharge. You see cervical inflammation, which is known as strawberry cervix. For candida, you see white curdy discharge. White curdy discharge. Lot of itching is something which you see in these patients. If you do microscopy, what do you see in candida? Pseudo hyphae or budding yeast. Pseudo hyphae and budding yeast is what do you see. So please remember, with this we have discussed almost everything about the STD. Coming back to the STD kit, can you tell me what is wrong in this STD kit ka photo? Can I add something in this? Yes, bacho. Recently kit number 8 has been added. Kit 1 was grey color for urethral discharge, cervicitis. 2, green color, vaginal discharge. 3, non-herpetic genital ulcer, non-allergic patients, white color. Kit 4, non-herpetic genital ulcers, allergic to penicillin, blue color. 5, herpetic genital ulcer, red color. Pelvic inflammatory disease, yellow color. Kit 7 is bubo, black color. There is a new kit added for anorectal discharge syndrome, and what is the color given to it? Brown color is given to it. So please remember, there is one more kit addition, which is the brown color kit. Other than that, they have also changed the dose of Cefixime to 800 mg in kit 1 as well as the dose of Cefixime in kit number 6 to 800 mg. So these three changes were recently done. Please keep that in your mind if you are going for your exams. Okay, chalo. So with this we are done with the STD. Coming to the next, rodent ulcer. What is this? Basal cell carcinoma, most common skin cancer. What is the common site? If I draw an imaginary line from the angle of mouth to the tragus, this is present above this line. Inner canthus is the most common site. Okay, so please remember, it is a locally aggressive tumor. Do not metastatize. This is a cancer of stratum basal cell. Recently there is a role of sonic hedgehog pathway, and that is why, what is that 2 drug which we give as a treatment nowadays? Anyone? Please remember, there is a change done in the treatment. Along with the microscopic Mohs surgery, you give these 2 drugs, vismodegib, sonidegib, which are the sonic hedgehog pathway inhibitors, recently given as the treatment modality for the basal cell carcinoma. So please remember, what is the treatment of choice? It is microscopic Mohs surgery, and these are the 2 drugs. I hope it is visible, vismodegib and sonidegib, which are sonic hedgehog pathway inhibitors. Okay, coming to the next. Okay, where is the next image? Next is malignant melanoma. Malignant melanoma. What is malignant melanoma? It is the cancer of melanocytes. 4 type: superficial spreading, lentigo maligna, acral, and nodular. Out of these 4, which is the most common? Superficial spreading is most common. Which is the rarest? Nodular is rarest, and it has poor prognosis. Now please remember, BCC always occurs on the face, sun exposed area, but malignant melanoma always occur on the covered area. But there is one exception. Malignant melanoma always occur in the covered area like back, like lower limb, but there is one exception, and that is lentigo maligna, which always occurs on the sun exposed area. And what do you call it? You call it the Hutchinson's freckle. You call it Hutchinson's freckle. Okay, so please remember, sometimes they give you this name. Do not get confused. Hutchinson freckle is nothing, another name of lentigo maligna. Okay, now coming to the next part, what is the A, B, C, D, and I think one more thing is missing, E criteria: asymmetry, border, color, diameter, and all these changes, all these evolution, if occurs suddenly, that indicate that we are dealing with a patient of malignant melanoma. How do you treat malignant melanoma? Wide surgical excision. Along with the tumor, you remove the surrounding normal skin also. So wide surgical excision is what is the treatment of choice for malignant melanoma. Coming to the next very quickly, vitamin A deficiency. What do you get in skin? Dryness. If you do not take care, you go for follicular hyperkeratosis, which is known as follicular hyperkeratosis, which is known as phrinoderma. Can you tell me, bacho, other than vitamin A deficiency, where else you can see phrinoderma? Where else you can see phrinoderma? You can see phrinoderma in essential fatty acid deficiency. This is the last year PYQ. Okay, so essential fatty acid deficiency will have the phrinoderma. So phrinoderma can be seen because of vitamin A deficiency and because of essential fatty acid deficiency. Okay, so vitamin A deficiency, they ask you in exam. Then what is this? In which condition you see this feature? 4Ds: diarrhea, dermatitis, dementia, death. This is a feature of vitamin B3. And what is vitamin B3? It is niacin. Who get niacin? Those who eat mainly maize and jawar. Why? Because maize has poor source of tryptophan, which is a precursor, while jawar have high amount of leucine, and that is why what happens, they do not allow the tryptophan absorption. Other than this, carcinoid syndrome patient, alcoholic patients, malabsorption syndrome patients, they all can get the classical symptoms of vitamin B3 deficiency known as the pellagra, the 4Ds: diarrhea, dermatitis, dementia, death. What do you see on the neck of these patients? Kessel's necklace, a very classical lesion which is present on the neck, sun exposed area. This is a feature of vitamin B3 deficiency. So very frequently ask these 2 deficiencies in your exam. Coming to this bluish discoloration unilaterally on the face, can you tell me what is this condition? In which condition the patient develop unilateral bluish discoloration on the distribution of trigeminal nerve. This condition is known as nevus of Ota, while shoulder, if there is unilateral bluish discoloration on the distribution of posterior suprascapular nerve, this is a feature of nevus of Ito. Very similar thing is Mongolian spot, which is seen on the buttock. But the thing is, Mongolian spot which is present in the buttock, bluish spot on the buttock, it improves on its own. But nevus of Ota and nevus of Ito, they remain like that. The reason is why you get nevus of Ota, Ito and Mongolian spot: premature arrest of neural crest cell. Premature arrest of neural crest cell give rise to nevus of Ota, nevus of Ito and Mongolian spot. Okay, ji, understood. Now I'm asking you one question. Can you see this image? Some discoloration on the shoulder area. Now imagine there was an adolescent individual with brownish discoloration on the shoulder area, and that patch has more hair in it. Can you tell me what can be the diagnosis? Anyone? Can you tell me what can be the diagnosis? A brown patch in an adolescent on the trunk with more hair, with more acne. What is the diagnosis? Very nice. Answer is Baker's nevus. Okay, chalo, coming to the next part, alopecia areata. Alopecia areata में patchy hair loss. It is an autoimmune condition where you see T lymphocytes, T cell against the hair bulb, the pigment containing portion of the hair bulb. When you see or when you do the microscopy, you will see exclamatory hair, the hair which is tapered from the lower side. Now, this is your very classical swarm of bee appearance. Swarm of bee appearance which you see when you do the biopsy. Patchy hair loss and the underlying skin is very, very smooth. Can anybody tell me, if you see the nails of these patients, what do you see on the nail of alopecia areata? What do you see on the nail? Bacho, can you tell me the answer? Uniform pitting of the nail is seen. Uniform pitting of the nail is seen on the nail of these patients. And if I ask you, how do you treat? Intralesional steroids to treat these conditions. Okay? Intralesional steroids should be given. Now, what is this? What does these two images indicate? Androgenic alopecia. We have male pattern and we have female pattern. Who classified male pattern alopecia, bacho? Male pattern was classified by male pattern hair loss classified by Hamilton. What is happening in Hamilton classification? The hairs are going backwards. There is complete loss of hair. The hairs are going backward. Complete loss of hair. This is known as the male pattern classification. While female pattern is hairline is not going anywhere. The frontal hairline is there only. But thinning occurs from the center, from the crown. This is your Ludwig's classification. Thinning from the crown, center line is, the frontal line is maintained. While in male pattern, the frontal line recedes backward. How to treat androgenic alopecia? Only FDA approved treatment is minoxidil, which is a vasodilator, 2% for female, 5% for male. That is FDA approved. This is potassium channel opener. It increases the blood flow to the hair follicle. Okay? So please remember, this is very, very important for your exam. Now coming to some images. Can you tell me what is this image? The grouped vesicles. Grouped vesicles at mucocutaneous junction, bachcho. Grouped vesicle at mucocutaneous junction. It can be inside the oral cavity also. This is a feature of herpes labialis or herpes gingival stomatitis, which is herpes simplex 1 infection, HSV1 infection. So please remember, this is a patient of HSV1, grouped vesicles present on the mucocutaneous junction. Now what is this? Chicken pox. It is HHV3, that is varicella zoster virus. Varicella zoster virus. In the first episode, it forms chickenpox, which has pleomorphic and polymorphic rash. The patient will have development of a macule, which goes into a papule. Then this papule will convert into vesicle. Vesicle will form pustule. Pustule will form crust. And the appearance is known as dewdrop on the rose petal appearance. Human herpes virus 3 first episode causes chickenpox. But what happens when this virus go dormant? First of all, where does it go dormant? Dorsal nerve root ganglia. After few years, the virus reactivates and virus forms, or the clinical presentation which we get is known as herpes zosters or shingles. What is the common problem here? The pain, the herpes associated pain, or we call it post herpetic neuralgia. The common site is thoracic, followed by cranial, followed by sacral, because these are the dorsal nerve root ganglia which are frequently associated with dormancy of the virus. So please remember, the second episodes will have a very classical localized dermatomal grouped vesicles associated with pain. Okay. Now coming to HPV, human papilloma virus. There are multiple viruses. Now this is a list of non-genital wart. Common wart known as verruca vulgaris because of HPV 2 and 5. Flat wart or plain wart known as verruca plana because of HPV 3 and 10. Plantar wart HPV 1 and filiform digitate wart HPV 2. Now, can anybody tell me genital wart, which is also known as condyloma acuminata? What is the causative agent? HPV 6 and 11. It is a low risk virus. HPV 6 and 11 will never cause cancer. It is 16, 18, 31, 33 which causes cancer. What is the treatment for any wart? The treatment for any wart is cautery. Remove the wart, excise the wart, cauterize the wart. But you do not do any cautery on the genital wart. What is the treatment of choice for genital wart? Only for genital wart, treatment is podophyllin. You can also give imiquimod, that is for genital wart only. Please remember, bachcho, if the patient is pregnant, both these two cannot be given. You cannot give podophyllin, you cannot give imiquimod. So pregnant female with genital wart, the treatment of choice is cryotherapy. Okay, so this I have written for genital wart treatment, bachcho, no confusion. Genital wart, normal individual, pregnant female, that is the difference in the treatment. Chalo, very nice, great. Now coming to the next part, let us very quickly differentiate between pemphigus vulgaris and bullous pemphigoid. Pemphigus vulgaris, which is an intraepidermal split. So pemphigus vulgaris and pemphigus foliaceus, they are both intraepidermal, while bullous pemphigoid, pemphigoid gestationalis, Linier-Ige disease, they are all subepidermal. Bullous pemphigoid occurs in an elderly age group, but pemphigus occurs in a young individual. What is the complaint of bullous pemphigoid? Itching, tense bulla, urticaria, but here pain with normal surrounding skin. The type of bulla in bullous pemphigoid is tense. Here it is flaccid. The mucosa in bullous pemphigoid is not involved but involved in pemphigus. It has no tendency to heal, and that is why poor prognosis. Until unless you treat a patient of pemphigus, it will not heal. But bullous pemphigoid, even without treatment, patient improves. Acantholysis and Nikolsky sign, they are both the feature of the pemphigus group, intraepidermal group. But in subepidermal, the acantholysis as well as Nikolsky sign, both are negative, both are absent. So please remember, this is something which is important. Coming to direct immunofluorescence. Direct immunofluorescence, if you are seeing the linear deposits, this is a feature of bullous pemphigoid. If you see granular deposits of IgA, this is your dermatitis herpetiformis. and if this is the intercellular IgG, this becomes pemphigus. Okay, so please remember, direct immunofluorescence finding, they will ask you multiple times in your exam. Now just last few more slides. Now coming to the type of scale: micaceous scale, psoriasis, Collarette scale, pityriasis, rosea. Ichthyosiform scale is actually fish-like scale in ichthyosiform disorder. Seborrheic scale, seborrheic dermatitis, and mica-like scale, pityriasis lichenoides chronica, pityriasis lichenoides chronica. Now, 5 P's, plain-topped, polygonal, purple pruritic papule. This is a feature of lichen planus. Very itchy, very pruritic. What do you see on the lesion? White lines known as Wickham's triad. What do you see on the nail? The most common nail finding is thinning of the nail. The most specific is dorsal pterygium. So please remember these two nail findings. The common is thinning, the most specific is dorsal pterygium. Coming to the next, mucosal lesions. What do you see on the mucosa of lichen planus? We see white reticulate lesions. Please remember, dental amalgam is the very frequent association. Mercury containing dental amalgam causes the white lines on the oral mucosa. So that is about lichen planus. Now what is this condition? You see extensor involvement. This is a patient of psoriasis. The erythematous scaly, silvery scaly plaque on the extensors with sparing of mucosa, sparing of central nervous system, very, very classical of psoriasis. There are different variants. Gutted psoriasis, which is triggered by group A beta hemolytic streptococcus, mainly occur in children, lesions mainly on the trunk. Erythrodermic psoriasis, where more than 90% of the body is red, which occurs because of withdrawal of steroid. Rheumatoid psoriasis, where you have thick scales. Then we have inverse psoriasis, where you have flexural involvement. Pustular psoriasis, where you have pustules. And impetigo herpetiformis, that is psoriasis of pregnancy. In any psoriasis, do not give systemic steroid, but there is one exception. And what is that exception? Impetigo herpetiformis, where systemic steroids becomes the treatment of choice. And lastly, what is this? In which condition you see claw clutching ball appearance? This is a feature of lichen nitidus. What is the clinical feature? Skin colored lesion, very small tiny lesions which appears, and that is because the lesions are localized, the T lymphocytes are localized. So this type of lesion seen in children on the dorsum of hand or on the penile shaft. So with this, very quickly we have finished our PYTs. I've tried my best to cover almost everything. I hope this class was interesting and you could able to recall whatever we have read in the class. So all the best to all my students and take care. Bye-bye.
Hello, very good evening everyone. How are you guys? Now we are going to start our session, and can you please acknowledge, is everything fine at your end? Audio video is fine? Audio video is fine, beta. Can we start? Very good evening. Can I start? Dead हो? कोई बात नहीं, है ना? So let me just start by saying, okay, कि आप लोग जिम में भी जाते होंगे जब आप पूरे टायर्ड, व्हेन यू आर फुल्ली टायर्ड, है ना, उसके बाद आपका ट्रेनर कहता है कि एक और करो, बस एक और, वो जो लास्ट वाला होता है ना, सबसे ज़्यादा इफेक्टिव होता है. सो नाउ यू आर कम्प्लीटली टायर्ड, है ना, जस्ट बिफोर द एग्जाम, बट एकदम लास्ट पुश एकदम देना आपने, है ना, समझ रहे हो? सो दैट इज गोइंग टू बी मोस्ट इफेक्टिव. सो डियर स्टूडेंट्स, लेट्स नाउ स्टार्ट. ओके. कोई बात नहीं, है ना, बहुत जल्दी आपको ये जिसको डर लग रहा है वो नॉर्मल है, जिसको डर नहीं लग रहा ये एबनॉर्मल है, ठीक है? इफ यू आर फेयरिंग फ्रॉम द एग्जाम दैट कम्स नॉर्मल, ठीक है? तो आप डोंट वरी अबाउट दैट. यस, ओके. चलो, डिसेक्शन की बात कर रहे हो आप? हाँ, डिसेक्ट करें. ओके, चलो स्टार्ट करते हैं बेटा. ओके, अब ये विल ऑल बी नाउ रिवाइजिंग द एनाटमी एंड प्लीज से कि अभी यहाँ पे जहाँ तक आपने लाइक ऑल द हाई यील्ड स्टफ यू आर गोइंग टू रिवाइज. ओके, चलो एक बार स्टार्ट करते हैं बेटा. Tell me, what are these foramen? Foramen of skull, definitely one question. This is cribriform plate for the cranial nerve 1. This is what? Optic canal for the cranial nerve 2, along with what? Along with your ophthalmic artery. And what is this? Superior orbital fissure 3, 4, 6 and V1. So very easy. And if at all they ask this question, beta, abhi last FMG में ये question आया है कि if there is a superior orbital fissure syndrome, what will happen? Of course these nerves will be gone, but if you add the second nerve, then this becomes orbital apex syndrome. It becomes orbital apex syndrome because second nerve will be present at the apex. That will be present but not in the superior orbital fissure as such, right? Now these are foramen rotundum, ovale and spinosum for the V2, V3 and the nervus spinosum, beta. All right. And internal acoustic meatus for the 7th nerve, 8th nerve, jugular foramen for the 9th, 10th, 11th nerve. Okay. Now you tell me this foramen lacerum. Okay. And what is this foramen? This is foramen magnum. What passes from the foramen magnum? Do you remember? Let me ask. Is it the lower end of the medulla or the spinal cord? Lower end of the medulla or the spinal cord? Bela bolo. Lower end of the medulla. Yes. तो आपको याद है ना बेटा? All right. आपको याद है ना? तो if अगर आपको याद है, सी नाउ यू आर टेलिंग लोअर एंड ऑफ द मेडुला, फ्यू मोमेंट्स बैक यू आर सेइंग कि हमें कुछ याद नहीं है, कुछ याद नहीं है. आपके दिमाग में इट्स ऑल देयर इन योर मेमोरी. यू मे नॉट हैव एन एक्टिव एक्सेस ओवर देयर. डेफिनेटली इन द एग्जाम एवरीथिंग विल कम इन योर माइंड व्हेन है ना, व्हेन यू विल राइट द एग्जाम एवरीथिंग यू विल रिमेंबर. डोंट वरी अबाउट दैट. याद हो जाएगा सब आपको. ऑलराइट. नाउ व्हाट इज दिस? We have greater petrosal nerve, which is coming from above, that's parasympathetic, deep petrosal nerve. And what is this? Is the Vidian nerve. And here you can see this is the pterygoid plate. Between the pterygoid plate and the palate, we have the ganglion, that is pterygopalatine ganglion. All right. And this is what we have: carotid body and sinus. Do you remember what was carotid body? Carotid body is the chemoreceptor. What is carotid sinus? Sinus is the baroreceptor. How to remember? A, B, C. Just like normal ABC, B comes after that comes C. B for body, C for chemo. BC वैसे तो BC से बन जाएगा, लेकिन हमें BC बोलने में ठीक नहीं लगेगा, इसलिए हम ABC बनाएंगे निमोनिक. यूज ऐसे ही करेंगे, राइट? ओके, अब आगे बढ़ते हैं. इससे पहले कि हम इसके नर्व्स रिवाइज करें, लेट मी गिव यू द हिंट. ओके, सबसे ऊपर हमारी ग्लैंड कौन सी है? लैक्राइमल ग्लैंड, बिकॉज इट इज द हाईएस्ट ग्लैंड. दैट्स व्हाई समथिंग ग्रेट इज रिक्वायर्ड. Highest gland, lacrimal, great required, greater petrosal nerve. Okay. Next gland is parotid hair, little less than the above. So little less means less nerve is okay, lesser petrosal nerve. Next gland is here, submandibular, third place, third alphabet, ABC, chorda tympani. You remember? So lacrimal, greater petrosal, parotid, little less, lesser petrosal, submandibular, chorda tympani. If they ask किसकी branch है, 797. Will you remember this trick, beta? 797. All right. Now let's see this. The greater petrosal nerve is the nerve of lacrimation, pterygopalatine ganglion, and for the lacrimal gland. ठीक है बेटा, याद रहेगा आपको, right? Next, lesser petrosal nerve for the salivation from parotid gland via the otic ganglion. Chorda tympani is also doing the salivation from which ganglion? Submandibular ganglion. And which gland? Again the submandibular gland, and you see sublingual gland. But chorda tympani का एक और रोल भी होता है, that is the taste. It carries the taste from the anterior 2/3 of the tongue and the lingual nerve, general sensation from the anterior 2/3 of the tongue. Ninth nerve, every sensation from the posterior 1/3 of the tongue, and all the sensation from behind the tongue will be the 10th nerve, that is the internal laryngeal nerve specifically. So far so good. Now let's discuss this table, very important. The all muscles of palate. Can you recall, beta? You recall with me? Yes, tell me. it will be supplied by VAC. What is VAC? Vago accessory complex. If they say mark a single nerve, in that you are going to mark only the 10th nerve then. What is the exception over tensor palatina is supplied by the mandibular nerve. Pharynx may we have VAC, but we have stylopharyngeus, 9th nerve. Larynx may recurrent laryngeal nerve, and cricothyroid, which is supplied by external laryngeal nerve. So we need to remember only one muscle which is exception. Rest all will be supplied by one nerve. Tongue muscles all are supplied by 12th, but one muscle, palatoglossus. The name is palatoglossus. It does not take supply from the glossus, it takes from the palatal aspect. Palate is supplied by VAC, that's why it is also supplied by VAC. Intrahyoid, all muscles answer cervicalis, but thyroid C1 via hypoglossal. Hypoglossal is the carrier supplied by C1. Okay. Now, sometimes they may ask this question that where is the deviation, beta? Deviation कहाँ पे होगा? 7th nerve, 10th nerve, 5th nerve, and 12th nerve में. So we need to remember this. 7th nerve patient when he comes with the deviation. That means deviation will be seen at rest. Okay. So we have the 7th nerve, angle of mouth, normal direction में deviation होगा. Why? If the left side is paralyzed, right side will pull towards it, right? So the deviation will be towards the normal side, and that will be seen at rest. Same is true for the 10th nerve, and we will check the ulnar deviation, okay? Because palate palsy will be seen. And 5th nerve के लिए we check the jaw deviation, where it is seen towards the abnormal wound doing protrusion. And same is true for the 12th, tip of tongue, and that will be also same. Why? Because if this muscle are working, protrusion will be in the midline. If it is not working, then you can see the deviation towards the abnormal side like this. So far, so good? Yes? Very good, beta. Now, pterion, very, very, very important area. अभी तक जो क्वेश्चन आए हैं वो पूछा गया है डीप में. 3 important structures. Anterior division of middle meningeal artery. If they ask the bone, lesser wing of sphenoid. But if they ask the brain, lateral sulcus ka stem of lateral sulcus. Along with that, last time they gave one question and they asked superficial. They did not mention the term pterion, but the area which was given was pterion. If at all the same question is repeated, last time the carotid angiogram was there. If the same area is repeated and you can identify the pterion area and some artery is there, then it will be superficial temporal artery. Please remember that. Okay, beta. Next. Now we all know that in the brain we have internal cerebral vein left and right. When the two internal cerebral vein will join together, they are going to make what? They are going to make the vein of Galen. This vein of Galen is going, and from above who is coming? Inferior sagittal sinus is coming. Inferior sagittal sinus will come, and that will make together the straight sinus. And from above who will come? Superior sagittal sinus like this, and from below who will come? Transverse sinus. This occipital sinus will come. Superior sagittal sinus will come, and they are going to make the confluence of sinus, which will start distributing in the transverse. Do you remember this, beta? Let me show you this in the like basic view over here. Let us start with this. You tell me, what is this round? This is the confluence of sinus. When it starts distributing, it will start in a transverse manner. So what is this sinus? This sinus is the transverse sinus. What next? We have the sigmoidal shape. What is this sinus? Sigmoidal sinus. Where it is going? Posterior part of jugular foramen. After exit becomes the internal jugular vein over here. And this is the P for pituitary fossa. By the side of it, we have the cavernous sinus. And this is petrous bone. Along the petrous bone superior margin, we have superior petrosal sinus. Inferior margin, we have inferior petrosal sinus. Inferior petrosal sinus will go out from here, and it will become the first tributary of the internal jugular vein. If they ask you, what is the first tributary of internal jugular vein? Answer will be inferior petrosal sinus. Okay? Now what is this, beta? What is this? Great auricular nerve. You remember great auricular nerve? सबको याद है ये nerve supply of the pinna. After also supplying the lower part of the pinna, outer surface, inner surface. Along with that, it gives one branch over here because the thumb position at the angle of the mandible. Now this particular position angle of the mandible will give various information. If they ask, the angle of the mandible supplied by, answer is great auricular nerve. If they can ask shaving area, they can ask skin over the parotid. Now skin over the parotid is important for us. Why? We'll discuss about it for the Fraze syndrome. But before that, let's revise outer surface and inner surface in the lower part by great auricular nerve. Upper and outer part. This is next to the parotid gland, that is auriculotemporal nerve. Okay. And inner part is the next to occiput. That's why lesser occipital nerve. And the concha region we need to memorize auricular branch of vagus, which is also called as Arnold's nerve or Alterman nerve. This particular only one concept, these two fingers, okay, they have a role. यहाँ पे देखो क्या है, Frey syndrome. कैसे बना Frey syndrome? Now learn this way. Normal circumstances में we have the gland. If the input for salivation comes, of course, via the gland salivation will take place. But outside skin is supplied by the great auricular nerve. And if the input for sweating is coming via the great auricular nerve, there will be sweating. There will be sweating. But this is normal. But by chance, if there is error and there is a faulty regeneration, what is happening? Parasympathetic fibers of the auriculotemporal nerve going and joining with the great auricular nerve. What will happen? Now input for the salivation will come, but end result will be sweating. तो पेशेंट खाने के बारे में सोचेगा, जैसे अभी आप लोग सब सोच रहे हो, है ना, या खाएगा या उसको स्मेल आएगी, तो उसको सलाइवेशन की बजाय स्वेटिंग होने लगेगी. दैट इज कॉल्ड एज गस्टेटरी स्वेटिंग और द फ्रे सिंड्रोम. बेटा, if they ask which nerve is involved, both are involved, but if you have to choose one, go with auriculotemporal nerve. That's the better answer. Similar thing can occur in a crocodile tear syndrome. Where is the lesion? Seventh nerve. Why? Because the seventh nerve is having the two nerve fibers. If the input for lacrimation, it results in the lacrimation, of course, but input for salivation via this nerve coda tympani, it will be resulting into salivation. If there is a lesion and the nerve gets ulta pulta, then we have this input for lacrimation, that's fine, but input for salivation also, then lacrimation. मतलब देखो सारी गड़बड़ खाने के साथ ही है. देखो अभी कैसा हो रहा है, एक पेशेंट में उसको सलाइवेशन की बजाय क्या हो रहा है, उसको स्वेटिंग हो रही है, ठीक है, तो वो फ्रे सिंड्रोम हो गया. अभी इस पेशेंट को क्या हो रहा है, खाना है, सलाइवेशन की जगह उसके आंसू आ रहे हैं, तो उसका क्या हो गया, उसको क्रोकोडाइल टीयर सिंड्रोम हो गया. अब आप भी खाने की वेट कर रहे हो, आपको भी खाने का मन है, सलाइवेशन की जगह आपको डर लग रहा है, आपका सिंड्रोम कुछ हो रहा है ना, ये नीट सिंड्रोम है, बट बहुत जल्दी आपके सिंड्रोम का सोल्यूशन होने वाला है. राइट, ओके, चलिए, वेरी गुड. Now this is very important area. Sometimes they give the question injury in the posterior triangle. Then what will happen? Then only trapezius will be gone. Beta, please remember, only trapezius will be gone, and this particular muscle trapezius will be affected over here. Sternocleidomastoid is getting the supply. Base of the skull पे क्या होगा? Base of the skull पे if there is an injury, then both the muscle will be paralyzed. So far so good. All right. Now let's revise this. यहाँ पे important, ज़्यादा important है nerve, but we will revise everything. So we can see this muscle is the scalenus anterior. Behind we have scalenus medius, and in between we have the subclavian artery having the three parts. Very important branch over here is the inferior thyroid. Direct question, okay? Direct question asked in AIMS, okay? Inferior thyroid. Then we have the suprascapular nerve and the transverse cervical artery. Okay, these three particular branches are coming from a common trunk called as thyrocervical trunk. All right. Now, one artery from his part will be going above, that's the vertebral artery, and one artery will be going down, that will be internal thoracic artery. This is coming down, this will be internal thoracic artery, right? And सबसे important यहाँ पे है phrenic nerve, and next is the vagus nerve. Both are anterior, but who is just anterior is the phrenic. Please remember, at the level of the neck, who is anterior? Vagus. But at the level of the root of the lung, who is anterior? Phrenic. Why? Because lower down the vagus will go posterior. It accompanies the esophagus, it will go into the posterior mediastinum. So neck pe who is anterior? Vagus. But at the level of the root of lung, who is anterior is phrenic, and the vagus is behind. Okay. Now, next nerve you have to guess, beta. What is this nerve going upward between the tracheoesophageal groove? What is the answer? Between the tracheoesophageal groove, answer is, that is your recurrent laryngeal nerve. Very good, beta. So this picture where all the important labelings are there, don't need to worry. Vagus, yes, it turns with the stomach. देखो सब कुछ तो याद है, अच्छा तो आंसर कर रहे हो, ऐसे ही घबराते रहते हो, एग्जाम में सब याद आएगा, don't worry. What is this muscle? This is like, this section can be given, then how to proceed. Start with the ramus. See, outside the ramus, masseter muscle. Very small muscle, temporalis, because mostly it has been inserted above. Okay. What is this? Is the pterygoid plate. Lateral to the pterygoid plate will be lateral pterygoid. Medial to the pterygoid plate will be medial pterygoid. Okay, so far so good. ठीक है बच्चे, आप मंजिल के बहुत करीब हो, इसलिए घबराना नहीं है। एक दो लाइनें सुना रहा हूं आपकी मंजिल पे, ठीक है, ध्यान दीजिएगा कि रख हौसला, बी पेशेंट, ओके, रख हौसला के वो मंजर भी आएगा, प्यासे के पास चल के समंदर भी आएगा, ओके, बी पेशेंट, डोंट गिव अप, थक कर ना बैठ, थक कर ना बैठ ऐ मंजिल के मुसाफिर, मंजिल भी मिलेगी और मिलने का मजा भी आएगा, ठीक है। इसलिए बेटा डोंट गिव अप, जस्ट एकदम लास्ट की तरफ है, अपना पूरा बेस्ट लगा देना है बेटा, ऑलराइट। चलिए, दिस इज व्हाट आर्टिकुलर डिस्क which is in continuity with the lateral pterygoid muscle. What's the importance? Sometime we do the yawning and because the force will be transmitted back, that is why there will be dislocation. The patient ने मुंह खोला and खोले का खुला ही रहेगा, he could not close it, all right. This is very important anatomy over here. If this look at the submandibular gland and the submandibular duct, we have the lingual nerve which is very nearby. We also have the hypoglossal nerve which is very nearby. These two are very close. If you are operating in this region, these two nerves are at highest risk of injury. So question sometime can be asked which nerve will be injured, which will be not injured. If they ask which will be injured, these two are at highest risk. But if they ask which will be not injured, inferior alveolar nerve will not be injured. Okay. Now this is investing layer because it invests all the structures together, and we have the pretracheal fascia just in front of the trachea, and this is the vertebral layer which is enclosing the vertebral compartment. All three of them, they are making the carotid sheath. Carotid sheath अपने आप में बहुत important है हमारे लिए, and we should also know the nerve between the trachea and the esophagus. What is that? That's a recurrent laryngeal nerve. Recurrent laryngeal nerve. Okay. First branch of external carotid artery is ascending pharyngeal artery. Okay, first branch as given in Gray's Anatomy 42nd edition. This is an update, so please remember this. Okay, one medial branch. Anterior three branches are there for the thyroid, tongue, and the face. Superior thyroid, lingual, facial. Posterior to the auricle, posterior auricular branch, and behind we have the occipital region. There we have occipital artery. Then finally terminates into maxillary and the superficial temporal. Okay. So far so good. Now this is what ligamentum denticulatum at the lateral aspect of the spinal cord, where we have 21 tooth-like processes. And we totally understand the crude will cross at the level of spinal cord. Crude sensation means pain, touch, temperature. But the fine will move upward at the level of spinal cord so that it can cross and relay at the level of the medulla. So what happens? Let's look at them together. Fine simply move upward at the level of spinal cord, crosses at the level of medulla, but crude will cross at the level of spinal cord. So finally at the level of spinal cord we can remember fine will move upward, crude will cross, and our mnemonic is FUCC. Okay, fine moves upward, crude cross, like that. Now we have Brown Sequard syndrome. अभी पीछे डरमा चल रहा था, वहां पे भी आप ब्राउन में काफी कुछ याद कर रहे थे, तो ये हमारा ब्राउन है. If you take the spinal cord, this is the midline of the spinal cord and half we have cut, hemisection. Okay, hemisection. Then you have pain and temperature, crude type of sensation. What will happen to them? They will be simply crossing. It goes upward, no problem. But opposite side, there will be a problem. Now you tell me, where is the loss of the sensation of pain and temperature? Ipsi or contra? Definitely contralateral loss of pain and temperature. But if you apply the same thing for the fine sensation, the fine sensation of this side cannot go above, but the opposite side they can simply go. So which side the fine sensation is lost? Which side fine sensation is lost? That's ipsilateral loss. Now this is the spinal cord and the nerves come out. They will be called as spinal nerve. The name is spinal nerve, but the technical name is lower motor neuron, LMN. And we have the fibers coming from above, which are the descending tracts. The descending tracts are called as UMN. They will be controlling the LMN at all the level, but where you have made the cut below, this UMN is not working. UMN is not working, the control is lost. LMN will overfire. So ipsilateral spastic palsy below the lesion. But where you are doing the dissection, you see, you have cut this. So at least this nerve will be gone. So that's why your ipsilateral flaccid palsy at the lesion will be seen. So far so good. Everything fine. Among the brainstem syndromes, all like brainstem syndromes, what have been taught in medicine are very, very important. But what has been most number of time has been asked is the lateral medullary syndrome. Let's go for this syndrome. If the lateral part is gone, lateral medullary syndrome, if the medial of the medulla is gone, medial medullary syndrome, also called as Desirine syndrome. Lateral का नाम क्या होता है? Wallenberg syndrome. So what will be the features, beta? Let's have a quick revision. Inferior cerebellar peduncle is gone. It will lead to ataxia, or some other features of the cerebellar involvement can also be seen. Okay, but ataxia will be minimum seen. Vestibular nucleus is gone. The role of the vestibular nucleus is to maintain balance. Balance is lost. Patient will have the nystagmus, vertigo, and the vomiting. Nucleus ambiguous. You see, palate, pharynx, and larynx are involved. It is not mandatory that everything will be given in the question. Even if it is single feature given, we will consider nucleus ambiguous is given. Okay. Spinal nucleus of trigeminal, ipsilateral, pain and temperature from face, but spinal lemniscus, same sensation from the body but contralateral. So ipsilateral face, contralateral body. Okay, same sensation lost. Descending sympathetics are gone. That means Horner syndrome. Now my question to you is, what is the most common artery involved in the lateral medullary syndrome? Lateral medullary syndrome, what's the most common artery? Answer is vertebral artery better than pica. Both are correct. Both are correct, but vertebral artery better than pica is the answer. As per Harrison, vertebral artery is a preferred answer. Now there is a rule of 4 by the Peter Gates. Please remember this in your exam. If there is a feature contralateral hemiplegia, या फिर involvement of the medial lemniscus, or these nerves are involved, it goes in favor of medial syndrome. It can be medial pontine, medial medullary, but whatever is happening, it is medial. If the features are given like ataxia, Horner syndrome, facial sensation lost, or the spinal lemniscus is gone, in those cases that will be lateral. It can be lateral pontine or lateral medullary, but it will be definitely lateral. So first we have identified whether medial or lateral. Next job is to do identification pontine or medulla. How to proceed? If you observe that facial nerve is involved or the cochlear nerve, hearing is involved, then you will say it is the pontine lesion. तो पहले medial lateral पता लगा लिया, फिर pontine कैसे पता लगाएंगे? If the 7th nerve or the 8th nerve involved है. But if by chance 9th, 10th, 11th nerve is involved, then we will say it is the medullary lesion. Okay? And involvement of the larynx, pharynx, palate का मतलब है dysarthria, dysphagia, loss of gag or hoarseness. Tell me, for the gag reflex, what is efferent? 9th nerve. What is efferent? 10th nerve. So far so good. What are the deep nuclei of the cerebellum? Deep nuclei of the cerebellum from lateral to medial will be this. Doctors eat good food. And the mnemonic के हिसाब से, what is this? Dentate nucleus. What is next is emboliform. And these are the globose. And finally, this is fastigial. Now, emboliform plus globose taken together, what is the name of the nucleus, beta? Taken together is called as interpositus. And we all know these nuclei, there have been evolution. So what we can say that our fastigial nucleus was earlier present. It is the nucleus of fastigial will be the nucleus of archi. Interpositus will be the nucleus of the paleocerebellum, and the dentate is the nucleus of neocerebellum. All right. Next, we have to identify how with the histology. So first look at these cells which are like behaving like cell layers itself. So they are neither fitting in this side nor fitting in this side. So they are behaving like a layer. So वो तो होगा Purkinje. And one side we have black dots, then we can make a guess it should be the cerebellum because the black dots is the granular layer. Let's apply this in this given section. Let me show you this. Can you understand these jutting out cells? They are behaving like layer in themselves. What is this jutting out cells, beta? Jutting out cells are the Purkinje cells, or their real pronunciation is Purkinje. You remember Purkinje cells, okay? So these are Purkinje, लिखते तो Purkinje हैं, पर बोलते Purkinje हैं. And the black dots are the granular, okay? So let's discuss the cell types over here. These are the layers, Purkinje layer, granular layer, and the molecular layer. But the cell types will be this. Basket cell, stellate cell in the molecular layer. All right. Purkinje cell in the Purkinje layer. Granule cells and the Golgi cells are present in the granular layer. All right, beta. And two type of fibers will be coming. One type of fiber which are coming from the olivary nucleus, that will be climbing up to the highest position. That's why called as climbing fiber, like this, directly communicating with the Purkinje. But the other set of fiber is called as mossy fiber, which are coming from all other sources. And mossy fiber can't reach upward directly. Via the granule cells, they will be going. Okay, so that will be reaching indirectly. So what is the take home message? Climbing fiber only for the olivary nucleus. Rest all afferent taken together, mossy fiber. And two output will be there. What is the output cell from the cerebellar cortex? Can you tell? Output cell from the cerebellar cortex, Purkinje. But cerebellum, deep nuclei. All right, beta. Next, this section is very important, even though they can ask direct question from anatomy, but otherwise very important for radiology point of view as well. Section is very important. What are these? Caudate, and what is this? Is the putamen, and this looking pale. That's why globus pallidus. Putamen and globus pallidus taken together is lentiform. The shape is lens-like. बट कोडेट एंड पुटामेन को हम एक साथ मिलाकर के क्या कहते हैं? नियोस्ट्राइटम. कोडेट एंड पुटामेन इज इक्वल टू नियोस्ट्राइटम. नियोस्ट्राइटम, right? Now we have T for thalamus and T for third ventricle. It is in between present. Lateral ventricle is above. And this is what? Can you make a guess, beta? What is this outside? जो सबसे बाहर present है, even outer to the lentiform nucleus. So this is the insula. This is what is the insula. Okay. And what is this? Some fibers are present in between, nothing but the internal capsule, which is condensation. Internal capsule, what type of fiber? Association, projection, or commissural? The question is, internal capsule will be what type of fibers, beta? Internal capsule is association, commissural, or projection? Internal capsule is projection fibers. Okay. एक्साइटेटरी एंड इनहिबिटरी का जो क्वेश्चन आप पूछ रहे हो बेटा, देयर आर टू पाथवेज, डायरेक्ट एंड इनडायरेक्ट पाथवेज. ओके, एंड बेसिकली दोज विल बी डिस्क्राइब्ड इन द फिजियो क्लास. ओके, दैट्स लाइक उसके डिस्क्रिप्शन के लिए तो इट रिक्वायर्स लॉट ऑफ टाइम, एंड वी आर सिटिंग इन ए सेशन वेयर इट इज द फाइनल लैप ऑफ रिवीजन. ओके, तो उसके लिए आप एक बार जो मेन क्लासेस है वहां से आप क्विकली देख लीजिए. ओके, now what is this? This is the corpus callosum, and this is the septum pellucidum, and this is what is the fornix. Now I will ask this question, beta. Fornix is the efferent from what? That's very important. Fornix is the efferent from what? It is the efferent from hippocampus, and from the hippocampus it comes in the form of fornix. Where it will reach? It will reach the mammillary body, and overall there is a circuit. What's the name of the circuit? The name of the circuit is Pepe circuit. What is the concern of the Pepe circuit? Memory. The function is it restores the memory, beta. Now input will come from where? There are three areas: corticostriate, thalamostriate, nigrostriate. Clinical question: nigrostriate fibers are gone. What will happen? Parkinson's. Also called as what? Also called as paralysis agitans. All right. Now floor of fourth ventricle. If they ask, this will be the usual marked area, that is the facial colliculus. Seventh nerve around the sixth nerve nucleus. Now the language. If they say damage to the structure producing the elevation is gone, who is the one who is producing the elevation? Seventh nerve. Then the seventh nerve is the answer. But if they say damage to the nucleus deep to the marked elevation, which nucleus is deep to the marked elevation is 6. So according to the language. So all the questions, read the language properly, beta. आपका आंसर बहुत important है. इवन सिंगल क्वेश्चन इज वाइटल. एक एक मार्क आपके लिए इंपॉर्टेंट है. एक एक मार्क पे आपका फ्यूचर डिपेंड करता है. सो प्लीज बी केयरफुल ड्यूरिंग द एग्जाम. ओके बेटा, वेरी गुड. नेक्स्ट, व्हाट इज दिस? इज द समथिंग दे विल गिव द हिंट. पिगमेंटेड ब्लूइश ग्रीन, सम पिगमेंटेड एरिया in the rostral part of the pons or the upper part of the pons. That will be locus coeruleus, highly adrenergic, concerned with the production of norepinephrine. What is this? Is the area postrema. And what is area postrema? Is the vomiting center, CTZ. These are some very important areas which we need to remember. Now talking about the openings of the diaphragm, we have IVC opening, esophageal opening, and the aortic opening. What is their behavior? That's important. Let's look at the table. Now the levels of these are what? Quickly revise. Yes, bolo beta, levels kya honge? T8, T10, T12. Structures क्या होंगे? IVCs, Of course, but which phrenic? Both or only right? Only right. Left will not pass through this. Esophagus and which vagus? Both vagus. Along with what? Left gastric artery branches for the esophagus. That means esophageal branch. Aortic opening mnemonic is ATA. A4, aorta. T4, thoracic duct. A4, azygous vein. Correct? During inspiration, what will happen? Can you tell, beta? During inspiration, what will happen? IVC will dilate or constrict? IVC will dilate. That is VR, because the venous return is increasing like that. Esophagus will constrict, but there will be no change in the aorta. Aortic, there is no change. So far, so good. Now, how the development will take place? There are 4 components which we need to memorize कि कहाँ से बनते हैं. Initially, we have septum transversum and the dorsal mesentery, but then eventually pleuroperitoneal membrane will come, and finally the cervical myotomes from the cervical region, they will start coming from the periphery and they will settle and make the large peripheral part. Eventually, you need to remember this. Central tendon of the diaphragm comes from the septum transversum. Small peripheral part is the membranous, large peripheral part is the mesoderm or cervical myotome. Cervical myotome, okay? What makes the crura? That is your dysentery. Now, sometimes there is a defect in the pleuroperitoneal membrane. Which hernia will take place, beta? That's Bosch-Dallek hernia. What is this? Most common type of congenital diaphragmatic hernia. What is the other hernia? Morgagni. What is the position of Morgagni hernia? We can remember by the mnemonic RAM. Right anteromedial. What is the position of the Bosch-Dallek hernia? Left posterolateral. ये क्या है? Root of lung. And most of the time question is asked, what is the arrangement anterior to posterior? Remember VAB. V for vein, A for artery, B for bronchus. Please remember VAB. And if at all they ask highest structure, that will be different. Right side may aparterial and left side may pulmonary artery. Why? Because left side may only one bronchus is there, so artery means the highest. But right side may we have one more bronchus and the extra bronchus is above the artery, so that becomes the highest structure. Okay. All right, beta. Bronchopulmonary segment. Certain features, they are conical. And tertiary bronchus they are having, artery they also having. What is important for us to remember? Vein is intersegmental. So सब bronchus भी अपना अपना है, arteries भी अपनी अपनी है. Vein is intersegmental, and the crucial point is what? The surgical resectable. The segments are surgically resectable. If at all they ask aspiration, which one to be marked? 6 better than 2. What is the name of 6? Apical basal or superior basal. What's the name of second? Posterior of upper lobe. Posterior of upper lobe. In case of, this was in the supine position, beta, but if they ask erect position, then answer will be segment number 10, that is posterior basal. What artery here? We can see this is nothing but the left anterior descending artery, and the vein is a great cardiac vein. And please remember these points. Dominance will be determined by the PIVA, which is posterior descending artery. Diagonal artery does not supply the right ventricle, and the right conus artery is the first branch. Please remember this. It is also called as third coronary artery, because kabhi direct it comes from the aorta. And the diagonal artery will go on the left side, so it will not supply the right ventricle. Why this point is important? Sometimes they give the image based question, they mark the right ventricle area, and then they will ask which artery will not supply. Okay, like that. You remember PIVA? Sabko yaad aa gaya PIVA? So PIVA is very important. Okay. Na leva na prama. Chut prava. Okay. This was little bit of the Russian language which I learned from my dear students. Okay. इसमें मीनिंग था कि लेफ्ट राइट नहीं है, थोड़ा बहुत स्ट्रेट पढ़ना है, बट हमें कंप्लीटली स्ट्रेट पढ़ना है, अपनी निगाह लक्ष्य पे रखनी है. ऑलराइट, चलिए. व्हाट इज दिस? दैट्स coronary sinus, and we have certain veins draining into it, which is not important. What is not draining here is more important from our exam point of view. So this is anterior cardiac vein, Thebetian vein, and right marginal vein sometimes. Please remember this. And anterior cardiac vein is most important among all these. Now, where is the finger? Finger is important. Okay. Finger is important. We need to see where the finger is. Where the finger is in the sinus. That means we have a gap over there. Why? Between the aorta and the SVC. If at all, as per the surgery, you require to put the ligation. Where you put the ligature? In this space. So ligation can be given if at all it is required. That's the beauty of the transverse sinus. But sometimes they can frame the question on the oblique sinus. If at all they mark the question on the oblique sinus, then what you need to remember is esophagus lies behind it. And please remember, left atrium, memorize this point. Left atrium lies in front of the esophagus and the right ventricle lies behind sternum. Okay, this is very important. Very good. Now, what is this fossa ovalis, which signifies foramen ovale? What is this? Floor of fossa ovalis formed by septum primum, but limbus fossa ovalis is formed by septum secundum. What is this artery? Superior thoracic artery, acromiothoracic artery, lateral thoracic artery, subscapular artery, posterior and anterior circumflex artery. The mnemonic is salt spa. The mnemonic is salt spa. Superior thoracic, acromiothoracic, lateral thoracic. The T is the thoracic which we have used along with all. And spa is subscapular pacha acha. What is pacha acha? Posterior and anterior circumflex humeral artery. Now what you can see over here is, this is a winging in action. So answer will be serratus anterior. But when the patient comes winging at rest, that is because of involvement of trapezius. What is this? This is a dorsal scapular nerve which is present in the medial aspect, which will be supplying levator scapulae, rhomboideus minor and rhomboideus major. Agar inka action pucha, to what you will be writing? And what is this triangle? Triangle of auscultation. Rhomboideus major ka action puche to retraction, that's the single best answer. Otherwise, we have elevation, retraction and glenoid cavity facing downward. All these three will be the answer. What is this nerve? Musculocutaneous nerve, which pierces the coracobrachialis. This is how we identify during the dissection. And after piercing and coming in the forearm, it becomes cutaneous and continues as what? Lateral cutaneous nerve of forearm. Very important question, PYQ. This is the cubital fossa, where we have the median nerve. Next to it, we have the artery, brachial artery, biceps tendon, and the superficial branch of the radial nerve. Superficial branch of the radial nerve at the level of snuff box sometimes gets involved. What's the name of the condition? Okay, this is the third lumbrical, but how to proceed with the palm muscles? Always remember, we have abductor muscle. How to proceed? Abduction is on the outside. So outer muscle is abductor pollicis brevis. Inner muscle is flexor pollicis brevis. Okay, this is abductor digiti minimi and the flexor digiti minimi. And deep to it is the opponens digiti minimi. इस side में deep muscle दिख नहीं रही है. If it is also visible, that will be opponens. But we can see these star marked muscles which have been cut. This will be FDS. Why? Because when we cut, we can see the muscle deep to them, and the deep to them muscle which we are highlighting with these dots. This is FDP because that's a profundus or the deeply placed muscle. From this deeply placed muscle, these muscles are taking a region that is 1, 2, 3, 4, which are nothing but lumbricals. So far, so good. What will be the action of the lumbricals? Thullu. You remember MCP flexion, IP extension. यहाँ पे क्या important है हमारे लिए जानना? This is a carpal tunnel where we have median nerve and we have FDS and FDB, which bursa is present around them. We have FPL on the opposite side, so we have bursas. On the lateral side, the bursa name is radial bursa, and the medial side, the bursa name is ulnar bursa. And where are these structures present? Ulnar nerve and artery. These are present in the Guyon's canal. That means if they ask carpal tunnel syndrome, we need to remember one important clinical, that is Palmer's sensation intact. But if they are Guyon canal syndrome or fracture of hook of Hammett, answer will be which nerve involvement? Ulnar nerve involvement. Do you remember the two brother story? What is two brother story? Let's have quick revision over here. Extensor pollicis longus all alone, where posterolateral aspect. And the other aspect is anteromedial, where we have extensor pollicis brevis, the small brother with the lady in question, abductor pollicis longus. They are present in the anteromedial aspect, anterolateral aspect, and posteromedial aspect. And here we have radial artery, which is the content. And in the roof, we have superficial branch of radial nerve. This is the condition for chiralgia. Now let's look at this. What is this nerve? Femoral nerve. But let's take this opportunity to revise everything over here. This muscle is the iliacus, coming from above psoas major. Okay, it becomes single iliopsoas. But this nerve is the subcostal nerve. Next will be iliohypogastric and ilioinguinal. This is a cut nerve. Why this nerve was cut? Because we cut the muscle. That means normal circumstances it is passing through the muscle. That is genitofemoral nerve. In this side we can see the genitofemoral nerve is piercing the muscle. And this nerve is the nerve of meralgia. That is lateral cutaneous nerve of thigh. And this nerve is coming from the obturator foramen. That will be obturator nerve. For the obturator nerve, please remember, pelvic tumor can be given because the nerve is passing from the pelvis. Ovary involvement, see inflammation or some disease can be given. Why? Because it is just lateral to the ovarian fossa. Okay, and it is passing from the obturator foramen, so that can be also given. And then they ask which movement is painful or which movement is not possible. Answer is adduction. Okay, femoral nerve will be the dorsal division, whereas obturator nerve will be the anterior division. All right, next part, this greater sciatic foramen, and what will pass from over here is the sciatic nerve along with some other structures. Most important is the pin structure. We have pudendal nerve, internal pudendal vessel, and the nerve to obturator internus beta. Okay, this is one short area jahan se question aayega, that is Trendelenburg. Inferior gluteal nerve will supply this, but superior gluteal nerve will supply these two muscles. This is chief extensor. Along with that, abductor and lateral rotator. ये चाहो तो भूल जाओ, but extension याद रखना है. Superior gluteal nerve is supplying these muscles which are powerful abductor and medial rotator. And this sign is important. The name of sign, Trendelenburg. Nerve tested superior gluteal, muscle tested gluteus medius and minimus. If you have to test, you have to mark one, go with gluteus medius. Okay. What is the name of the gait? We have lurching gait and the waddling gait. The effect will be seen on the dip will be seen on the normal side, because it was the duty of the opposite side muscle to maintain the position. So dip is seen on the right side. The weakness will be on the left side. That means, okay. Now these veins are important and we need to remember this condition. Can you tell beta? Great saphenous vein, short saphenous vein. Which one is medial? Great saphenous vein is medial, but short saphenous vein is lateral. With respect to malleolus, great saphenous vein is anterior and short saphenous vein is posterior. And the great saphenous vein remains always medial. Medial leg, behind knee, medial thigh. But short saphenous vein is not lateral, rather it is posterior. Accompanied by saphenous nerve, very important. This question has been asked 2-3 times. And short saphenous vein will be accompanied by sural nerve. The termination will be what? Femoral and popliteal. So this is a diagram where we can see the inguinal region beta. Usually they don't give the sign ka side. They will tell ki the dip will be seen where. That's how they will ask. Okay. Now please remember this. We can see the fascia transversalis. Can you see fascia transversalis all throughout? That makes the posterior boundary over here. Who is anteriorly present? External oblique. Okay. And can you see these two arching? ऐसे दिख रहा है ना, roof like arching. They are making the roof. Arch fibers of internal and transverse. And what makes the floor is the inguinal ligament. Inguinal ligament also called as Poppert ligament. The other name is Poppert ligament, beta. So far, so good. This is the spermatic cord. What is the content in case of female? What is the content in case of female, beta? In case of female, the content is round ligament. Now the round ligament is the derivative of what structure? Can you tell? Round ligament is the derivative of what structure? Round ligament of uterus is the derivative of gubernaculum in case of female. Now what is this marked structure? This is the falciform ligament and the marked structure is ligamentum teres. We can see the round. Teres का little meaning होता है round. Ligamentum teres is the remnant of what? It is the remnant of left umbilical vein, which is of course the content of falciform ligament. And we can see this is median umbilical ligament and these two are medial umbilical ligament. What are they remnant of? Median umbilical ligament, remnant of urachus. Medial umbilical ligament, remnant of umbilical artery. So in this picture, we can revise the important fetal structures. Epiploic foramen, again very important area from the peritoneum. What makes the anterior boundary over here? Right free margin of lesser omentum. Above we have the liver, below we have the duodenum. What is present behind? Do you remember, beta? Do you remember what is present behind? So in the section we can see behind we have IVC, right suprarenal, and this is T12 vertebra. And now we can see in the section that this is containing portal triad structure. So sometimes you see there is an injury and we hold it. We put the pressure to stop the bleeding. What is the name of the procedure? To stop the bleeding, we press this area. What's the name of the maneuver? That's the Pringle maneuver. Okay. So what is this ligament over here? Gastrosplenic or linear? This one is the linorenal. So it contains splenic artery. This will contain the short gastric artery. Okay. Here you have the portal triad, but here you have the gastric artery. Gastric artery means left gastric and right gastric artery. Left and right gastric artery will be present along the lesser curvature. Now this is the thoracolumbar fascia, which is present on this side and giving these layers, that is covering the quadratus lumborum and the erector spinae this way, anterior layer, middle layer, and the posterior layer. On the opposite side, lateral side, it is you see connecting what? Internal oblique and transversus abdominis muscle, but not to the external oblique. Okay. Now how to reach the kidney? We are going to start with the procedures. So step by step, let's look at them. First, we will remove the skin, then superficial fascia. After that, posterior layer of thoracolumbar fascia. Then we can see the erector spinae, then middle layer of thoracolumbar fascia, then quadratus lumborum, and then anterior layer of thoracolumbar fascia. This is how we will proceed. So far so good. आप ऐसे बहुत लोग बहुत जल्दी सर्जन्स बनने वाले हैं और उनमें से फर्दर आप कुछ लोग यूरोलॉजिस्ट बनने वाले हैं एंड यू विल बी ऑपरेटिंग ऑन द किडनीज इन ए लीगल मैनर, है ना? आप लोग करोगे ना, निकालोगे ना किडनीज, नॉट निकालोगे, आई मीन ऑपरेट करोगे, राइट? ट्रीट करोगे, राइट? ओके, चलो ठीक है. तो फिर आपको ये तो जानना पड़ेगा ना, हाउ टू प्रोसीड. दिस इज हाउ यू, व्हेन यू बिकम द यूरोलॉजिस्ट, यू विल बी इन द ओटी, यू विल बी रिमेम्बरिंग मी, राइट? उस समय मुझे थैंक्स बोलना एक बार के लिए कि सर सही है, मजा आया, राइट? What is this? Ejaculatory duct where the semen will be put, but after that nature ensures that it does not go in a retrograde manner. It should always go downward. How to prevent that? This is a muscle designed by the nature, that is internal urethral sphincter. Internal urethral sphincter, the role is it will contract at the time of ejaculation. It will prevent the retrograde manner. Okay. So we can say it is going to prevent the retrograde ejaculation in male, but in a female it is absent. Why? Because ejaculation nahi hai, to muscle nahi chahiye. And the third point, it gets injured in TURP. ठीक है, जो यूरोलॉजिस्ट बनेंगे उनको ये प्रोसीजर भी करना रहेगा, TURP, but in this case muscle will be injured. That's why complication is retrograde ejaculation will be present. So far so good. Now anal canal. ठीक है, above and below. Above is endoderm, below is ectoderm. ANS above, below somatic. Now you tell me, if ANS, is it painful or painless? Obviously ANS तो painless ही होगा ना. and below will be painful. So we have superior rectal artery above and the inferior rectal artery below. But which vein above? Portal vein. Which vein below? Systemic. Lymphatics internal iliac. Why? Along with the lower part of the rectum, upper part of anal canal will also drain there. But the superficial part, like below the pectinate line, that will drain into superficial inguinal lymph nodes. What about the epithelium? What about the epithelium? Epithelium will be simple columnar epithelium. That's the GIT का the epithelium है ये. But यहाँ पे क्या stratification? Now, if this is the pectinate line के below कौन सी line रहती है? White line. And the white line represents what? Mucocutaneous junction. White line represents mucocutaneous junction. Now, dear friends, what is this? Can you make a guess what we can see over here? Striations present, but along with the striations, branching present. So this is definitely cardiac muscle. Intercalated disc have been marked. Intercalated disc means it will allow fast movement, so it has the gap junction but not the occludence beta. All right. Now what you can see over here is the hair follicle, and next to the hair follicle we have some gland. Grape-like cluster is there. So this is how we can identify sebaceous gland. Okay. It has been asked number of times. अगर आता है आपके एग्जाम में क्वेश्चन तो होलोग्राइन आंसर है बेटा, very very important. If you observe such type of picture where the cells are present in group-like manner, cell nests are present, but yes, fibers are not seen. This is where you will mark hyaline cartilage. But this type of arrangement where you observe short and long wavy fiber along with some cells, like it can be single, it can be nest formation, but the wavy fibers are important here. Elastic. If you see this type of very disciplined behavior, parallel rows of the cell and the fibers, why it happens so? Because if you write cartilage as cartilage, क्यों नहीं है sweat gland? Very good question. Sweat gland होता तो it will show the you see coiling, and it will be very away, not very close to the hair follicle. Sebaceous gland will put sebum on the hair follicle for the lubrication. Sweat gland will be very away. Okay, so if you see very close, then and grape-like, then sebaceous, away and coiling, then sweat. Okay, cartilage ko if you write cartilage, it will tell you that it is having the type 2, but if you ask the bone will tell you type 1. So cartilage is having type 2 fibers, bone is having type 1 fibers. What about the fibrocartilage? Even though it's a cartilage, it is having type 1 and 2 both. And who is the dominant? Type 1 is the dominant over here. Now, these striated ducts are the key feature of salivary gland. It will be seen in all the salivary gland. But when you look at the exocrine part of pancreas, which is having quite similarity with the salivary gland picture, but it has two important differences. What is that? In the exocrine part of the pancreas, there will be absence of the striated duct, and second, there will be presence of the centroacinar. So this is the acinus, this is the center of the acinus where we have this cell present. All right. Now, if they ask the stem cell of the gastric gland at the isthmus, which has been asked, and they can ask intestinal gland also. If at all they ask, answer will be basal. What is this? The space of Dissay. Kupffer cells will be not present in the space of Dissay. It is in the sinusoids. But who is present in the space of Dissay is the hepatic stellate cell or the Ito cells. Okay, like that. Anterior neuropore closes in which day, beta? Anterior neuropore closes in which day? Day 25. Posterior day 28. If they close, then everything fine. If they fail, then there is an error. What error will take place? Failure of closure of anterior neuropore, anterior cephali, and posterior neuropore, spina bifida. So far, so good. For the face formation, 5 processes are there. 1 frontonasal, 2 maxillary, and 2 mandibular. Mandibular will make lower lip and chin, which is not asked. What is important from our exam point of view? Lip. So let's directly go to the lip. Upper lip will be formed by 4 processes. What are these? Maxillary, medial nasal, maxillary, and wherever there is non-fusion, it will lead to cleft. And the same processes are making the palate also. That's why They can be seen together, they can be seen individual also, right? That's what we need to remember. So far so good. ठीक है बेटा, तो हम पूरा एकदम टाइम से कट टू कट चले हैं, राइट? अपना अलॉटेड टाइम के अनुसार we are almost about to finish our anatomy part. I hope you could revise properly with me in a given, ये जो प्रिपरेटरी टाइम था इसके अंदर हमें सारा पोर्शन रिवाइज करना था, बट वी कुड डू इट. ठीक है, कुछ कुछ याद आ गया, थोड़ा बहुत कॉन्फिडेंस आ गया. So guys, I don't know how much trust you guys are having on yourself, but believe us, we have trust on you. तो हमारे विश्वास में आपका विश्वास मिला दीजिए, तब मिला जुला के अच्छा खासा हो जाएगा, राइट? एंड बिलीव इन योर सेल्फ एंड बिलीव इन गॉड. आप प्रे करके जाओ, ठीक है, एंड एवरीथिंग विल बी फाइन. मिरेकल विल हैपन बेटा, याद रखना ये बात, भूलना मत. आप बहुत जल्दी क्रैक करने वाले हो, राइट? नाउ द टर्मिनल पार्ट. अब एक टर्मिनल पार्ट है बेटा, राइट? वो है गैस्ट्रोस्काइसिस ओम्फेलोसील के बारे में. ओम्फेलोसील is because of non-reduction of hernia. Gastroschisis is reherniation because the defect lies in the wall. Site is umbilical. Gastroschisis will be paraumbilical. Amnion cover present. Last time question क्या आया था? Cover is made up of what? And our workbook says amnion cover. It is made up of amnion. Gastroschisis is nothing. Prognosis, chronic prognosis or the overall prognosis will be worse, but gastroschisis will be acutely worse. All right, beta. Now, pronephros appear and disappear. No need to memorize. Forget them. Mesonephros also won't make anything. We can forget them. What is important for us is the metanephros, but this duct is important for us. That is a mesonephric duct. Only remember these. So metanephros will make the final system, and one bud will come, ureteric bud. That also makes the final system. How? Like this. We can say the metanephros is making the excretory part, and the collecting part will be coming from the ureteric bud. That's all. After formation, kidneys should ascend. Testis descend, kidneys ascend. If they fail, then like this. Either the pelvic kidney or horseshoe kidney. And who blocks the ascent? Inferior mesenteric artery. Now, dear friends, एक winning mantra भी कर लेते हैं. एक winning mantra भी कर लेते हैं ताकि आपके अंदर confidence और भर जाए. तो always be focused just like Arjun. Okay, आई एकदम अपने लक्ष्य की तरफ. अब मेरे साथ साथ रिपीट करेंगे बेटा. I am the best. Brachial plexus, 2 injuries are there. Okay, if you want to learn Erb's palsy, that will lead to arm is adducted. अब बना लो ऐसा, arm is adducted and medial rotated, and you see the forearm is not like this. It is going, biceps is paralyzed. It will be extended and what? Pronated. Okay, supination is lost. And if lower trunk का injury आएगा, clump case आएगा तो claw hand हो जाएगा and Horner syndrome. Okay, that's what we should remember. All right. Involvement of the nuclei will be medial may you have to understand the efferent columns, and afferent column will be all in the lateral. Lateral most column will be SSA. All right. Okay. चलो एक बार एक विनिंग मंत्रा कर लेते हैं बेटा. अब स्टार्ट करो, साथ साथ बोलना. I am the best. I am the best. I know that I am a winner. Okay. It's like you should know that you are a winner. Only it's a matter of fact. 1 week ही रह गया है. And then you are going to win this game. Yes, you know, you should know it. I know I am a winner. And most importantly, God is with me. So I am the best. God is with me. Okay, I can do it. So taking all the factors, I can definitely do it. Isn't it, beta? Yes, tell me. I am best and I can do it. I can do it. Yes. Yes, I can. Yes, I can. Yes, I can. So these are the stages, and definitely one stage will come where you will say, yes, I did it. So yes, I can and I did it. Little bit gap is remaining in these two phrases. So we are with you now. The ball is in your court. You play well and we have trust on you guys, and definitely you are going to excel. लेकिन जब आप बोलोगे yes, I did it, don't forget to send a message. We will be waiting to hear from you guys. Okay, and let me tell you, we'll be very happy and very proud of you. Thank you so much, dear friends. Do connect with me on these platforms, and I would like to hear from you when you have you are selected, when you have cracked the exam. My best wishes. Thank you so much, everyone.
Hi everyone. So let me know quickly if I am audible and visible. Hi everyone. I'm audible and visible. Yeah. Hi everyone. So the thing is we are doing marathon, but I'm the last person, so maybe I have to run quickly now because most of you must not have your dinner. So good evening everyone, and yeah, I am the winner. I am best. As Doctor, I was listening to Dr. Sandeep. I am the winner. I am the best. I am the best. वो गाना था ना ऐसे. Okay, so I have been allotted time of 30 minutes to cover the important previous year topics in NEET PG NEET marathon session. I will just revise as quickly as possible, as smoothly as possible, as concisely as possible if I try to do in this half an hour session, maybe half an hour, 40 minutes. All right. So let it be a fast marathon. And all the questions which we will discuss, the NEET questions will be discussed here. Even INICET and FMG question, and FMG question of the recent July you should see for the NEET exam as well, because there are some overlapping. Okay, let's see. The first page is regarding the anatomy. So anatomy, what things you need to know is the anterior chamber. This is the cornea. This is the lens, and this is the iris. So anterior chamber is from the posterior surface of cornea till anterior surface of the lens, iris, lens, diaphragm. Behind the iris till the zonules are the posterior chamber. This is a simple thing, but you should know these two things, that the intrazonular space is known as canal of Hanover, and this is canal of Petit, which was the previous question, between the zonules and the posterior segment. Behind the lens there is a posterior segment, that is nothing but vitreous. So aqueous is present in the anterior segment, vitreous is present in the posterior segment. Now, yes, of course, I didn't. Don't worry about this. I am taking my time. So this is canal of Petit is one which you should know for the exam. Now for the embryo, embryo you should know that there are four things. I always say how to remember embryo is four clinical derivatives of there. If you remember three of them, embryo is sort out. Like surface ectoderm is remembered by SLE, skin of eyelids and appendages, lens, lacrimal gland, and epithelium of cornea conjunctiva. That is surface ectoderm. That's why when there is a problem of surface ectoderm like eyelid coloboma, ankyloblepharon, adhesion between the two eyelids, or loss of any tissue in the eyelid, that is related to surface ectoderm. And this eyelid coloboma is important. That is most common cause of exposure keratopathy. Yashuji, marathon hai. Surface ectoderm has SLE. Now, optic cup, also known as neuroectoderm, that you can derive by ROMES. Retina, optic nerve, muscles of iris, epithelium of iris, and the main vitreous and zonules. So, ROMES, SLE, and everywhere in the body, mesoderm, MESO. All the muscles of the body, all the blood vessels of the body. One exception is temporal sclera. And there is a hyaloid vessel which joins the lens and the optic disc. That is also why every blood vessel is formed by mesoderm. So mesodermal derivative will be hyaloid vessel derivative, that is persistent hypoplastic primary vitreous. That's an important question. Means if this picture is given to you, it is asked which derm problem it is. It is mesoderm, that is persistent hypoplastic primary vitreous. While if you are asked a question over this, if you see over here, there is a loss of iris tissue. And any loss of any tissue is known as a coloboma. So all the eyeball colobomas are formed inferiorly because a fissure is formed inferiorly. There is an optic fissure which is inferiorly known as choroidal fissure, closes by 36 days. So all the eyeball colobomas are located inferior. Eyelid coloboma can be superior and inferior. So again, eyelid coloboma is due to surface ectoderm problem. Eyeball coloboma is due to optic cup problem. Hyaloid vessel persistent due to mesodermal problem. Rest everything, SLE, ROMES and meso, rest everything will come in neural crest. So that you take it as an exception. You can't remember everything. So remember MESO, remember SLE, remember ROMES. That is the way of remembering embryology and the clinical point of embryology. Now next we'll now I'm discussing this in the same sequence as live rapid revision. So I will revise the LLR quickly, whatever I can, in the 30-40 minutes. Now there are 4 senses. Color sense is checked by Ishara chart most commonly. Light sense is checked by torchlight. Contrast sense, various chart. One chest is Paley-Robson chart. And form sense tells about the visual acuity, in which Snellen's chart is the most common chart. Then you can ask the full form of early treatment of diabetic retinopathy study, that is ETDRS chart. Both are form sense, means shape and size are changing. Now Snellen's is based on MAR, while ETDRS is based on log MAR. Snellen's done from 6 meters, ETDRS is done from 4 meters. How to calculate the MAR? Just reverse the visual acuity. 6 by 60, just reverse the visual acuity. 6 by 60, just reverse the visual acuity, you will get the minimal angle of resolution. But if the entire letter is asked, you have to multiply the minimal angle of resolution by 5, because Snellen's chart has told that every letter has 5 segments. So 6 by 36, only MAR is asked, answer is 6 minutes. If the entire 6 by 36 is asked, answer is 30 minutes. So that is a minimal angle of resolution. Just reverse the visual acuity. But for the total letter, you have to multiply the minimal angle of resolution by 5. That is told by Snellen's chart. So this is one which you should remember, Snellen's chart. Okay. Now one question is definitely going to come in the visual pathway. Every exam, this question comes in the visual pathway. Now this is the superior view. This is the right eye, this is the left eye. If I quickly revise, if there is a lesion in the right side optic nerve, this one, right side optic nerve. So right side optic nerve will lead to right total blindness, right anopia. If there is a lesion in the optic chiasma, both nasal fibers are crossing, it will be bitemporal hemianopia. The only heteronymous, means opposite side defect, is bitemporal hemianopia. Like in pituitary gland tumor, it is present. FMGE question was there. Right side optic tract. Right side temporal fibers are coming. So right side nasal defect. Always when visual field is given to you, it is patient's view. Left side nasal fibers are coming. So left side temporal defect. So both sides same defect. This is left homonymous hemianopia. So you have to remember, when the lesion is behind the chiasma on the right side, it has to be left homonymous. Whether it is the right optic tract or right LGB or right temporal lobe, right parietal lobe, right occipital lobe. LGB is keyhole visual field defects, that is not asked, but temporal lobe and parietal lobe is very, very important. In there is the temporal lobe, right side temporal lobe lesion, it has to be left homonymous, but only superior quadrantanopia, like a pie, because only the inferior fibers are involved, that is mere fibers. Exactly opposite is the right parietal lobe. The superior fibers of the radiations are involved. So inferior quadrantanopia, that is pie on the floor. So again, pie in the sky, temporal lobe. Pie in the floor, parietal lobe. But that is homonymous. And if the question comes, the patient is not able to see on the left side from both eyes, means left homonymous hemianopia, but central vision is spared. If central vision is spared, that is a very, very favorite question of every exam. That is a keyhole vision. That is macular sparing. So this is the right left homonymous hemianopia, right side occipital lobe damage, because the tip of the lobe has additional supply from middle cerebral artery. So this keyhole vision is important. Keyhole defect in LGB will not be asked. Keyhole vision in occipital lobe lesion. Macular sparing is therein. So only difference of optic tract and occipital lobe is macular sparing. That is very, very important to understand in the exam. So one question of visual field is definitely going to come in the exam. Okay. And always when the visual field is given to you, so who can tell me quickly, if I just draw a visual field for you, tell me if this question comes in the exam, where is the lesion? Tell me. This is the visual field given to you, where is the lesion of this patient? This is left homonymous, inferior quadrantanopia. The lesion is in right side parietal lobe. Good. Alright. Now Horner syndrome is very, very important. Horner syndrome, the features like you see in this picture, what is happening? What is the difference of pupil size is known as? Difference of pupil size is known as anisocoria. So here there is the left eye pupil is smaller and difference of color is there, that is heterochromia iritis. So smaller pupil, mild ptosis is there. This is because of sympathetic problem, Horner syndrome. Always a unilateral condition, meiosis, partial ptosis, because only Muller muscle is having problem, last year's NEET exam question, because these are all supplied by sympathetic pathway. Color of the iris melanocyte is not able to form, so heterochromia iritis only in congenital Horners. Loss of sweating is there, that is anhydrosis. But who can tell me loss of sweating is not seen in which Horner syndrome? Central Horners, preganglionic, postganglionic. In postganglionic, you see in postganglionic, sweating fibers, they don't go. If there is a postganglionic Horner syndrome, sweating is normal, means anhydrosis is not seen in postganglionic Horner syndrome. What can be the answer of preganglionic Horner syndrome? Pancoast tumor important. If the patient has Horner syndrome with Pancoast tumor, preganglionic fibers are involved. So Pancoast tumor, a patient comes with breathlessness, with the ptosis, meiosis. That can be Horner syndrome due to Pancoast tumor, preganglionic fibers are involved. So all these are features of Horner syndrome. Now who can tell me Horner syndrome, the anisocoria is maximum in which light conditions? In dark or bright light? In dark. Why? Because in dark the Horner's pupil will not dilate. Normal will dilate. Now if I quickly revise the other pupils with you, just the names. ED's pupil. ED's pupil, where is the lesion? Same side ciliary ganglion. And there is a diluted pilocarpine test for ED's pupil. Amarutic pupil means pupil is not reacting at all. Optic nerve lesion, total optic nerve. Complete optic nerve lesion, amarutic pupil. Marcus gun pupil. Marcus gun pupil is seen in partial optic nerve lesion as the first sign of any optic nerve pathology. Wernicke pupil. Wernicke pupil is seen in optic tract lesion. Argall-Robertson pupil, that is seen in pretectal nucleus. That is neurosyphilis, sexually transmitted disease. Light reflex present, light reflex absent, accommodation reflex present. Knee reflex is present, light reflex absent, that is Argall-Robertson pupil. And Marcus gun pupil is by swinging flashlight examination. ED's pupil tested by diluted pilocarpine test. In the entire world, diluted pilocarpine 0.125 can constrict only ED's pupil because of supersensitivity. So ED ciliary ganglion, amarutic pupil, optic nerve complete, Marcus gun partial optic nerve lesion by swinging flashlight examination. Wernicke optic tract, Argall-Robertson sexually transmitted disease, pretectal nucleus in the dorsal part of midbrain. Horner's pupil due to sympathetic problem, like we just discussed. Now, just the basics of optics. Everything, myopia, hypermetropia, astigmatism is far point concept. If all the rays are focused on the retina, it is normal emmetropia. If all the rays are focused before the retina, that is myopia. Behind the retina, hypermetropia. But at different point, it is astigmatism. Now, quickly. Boophthalmos, very big eyes. In congenital glaucoma, that is example of axial myopia. Keratoconus, the cornea curvature is increasing. That is curvatural myopia. And if the lens is in patellar fossa, can come anteriorly. Anterior dislocation will lead to positional myopia. But there is a patient, old patient, NEET exam question, old patient with decreasing far vision, but improvement in the near vision. He is getting a second sight due to nuclear sclerosis. And nuclear sclerosis means index myopia. Okay, so keratoconus, curvatural, anterior dislocation, positional, and so on. Now there are 5 different types of astigmatism. One ray on the retina, one before is simple myopic, both ray before compound myopic, one in front, one behind is mixed, both behind compound hypermetropic, and one on the retina, one behind is simple hyperopic. But how do you say which rule? With the rule or against the rule? So there is a principle which was asked in FMGE and previous NEET also, Sturm's conoid principle. Sturm's conoid is a principle for astigmatism. You see in the 3 dimension, the vertical rays are focused on point B and horizontal rays are focused on point number F. So if they are not focused at a single point, it means it is astigmatism. Now if the retina is at point number A, both the rays are behind, that is compound hypermetropic astigmatism. But here who can tell me which rule? It is with the rule. By definition, ये तो रटना पड़ेगा, बुरी तरह रटना पड़ेगा BTR. That vertical steeper is with the rule, horizontal steeper is against the rule. And how do you decide which is steeper? The axis which is focused more in front is steeper axis. So here red is focused more in front, so vertical is red, that is steeper axis. So all these astigmatism are with the rule astigmatism. So if I ask a question, if the retina is at point number F, if the retina is assumed to be point number F, one ray is on the retina, one ray is before the retina. That will be simple myopic astigmatism. If the retina is at point number B, one on the retina, one behind, simple hypermetropic astigmatism. If the retina is at point number C, D, E, one in front, one behind, mixed astigmatism, everything is with the rule over here. That is the Sturm's conoid. Image was asked in FMGE also, in previous NEET exam also. But how can you answer the question from retinoscopy values? If after 3 steps of retinoscopy, vertical axis is -6, horizontal -4, this is given to the patient. So you are given this minus means you don't have pen paper. So we will not solve by pen paper today. -6, -4, both are minus means both are in front of the retina. That's why you're giving minus. So both in front, different point means compound myopic astigmatism. Whose will be more in front? -6 you want to diverge more. So -6 is more in front. So -6 is in vertical. So this will be compound myopic astigmatism with the rule. So both minus means both in front. So if I ask another question quickly, 0 and -2. 0 means on the retina, -2 front of the retina. This will be simple myopic astigmatism against the rule because -2 will be in front of the retina. But from prescription of glasses, how to solve? By simple mathematics and English. +1 diopter sphere means +1 works in both the axes. -2 at 90 means it is kept at 90 degree. 90 means vertical. So it will be working and horizontal. So +1 will be vertical and -1 will be horizontal. So +1 is behind the retina, -1 in front. That is mixed astigmatism, and minus is in, it will be +1 -1. -1 is in horizontal axis. That's why it is against the rule astigmatism. That's an excellent answer. That is how you solve. One more question quickly I give you. +1 diopter sphere with +4 diopter cylinder at 180 degree. Without pen paper you do it because you won't get pen paper. +1 both axes. +4 is kept at 180. It will work vertically. So +5 +1. Both plus means both are behind the retina. Compound hypermetropic astigmatism. Which is steeper? +1 is more in front. That is with the rule astigmatism because +1 is more in front as compared to +5. Oh, sorry. This will be what? +1 both axes, +4 as horizontal. It will work vertical. So +5 in the vertical, +1 in the horizontal. Compound hypermetropic astigmatism. +1 is in horizontal axis. That is steeper. That is against the rule astigmatism. Good. Okay. In refractive surgery, you know LASIK is one corneal surgery. First question, it is a corneal surgery. First step, you create a stromal flap by either femto laser or blade. Second is the main step, excimer laser to make the cornea thin and then repose it. You can correct myopia and hyperopia over here. So what is important is, it is contraindication important. So LASIK is not done in severe dry eyes, contact sports and thin corneas like keratoconus. Because cornea is thin, you will perforate the cornea. Why severe dry eyes contact sport? Because of flap. Flap is there. So which is a flapless surgery? You should know SMILE. So these contraindications are not in SMILE. Refractive lenticle extraction, that is also flapless surgery. Like no excimer laser, femto laser is used. But this also, it is contraindicated in thin cornea. Because here also you make the cornea thin. And this was a question. Radial keratotomy is absolutely contraindicated in contact sports because you will rupture the cornea because you make cuts in the cornea. So absolute contraindicated in contact sports in boxers is radial keratotomy. Relative contraindication is LASIK. Before 18 years of age, you can't do any refractive surgery. So radial keratotomy, absolute contraindication. LASIK, relative contraindication of contact sports. Phakic IOL means you place the intraocular lens between the lens and the iris. That is sulcus. That is the implantable collamer lens. Collamer is the material of the intraocular lens. Okay. Okay. Now, cataract and cataract surgery question. We'll just identify the cataracts today. If a picture is asked over here, this is the most common congenital cataract, blue dot cataract. If this question is asked, nothing to be done because it is the most common but does not decrease the vision. It is blue dot cataract. But most common congenital cataract causing decrease in vision is zonular cataract. There are radial spokes and riders, that is pathogenic. This is the most common cause of leukocoria as well. And cataract surgery as soon as possible in a child. Now, Just to identify, this is the Christmas tree cataract that is seen in myotonic dystrophy. Wilson's better answer for sunflower cataract. Snowflake cataract seen in diabetes mellitus type 1, not in type 2. Type 2 is same as senile cataract. While blunt trauma, if there is history of blunt trauma, there is a star-shaped cataract known as rosette cataract. So identification of cataract shape is very, very important. While senile cataract, the most common senile cataract will be a cortical cataract. That is a cuneiform cataract, like a wedge opacity. A wedge opacity is in the periphery, that is a cuneiform cataract. Well, cupuliform, one example is posterior subcapsular cataract, when the cataract is involving the posterior surface of the lens. And there are various differentials of PSC, you should know that. PSC seen in BSc, I have told multiple times. While old related cataract, hypermature nucleus sinks to the bottom, that is hypermature Morgagnian cataract, which can lead to phacolytic glaucoma as well, open angle glaucoma. And this was an image to be asked in one NEET exam. Iris shadow. This is the iris shadow seen only in immature senile cataract. Morgagnian is hypermature cataract. Now, cataract surgery complication or cataract surgery. Quickly, if I just revise, the first step is you enter the anterior chamber by paracentesis. Vitreous aqueous will come out. You put viscoelastics. Circular opening in the anterior capsule by trypan blue dye, that is anterior capsulorhexis. Then the two main steps are hydrodissection and delineation. Dissection, you remember, you put water under the lens capsule, and delineation, you put water inside the lens fibers. And the main step is electrical converted to mechanical energy by piezoelectric crystals, that is emulsify the nucleus into small pieces and aspirate them. And the best position to place the intraocular lens is in the posterior chamber. And then you don't you remove the vitreous by phacoprobe. If you don't remove the visco, you have to remove the viscoelastic because it will lead to high pressure if you don't remove. Sutures are not used in phacoemulsification. Sutures are used in extracapsular cataract extraction surgery. So these surgery steps are very important, that is phacoemulsification. But the most common in India is small incision cataract surgery. Hydrodissection not in good Suha Lakshmi Selvan. Hydrodissection is not done in posterior polar cataract because that will lead to nuclear drop in the vitreous. Now what will happen? This is the most common complication of cataract surgery. Last year's NEET exam question. Patient comes with Elschnig pulse, decreased vision with glare. That is also known as after cataract, and you make a hole in the center, that is NDI capsulotomy. Sedal test. If the word sedal test comes, sedal test positive means the wound is leaking. If the wound is leaking means aqueous is coming out, that will lead to shallow AC and low IOP. So sedal test, anywhere sedal test come, it is wound leak. You have to resuture the wound. Anywhere PCO comes, NDI capsulotomy. Now after cataract surgery, you get a hypopyon. Yellow thing is hypopyon, red thing will be hyphema. Hypopyon with painful decreased vision, vitreous is involved, that is acute endophthalmitis. Why not panophthalmitis? Because in panophthalmitis, cornea sclera will also be involved. And endophthalmitis, you have to give intravitreal injection of antibiotics. If it doesn't resolve, then vitrectomy. Organism was asked this INICET exam, so it can be repeated. Within 1 day, staph aureus. After 2 to 4 days, staph epidermidis. That's most common. After 1 month, propionibacterium acne. Overall, most common is staph epidermidis. That can happen after 2 to 5 days. After 2 to 5 days. After 1 month, it is propionibacterium acne. How to differentiate this from toxic anterior segment syndrome? That is only in the anterior segment. Hypopyon will be there, but only the inflammation in anterior segment. Vitreous will not be involved. That is the inflammation to IL material. That is within 24 hours also. So TAS versus endophthalmitis is an important question. Endophthalmitis question you must expect this time as well. Or a cataract surgery complication. Then blowout fracture. Blowout fracture. Why the blowout fracture is in the floor? Because the floor has a weakest point of the orbit, that is maxilla. That is seen in blunt trauma, maxilla fracture, floor fracture, teardrop sign, blowout fracture. Inferior rectus muscle फंस सकती है, entrapped, restrictive squint. Means patient will have difficulty in looking up or down. Difficulty in looking up. Because IR is not paralyzed, IR is restrictive. If IR is paralyzed, then the patient has difficulty looking down. Here muscle is stuck, patient has difficulty looking up. It's a floor fracture, maxillary bone fracture. That's the weakest point of the orbit. Seen in blunt trauma. Now I quickly revise proptosis for you. Proptosis is protrusion of eyeball. If it is coming with, most common cause of unilateral bilateral proptosis is thyroid eye disease. It is HL mediated. Most common cause can be seen in any thyroxine levels, and vision loss can be there. There is a NOSPECS, no specs classification, and belly of the muscle is involved. Inflammation is there, gag deposition is there. Steroid is a mainstay of treatment. Which is the most common exophthalmometer? Hertel's exophthalmometer. Now, if there is an axial, means central proptosis, with RAPD means Marcus gun pupil, means optic nerve tumors. In a child, it will be optic nerve glioma. Middle age, it will be optic nerve meningioma. Radio question can be come with patho, radio, and ophthal question can come. Both are associated with neurofibromatosis. While if a patient comes with pulsatile proptosis, after head trauma with pulsatile proptosis, it will be keratico-cavernous fistula, in which the bruit is positive. Whether the patient comes with intermittent proptosis, more on bending, Valsalva, then it will be orbital varices. So again, pulsatile proptosis, keratico-cavernous fistula. Intermittent proptosis, more on bending, Valsalva, orbital varices, mostly seen in young males. Overall, most common cause of proptosis, thyroid eye disease. Yeah, Coca-Cola bottle shine Shagupta is saying that is the radio question. Now, last year 2 questions come from this table. Proptosis in a child, if painful proptosis and sinus history is there, trauma history is there, that is orbital cellulitis. Then you can ask it is a preseptal or postseptal. How to do? 3 things cannot come in preseptal cellulitis: proptosis, decreased eye movements, and decreased vision. If proptosis, decreased eye movement, decreased vision is there, it has to be orbital cellulitis. Then abscess, we have to differentiate radiologically. Then histopathy, if there is a round cell tumor and keyword is Descemet positivity, that is rhabdomyosarcoma, most common in the orbit tumor, malignant tumor in orbit in child. Calcification is a keyword. Synaptophysin chromoganglion is keyword, that is retinoblastoma. Well, ecchymosis, bilateral ecchymosis is neuroblastoma. And just now told you, if a child has axial proptosis, painless axial proptosis with RAPD, with leash nodules, that is neurofibromatosis, glioma. While this picture was there, dermoid. Dermoid is a most common benign tumor in the child in the orbit. You have to take it out. It is a limbal dermoid. And skin, you must have studied capillary hemangioma. So dermoid is the most common benign tumor in the orbit in child. Excision is done. Now, differentiate keratitis, uveitis, scleritis, epistaxis, conjunctivitis. All will have redness. Pain and redness will be there in all. Key features are photophobia will be there in keratitis, uveitis. Discharge as the keyword is more in conjunctivitis. If hypopion is there, it means it is hypopion will rule out conjunctivitis and scleritis and epistaxis. Hypopion will be there in keratitis and anterioritis because it is inside the eyeball. Now, along with this, painful decreased vision with keratic precipitates, cells flare, small irregular pupil is very, very important. That is anterior uveitis. Small irregular pupil. Festoon pupil is seen after dilatation. Most common cause of anterior uveitis is we don't know. Festoon is seen after dilatation. Keratic precipitates can be mutton fat KPs and granulomatous disorders. So painful decreased vision with hypopion, cells flare, keratic precipitates, anterior uveitis, small irregular pupil. Painful decreased vision but large dilated pupil, that will be acute angle closure. Acute congestive glaucoma, acute angle closure. But small irregular pupil, that will be anterior uveitis. Now, contact lens history can be there in any keratitis. So, pain, decreased vision, photophobia, contact lens, overall most common cause, pseudomonas. But if you wash with dirty water, tap water, when signs are less, symptoms are more, that is acanthamoeba. Whereas trauma history, rough texture, satellite lesions, FMGE question, satellite lesions, feathery margins, it is fungus. While a very, very important, cobalt blue filter, fluorescein dye under cobalt blue filter, linear branching ulcer, sensations of the cornea reduced, low immunity, sensations reduced, dendritic ulcer, linear branching, stained by fluorescein under cobalt blue light, knobs are there, viruses present in the knobs, that is herpes simplex, dendritic ulcer. Topical acyclovir is given 5 times a day, steroids are contraindicated. But steroids are given in interstitial and deciform keratitis, you should know that as well. Now, scleritis, the most common cause is rheumatoid arthritis. and scleritis can lead to different type of cephaloma, like limbus is involved intercalary, ciliary body involved ciliary, equatorial involved in half of the eye. All these three are seen in scleritis complication. Most common cause rheumatoid arthritis. Anterior uveitis, anterior cephaloma seen in corneal ulcer. Cornea is thin, lined by iris and bulging. While this posterior cephaloma is a hallmark of high myopia. Again, a FMG question last week. So posterior cephaloma, high myopia, more than 6 diopter myopia. Anterior cephaloma, corneal ulcer. Intercalary equatorial ciliary seen in scleritis. There has to be bulging in cephaloma. So this picture is ciliary cephaloma. Rheumatoid arthritis with this picture, ciliary cephaloma, not scleromelia perforans. Scleromelia perforans will lead to cephaloma later on. But this picture is showing bulging, so that is cephaloma. Now conjunctiva, if I tell you keywords and the key signs. If the history, itching is the main symptom with cobblestone appearance, papilla. Papilla, itching, allergic conjunctivitis. But seen in a young boy with itching in summers, that is vernal keratoconjunctivitis, Horner Tranta dots, white dots are there. But history, same history is there, but contact lens history is there. Same picture, contact lens history, sutures, then there's giant papillary conjunctivitis. That is type 4 hypersensitivity. That is type 1 plus 4 hypersensitivity. Better answer is type 1. That is vernal keratoconjunctivitis. Better answer is type 1. Now follicle goes in favor of infection. And symblepharon is addition of bulbar and palpebral, that is cicatricial severe dry eyes. Chemical injury is one of the example of severe dry eyes. Now one infection is trachoma. Trachoma, follicle should be there. F, inflammation more than 50%. Scarring is important, Alt's line. Misdirection of eyelashes known as trichiasis, and opacity in the center of the cornea. So Fisto classification for trachoma, AB, ABC cause it. Safe strategy, you should know, that is easy question, safe strategy, but it will be asked. Trachoma is eliminated, but questions are not eliminated. Okay. In the conjunctiva, one degeneration is also important. Multiple times the question is asked, that is pterygium. So pterygium is head, neck and body. This part is what? Head, which is growing towards the cornea. Towards the sclera is body, and towards the limbus is a neck. It is an elastotic degeneration. Decreased vision is due to astigmatism. Head has iron line, that is Stocker's line, and excision is done with autoconjunctival graft is the best management. Adjuvant is mitomycin C to decrease recurrence. Head is towards the cornea, Stocker's line is towards the cornea, that is iron line. Both are due to this pterygium and pingucular, both are due to ultraviolet rays. That's why most common in nasal bulbar conjunctiva. Pingucular is fatty deposition. Picture will be, if asked, picture is asked. Pterygium is an important question. Pterygium, most common decreased vision is due to astigmatism. So one example of irregular astigmatism is keratoconus. Keratoconus, young patient, frequent change of glasses, that's famous sign. That is Fleischer's ring, F, that is iron deposition in the epithelium. Corneal astigmatism, myopia and Munson sign is important. Patient looks down, lower eyelid bulges. Oil droplet reflex, Vogt stria, scissoring reflex. That is famous signs of keratoconus. Each and every line of keratoconus is important. Contact lens of choice is rigid gas permeable. Investigation of choice, pentacam. For progressive keratoconus, increase the strength of the cornea by C3R procedure. And last to last year NEET exam question, this is intracorneal ring segment made up of PMMA. In which layer of the cornea it is put? Stroma. That is intracorneal ring segments. So again, famous signs, young patient, frequent change of glasses, investigation of choice, pentacam, rigid gas permeable contact lens. For progressive keratoconus, C3R procedure, corneal collagen cross-linking by riboflavin under ultraviolet rays, UV rays, A rays. And intracorneal ring segment picture is important. Now, which is the muscle which elevates the eyelids? Levator muscle more than 15, Muller muscle 1 to 2 mm. Levator supplied by third nerve, Muller muscle supplied by sympathetic. So in third nerve palsy, severe ptosis. In Muller muscle Horner syndrome, partial ptosis. Orbicular is supplied by seventh nerve, closes the eyes. And if the patient is not, if seventh nerve palsy means Bell's palsy, that will lead to lag ophthalmos. That is inability of the closed eyes in primary gaze. That is seen in seventh nerve palsy. Now tarsus is present in the posterior eyelids, and there is a gland, moving gland in the posterior tarsus. If there is a meibomian gland blockage, there will be chalazion in the posterior, means internal eyelid. So chalazion is related to meibomian gland. Infection of chalazion is internal hordeolum. Now at the root of the hair follicle, that is zeiss. So infection of zeiss and hair follicle is external hordeolum, that is stye. That was asked in the FMGE as well. So can be asked. At the root of the hair follicle, there is zeiss gland, and infection at the base of the eyelash will lead to external. External means outside eye. Outside eye, that is external hordeolum zeiss. So hair follicle zeiss for external hordeolum. Internal hordeolum is infection of meibomian gland. Chalazion is a blockage of the meibomian gland. It's a lipogranulomatous inflammation of meibomian gland. For internal external hordeolum, antibiotics is given, mainly systemic antibiotics. For chalazion, incision and curettage. And for small chalazion, intralesional steroids. Now there is a Marcus Gunn pupil and Marcus Gunn jaw winking phenomena. Patient moves his jaw, eyelid wings. That's a complicated congenital ptosis. Lateral pterygoids and fifth nerve are involved. So young male or a baby suck the nipple, the pterygoids send impulse to LPS and eyelid goes up down. So that is complicated congenital ptosis. Marcus Gunn pupil in partial optic nerve lesion, Marcus Gunn phenomena in complicated congenital ptosis. Now, this is the lacrimal gland apparatus. If there is a blockage of the nasolacrimal duct, water will accumulate in the sac. So there will be watering. Increased watering due to obstruction is known as epiphora. More water will accumulate in the lacrimal sac, that is known as acute dacryocystitis. But if there is a chronic NLD obstruction, you can press the lacrimal sac, that is, and mucus will come out, that is regurgitation positive. It is positive in acute also, but it is not done because in acute there is pain. In chronic you can do regurgitation as positive, and treatment depends on the age. Less than 9 months, Krigler massage. 9 months to 4 years, you break the obstruction by Bowman probing. And 9 months to 4 years, you make an opening from the lacrimal sac to the bone, to the middle meatus of the nose, that is DCR operation. Which bone of the nose is broken down? Middle meatus. Which bone of the orbit is broken down? Maxillary and lacrimal. Better answer is lacrimal. That also is previous question. So DCR operation after 4 years, maxillary lacrimal broken down in the nose, in the orbit. What is broken down in the nose? That is middle meatus. Normal opening of NLD is in the inferior meatus. DCR opening is in the middle meatus. Good. Now, Bitot spot, everyone claims Bitot spot question. That's a vitamin A deficiency. Bitot spot comes in X1B stage. Vision is not reduced. Vitamin A is the most common deficiency, is the most common cause of childhood blindness. But Bitot spot is not causing blindness. Melting of the cornea, scarring of the cornea causes blindness. And if there is a Bitot spot, you have to give oral dose. Less than 6 months, 6 months to 1 year, more than 1 year, international units. Less than 6 months, 50,000, 6 months to 1 year, 1 lakh. But if intramuscular is given, that is half of oral dose. Bitot spot more common in temporal conjunctiva. Pterygium pinguicula more common in nasal conjunctiva. Now, most common test for dry eyes is Shermer test. You put a Shermer stick, wait for 5 minutes. More than 15 is normal, less than 5 is severe. And this stain is the most common stain, that is a fluorescein stain. Again, under cobalt blue filter, it is a very, very important stain. Again, whenever fluorescein is used under cobalt blue filter, green fluorescence comes out. Okay. Now, visual field, more questions. Now, in the retina, there are 3 types of fibers. Papillomaculobundle fibers, there are central fibers. This is the right retina. This is optic disc. This is papillomaculobundle fibers for central vision. So whenever there is a papillomaculobundle fiber involvement in the visual field defect, there will be central scotomas. Visual field always patient view. So central scotoma, centrocecal scotoma, when central fibers are involved, like in optic neuritis, like tobacco, alcohol, antitubercular drugs, all ATT except ethambutol. Radiating fibers are most resistant to glaucoma. They are responsible for temporal vision. So last fibers to involved in glaucoma are temporal fibers, temporal vision. Radiating fibers are nasal, they are corresponding to temporal vision. While most susceptible to glaucoma are arcuate fibers. So that's why the first visual field defect in glaucoma is paracentral scotoma. First visual field defect in optic neuritis is central scotoma. So glaucoma progression, if I quickly revise with you, first is paracentral scotoma in the nasal visual field, then it becomes cedial scotoma, then arcuate scotoma, then double arcuate, that is ring scotoma, then Roinez nasal step, and last is temporal vision. Central scotoma again in optic neuritis, paracentral first in glaucoma. But isopter contraction not involving the blind spot is the first change in glaucoma. This is centrocecal scleroma. Now last year enlargement of blind spot was asked. So I'll give you 4 differential of enlargement of blind spot. One, enlarged blind spot with lacquer cracks, phosphorus spots and posterior sublunar, that is high myopia, more than 6 diopter myopia. Enlarged blind spot with patient of high CSA pressure, that is papilledema, bilateral enlargement of blind spot. Also seen in peripapillar myelinated fibers and of course with optic neuritis. Most common cause of optic neuritis is demyelination, that is multiple sclerosis. Multiple sclerosis will also have painful eye movements. So 4 differentials. 1. Multiple sclerosis, optic neuritis, papilledema, high myopia, peripapillar myelination for enlarged blind spot. Blind spot is due to optic disc. So optic disc is enlarged, like in high myopia, papilledema, blind spot is also enlarged. Glaucoma is not a reason of enlarged blind spot, please. Okay. Which investigation for the layers of the retina? That is OCT, optical coherence tomography. Identify the layers of the retina. Layers of the retina identification is important. The last layer of the retina is retinal pigment epithelium. Visual pathway I will discuss, so that will discuss the layers also. So light comes, goes to rods and cones. From rods and cones, the impulse goes to bipolar via outer plexiform. Then it goes to ganglion via inner plexiform. Then ganglionic nerve fiber axons are the axons which form the optic nerve. Light impulse to nerve impulse, that is phototransduction, occurs in rods and cones. So rods and cones have outer segment, inner segment. Outer word is towards the choroid, inner is towards the vitreous. So outer segment, this X is the inner segment, Y is the outer segment. Outer segment contains a membrane disc, that is rhodopsin and adopsin. Now retina question, if I quickly devise, there is a condition cherry red spot in which fovea is spared because fovea is central part of the retina, does not contain all the layers. Ganglionic layer is not present in the fovea, so if there is a ganglionic layer edema like in central arterial occlusion, blunt trauma. So history of rheumatic heart disease, arrhythmia is coming with cherry red spot, answer is CRA. History of blunt trauma is there, that is Berlin's edema. But history of glycogen storage disorders like mental retardation, skeletal muscle weakness without organomegaly, that will be Tay Sachs. With organomegaly, Niemann-Pick's. All these are example of cherry red spot. Fovea is spared. Fovea is involved in bullseye. The most common cause is chloroquine because it is a melanotropic. Highest melanin is there in the fovea. Now 4-5 quick retina diagnosis there. 1. Patient comes with floaters, flashes, field defect, curtain sign. Floaters, flashes, curtain sign, field defect. That is rhegmatogenous retinal detachment. Remember, flashes is seen only in 3 conditions. Whenever there is a pull on the retina, that is rhegmatogenous detachment, posterior vitreous detachment, and migraine. Flash is seen only in rhegmatogenous detachment, posterior vitreous detachment, and migraine. Floaters when the vitreous is having problem, like vitreous hemorrhage. So vitreous hemorrhage keywords are floaters, sudden decreased vision, and a dark glow. If something is before the retina, there is a dark or no glow. So floaters, sudden decreased vision, and dark glow. Which type of retinal detachment occurs in diabetic? That is tractional retinal detachment. In pregnancy, malignant hypertension, exudative retinal detachment. Central serous retinopathy is a type of exudative, means more fluid is coming from the choroid. So OCT showing neurosensory retina and RP separation, central detachment with the ink blot appearance, that is CSR, central serous retinopathy. Nothing to be done, wait and watch. But multiple causes of cystoid macular edema. Cystoid macular edema can be caused due to diabetes, due to VEGF, venous occlusion VEGF, various drugs like adrenaline, prostaglandins, myotics, high dose of niacin. Increased thickness is there in the retina. It can be a complication of cataract surgery, Irving gas syndrome, and a flower petal appearance on angiography. So flower petal with increased thickness, cystoid macular edema. Ink blot with neurosensory detachment from RP, CSR. CSR example of exudate detachment, wait and watch is the answer. CME, multiple treatments. If diabetic patient, anti-VEGF injection. Drugs, always stop the drug. Irving gas syndrome, steroids, NSAIDs. Treatment depends on the cause. Now diabetic retinopathy, if we talk about diabetic retinopathy stage. Very mild NPDR has microlesions, that is hyper Dodson angiography. That is very mild non-proliferative diabetic retinopathy. Now, in mild to moderate, there will be hemorrhages and exudate. So, hemorrhage is red, exudate is yellow. Small, shiny yellow, that is hard. Large, fluffy is soft, that is cotton wool spot. Fundus sign, that is mild to moderate. Then very severe, very severe, you have to know the rule, 4-to-1 rule. But if the word comes new vessels anywhere in the retina, new vessels elsewhere, new vessels on the disc, it will be proliferative stage of diabetic retinopathy. And only two signs are bleeding. Two signs are hyperfluorescence on angiography in diabetes. One is microlesions and new vessels. And proliferative stage of diabetic retinopathy, main management is pan-retinal photocoagulation. Secondary is anti-VEGF injection. Now, tractional attachment also comes in PDR stage. Vitreous hemorrhage also comes in PDR stage. The only reason of sudden decreased vision in diabetes is vitreous hemorrhage. And three keywords I told you already for vitreous hemorrhage. Tractional attachment also comes in PDR stage. So, new vessels, tractional attachment, vitreous hemorrhage comes in proliferative stage of diabetic retinopathy. Now, normal arterial ratio is 2:3. That is normal. In hypertension, it will be 1:3. But in central venous occlusion, it will be 1:4. With tortuous dilated veins, hemorrhages, flame hemorrhages, cotton wool spots everywhere, like a splash tomato appearance, blood thunder appearance, 100-day glaucoma, all keywords are there in CRVO. Again, treatment is pan-retinal photocoagulation. So 1:3 hypertension, 1:4 CRVO, splash tomato appearance, blood thunder appearance, 100-day glaucoma, CRVO managed by pan-retinal photocoagulation. Then most common dystrophy in the retina is retinitis pigmentosa, in which there is a wave like A wave and B wave. A wave decrease early, B wave later. Night blindness, young patient. Nyctalopia, early feature night blindness. Bony spicule in the peripheral retina, that's why it's a differential of ring scotoma tunnel vision. Triad, bony spicule, arterial attenuation and waxy pallor. Vitamin A or docoxahexaenoic acid can be given. Differential of ring scotoma tunnel vision is important, that is pigmentosa, advanced glaucoma, pan-retinal photocoagulation, 2 drugs vicabatrin quinine, differential of ring scotoma tunnel vision. Alright. Central scotoma seen in optic neuritis. Paracentral scotoma seen in first defect of glaucoma. One question of visual field is definitely going to be asked. Intraocular pressure measured by Goldman applanation tonometry is a gold standard. Gonioscopy checks the angle of anterior chamber. Direct mirrors are not there, indirect mirrors are there. One example of direct important, Coepe, Swan-Jacob, Richardson. Coepe you remember. What are the optic disc changes in glaucoma? The neurodelta rim is thin, so increase in the cup disc ratio. Bending of vessels, bayoneting sign, laminar dot sign, nasalization of vessels. Again, thinning of the neural rim, bending of vessels, laminar dot sign and nasalization of vessels are seen in glaucoma. Open angle glaucoma, closed angle glaucoma told by gonioscopy. Open angle, closed angle, both are treated by prostaglandins as a drug of choice. First defect is paracentral scotoma. And again, patient comes after painful decreased vision, dilated pupil. Then answer is acute angle closure. Mannitol is given with pilocarpine because treatment of choice is iridotomy. But if the same question comes, that patient after seeing movie come with painful decreased vision with small irregular pupil, then it is acute anteruveitis, topical steroid is the answer. Then congenital glaucoma, the keywords are HAB stria, boophthalmos means axial myopia, so photophobia, watering, blepharospasm, big blue eyes, high IOP in a child, HAB stria. There are only two striations in ophthalmology, H for horizontal, H for HAB, V for vertical, V for walk stria, that is in keratoconus. Goniotomy is a management of choice for congenital glaucoma. And lastly, let us quickly squint and injuries revise. So, in the squint, if you know this Herring's law, then diplopia questions are also very easy. Like if a question is asked, this is primary case. Both eyes are looking on the right. So, both eyes are looking on the right. Which muscles are working? Right LR and left MR. That's when right LR palsy, left MR palsy, maximum diplopia is on dextroversion, looking right. Dextro elevation, which muscle working? Right SR and left IO. That's when right SR palsy and left IO palsy, maximum diplopia is on looking right and up. So in the direction of paralyzed muscle, where is the muscle working? That is the direction of maximum diplopia in parallel squint. Like in levo depression, which are the muscles working in levo depression? Levo depression is left and down. Right SO and left IR are working in levo depression. That is why in right SO palsy, maximum diplopia will be looking left and down. Means horizontal looking left, vertical looking down. So in the direction of paralyzed muscle, if you know the Herring's law, the question can become easy from this cross. Line diagram is very important. That is Herring's law of equal innervation. Now in the picture, if they ask a question, this is squint. Right eye looking straight, left eye is going inside. Inside is esotropia. This is tropia, manifest. Exo is outside, hyper is up, hypo is down. And how do you know the degree? This is asked in FMGE also, it can be asked for you. If at the limbus it is 45 degrees of squint equal to 90 prism diopters. If it is at the pupil border, if the reflex, Hirschberg reflex in the center, no squint. At the pupil border, it is 15 degrees of squint. Between the pupil and the limbus, 30 degrees. At the limbus, 45 degrees. And 1 degree equal to 2 prism diopters. So this is left esotropia, left LR palsy. So left LR palsy will have maximum diplopia looking left. Patient will come with left face turn only. So 6th nerve palsy will have esotropia. 4th nerve palsy means SO palsy. Left SO palsy will have hypertropia. And left SO palsy, who can tell me quickly? Left SO is working in which gaze? Very important. Left SO is working in dextrodepression. So patient will have maximum diplopia looking right and down. He will come with chin down, right face turn, and superiors come with opposite head tilt. Means left SO palsy will come with right side head tilt. Superiors come with opposite side head tilt. So dextrodepression will have maximum diplopia looking right and down. Please remember, left SO is working on the right side. And third nerve palsy, very very important. Only if there is a ptosis with squint, it has to be third nerve palsy. Because of LPS is not working, patient eye is having down and out, down because of SO, out because of LR, and see pupil is dilated. Anisocoria. Now this anisocoria is more in which conditions? Anisocoria is maximum in light conditions. Honest pupil, anisocoria is more in dark. Here in light, right will constrict, left will not constrict. ED's pupil also, anisocoria is maximum in light conditions. But in ED's pupil, ciliary angle lesion, there is no squint, no ptosis. So if ptosis is there, in squint it has to be third nerve palsy. Down and out eye, pupil is dilated, maximum in light conditions. So just to revise quickly in squint, down and out eye with ptosis, third nerve palsy. Esotropia, 6th nerve palsy. Hypertropia, it is 4th nerve palsy. Okay. Last year this question was asked, verse 4 dot test. Right eye will see only red color, left eye will see only green color. 4 dots are there and fourth will be mixture. So 4 dots in a normal person. 2 red dots means right eye is working, left is not working, that is left suppression. Last year's NEET question. 3 green dot means right is not working, that is right suppression. And 5 means diplopia. Now this is patient's view like visual field. So patient is saying, you are the patient saying the red dot is on the right side in this picture. If red dot is on the right side and right is on the red is on the right, it has to be uncrossed diplopia, and uncrossed seen in ESO and crossed seen in EXO. If the patient says red is on the other side, that is crossed diplopia. You have to interpret like a patient view. Same for Maddox rod. You have to interpret like a patient view. Maddox rod means cylinders. If rods are kept horizontal, the patient will see a vertical line. And if the torchlight is in the center, patient is normal. And in this patient, see, you are the patient saying, I am wearing Maddox rod on my right eye. You are facing the screen. They have to mention you are facing screen. You are the patient. You are saying the line is on the right side. If line is on the right side, it means it is uncrossed diplopia. If line is on the left side, it is crossed diplopia. Again, patient view. Only 3 interpretations of the patient's view. One is Maddox rod, Worth photo test, and visual field. It has to be interpreted as patient view means you are the patient. So Worth photo test question is expected again, or even a Maddox rod question. Alright. Quickly, if I just remember chemical injury. See, chemical injury, why controversy? Any patient comes to you, you have to take history first. You can't assume. वो ऐसे थोड़ा लिखेंगे पेशेंट आया आपके पास और पानी डाल दो. So you have to have a history first. Then you wash the eyes in chemical injury. Most common chemical is lime, most common acid is H2SO4. Alkali is more dangerous. But injury, any injury, you have to have history first. Blunt trauma features will be periorbital hematoma, but if it is in both eyes, it is anterocranial fossa fracture, raccoon eyes, panda eyes, battle sign, middle cranial fossa fracture. Hyphema. See, hyphema and vitreous hemorrhage, one word is very important. They can ask any blood in the eye, you will ask the patient to propped up position, means head up 45 degrees, so that with gravity blood will go down. So hyphema, vitreous hemorrhage, 45 degrees head up position to settle down the blood down. Root of the iris is the thinnest, so iridodialysis, these shape people can be seen in iridodialysis, can be seen in blunt trauma. Now if there is a whitest deposition on the lens, that is pseudo exfoliation. Brown means iris pigment of the lens is Washer's ring. Always the ring is smaller than the pupil. So Washer's ring, iridodialysis, hyphema, blowout fracture, ecchymosis all goes in blunt trauma. While in penetrating trauma, if copper goes inside, that is chalcosis. Iron goes inside, that is sidrosis. Sidrosis can cause hyperpigmentation of iris, that is heterochromia iritis. So chalcosis, sunflower cataract seen in cases pressures. But don't just, without history, if the patient says that I have problem in walking, doctor says he has hepatosplenomegaly, jaundice, basal ganglia problem, then KF ring, then it is a Wilson's disease. If the history of penetrating trauma, then it is chalcosis. Most common foreign body to go inside is chisel hammer, that is iron. And lastly, don't jump for the answer if there is a penetrating trauma, painful decreased vision, corneal infiltrates, eye restricted movements, cornea is involved. And fellow eye is not involved. If fellow eye is not involved, it cannot be sympathetic ophthalmia. It is either endophthalmitis or panophthalmitis. How do you say difference endoph and panoph? Cornea sclera is involved, it is panophthalmitis. Cornea sclera not involved, it is endophthalmitis. Most common organism after penetrating trauma causing endophthalmitis and panophthalmitis is Bacillus cereus. After cataract surgery, end of panoph is staph epidermitis. Bacillus cereus most common after trauma, remember this point. But if the fellow eye is having granulomatous panuveitis, Dallen-Fugue nodules, that is sympathetic ophthalmia. Now this mutton fat KPs is granulomatous. Now these Dallen-Fugue mutton fat panophthalmitis can be seen in Vogt-Kyangi-Harada syndrome without a penetrating trauma. If there is a penetrating trauma and the other eye is involved, that is sympathetic ophthalmia. Intravenous steroid is given as the answer of sympathetic ophthalmia. For panophthalmitis, systemic antibiotic is given. And if it is not resolved, then you take out the eye, that is evisceration. For endophthalmitis, intravitreal injection of antibiotic, not resolving, vitrectomy. For panophthalmitis, systemic antibiotic is the answer. If not resolving, then evisceration. Not enucleation. Enucleation is contraindicated in panophthalmitis. Management of sympathetic ophthalmia, Muskan, is intravenous steroid. For the sympathetic ophthalmia eye, other eye has to be involved. If other eye is not, if the question is painful decreased vision, corneal infiltrates, eye movement restricted, other eye is normal, it cannot be sympathetic ophthalmia. Sympathetic ophthalmia means the other eye is having type 4 hypersensory reaction because of traumatic eye. Normal eye is getting problem. That is sympathetic ophthalmia. Intravenous steroid is the answer for that. Okay, so that is your revision, and this is the last session for today. Of course, it is marathon, so of course 30, 40, 45 minutes was there. 30 minutes were allotted, but still 10-15 minutes more. And I want you people to just relax. Tomorrow also will be a marathon. So after the marathon, you can see the marathon in your recorded version as per your time. Now you just relax. Just recapitulate what have you done. You will think that you don't know much, but it will not. It's not like the case. Everyone, when we were giving exam, everyone thinks that whatever we are doing is not enough. So that is not the case. Whatever hard work you have done, it will click in the mind. But one thing is very important. Stress will decrease your performance in the exam. At least 10 questions I always say you will get wrong if you just panic or you will stress in the exam. So I know it's difficult, but trust me on this. I have faced many students, many of our faculties have faced like this when we were giving exam 100 years back. So stress taking and making calm in the exam is very, very important. It is difficult, but this is also one of the game changers. Your hard work is incomplete if you panic. Many good students who did very good study in GTs, if they panic, they will not be able to perform their best. So please try to be calm during and before the exam. 2-3 days before the exam, many things will come. Ye kar lo, wo kar lo, ye kar lo. Don't do like this. Okay? Stay calm, stay positivity. One day before, at 8 o'clock, just relax. When I used to give my exam, one day before 8 o'clock, I just stopped studying everything. I just was at my peace, at calm. Then only you can perform better in the exam. Best wishes from all our side. Thank you very much for listening. You can see it's recorded as well. Thanks a lot. Best wishes for tomorrow and of course the main Sunday. Chalo, thank you. Bye bye.